one or
Thank
two
you, sir.
questions from my side.
Yes,
How
sir.
many cases of your series didn't have any specific etiology, like primary
Sir,
prostate meningitis?
yeah, sir. One patient we did all the investigation, but we were not able to found out the etiology, so we labeled him as idiopathic. Rest all six patients we had like two were viral, then one had a tuberculosis etiology, one was secondary to trauma. So in other six patients we were able to list the etiology. The first
And
patient we had a
in that
yes, sir.
primary prostate meningitis patient, did you order
Yes,
any
sir.
genetic test like HLA linkage and anything else?
Sir, genetic testing we couldn't perform because of the like shortage of the patient was from poor socioeconomic strata, and like he was not affordable, so we couldn't assess the genetics.
And what
Rest,
about recurrence? Recurrence, have you reported any recurrence of prostate
sir,
meningitis,
in
though it is?
sir, in one of the patients in the CMV group, the recurrence was noted, but the recurrence was not that great. Like it didn't damage the retina too much, so the final visual outcome was good because our follow up was minimum of 1 year. So one patient only he had a recurrence. Rest all were was subsided after the first treatment, sir.
Thank you.
Thank you, sir.
So, so do we have Dr. Farheen Kulsum with us? Uh, Dr. Pranav Kansal?
Yes.
Yes, sir.
Dr. Pranav, are you ready with your presentation?
Yes, sir. Yes, sir.
Sir, can I leave for the other presentation?
Yeah.
Thank you. Thank you, sir.
So I'm
Thank you.
sharing my screen now. Sir, am I audible?
Yes, you are audible.
Yes, sir, you are audible.
Your screen is visible. Put it in the presentation mode. You're good to go.
Yes, sir.
Dr. Pranav, yeah.
Yes, sir. So, good morning, one and all. So, I'm presenting my paper titled Relationship of Interleukin-6 and Vitamin D in Posterior Segment Diseases of the Eye. And the aim of the study was, just a minute. The aim of the study was to study the plasma levels of interleukin-6 and vitamin D in the posterior segment diseases. Our study was a case-controlled study on 93 patients who presented to our OPD. Institutional Ethical Committee clearance was obtained from before the start of the study. The patients were segregated into Group A, comprising of 60 patients with posterior segment diseases, and Group B, comprising of 33 patients of age and gender matched healthy controls. The exclusion criteria was any systemic inflammatory diseases, any autoimmune diseases, history of retinal laser photocoagulation, any history of intraocular surgery, use of corticosteroids, or history of use of oral vitamin D supplementation for the past 3 months. A detailed history and examination was done. Fasting blood samples were collected in K3 EDTA vials, and plasma was separated by centrifugation. IL-6 and vitamin D estimation was done using ELISA kits. A statistical analysis was done using SPSS 21, and a p-value of less than 0.05 was taken as significant. Coming to observation and results are out of the 60 patients in our study group, patients with diabetic retinopathy formed the majority of the patients, followed by retinal vein occlusion, age-related macular degeneration, uveitis, and Eales disease. Plasma vitamin D concentration was found to be significantly lower in the diseased participants as compared to healthy controls. And plasma IL-6 concentration was found to be significantly higher in the diseased participants as compared to the healthy controls. It was also observed that IL-6 was negatively correlated with vitamin D levels, but this correlation was not statistically significant. So Van et al. Previous studies have showed that Van et al. In 2019 reported that lower vitamin D concentration in blood was significantly associated with higher prevalence of diabetic retinopathy in middle-aged and elderly diabetics. Similarly, Kim Park in 2018 observed that serum vitamin D may increase the risk of early and late ARMD in Koreans, and may also be associated with subretinal fibrosis. So our study also observed that plasma vitamin D showed that plasma vitamin D levels were significantly decreased in posterior segment diseases as compared to healthy controls. Regarding IL-6, Yildirim et al. In 2012 observed that the mean IL-6 levels were higher in age-related macular degeneration patients as compared to control group. Our study also showed similar results in our study group as compared to the healthier controls. So this indicates a possible inflammatory pathogenesis in these diseases, and vitamin D is known to have anti-inflammatory action, so amongst various other effects in the body. So this negative correlation between vitamin D and IL-6 may be a possible target for future therapeutic regimens. So the key message being that this inverse relationship can be used as an important therapeutic target in these posterior segment diseases. That's all. Thank you.
So, Dr. Pranav, a small problem that I have with this paper is that it is too disease non-specific. I mean, it's very difficult to correlate anything if you do not subgroup analyze. Have you tried and do it between diabetic retinopathy versus vein occlusion versus? Problem is it's a small subset yet, and we need to even be very carefully analyzing these results in diabetic retinopathy also from mild to moderate to severe to PDR and different stages of vein occlusion and AMD. Just to have a very broad, as of now, it's a very broad subset to really correlate.
When we were planning our study, so we were finding what are the diseases that where vitamin D has already been studied, and we came about in our review of literature, we saw that diabetic retinopathy was also showing inflammatory pathology. ARMD was also studied in all these diseases, and similarly vein occlusions and these uveitis do have inflammatory mechanisms. So we took all of them. That also increased our number of cases, and so we took all of them together and studied all of them. Now we are we can do a subgroup analysis. I have not done it particularly yet.
The problem with doing it all together is that you can't answer therapeutically anything now.
Yes, sir.
Because it's a broad group now. Now you can't really take it to your clinic to say, okay, I'll start giving vitamin D tomorrow. Because the numbers are not there to really say whether it really works or not.
Yes, sir.
Dr. Dilip, please.
Or for something to prove as a causative factor or as a etiological factor, we need to follow certain points. So here it's a very broad study. It's an initial, I could say, a pilot study to direct future
Yes,
studies.
sir. Yes, sir.
And most importantly, this issue which sir has raised is of confounders. So there are various confounders which even affect the exposure and the outcome. So in this case, IL-6 and plasma level of vitamin D can be affected because of various other systemic conditions which have not been taken care of and excluded or stratified. So that subgroup analysis with stratification or multivariate analysis can be very helpful in these cases to bring out the real trend. So that can be easily done.
Yes, sir. So we tried to take a good history regarding any systemic inflammatory diseases. So we had in our exclusion criteria, we put that any systemic inflammatory diseases will be patients with any systemic inflammatory diseases will be excluded. Apart from that, any history of laser photocoagulation, because that also increases the inflammatory stress in the eye. That will be those will be excluded. Patients with intraocular surgery who have gone under intraocular surgery will be excluded in the past 3 months.
So we need a more
specific. I understand. This was.
It's a good attempt. It's a good
yes.
attempt.
We would want to pursue a study where we would supplement vitamin D and then see the changes. We would want to do that, but we would just first wanted to see whether there's a correlation between these two things or not.
Thank you.
Thanks.
Sir,
Thank you.
Dr. Prashant wants to leave early. He has some prior commitments as another presentation. Can we request him to present?
Sure.
Dr. Prashant, you
Sir,
are not unmuted.
good morning. Pardon, sir?
Sir, please go ahead.
Sir, am I audible?
Yes, sir.
Good morning, sir. Good morning to you all. Today I'm going to presenting my free paper on the rough of foveal Maladay in case of an acute liver failure. My patient was 32-year-old male with the acute liver failure who was a known case of hepatitis B, had a supra-added infection of hep C resulting in acute liver failure. Patient presented to ROPD with a history of 2 weeks of gradual onset, painless progressive diminution of vision in both the eyes simultaneously. There was no prior history of using any reading glasses or a distant visual acuity glasses. No history was given regarding the pain, photophobia, watering, or redness. There was no significant family history which could have contributed to his present status. Upon evaluation, one sec, sir. I think this okay. When we were examining the patient, we got his lab reports, which showed us a total bilirubin of 12.6, which was 10 times more the average value, and alkaline phosphatase at 392, almost thrice, where the alanine phosphatase was 940, which was almost 7 times the maximum permissible value. Now, the liver function also determines the updated function. So we went ahead with the prothrombin time, which was 20 seconds, so raised 1.5 times, and INR was 1.9, which is almost twice the allowed higher value. On the ocular examination, we found the distant visual acuity to be 660 in both the eyes, improving only to 636 with refractive correction. IOP was within normal limit. Contrast sensitivity suggested reduced contrast to 1.2, where the color vision was mildly reduced to 22 out of 25 in Ishihara charts. MFLA grade was performed, and the patient reported cefaloscotoma in both eyes. Anterior segment examination was within normal limits. There was no cataract seen or any corneal pathology was present. Fleischer rings were ruled out. No sign was seen of raised ceruloplasmin levels. In the posterior segment examination, optic disc was within normal limits. The cup disc ratio of 0.3, NRR was healthy. The blood vessels was within normal limits. AV ratio was maintained at 2.3. There was no sign of any vasculopathy or an optic neuropathy. However, during the posterior segment examination at the fovea, we could see a discrete 1.5 mm, 1/5 of a DD of an optic disc size foveal lesion, which caused a yellowish tinge in both the eyes. So the initial provisional diagnosis which we had no idea what we were dealing with. So we diagnosed an unspecified foveal lesion, and we went ahead evaluating the same with the help of auto-ref and OCT. On the OCT, we saw a hyperreflective layer lesion involving the inner layer of the fovea with an intact ellipsoid zone. Now, this patient was a known case of liver disease. So we thought that there might be some vitamin A levels discrepancy, therefore the ellipsoid zone is affected. However, the OCT showed us there was no abnormality as far as the ellipsoid zone is concerned, and there was only a deposit at the inner retinal layers. We followed with the autofluorescence. Both the lesions were hyper-autofluorescent. We went ahead with the NFAS analysis. NFAS analysis, I've just cropped up the two main. One is the vitreoretina interface, where we can see some reflective lesion right at the fovea. Whereas when we go to the ellipsoid zone is intact. Now this finding is same in both the eyes, and there's no abnormality, there's no change seen as far as the NFAS analysis is concerned. Moving ahead, coming to the discussion part, luteins, they are known to be protective, curative, and preventive against ocular inflammation-induced disease. In case of chronic liver patients, we know that there is a direct relation between the retinal vitamin A levels and the disease per se. The deficiency of fat-soluble vitamins, which may follow chronic cholestasis, causes because of malabsorption. Chronic vitamin A deficiency is known in this proven in the literature that it causes a disturbance of retinal rod photoreceptor function. It's more common in advanced primary biliary cirrhosis. However, since a patient had an acute liver failure, there is no literature present which says any findings ever found on macula oblique fovea in a case of acute liver failure. I went through the literature. I could find 2 literature studies. One in the posterior segment findings of vitamin A deficiency, which showed pictures similar, foveal pictures similar to my case. However, when we compared the OCT findings were completely opposite. In this case, we are finding more of an ellipsoid zone involvement, whereas in my case, ellipsoid zone was intact and the hyperrefractory structure lesion was seen at the inner retina. We went ahead with the evaluation of vitamin A levels for this patient, which came out to be 8 milligram per deciliter, which is less than the normal. Since this patient was a known case of hepatitis B, he might be having an underlying chronic liver disease, which just got accentuated because of suprared hep C infection. The second study I could quote was about the OCT in findings in vitamin A levels, because that was the main giveaway, which helped us to decide where exactly is the lesion and is this lesion secondary to
Sir,
vitamin A
the time is up.
deficiency. Sure, I'm done, sir. So we hypothesize that the retinal higher order aberrations, they're induced by the xanthophyllic deposit at the fovea, which have led to the reduced vision in the patient in both the eyes simultaneously. Sir, I'm done. Thank you so much. Any questions, I'm open to it.
Divya, you want to go first or shall I ask? Okay. Dr. Prashant,
Sir.
Number 1, vitamin A affects photoreceptor. I was
Yes,
not surprised all the literature is showing ellipsoid zone damage, because that's a photoreceptor entity. In your case, what you could see was ILM or sub-ILM lesion.
Sure.
Why did you correlate it with vitamin A?
Sir, since this patient came to us in an acute liver failure setting and was known case of hepatitis B, the hepatitis B patients having a underlying chronic liver illness is a known fact. When we spoke to our GI department, they said that there are patients who are on chronic follow-up who are found to be. So since liver is the primary site of metabolism, vitamin A deficiency is seen in patients who have chronic liver illness.
I understand, Prashant, the liver failure and vitamin A correlation.
Sure.
What I'm not correlating is your fundus changes and vitamin A. I have an alternative hypothesis. Just think about it. What is another thing which is deficient in liver failure? Another thing deficient in liver disease is vitamin K, and the patients are predisposed to bleeds. Why could not this be a resolving sub-ILM hemorrhage sitting at the fovea? It has changed its color, altered its color. You could see a shadowing effect onto the outer layers from a dense hemorrhage. I don't find a correlation between your finding and vitamin A. That's my point.
So that's exactly why I brought this on an open panel, so that at least I get to hear more idea. Like this vitamin K theory, we could not perceive only. But now, since we have collaborated with the GI department, that more and more cases who are getting admitted with us with liver failure settings, we would like to examine all of them so that we have more consolidated data. Now we will again. I was initially thinking about vitamin A levels, but now I'll also think about sub-ILM bleeding, and so that if something significant or solid comes up, at least we can publish it, and so that more people get benefited by the same.
Thank
you, sir. Thank you for that.
Thank you, Prashant. Dr. Dilip.
As sir has rightly pointed out, the primary pathology in your case is in the superficial retina. It's a hyperreflective pathology which is coming on OCT, which is causing shadowing. So it is most likely a resolving sub-ILM or a sub-ILM or a inner retinal bleed which is resolving. And as you know, in cases of chronic liver failures or even in acute liver failures, these coagulopathies are very common. So we have seen multiple cases of coagulopathies like in dengue or in viral fevers, which have resulted in this kind of foveolitis-like picture in which there is superficial retinal involvement, either because of inflammation or because of hemorrhage, and these causes hyperreflective lesions with shadowing, sir. So it is most likely a resolving bleed, and because it is not related to vitamin A, as sir has rightly pointed out. It is because vitamin A affects photoreceptors, so ellipsoid zone should be involved in those cases. So kindly redo the systemic profile and let's see what we can later on suggest.
So if I can just bring it, the coagulopathy was present because prothrombin time was at 20, where the INR was 1.9. As
So
far as
these-
what it, I agree
These
to what
can,
you're saying
these
now.
can
that
result
you're
in
saying to me.
spontaneous hemorrhages at the fovea, and these can resolve with time. So you have seen the patient with improvement. That is why the hemorrhage might be resolving at that time, sir.
Right.
Maybe so. The history was only 2 weeks duration, and in 2 weeks duration to get a resolving hemorrhage. I mean,
No,
not
we
much.
can get, sir. We can get small hemorrhages can resolve with time.
The patient is on regular follow with us. Let's see for after 3 months. If I have improvement, then I'll be okay. It was what it was. If not, then there's more head to be put into the same.
Thank you.
Please, sir.
Can we go ahead with the next speaker, Dr. Shivangi? Dr. Shivangi Singh?
Yes, sir. Sir, am I audible?
Yes, you are. Can you please start your screen sharing, ma'am? We are running short of time.
Okay.
In the meanwhile, we also have Dr. Farina with us. I believe we'll go with her next if that's okay. Dr. Shivani, please start your screen sharing.
Yes, I started, sir.
It's not yet seen.
So there is some issue.
Okay. So, in that case, Dr. Fareen?
So is my screen visible now?
No, not yet.
Hello, sir. I am audible. Am I audible?
Yes, you are.
Good
Can you
morning,
please
good morning,
try your screen sharing?
Okay, sir.
Since you have come right now, which you were your first talk, so we're going to give you 2 talks back to back. Correct? You've got 2 talks, right?
Yeah, okay.
Yeah. Okay, so start your screen sharing. Let's see if it's working. Dr. Shivani, we'll come back to you.
Sir, I have that one paper only. It got sent 2 times. So I
Acha.
have the same paper only.
Wonderful. But still आपको time तो सिर्फ 6 मिनट ही मिलेंगे.
Yeah, sure, sir.
ठीक है. So आप please screen sharing चालू कीजिए. Can you please try and do that?
Okay, sir.
Dr. Shivani, in the meanwhile, I would suggest restart the system, log back in, and we'll try and figure it out.
Yes, sir.
Dr. Fareen, please start your screen sharing.
Okay, sir.
The others, I kindly request to start the screen sharing as soon as possible because that's how we save time. Dr. Fareen, we are running out of time.
Yeah, sir. I'm trying, but it's not happening.
Is there some issue?
Nikhil,
Yes.
is it some issue from our end?
No, not at all, sir, because screen share is starting and stopping. I just tried to do that. And no, sir, it's no issue from our end.
We'll go on to the next speaker then.
Yeah.
But Dr. Yusra Asad is not there. Dr. Apurvi Batra.
Dr. Apurvi, could you please start your screen sharing?
Yes, sir.
Oh, I have to do it without.
You understood now. Fareen has understood her problem, but we'll have to come back to you, Fareen.
Okay.
But just try, anybody's screen which goes in, it's like a lottery now. जिसका भी screen आ गया वो चालू कर सकते हैं.
Sir, am I audible? Prakriti?
Yes, Dr. Prakriti, you're audible.
Yeah. So can you see me?
Yes, we can see your screen as well.
Okay.
Yes. Your 6 minutes starts now.
Yes, sir. Sir, good morning, sir. Myself, Dr. Prakriti Singh. I am presenting a clinical finding of central retinal artery occlusion in mucormycosis in post-COVID-19. I wanted to say the authors have no financial interest in the subject matter of this presentation. Introduction. Mucormycosis, previously called zygomycosis, is a rare but serious angioinvasive infection caused by a group of fungi called mucormycosis.
See your slides. I mean, I can't see them very clearly. Sorry.
You can't see them clearly, sir.
This is coming like a.
Are they PDF?
They're looking like a PDF format.
Yes,
I think
sir.
she's sharing it with a mobile phone. Do one
Yeah.
thing, tilt your mobile phone to a landscape mode.
Okay, sir. I'll do it, sir.
It should immediately reflect it. Stop your screen sharing and restart it.
Yeah.
Okay.
Yeah.
Much better.
Now I'll do it
Yes,
again.
you can continue with the same, the place where you left out, ma'am. Go ahead.
Okay, sir. Now you can see, sir.
Yeah. Much clear. Much better.
You can go to the slide where you left out.
Okay. So it is caused by mucormycosis is a rare but serious angioinvasive infection caused by a group of fungi called Mucormycosis species. Spores of these fungi could be found in soil, fallen leaves, compost, animal dung, air, and can be inhaled and then infect the lungs, sinuses, and extend into the brain and eyes. Less often, infection may develop when the spores enter the body through a cut or an open wound. Mucormycosis is not a contagious disease. It means that it cannot spread from one person to another. Mucormycosis mainly affects people who are immunocompromised or patients already infected with other diseases. High risk include people with diabetes, solid organ transplantation, neutropenia, that is low neutrophil count, long-term systemic corticosteroid use, iron overload. The high risk for people living with HIV and those using immunomodulating drugs, including the antifungal also, that is voriconazole in some high-risk group. So in COVID-19, we saw that there was irrational use of corticosteroids, which may be one more causes for mucormycosis in post-COVID-19 patients. Clinical presentation is classified according to the organ involvement. It can be rhino-orbital, cerebral, pulmonary, cutaneous, gastrointestinal, or disseminated. This classification is given by WHO. Mucormycosis is aggressive and life-threatening infection requiring prompt diagnosis and early treatment. Treatment usually consists of antifungal medications and surgery. Now, COVID-19 associated mucormycosis. Fungal infections, including mucormycosis and aspergillosis or invasive candidiasis, have been reported in patients with severe COVID-19, or those recovering from the disease have been associated with severe illness and death. India reported a surge in mucormycosis case, and prevention of COVID-19 associated mucormycosis needs to focus on aiming for better glycemic control in COVID-19 patients and monitoring the use of systemic corticosteroids in treating severe cases. The disease burden globally is 0.005 to 1.7 per million population, but in India, the prevalence is 80 times higher than the prevalence which is found in developed countries, that is 140 per million population. And due to the constant rise of mucormycosis case in second wave of COVID-19, India made mucormycosis a notifiable disease in May 2021, and so does Karnataka, the state from where I am doing my PG, had made it a notifiable disease. The aim of the study will provide insight into the disease burden, population characteristics it involves, and risk factors. It evaluates clinical spectrum of the disease and outcome of these patients. Materials and method, we have it's a case report, and it was a case report, and we have included only post-COVID status patient and design. It's a retrospective case report, and patient visited Department of Ophthalmology of B.R. Ambedkar Medical College and Hospital. Inclusion criteria was just patient with post-COVID status, and exclusion criteria was any solo history of immunocompromised state which lead to mucormycosis apart from COVID-19. Now the case report, a 50-year-old female patient was referred to our OPD with severe vision loss, that is for 5 days, and she was noted with drooping of left eyelid associated significantly decreased ocular mobility. It was also associated with intermittent headache, facial pain, and left side nasal blockage. She was diagnosed with central retinal artery occlusion in the left eye by a local ophthalmologist and referred to us for further management. She was conscious, oriented, and afebrile at the time of presentation, and BCVA in the right eye was 6/6, and there was no light perception in the left eye. Ophthalmological examination revealed complete ptosis, total ophthalmoplegia in left eye, and impairment of cranial nerves 3rd, 4th, and 6th. She had left infraorbital hypoesthesia also. Anterior segment examination showed dilated fixed pupil in the left eye, and fundus examination of the left eye revealed generalized retinal edema, retinal arterial attenuation, and presence of cherry red spot at the posterior pole, suggesting CRAO of the left eye, whereas fundoscopy of the right eye was unremarkable. Current medical history at that time revealed poor control of type 2 diabetes, and her random blood sugar level at that
1
time
minute
was,
left.
sorry, okay, was 498. This is the fundus picture which we got it on the first visit, which shows retinal edema and retinal arterial attenuation. Okay. Then we had MRI of the brain, which shows that enhancing soft tissue in the left ethmoid sinus. Okay. And we can find conglomerate abscess was seen in the left frontal region also. Coming to the patient showed a dramatic clinical response with improvement in his diabetes. She had completed intravenous liposomal amphotericin B and discharged well after 10 weeks of hospitalization. Last control visit revealed that his left eye remained blind with complete ptosis and total ophthalmoplegia. Fundus examination of the last visit revealed optic atrophy, generalized retinal arterial attenuation, and retinal atrophy at the macula, which was confirmed by the OCT also. This picture shows fundus picture of the last visit. So the main aim for finding for this clinical finding was generally mucormycosis never presents with CRAO as the first presenting symptom, but in my case, this was the first presenting symptom. Our patient presented with an intermittent headache, facial pain, left-sided nasal blockage, complete ptosis with ophthalmoplegia, CRAO, cavernous sinus.
I'm sorry, ma'am, but the time is up.
Okay.
I think it's a good case presentation, and my first thoughts are that because your patient presented with cavernous sinus thrombosis, so in a case of mucormycosis, the patient presents with cavernous sinus thrombosis, there is a high chance that the angioinvasive fungus actually obstructs the central retinal artery, causing CRAO. So it is primarily the CRAO which is caused due to mucormycosis, which is well reported in literature. Also, the presence of COVID-19 predisposes the patient in various cases due to mucormycosis that has caused CRAO. So it is primarily the mucor that has caused the CRAO, not the COVID, sir. Over to you, sir.
I agree, Divya, and it's a interesting point to be emphasized for other ophthalmologists. We have had this is what is described as red herring in mucormycosis, wherein CRAO has been reported without even ophthalmoplegia, without even ptosis. Though in your case, other signs of cavernous sinus were there.
But sir, initially the patient was diagnosed with CRAO. So being an ophthalmologist, we have to take an account that it could be a post-COVID-19 mucormycosis also, sir.
That's right. Point well taken, Prakriti. Thank you.
Thank you, sir.
Dr. Shivani, we can see your screen, but it's coming blank as of now. You just have to wait.
So can I leave for my other presentations?
Sure, ma'am.
It's seen, Dr. Shivani, it's seen. You can get started. Just unmute yourself, please.
Yes, sir. Good morning, everyone. The topic of my presentation is a study of retinal nerve fiber layer thickness in chronic kidney disease patients. Okay. So, introduction, chronic kidney disease is a metabolic disorder affecting kidney structures and function. Several ocular changes have been reported in patients of CKD, such as decrease in tear output, deposition of calcium in conjunctiva and cornea, superior limbic keratoconjunctivitis, band-shaped keratopathy, fluctuation in IOP, osmotic cataract, punctate cataract secondary to hypocalcemia, and optic neuropathy. Optic coherence tonometry uses a low coherence interferometry, and it has the ability to detect any change in the retinal nerve fiber layer thickness. So ischemia in CKD patients affects retinal microvasculature, which results in decrease in RNFL thickness. The thickness of RNFL varies at various stages of neuropathy. Variation in RNFL thickness is strongly correlated with visual defects. Decrease in RNFL thickness may be suggestive of early changes of optic neuropathy. Aim of our study was to study the retinal nerve fiber layer thickness in chronic kidney disease patients and to compare it with the normal healthy individuals of same age group, and also to correlate RNFL thickness in CKD patients with and without hemodialysis, and also to correlate RNFL thickness with the duration of CKD. The selection criteria, we included patients aged more than 18 years who had CKD, and these patients were included in group A, while the healthy population for the age match was included in group B. The proposed study was conducted over the period of 12 months. It was an observational study, and we studied minimum 150 eyes for each group. We excluded any ocular pathology which caused reduced vision, like glaucoma, ARMD, arterial occlusion or venous occlusion, diabetic retinopathy, vitreous hemorrhage, etc. History of any ocular surgery or laser surgery, poor media clarity, uncooperative patients, and patients not giving consent. Detailed history and examination included visual acuity examination, IOP measurement, anterior segment examination, dilated fundus examination, and RNFL thickness measurement with the help of OCT. So talking about the results, total of 150 subjects, that is 300 eyes, were enrolled in our study. 75 subjects who had CKD were included in group A, while rest 75 subjects who did not have CKD were included in group B. Mean age was almost same in both the groups, which was around 47 years. Out of these 75 patients, 23 were females and 52 were males. Majority of the CKD patients were on hemodialysis. Then comparison of mean of average RNFL thickness was done between group A and B, and we found that the RNFL thickness was thinner in group A as compared to group B. Comparison was also done in all the four quadrants, and statistically significant thinning was noted in superior and inferior quadrant of group A. On comparing RNFL thickness between the hemodialysis and non-hemodialysis group, we found that statistically significant increase in thickness was seen in the hemodialysis group. And with the stage of CKD, we found that RNFL thickness was thinnest in CKD stage 5, followed by stage 4 and stage 3 in the descending order. Yet there was no statistically significant variance noted. So, concluding, the mean of average RNFL thickness was statistically significant, thinner in CKD patients as compared to non-CKD patients. Statistically significant thinning of mean of average RNFL thickness was noted in superior and inferior quadrant in CKD patients. A statistically significant RNFL thinning was noted in nasal quadrant with advancing stage of CKD. A statistically significant thinning of average mean RNFL was noted in hemodialysis group as compared to non-hemodialysis group, and a negative correlation was seen when mean average RNFL thickness was compared with the duration of CKD. A similar study was done by Gadela, DNB et al., who compared RNFL thickness in CKD patients and healthy control. And in his study, he found a statistically significant thinning overall and in superior nasal and inferior quadrant, but there was no significant change in the temporal quadrant. Demir et al. Also conducted a similar study, and the statistically significant thinning was seen in the CKD patients in all the 4 quadrants as compared to the normal subject. The limitation of my study was it was a cross-sectional study, therefore comparison of RNFL thickness pre and post hemodialysis could not be assessed. Other limitations were interpersonal variability while taking OCD reading and small sample size. These are my references. Thank you.
Shivangi, can you, for my understanding, explain the understanding of why do you want to do a RNFL thickness in CKD patient?
It is said that it is an early indicator of optic neuropathy, and it can be diagnosed even before the visual field changes occur. So, if we do RNFL thickness, if we do analyze via OCT, and if we see a thinning, then it is an early indicator of optic neuropathy changes.
One thing more, in your study, have you found any relationship between RNFL thickness in various diseases, like stages of CKD, like in which stages it is most affected and in which stage it is least affected?
Yes, I have mentioned in my study, as the stage increased, as there was increased stage, like in stage 5, there was more thinning as compared to the early stages of CKD.
So, like in literature, it is said that generally stage 3 CKD onwards only the changes will appear. Before that, it is of no use.
Yes, actually, my patients were all admitted patients. So mostly, what I took was stage 3 and above. So there were only 2 patients who were stage 1 and 2.
So, Shivangi, one important confounder here which I perceive is going to be hypertension control. All these patients are bound to be hypertensives, and I mean, how good has been the hypertension control for such patients would may turn out to be an important confounder when we correlate directly with CKD.
Sure.
So, somewhere in your study, you should try and see if hypertension control can be also mapped out with it, and see whether the patients who are better controlled on hypertensive versus non-hypertensive,
Yes.
or those with not a good control does carry a significant change.
You can also study the choroidal structural changes like choroidal volume also. So they can also help in you in correlating with the RNFL loss. And you can always do the macular OCT to analyze inner retinal layer thicknesses like ganglion cell layer and inner plexiform layer, so that these can be additional markers to support your diagnosis.
Yes.
A good study. Yeah.
Thank you.
Can we move to the next?
Yes, I believe we have Dr. Reema. Could you start your screen sharing? Oh, Apurvi has started. Dr. Reema will go after Apurvi. Apurvi, could you please unmute yourself? Put this in the presentation mode. Yeah.
Good morning, I'm Dr. Apurvi Batra. I'm going to be presenting to study the comparison between self-resolution and laser therapy and in central serous retinopathy in patients presenting to a tertiary care center. Central serous retinopathy, also known as central serous choroidopathy or central serous chorioretinopathy, is one of the several chorioretinal disorders characterized by serous detachment of the neurosensory retina and or the retinal pigment epithelium. CSE is one of the 10 most common diseases of the posterior segment of the eye with the usual self-limiting course, is known to present as persistent or recurrent form and a frequent cause of mild to moderate visual impairment. There are 2 common types of CSE. The more common type, typical or classic, is seen in younger patients and causes acute localized detachment of the retina with mild to moderate loss of visual acuity. The second variant, called as diffuse retinal pigment epitheliopathy or chronic CSE, is common in CSE associated with chronic steroid usage. The third, less common form of CSE usually causes bullous retinal detachment located inferiorly. A retrospective comparative study was done at a tertiary eye care center for 60 patients in the age group of 20 to 50 years, presenting with complaints of diminution of vision, black spot in the field of vision, or distorted vision, were evaluated for uncorrected and best corrected visual acuity and a detailed ophthalmic assessment was done. The posterior segment examination included Amsler grid charting, direct ophthalmoscopy, and indirect ophthalmoscopy with a plus diopter 20 diopter lens, slit lamp biomicroscopy using a 90 diopter lens, and fundus fluorescent angiography and a spectral domain optical coherence tomography scans of the retina. We included patients in the age group of 20 to 50 years, patients who were fit for undergoing a fundus fluorescent angiography, fundus evaluation showing neurosensory detachment at macula suggestive of CSR. We excluded the patients whose age was above 50 years. They presented with atypical CSR or patients with abnormal creatinine and having a history of drug allergy, which is a contraindication for FFA. In our study, we concluded that 68 eyes of 60 patients diagnosed with CSR, amongst which 54, that is 90%, were males, and 6, that is 10%, were females with a male preponderance. 54, that is 79.4% eyes presented with complaint of diminution of vision, 20, that is 29.4%, with black spots in the field of vision, and 16, that is 23.5%, with distorted vision. 32 eyes, that is 47%, had best corrected visual acuity between 6.6 to 6.12. 21%, that is 21 or 31% eyes, had the best corrected visual acuity between 6.18 to 6.24, and 15 eyes, that is 22%, had 6.36 to 6.60. On FFA, 60 patients, of the 60 patients, hyperfluorescence with ink blot pattern was seen in 46 eyes, that is 68%. Smokestack pattern was seen in 15 eyes, that is 22%, and diffuse leakage was seen in 7 eyes. Based on the presence of leakage on FFA, patients in a study were treated conservatively or by laser photocoagulation, respectively, and followed up to 3 months to check for anatomical and visual impairment. 28 out of the 30, that is 93.33% patients treated with laser photocoagulation improved visual acuity considerably with fundus findings of resolving subretinal fluid, while 22 out of the 30 patients treated conservatively improved their visual acuity and resolving subretinal fluid after 3 months. So out of the 35 eyes showing initial best corrected visual acuity ranging from 6.6 to 6.60 and treated conservatively, 26 eyes showed improvement in the best corrected visual acuity post-treatment ranging from 6.6 to 6.36 and resorption of subretinal fluid. Out of the 33 eyes showing initial best corrected visual acuity ranging from 6.6 to 6.60 and treated with laser, 31 eyes showed improvement ranging from 6.6 to 6.80. Laser photocoagulation shortened the course of the disease by inducing rapid remission of subretinal fluid. However, in our study, one patient showed bilateral recurrence of CSR despite treatment with laser photocoagulation bilaterally. On repeating FFA, a new leakage point was found away from the previous site of leakage treated by laser. We can conclude that CSR affects young to middle-aged individuals between 20 to 50 years of age, usually showing a male preponderance. FFA findings shows a ink blot pattern of leakage, more commonly in almost 2/3 of the cases. Most patients affected with CSR present with an initial best corrected visual acuity ranging from 6.6 to 6.60. Most patients of CSR treated conservatively resolved spontaneously within 3 to 4 months, with the visual acuity returning to 6.6 to 6.36. Laser photocoagulation of the leaking spot in CSR increases the resorption of subretinal fluid and thereby shortens the course of the disease of the treated patients with best corrected visual acuity, returning to 6.6 to 6.18 in 93.33% of the affected eyes. However, it does not decrease the chances of recurrence. Thank you.
Thank you, Purvi. First a question and then a few comments. What was the duration of waiting time between presentation and you considering for a treatment? Or did you take up the patient the moment he presented to you?
Sir, in patients who required early resolution of good vision, we took them up for treatment as soon as they presented to us.
Okay. So there was not any, those patients who were in treatment arm did not have a conservative initial period.
No, sir.
Okay. Now there are two big problems with this study, which I would like to highlight. One, there is a big bias involved. You realize this that you did not randomize your patient into the two groups. Based on your FFA, you took a decision कि ये treatment करना है या ये conservative पे डालना. So if I look at it that way, all the patients which did not have a clear-cut leak would have gone into the conservative arm, right? And the patients who do not have a definitive leak or have more RP damage, and that's why you cannot pick up a definitive leak, are the patients who will tend to do more worse in visual acuity. So by not randomizing and picking and choosing based on your angiography, you have automatically made the conservative arm a little worse compared to the treatment arm. Okay, so it brings in
Yes.
a big bias there in this study. And a second comment, whenever you're trying to present visual acuities for studies, it will be better instead of talking about ranges, you talk also about mean and the spread. Because with this kind of a range 66 to 660, 66 to 636, you really do not come to know about the change in the outcomes. Okay,
Yes, sir.
Dr. David.
How long was your follow-up?
So 3 months of follow.
So in 3 months, like sir has already said, in cases of acute CSC, we just observe for 3 months, and most of them, 90% of them, resolve. So it's a large bias there, because generally we prefer laser for patients who have non-resolving CSC or extrafoveal leaks. If after at least 6 weeks, or we wait for 3 months, if they are not improving, then we do laser. So it's not, the study design is not up to that mark, but yes, you can just improve on that. Thank you.
Yes, sir. Thank you, sir.
Thank you. Can
Dr. Rima, could you start your screen sharing? Put it in the presentation mode.
Yes, sir. Good morning, everyone. Myself, Dr. Rima. I'll be presenting on demography and clinical characteristics and visual outcomes of patients with intraocular foreign bodies presented in a tertiary care center. So intraocular foreign bodies are a major cause of ocular trauma, resulting in legal blindness. Visual prognosis depends on the zone of injury, type, size of foreign body, and subsequent complications. Longer the foreign bodies stay in the eye, greater damage they make. So these make IOFBs one of the leading cause of monoocular blindness.
Can you go to the full screen mode, please?
Yes.
Yeah.
So purpose of my study was to determine the demographic characteristics of intraocular foreign bodies patients presented to the tertiary care center and the visual outcome depending on the time of presentation, location of the foreign body, and the type of foreign body. Study was carried out at MNJ Institute of Ophthalmology, Ahmedabad from October 2020 to June 2021. A prospective case study of 15 consecutive patients of foreign bodies presented at our tertiary care center was conducted. Patients were examined, detailed history noted, and were recalled for comprehensive examinations. Following variables were recorded for study purpose: age, gender, cause of trauma, occupation, complications, best corrected visual acuity, type of foreign body, consequences of the retained foreign body, and the time interval since the injury. Slit lamp fundus, sonography, foreign body localization based on orbital CT scan were done respectively. All these patients underwent surgical removal of foreign body, and the final visual acuity at 6-month follow-up visit were noted. So out of 15 patients, 54% of cases had foreign bodies located in the posterior segment. These patients underwent pars plana vitrectomy followed by removal of foreign body respectively. 40% cases had foreign bodies in the anterior segment, including cornea, iris, lens. These foreign bodies were removed followed by anterior chamber formation and primary wound closure. 26% of the cases were presented with traumatic cataract as secondary complications. So these were managed combined with phacoemulsification, pars plana vitrectomy, foreign body removal with primary IOL implantation. And 6% had impacted foreign bodies in the sclera. So these patients underwent careful removal of foreign body followed by suturing under minimal manipulation. Following results were interpreted based on the parameters. So out of all patients presented in the age criteria, 53.4% were in the age group from 20 to 40 years of age, which include the young to middle-aged people. 80% of the cases were of males. 60% had metallic foreign bodies, followed by stone, vegetative matter, and other. Most of the people had affected eye in the left side. Among the causes, in our study, most victims were those working in the field or exposed to the environment or the workplace. Therefore, in majority of the cases, hammering stone at workplace was a commonest, accounting 46 to 47%. Labor was the commonest occupation seen in among 60% of the cases. Common secondary complications that were observed were traumatic cataract seen in 26.1%, followed by vitreous hemorrhage, hyphema, iridocyclodialysis, lens subluxation, retinal detachment, and endophthalmitis. In 60% of cases, foreign bodies were located in the posterior segment, followed by anterior segment. In majority of the cases, 53.4% of the cases were presented within the 24 hours of injury. So these patients had relatively better visual outcome. In the visual acuity criteria, average final visual acuity was perception of light, which were positive in 46% cases, followed by counting finger or better vision in 40%, and no perception of light was seen in 13.3% cases at 6 monthly follow-up. So patients with intraocular foreign body usually had poor prognosis. Intraocular foreign body can cause direct mechanical damage along their path, but they can also dissociate and cause additional intraocular damage. Additionally, foreign bodies, they carry a large number of pathogens or its own toxicity and may cause damage to the eye. Compared with the anterior foreign bodies and posterior foreign bodies were more likely to give worse visual acuity. So this is probably because the foreign bodies were able to reach the posterior segment, often carry more energy, thereby more damage. So intraocular foreign bodies located in the vitreous always tend to be accompanied by retinal lesions and breaks. So these foreign bodies are usually of smaller size, sharper shape, and less resistance. Final visual outcome in these patients were dependent on many factors. Earlier the presentation, so earlier was the management given and better were the prognosis. Visual outcome of these patients were also dependent on secondary complications and the timely management. Also, we concluded none of them were wearing glasses or protective goggles at the time of injury. Therefore, eye protection should be enhanced for people at work, and there should be implementation of safety measures and education at the workplace. Thank you.
Thank you, Dr. Rima. Good demographic of foreign bodies. I mean, there are quite a few facts which we see intuitively and which are studied nicely points out. Yeah. Divya, you want to add anything?
So one more suggestion: whenever you are presenting like factors which are responsible or the predictors, so always try to present it more specifically, like earlier the time, so exact time duration or the median time duration, and the test of significance should also be placed along that, so it increases the value of your presentation.
Okay.
We go on to the next presentation.
We don't have anybody else. Dr. Farheen lost contact. Dr. Yusra did not show up. Dr. Ankur, no show. And Dr. Kirandeep also a no show.
I think Dr. Fareen had 2 papers to present.
No, so she clarified. If you look at the subject also, it is the same. By mistake. So
What to do?
So now I think we can conclude the session by, and as a matter of fact, if you look at it, the time given to everybody was 7:30. So it's already 8:36. So in case if they have not even shown up even once, we can't take it. Dr. Farheen did call one of our technicians from the Grover AV team, and she says, I'm having technical difficulties. I will not be able to present now. That's for sure. She was asking us if she could present in the next session, which I believe it's not going to be
I
possible.
got a message from Dr. Yusra that she is down with some illness, so she is also not able to.
Okay, so I believe then we can conclude this session, sir, and we'll just wait for the main session to get started.
Thank you, Nikhil. Thank you, Dr. Divya.
Thank you, sir.
Thank you.
Everyone.
Again, thank you all the presenters for being on time. We really appreciate it. Apologies for the others who did not join in, and we could have given you more time, but we were expecting them to come and show up at the last minute. Thank you so much. Thank you so much, judges. Thank you.
Thank you.
Good morning. Can I just try and make sure my presentation is working? Are my videos visible?
Yes, sir. Your screen is visible.
Okay. Thank you.
Your network bandwidth is low, sir.
I'll just try again. I just showed.
Good morning, sir.
Good morning. Good morning.
We still have 13 minutes.
Yeah. So just wanted to make sure whether the video is actually playing or
Yes,
not.
please.
It's running, right? You guys.
Yes, we can see it.
Thank you so much.
Does that video also have audio?
No audio in any of the videos.
Oh. If there is audio while sharing it, you just have to select the audio option as well.
Okay. Yes, correct.
Dr. Kirandeep,
Yes, sir. Good morning, sir.
you have come for your free paper presentation.
Yes, sir. Actually, I was having presentation in another hall, so I got late,
You
sir.
could have just let us know because the other speakers were not there. We concluded that session.
Oh, okay, sir.
So I'm sorry, but
Okay.
we will not be able to go ahead with that.
Okay, sure,
So
sir.
just thought of at least, but अगर आप बता तो देते कि आप आ रहे हो, just log in once, write a message to everybody that I will be back
Okay. Sorry.
because your talk was the last one.
Yeah, sir. Actually, in one more session, it was the last one, so that is why, like, I had 3 presentations in the same time period. That's why, sir.
You would have just or used, this is virtual, so you can have one on mobile, one on your laptop. One on your friends.
Sorry, sir. Okay, no
No
problem.
problem. But we had to conclude because we concluded at something around 8:36.
Oh, okay.
So
No
because there
problem.
were Fareen was not there, the other speakers were also not there.
Okay, okay. No problem.
All
Thank
right.
you.
Take
Thank you.
care. Bye bye.
Thank you. Bye.
Hello.
Hello,
Hello.
sir. You're audible.
Yeah. Can you hear me?
Yes, sir. Loud and clear.
Yeah. Mine is the first talk. Should I try my?
Yes, please.
Let me share the screen first. Can you see the screen?
Yeah, we can see the summary. Yeah, perfect, sir. Wonderful.
Let me see whether my video is on. Is it
It's
on?
visible, working. Wonderful.
I think it's
Yes, sir.
so.
We shall be getting started in the next 7 minutes.
Yeah.
We try to keep it early and just 1 or 2 minutes before time.
Absolutely.
And the total time allotted is 7 minutes each talk.
Yeah.
We're going to have the discussions right at the end of all the 13 talks.
Okay. So, but I would not be available then. So no
Oh.
issues. No issues. No issues.
Okay.
No issues. Because I have some preoccupations.
I understand. I understand. But it's my duty to inform you accordingly.
Thank you.
Good morning, sir.
Good morning, Shailji. How are you doing?
Yes, sir. All well, all well. So how are things there back?
I'm not
Not-
sure whether it's lull before the storm.
Hope not, sir. Hope not.
But you know, the worst part of the whole story is that every second person
Sir.
or third person is having cough, is having fever,
Yes, sir. Yes, sir.
and nobody is getting it checked.
Correct, sir.
I don't know whether it's the change of season or that.
I think same here, sir, because of this constant few days monsoon, few days back to heat, monsoon heat, chal raha hai, to same here, sir.
Absolutely, absolutely. And people have gone berserk, you know. Nobody's.
Yes, yes. People now have said कि अब enough is enough. जो होना है हो जाएगा ऐसा ही है sir. Absolutely.
How's sir?
All good, sir. All good. Absolutely. Here also things are all. I mean, it's almost impossible to say that there is something like still COVID or anything like that. And particularly from next week we have Navratri Garba.
Oh my God.
So this time they have, last year it was complete ban. This time they have allowed partial relaxation, which means, you know, on paper partial, but otherwise it will be full fledged.
I know. I can understand. I can understand.
Yeah.
How has been the physical attendance in DOS? Any idea?
No, not really, sir. But I believe they had a cap of 500 participants or people there, including the AV and the event team.
Okay.
So we do not have an idea on that, but I'm aware of two things. Number one, there was a physical conference which took place in Pune for gynecologists, and which went well with a cap of 200 doctors. I was there. I was a part of it, so yeah, I know that.
Okay.
Physical conferences are going in well, and it's all about the permissions now.
Yeah. Good. Good. Let's see. Because the next rather a fortnight or so, or maybe a month is going to unfold, or you know how things are going to be.
Absolutely right, sir. Hopefully it all goes well.
Yes.
Nonetheless, I am from Pune. I guess, sir, you're from the south?
My physique makes me appear as if I'm from south, but I'm right from the northwest.
Oh, wow. Okay.
Good morning, Dr. Rohit.
Good morning, sir. Kya haal hai ji? How are you doing?
Good morning, Dr. Vasavada.
Good morning, sir. Good morning, sir. So good to see physical.
Absolutely, absolutely.
So we shall be getting started in the next 2 minutes. We are going to have Dr. Rohit Om Prakash sir presenting first, followed by Dr. Dr. Vasavada. And after that, as people come, we will let everybody know. But these are the two speakers, so we shall start on time.
Absolutely. So how has been the physical attendance?
Sir, it is basically we wanted to hold it, and we were granted permission for a limited number of participants. So it is okay because we staggered it over a week.
Yeah, I know, absolutely. Absolutely, sir. But I think this was the first one, people have some hesitations.
This was the actually, I think, first conference which has been granted permission.
Absolutely, absolutely.
So in this case, we could say you're the pioneer, sir, and I hope everybody else also gets the permission now.
Yeah, absolutely.
Yeah.
Dr. Subhash, I'm the co-chairman, but I have to leave. So after my talk, I would be leaving because I have.
Okay, sir. Sir, I am here only just to welcome you and then hand over to the chairman, co-chairman, and moderators.
Dr. Namrata is here.
Namrata has joined.
Yeah.
So, Dr. Namrata ma'am.
Yeah, hi.
So, Dr. Rohit and Dr. Vasavada has joined.
Thank you so much. Thank you so much, Dr. Rohit Om Prakash and Dr. Shell both for joining in. And like you were discussing, I think this is the first medical conference that has got a permission on this large scale, and that too in a very short duration of time. We have to thank Dr. Subhash Dadia for that. Otherwise, till the last day, we were not sure whether we will be allowed to do it in Ashoka or not.
Dr. Subhash, he is full of, whatever absolutely. I think hats off to him, as always.
So, so at least I realized that doing a hybrid is more difficult than doing a virtual or physical. And at least the only thing is that it has started some semblance of a physical gathering. So we had about 400 people in the dinner. And we had yesterday live surgery hall was quite full, which was heartening. And the other sessions also, people have joined virtually, but there were people who came from Lucknow, then Banaras, from Meerut. So even we had people from Pondicherry and from, Trichy. So it was a mixed kind of a crowd, but at least they are learning to, come back to a physical format.
Absolutely.
And thank you so much, Dr. Rohit Om Prakash, for your oration for DOS, which you so generously have,
Then please, it's a privilege.
So we will be doing, like I said, discussed with Dr. Subhash also. We will be doing after 2 to 3 weeks another ceremony, which will be the taking over and handing over. And that we'll have only the orations followed by presentations of the orations.
Great.
Thank you so
much. I've already conveyed it to Dr. Burato.
Okay. Thank you so much. Thank you.
So, basically after formally welcoming them, we can start the session.
Yeah.
So, very good morning to one and all, and welcome to plenary session. And I hand over to Dr. Rohit Om Prakash to start the session.
Thank you, Dr. Subhash, for the privilege of getting the ball rolling on the final day in Hall A. So I have been assigned by Dr. Namrata to speak on. Can I share my screen?
Yes, please.
Yeah, just
Rohit, can I have 1 minute, Rohit, if you don't mind? Good morning.
Yeah, sir.
No, I just want to, because there was a problem in sharing my screen yesterday.
Yeah.
Can I just share my screen and then after that you can do that, because otherwise I'll sort it out.
Yeah, why not? Please, if Dr.
Yeah,
Namrata,
can you
is it
just
okay?
stop sharing? I'll just, if you don't mind, I'll take only half a minute.
Yeah, sure. So I'll stop.
Welcome, Dr. Mohan Rajan.
So I'm not able to share my screen again. Same problem.
Again,
is
the
there.
whiteboard. I don't know what is this. Anyway, I will just sort this out.
Namrata, the same problem, Namrata.
Yeah.
Yeah. I don't know
Uh,
what.
Dr. Rohit, you can start your screen sharing again, please.
Thank you. Thank you very much. So,
Yes.
is the screen visible and am I
Yes.
adequately audible?
Yes, sir. Yes, sir. Please go ahead. Your timer is going to be started now.
Yeah, I would like to thank Dr. Namrata and Dr. Subhash for the privilege of speaking on the talk, Capsulorhexis Challenges in Calcified Subcapsular Plaques. So there are quite a few challenges. The management is difficult with plaques in subcapsular calcified plaques because these plaques cause difficult completion and can cause capsular extension. So what is the basic plan? First, once you have identified that there's a plaque, we have to realize that the plaque is adherent to the anterior capsule in the paracentral or mid-peripheral area. So the plan is to create a small rhexis anteriorly and centrally within the plaque, which is a relatively non-adherent area. And once that capsulorhexis has been done, the central capsulorhexis, the subcapsular plaque is separated and it is removed and the rhexis is enlarged. So this is the first case which I did. So there were quite a few hiccups which I would like to take you through. So after, anterior capsular staining, the initiation was done with the cystitome, and the plan was to create a rhexis, a small rhexis for that matter, central to the adhesion of the plaque to the anterior capsule. You can see how easily, when I'm central to the plaque, I can create a small rhexis for that matter. So this small rhexis is possible only when you are central to the plaque. Once the central rhexis has been completed, as you would see now, I used a round spatula since this was the first case, which I should not have. So round spatula should not be used. Then I thought I'll use a cystitome to separate it, which I was able to do. I had not separated 360 degrees. So this was my first venture. I would show that even without separation, I had to do it very slow to remove the plaque to separate the plaque from the anterior capsule. So I was doing two steps concurrently. I was separating and removing, which should have been done in two steps. So I'm using different ports to my advantage to separate the plaque from the anterior capsule. You can see how I have been able to do it 50%, and this part, this would remain, not fully separated, and I'm trying to remove that, and you can see how, I'm having difficulty because this was the first case. I'll show in the second case where I was mature, where I was experienced. You can see how the plaque is now in the last step of being removed. So this part of the plaque has been left behind. So I'll show you in the next video how I managed to remove the plaque. So this is a patient with a small pupil and with a subcapsular calcified plaque. After doing the routine, pupillary dilatation, a central capsulorhexis has been initiated. The best area should have been this, where I should have started. So nevertheless, that was still the second case. So I continued and I was able to separate to create a small rhexis right in the center. Now I was wiser. I used a flat spatula for that matter, used this port from this side, and I'm being very cautious, I'm being very slow, taking my time to separate. So you can see how I am separating the plaque from the anterior capsule. This would not have been possible with flax because separation would have to be done. Here you can see I'm still continuing and I'm removing separating the plaque from the anterior capsule. I should have created another, what should I say, side port here and separated all this plaque which was there. Now I am removing it. You will find that it is easier to remove it. So once that has been removed, so I am now enlarging the rhexis, creating the rhexis is now being enlarged. Trypan blue staining could have been done now again so that the whole anterior capsular rhexis visualization would have been done. Nevertheless, I continued and completed the rhexis. This was a brown leathery cataract. I'm using a pointed tipped chopper for that matter, and doing rotating it easily because these white cataracts don't have any problem with rotation, so you need not do any hydrodissection. So I'm just continuing with the process of separating. The separation is being done. So this is the routine stuff which is being done. So which would have been done in any of the brown in white cataracts. So I'm just trying to forward it. I'll forward it because these steps. So once separation was done, the capsular rhexis is completed. So in summary, the plan, you have to plan the management. Initiate right in the center, not the way I did it. Create a small rhexis, flat spatula separation from all, totally separate from 360 degrees. Plaque is removed, enlarge the rhexis, and complete the case. Thank you very much for your kind attention.
Thank you so much, Dr. Rohit Om Prakash. Thank you for an excellent presentation. Are there any questions from the other panelists? We welcome Dr. J.S. Tityal sir, who's the chairman of this session. Welcome, sir, and good morning.
Yeah, good morning to all of you. It was a very nice talk, Rohit. As usual, beautiful demonstration of technique. I think the technique you showed for all these difficult capsulotomies and capsular rhexis. I think the tips we have learned from you how to handle these, difficult capsular rhexis cases. Very beautifully demonstrated.
Yeah, thank you, sir. Thank you.
Yeah.
Welcome, Professor Tityal, sir.
Yeah, good morning, Subhash. Good morning, and wonderful work, and many congratulations to your team.
Thank you, sir. Thank you.
Terrific work.
Can I request Dr. Vasavada sir to please start his screen sharing now? To save time, as discussed, Dr. Rohit had to leave for another engagement. So we had the discussion. For the others, a kind request, if all the discussions can take place right at the end, it would be enlightening for all the panelists and the delegates.
No, I think we'll take the discussion in between only.
In between them? Okay,
yeah.
okay, ma'am. Okay, ma'am. As you say. So, Dr. Vasavada, we can see your presentation. You can get started.
Thank you very much to the entire DOS team, Madam Namrata Madam and Subhash sir for this opportunity. I think toric IOLs is not unique. It can be, stayed away from complications. So this is a standard case, and you can notice the focusing is not great. The focusing is on the posterior capsule while doing the capsular rhexis. So somewhere during the joining of the capsular rhexis, certain movements were probably not appropriate. The was not divided very well into small pieces, and you can notice almost the entire nucleus is trying to be prolapsed out to try and emulsify it at the iris plane. some little bit of iris prolapse also. Because it's a relatively soft cataract, this will be managed almost without almost any form of division. And last is coming out. There is definitely in the capsular axis. A large split of the anterior capsular axis around this area. Now, the possible causes joining the focusing was not great. Maybe a nick might be created, or while
We are facing some connectivity issues. We have Dr. Ramamurthy sir. Can we have Dr. Ramamurthy sir to go next?
I think we've lost connection from
Yes.
Dr. Shell.
Yeah, we also have,
No, it's there again.
it's there again. Yes, he's back.
Shell, can you hear us?
We can see your screen, sir. You can go ahead.
Sorry for that. Yeah. And
No,
the
that's-
first step that you need to do is to make sure that you don't allow the chamber to collapse. So inject the dispersive viscoelastic. Once a dispersive viscoelastic is done, unfortunately not much of cortex was remaining, but in this area of open capsule, we need to be very careful. So I've reduced my flow rate. You can use an appropriate vacuum, but reduce your flow rate so that you don't catch anything inadvertently, and be very slow. And this is the place where after occlusion, after you hear the ting sound, only then try to swipe and make sure that you've caught only the cortex and nothing else, no fornix, no equatorial capsule, because you want to try and preserve this tear from extending up to the posterior capsule. So let things happen slowly, but under your vision and under appropriate parameters. And once that is done, again, make sure that the chamber doesn't collapse. Now, the problem here was placement of a toric IOL. And unfortunately, the placement axis was almost exact in the area of the anterior capsular split. So we all know that toric IOL require rotational stability. And for that, we need to make sure that there is a reasonably good capsular axis cover all around. Having had some experience in previous such cases, we decided to go ahead with single piece implantation in the back. And implantation here is key, that we want a slow unfolding. So even if otherwise you are used to injecting under BSS, please use a viscoelastic in this time, because you don't want a sudden jerky opening of the IOL that can again jeopardize. And here, of course, you want to make sure that you don't have to rotate too much after viscoelastic removal. So unfortunately, the Varion is not seen on the microscope, but I'm aligning it to this 112-degree axis almost there, to make sure that after viscoelastic removal, not much of rotation is required. So having done that, in this situation, because there is an open anterior capsule, you don't necessarily need to go behind the IOL, because through this gap, the viscoelastic with a little bit of rock and roll will pop out. And make sure even while you close the eye that you don't allow the chamber to collapse. So hydrate all the wounds except for the irrigation before you pull out your irrigation handpins. And this is the patient now he's completed more than 5 months of follow-up. The IOL is very stable in the same location that we have left, and you can notice this anterior capsule split. So toric IOLs can be considered in cases of select anterior capsular split, and stability is not an issue in the long run. Another case of another capsular compromise. This was a fairly dense cataract with a very small myotic pupil. So we have used iris retractors, and things seems to be going off quite well. The fragments have been well divided into small pieces. This happens quite often in small pupils, that some fragment is stuck behind the iris, and during irrigation aspiration we noticed that after cortex removal there was one chunk of fragment that was left behind. Now ideal would have been to go with the phaco probe and remove this, but I thought let me just remove it with irrigation aspiration since I'm there. And notice here, very soon you'll notice that because of the extreme high vacuum with which I'm trying to remove, I will inadvertently catch the posterior capsule. Notice those folds. So that was the time when the occlusion just got lost and the capsule was caught, and that created a punch in the posterior capsule. So this could have easily been avoided if I had used a phaco probe to emulsify that residual fragment. But now with this situation, again, make sure that you don't allow any vitreous to prolapse. So inject dispersive viscoelastic before taking out your probe. And now was the time to try and manage this sponge opening, because this was also an eye where a toric IOL was being planned. So now I decide to try and convert this into a posterior capsulorhexis. So this is now a cohesive viscoelastic going on. And here the use of micro incision capsulorhexis forceps really helps. So I'm trying to convert this into a fairly decent size posterior capsulorhexis. And once you convert that into a posterior capsulorhexis, it will act like a strong scaffold, and you can even consider in the bag IOL implantation. The only thing that I realized after completing the capsulorhexis that when I'm trying to pull out this flap, it's not coming out easily. So that means there is a tug of vitreous which is attached to this flap. So at this point of time, don't try and pull it out, because that can bring a larger tug of vitreous and cause further problems. So I go through the pars plana and remove the vitreous from the area of the posterior capsulorhexis. And because I have a strong posterior capsulorhexis margin, I go ahead and consider in the bag toric IOL implantation. In the end, of course, make sure that there is no vitreous disturbance. So inject triamcinolone acetonide. And fortunately, there was none. And the IOL was rotated into its proper place. And this is the patient again at 4 to 6 months follow-up. You can see the posterior capsulorhexis and a stable IOL where we had left it. So these are a couple of case scenarios of anterior and posterior capsular compromise, where if you handle them or manage them well, you can still consider in the bag IOL implantation, even of a toric IOL. Thank you so much.
Very good. Very nice presentation, Shail. I mean, I think toric IOLs in difficult situations. Obviously, if you have made a posterior capsulorhexis, the capsular bag is intact, then placing a toric intraocular lens is quite fine. But as in the first situation you showed, where the anterior capsulorhexis margin is not intact, maybe these cases are quite difficult, especially when the orientation axis is along the axis of runoff. And usually it's said that the rotation of the intraocular lens takes place in the first 1 hour. But in these cases, it can happen much later. And you have to make a mental note of it. And I would rather wait for about a couple of months. And just in case there is a residual astigmatism left over, then it's better to handle it on the cornea, doing a laser vision correction rather than trying a re-rotation, because the tendency of the lens would be to go back to the position that was there. In case you're not very experienced with it, and if it's a small cylinder, it's always a good idea to maybe go ahead with a monofocal lens and handle the cylinder on the cornea.
Absolutely.
Very well, nicely presented.
Can I now request our next speaker? We have Dr. Ramamurthy also. We've also got Dr. Suben Bhattacharjee. Can I?
Dr. Suben go.
Yes.
Sure. Thank you, sir.
Dr. Suben, could you
yeah, I'll share my screen.
Yes, please.
Is my screen visible?
Yes, sir. Your screen is going to be just coming live.
Yeah, fine. I just my settings.
Good morning, all.
So just yes, now it is visible. Could you just put it in the presentation mode, sir?
Thank you. So good morning, everybody. I'll be talking about the small pupil lessons that we learned from the BX experience. We gained some insights. Can I continue?
Yes, please.
Yeah. So the small people lessons that we learned from our BX experience, we gained some insights and busted some myths. I'm Suben Bhattacharjee. I have a financial interest in the BX People Expander, and I thank Dr. Deepak Magur for lending his videos. So before the BX, what we had was the iris hooks, the Malyugin ring, and the eye ring. The insights that we gained are: one is that iris can be bent without any harm. It can be reversibly bent. Now, there's a myth that X or Y device works best in IFIS pupil. Well, that's wrong. Iris prolapse depends on the grade of IFIS and not on the device. The IFIS pupil is elastic. We knew that, but we never applied that knowledge. So we need to identify the rigid pupil and stretch it before using any device. The common myths that we busted along the way were there was a popular misconception that square-shaped pupil with 4 hooks or a pupil expander is the most effective. No, that's not true. For hard cataracts, expand or dilate the pupil as much as possible. Use iris hooks as they provide the largest pupil. Sorry, that's not true again. For very small people, use only iris hooks. Not really true. For intraocular myosis, use iris hooks. Again, not true, because with the BHEX, you can always very safely not engage the capsular rhexis margin. And for a shallow anterior chamber, again, use only iris hooks work. Well, that also is not true. We'll prove our point. So the BHEX is a radically different concept. The inventive step is that it's a single plane device, where in a Mulligan ring or an eye ring, the scroll straddles the pupil margin, whereas in the BHEX, the pupil margin straddles the notch. So that the other devices are biplanar devices. This is a single plane device. And the biplanar devices obviously snag the incision, require an injector, and have a thick profile. Whereas with the BHEX, the injector is obviated, it's a thin profile. And as I said, iris can be bent without any harm. So why is the hexagon such a big deal? Now, all that we need is a 5.5 to 6.5 millimeter pupillary opening to do our job. So if we have a square device which provides a 5.5 millimeter opening or a 6.5 millimeter opening, the circumcircle diameter would be 9.2 millimeters. Whereas if we have a hexagonal device which provides a 6.5 millimeter opening, the circumcircle diameter would be 7.5 millimeter. Now, what difference does it make? You place the square device in the anterior chamber and the corners to AC clearance is dangerously narrow. If you place the same hexagonal device in the anterior chamber, we have a safer and wider clearance. So for the same effective pupillary dilatation, you have a lot less crowding in the anterior chamber and a safer device in place. And there is another myth, like I said, for IFIS. Now, IFIS has 2 components, the myosis and the iris prolapse. As far as iris hooks and pupil expanders are concerned, for the myosis, they provide a constant pupil size, a good visibility, and a safe phacoemulsification. As far as the iris prolapse is concerned, no device actually helps. The iris prolapse entirely depends on the severity of the IFIS and the pathological damage to the iris, stroma, and muscles. So there is no credit to the pupil device when you don't have iris prolapse. It's just lower grade IFIS. So you may get away with the device in one case, and you may not get away with that with it in the next case. So the BHEX is a single plane device. We have thick, strong flanges and thin, flexible notches, and we have tabs for holding. So the BHEX is as thin as a human hair, and that's a huge advantage. About 75 microns, and it's very, very thin. You need a BHEX 23 gauge forceps to use it. That's a necessary accessory. Now, Chang and Campbell told us long back in 2005 that unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So small pupils are of 2 types, elastic or non-elastic. So the elastic pupil is like a rubber band, it's stretchable. Any expander will work. The rigid or the fibrous non-elastic pupil is not stretchable, it's tearable or breakable. So you will need a Coughlin hook or a bulky expander to tear it. That is absolutely clear. So the choice of pupil expander will depend on how you wish to tear the rigid or non-elastic pupil. With 2 Coughlin hooks, you have controlled tears in a round pupil. You could use a thin device like BHEX, which is 75 microns, it occupies less space in the anterior chamber, allows easy movement of instruments. Now, if you want to do it with a pupil expander, you'll have a poor control, you'll have asymmetric tears. You can use the Mulligan ring. You can use APX eye ring. It's a bulky device. It occupies more space in the anterior chamber, obstructs movement of the instruments. So I would suggest that we check the elasticity of the pupil before starting. You just inject a bit of BSS into the anterior chamber as soon as you've done the paracentesis. Now you see that momentary expansion of the pupil. That is a clear indication that that pupil is spine-sile or does not require any stretching. Now this is a case where you inject BSS as much as you want and the pupil does not budge. It's got a fibrous ring over there. There's a little bit of pseudoexfoliation also. This needs to be stretched before you can place a device. I mean, how you want to stretch it? Well, you can use 2 Coughlin hooks or you can use the bulky expander. That's your choice. So what matters most is the elasticity of the pupil and not the size. Again, another thing is how big do you want the pupil to be? Now, aren't we all skilled enough to perform phaco with a 5.5 millimeter pupil, which will not get smaller? That's important because when we start a case, we say, okay, it's 5.5, I'll get away with this. So if you're sure that it's not going to get smaller, well, what else do you need? And BHEX does provide a 5.5 pupil. So let's look at this video by Deepak Megur. If it's a pupil which is smaller than 4 millimeter, I would recommend that we do a good stretch. The pupil is still round. And now you can place your device, any device, even if you use iris hooks, you have a wonderful pupil at the end of the surgery. That's very important. You don't have any irregular tears or asymmetric tears. So this is a pretty hard cataract, and a 5.5 pupil, it's not a very big deal. So all that you need to do if for a hard cataract is chop it into smaller fragments. Now, intraoperative myosis. Let's look at this video. Now, in malignant ring, the gaps in the screws are not visible. So from the top view, when you are engaging, you may engage the capsular rhexis margin, and that would be a disaster. With the BHEX, the gaps in the notches are clearly visible from a top view. So it does not engage the capsular rhexis margin. You engage the pupil margin with certainty. As you tug those flanges and push them to the periphery, you have instant confirmation that you have not engaged the capsular rhexis margin. And even if you do, you can just retract a little and go back again. So that's a huge plus. Now, in a shallow anterior chamber, like I said, BHEX is a 75 micron device. So the corners of the malignant ring or any other device is about 0.9 millimeters. So that is a lot of difference. So, and the mid-peripheral anterior chamber is a lot shallow. It's almost half the central anterior chamber. So with the AC, which is about 2.5, the mid-peripheral anterior chamber would be 1.25, and that's a tight job over there. So with the thinner device, you can get away much easier in a shallow anterior chamber. So this is a complex video which was posted in the American Academy by Dr. Michael Henry. I thank him for that. Now, this is a video where you can see you're getting about a tube shunt. And despite the huge tube shunt in the place, shallow anterior chamber, the thin BHEX is maneuvered around the tube easily without any collateral damage. And that is a big advantage in these cases. So the BHEX can be removed through a 1 millimeter side port incision. No device allows you that luxury. So when you have an iris prolapse in IFS, this would be a big blessing or a huge advantage to get away. So these are a few publications in the Journal of Cataract and Refractive Surgery and the IJO. I'd encourage viewers to read that. This is a PDF which is available online on our website about the tips and tricks to use. It's a freely downloadable PDF which has got video links which takes you directly to the scene which is being discussed. And I would encourage viewers also to take a look at these tips on phacoemulsification that's published at eophtha.com. Thank you very much for your kind attention.
Thank you, Suven, for that excellent presentation, like always.
Thank you.
So now I would, should we, Dr. Ramamurthy would want to discuss something?
Yeah, just excellent presentation as usual. Suven, always learn something, though I've heard this before. The only comment I want to make is you have to differentiate between a small pupil phaco and phacoemulsification, a small rhexis phacoemulsification. As you're mentioning during your talk also, sometimes we start with a 5.5 millimeter pupil and you get a nice 5 millimeter rhexis. Subsequently, especially if it's a small reasonably medium grade cataract, the pupil comes down. Most often we are able to manage without any devices. I just have one question to you, and I've often had this thought. There are occasions when you use a pupil expander with a capsular support system. So in case we have a BHEX ring in place, it's possible to use a capsular hook to, in case you need to have a subluxated situation.
Yes. So we can do that because the capsular rhexis margin is within the expanded pupil, and the devices that are available now also provide equatorial support. So they're going through the capsular margin and engaging at the tip of the device. The capsular device is at the equator, so it can jolly well be used. No issues with that.
Thank you.
Thank you, sir.
In the meanwhile, can I request Dr. Mohan Rajan sir to please start his screen sharing?
Shall I share my screen? I'll just try to share my screen.
Yes, sir. You can continue the discussion, and then if the screen works, then we can go ahead.
Yeah, absolutely. I'll just try to share the screen.
Sure.
Everybody is aware of Mohan Rajan's problem. I don't know why we are not able to sort it out, and it works everywhere else but here. Mohan, let's hope this time.
He's the TNOA president. You better make it work.
Again, it's the white screen only.
I don't know how. Abhishek, can you please sort it out?
One minute. I sorted this out. You're able to see my screen now?
Yeah. You were choosing the wrong screen.
Thank you very much.
Thank you so much, Mohan. Finally.
Yes.
There was a very small
Yes,
thing
sir.
I did.
Perfect. I think we can go ahead.
I think, Dr. Mohan, we can go ahead with your talk. We don't want to take any chances
Yeah,
now.
I'm starting. Sorry. Thank you, Namrata, Subhash, and the entire DOS for the wonderful opportunity. I missed a really wonderful opportunity yesterday in the DOS OPL because I was not able to share my screen. Today, I'm going to talk on the IOL implantation in the absence of capsular support. These are my financial interests. Early recognition combined with advances in instrumentation enabled effective management of posterior capsular rupture during phacoemulsification. What are the options available? Options available are IOL in the bag, in the sulcus, AC IOL, iris claw. You can have SF IOL sutured or a Yamane technique or a glued IOL, whatever you want. So this is just to show you a PCR which happened long time back. You can see here. And the only thing is when you have PCR, I think Abhay Shale was beautifully talking about it. Don't withdraw the handpiece. Whether you are in the phaco or the IA, if you try to withdraw the handpiece, what is a small PCR will become a huge PCR, and that's what has happened. And the nucleus also started sinking. In this particular case, what I did was always remove the vitreous first and then remove the cortex, do an bimanual, that is separate the irrigation from the aspiration and go ahead. You can see this in this particular patient, the rhexis is intact. I went ahead with the Sensor 3-piece lens in the sulcus, and the patient did very well. And till about 3 months back. Why till about 3 months back? Because he died of corona now. Okay. Next one is, you can see here again, another patient is, you can see here, when I'm removing the last piece of the nucleus, there is a posterior capsule tear, similar to a posterior capsule. Rhexis there. And once I do that, I remove the piece there because of the post-occlusion surge and because of the second generation phaco machine, which I was using long time back. And again, once I notice a posterior capsule, I don't withdraw the handpiece. I inject viscoat into the anterior chamber. The viscoat goes and plugs the PC tear and prevents the hydration of the vitreous. Once you have a bimanual IA, the PC tear gets plugged by the viscoat and doesn't enlarge. And once you have a bimanual IA, the bimanual IA actually tampons the vitreous, that is the capsular break, and also tampons the vitreous and also prevents the hydration of vitreous. So once you have the bimanual IA, you can see here, it works very well. Again, I was removing the cortex and then go ahead and doing the vitrectomy. This particular case, I was able to put a multi-piece lens, that is the MA60 Acrisoft lens, into the bag because the PC tear are exactly the same. Again, this is a post-operative picture. Just to show you, this is a patient who have wanted a toric lens, and this is a doctor who came all the way from Kerala. The lens started sinking into the vitreous cavity. I went ahead and did what is called an anterior assisted levitation of the lens, extended the incision. I went ahead and did this thing. But again, the rhexis is intact in this particular case. So once you do this, you can make sure that you always have to remove the vitreous and then remove the cortex there and remove the vitreous there. You can see you can do a bimanual vitrectomy, separate the irrigation from the cutter. Don't use a coaxial irrigation aspiration or a coaxial or what you call the vitreous infusion suction cutter. Always have the irrigation separately from the cutter. So that makes the life easy and also prevents the collapse of the anterior chamber. You can see that I'm removing the vitreous in the anterior chamber. Then you can see this is another patient with the posterior polar cataract. As you know, posterior polar cataract, there can be a pre-existing dehiscence of the posterior capsule. All these are there. You can see again, I'm doing a bimanual IA. This particular lecture is focusing on how to implant a lens. So you can see there's a typical 2 pillars on the posterior capsule in a posterior polar cataract. Again, I'm injecting viscoelastic every time I come out of the eye, preferably viscoat, but whatever you're comfortable, you can do that as well. Again, you can see here, I'm putting a multi-piece lens in the sulcus. I don't leave it in the sulcus there. I don't leave it. I always, when I put a multi-piece lens in the sulcus, I always try to capture that lens into the capsulorhexis margin. This is called the optic capture. It's very, very important because it maintains a long-term centration of the lens and also prevents the UGH syndrome to a great extent. So once you do this, you can see here, the end point of the optic capture is the ovalization of the capsulorhexis margin. This is very, very important. So that the haptic is the sulcus, the optic is captured just by tapping it beneath. So you have to make sure that the rhexis is not very large, not very small. Ideal size of the rhexis in a posterior polar cataract will be around 5 or 5.25 millimeter, which will enable you to capture this. Again, you can see here another patient with the, when I'm removing this thing, we can see there's a small tear in the posterior capsule. And there's a linear tear, so it's very difficult to convert this into a posterior capsular rhexis. Otherwise, it would have been in the center. I would have converted that into posterior capsular rhexis. Again, I'm injecting viscoelastic and using bimanual IA and going ahead and putting a single piece lens in the bag. But once I'm putting the single piece lens, because I've not converted this is a message I want to give everything. I've not converted that into a posterior capsular rhexis. It's not as strong. So once I put that lens in the bag, you can see that the posterior capsular range starts extending. Fortunately for me, the lens was stable without any problem. Just to show you another patient with the femto, the hard cataract. Again, you can see here the lens starts sinking because of probably hydro rupture which has occurred in this particular case. I'm extending that. But more importantly, I just want to show you one important thing here. I'm doing an anterior vitrectomy and removing the cortex as well as the vitreous as well. Whenever you have a PCTA, the pupil always becomes small. Use iris hooks, because if you use iris hooks, you know exactly where the sulcus is, and because otherwise you put a lens, next day it will be on the macula. So you have to make sure that you put a lens, a sulcus fixated lens, make sure that it is right in front of the capsular rhexis margin. Again, another patient, this is an anterior levitation. So this is an old patient, so I just went ahead with an anterior levitation, lens started sinking into the vitreous cavity, and then I went ahead with an anterior chamber IOL. You can put an anterior chamber. Only thing is the sizing of the IOL is very, very important. Make sure that the vitreous is completely removed, the pupil is round. Do an iridectomy in this patient. This patient did very well after the surgery. You can see that this is the postoperative pictures of this patient. Again, you can put an iris claw lens in the absence of complete capsule loss, anterior and posterior capsule. Iris claw lens, many people are doing the retro iris claw lens. Very simple technique. I always use a scleral incision for these patients because it makes life easy. I do either a secondary or a primary implantation. Or you can go ahead and do a scleral sutured fixation IOL. And you can see here, this is a suture fixation. I use a 90 Prolin. Nowadays, I'm doing more of a glued IOL, which is making life easy for me because we have done one of the largest number of glued IOL coming from the land of the glued IOLs here. You can see this is a scleral flap, 0-180 degree. It's very, very important. Use the Ashwin Agarwal marker there. And then once you do that, you can put an anterior chamber maintainer or a pars plana infusion. So if you're not you're a little apprehensive about pars plana infusion, many people, anterior segment surgeons, you can go ahead with the anterior chamber maintainer, or you can use the TACM or the trocar anterior chamber maintainer, which is described by Amar. Then go ahead and do the what is called the handshake technique, and externalization of the haptic. Always catch the tip of the haptic is very, very important. Once the lens comes out, don't try to pull it out. If you try to pull it out, it will break. Always catch the tip. Use the glued IOL forceps, which is made by the Epsilon company. I don't have any financial interest. And then you can do the Chariots, Gabor Chariots tunnels there with a 26 gauge needle or a 27 gauge needle and try to tuck it inside. You can see the ACM maintains that the whole ball game is with fluidics and not with the viscoelastic in this particular glued IOL. Again, you can see the Yamane technique. Many people are using this as well. And then, of course, the Canabrava technique. Since I'm running out of time, anybody knows this, the Canabrava technique. I'm not doing this. I just borrowed this from Canabrava, and you can see how this he's using a 60 Prolin to put that Acreos IOL. This is a 4-point fixation, which makes that lens very, very stable. There's no torque of the lens and makes life very, very easy and very comfortable. Thank you again, DOS, for the wonderful opportunity and the patient attention. And I want to thank Namrata, Subhash, and the entire DOS team for a wonderful 1 week, I would say, and a scientific extravaganza. Yeah, I've not seen this anywhere, and hats off to you guys.
Thank you, Mohan. I'm so glad the presentation finally came on.
Thank you very much.
Next, I believe we have Dr. Amamurthy.
Okay.
Any questions from the panelists?
Yes, I was also about to ask that, but I guess since the presentation was well said. I think Dr. Namrata would like to definitely say something.
I think we can take Dr. Ramamurthy's talk and then we can, after that, take questions.
Thank you so much, Namrata, Subhash, Kityal. I mean, wonderful conference and truly a rich learning experience. Thank you for making me a part of this. And what I'm going to be dealing with is just simple short videos elucidating how a trench made in almost every type of cataract makes it easier. You can look at a heart cataract scenario like this, and one of the primary things is to get a good rhexis. I usually aim at a 5mm rhexis, but when I have a heart cataract situation like this, is usually a 5.5mm rhexis because you need adequate space to chop this nucleus. And hydrodissection is necessary. And since I see a good anterior shift, I do not do a multi-quadrant hydrodissection. I always make sure that the nucleus is freely rotating before I go ahead with the emulsification. That's the cortex and the epinucleus being removed. Now is the point I want to emphasize. I always create a trench which goes up to about the middle of the nucleus, which is about 2.5 times the tip diameter. And it almost goes to about 2/3 the thickness. Once I do this, I get a good purchase on the meat of the nucleus. And now I'm using only longitudinal phaco, no torsional phaco. As you can see, the IOP is just at 30 and the vacuum is at 600. And it's the trench is not just the first chop, but every chop, it gives me adequate space for going ahead and getting a purchase on the nucleus. I think as far as you are going to get bury a new phaco tip into the meat of the nucleus, then the chopping itself becomes quite easy. As you can see, the chopping action actually occurs in when I'm in foot position 2. I just give a small burst of power and then subsequently bury the tip of my nucleus into the nucleus meat, and then subsequently go ahead with the chopping. The number of chops I do entirely depends upon the grade of the cataract. For a reasonably hard cataract like this, you usually like to have 6 chops, and as you can see, this segmented into 6 different segments, and this proceeds in a very methodical manner. A good hydrodissection done earlier also helps you to rotate the nucleus in a very nice manner. As you can see, the vacuum goes up to 600 when I'm burying my tip into the nucleus, and the chopping actually happens when I'm nicely holding the nucleus on. And right through, the intraocular pressure is maintained just about 30 millimeters, which corresponds to a bottle height of about 41 centimeters. And once this is done, of course, it's important to emphasize that dispersive viscoelastic is used multiple number of times. And it's essentially as far as aspirating the nucleus fragments is concerned, in this, it's only torsional phaco. There's no longitudinal phaco that is used. Again, the vacuum is at about 600. The IOP remains at 30. Most often, the phaco tip remains stationary, and you can see the excellent followability. And basically, the point is a nice trench, a longitudinal phaco for getting a purchase on the nucleus and creating a division of the nucleus, and subsequently only torsional phaco when it comes to removal of the nucleus fragments. It is a repeatable technique and works well in my hands. And when it comes to a post-LRCA scenario like this, usually what I do is again use a sextant, that is 6 segments, and there is also a certain amount of softening. Again, you can see it's a trench that is made, and subsequently the division of nucleus is along the fault lines that have already been created with the laser. And you would see that if you have noticed the CDE in this particular case, where the nucleus is about just as hard as the previous case, is about 50%. This is the advantage of using laser prior as far as nucleus emulsification is concerned. The fact that the nucleus is softened up by the segmentation and the softening that it has been subjected to earlier. Otherwise, the steps proceed exactly the same. I go ahead and proceed, make a trench initially, which gives me a nice purchase onto each and every nucleus fragment. You can see I have just used about 2.5 CDE for dividing the nucleus into multiple fragments. That is also because of the pre-chopping that has been done with the laser. And subsequently, it is an iris plane phacoemulsification, where the fragments or free-floating fragments are brought into just in front of the iris plane, and we use almost similar parameters. You can see compared to about 2021 CD in the previous case, here it's sub 10, and that I believe is partly because of the laser that's being used. And this is a toric intraocular lens that's well oriented using the Varion. What about soft cataract? That again sometimes can be quite a challenge. In these cases, what I do when I'm using the laser is to go ahead and remove the capsular rhexis, and then subsequently what I do differently is the hydrodissection, where I dissect right through the central trench that has been created, and subsequently go into the trenches that are on the sides also. I find that once it is done, the nucleus fragments is almost entirely separated, and then there is very little. You can see that the CD will be zero right through, and it's essentially phacoaspiration that's being done, and it's almost because of the earlier segmentation that has been done with the laser and the hydrodissection that has been done into the cleavage planes. You almost get completely divided nucleus fragments over here, and each pie-sized fragment is just phacoaspirated in a very methodical manner. As we all know, sometimes soft cataracts can be quite challenging, and I find that even when I do a clear lens extraction, a procedure like this helps me and makes the entire procedure much more controlled. This is again a toric intraocular lens that has been implanted, and let's go on to another situation. As we all know, posterior polar cataract is often a challenge. Exactly the same steps. Only thing is I'm doing hydrodelineation and not hydrodissection. And please see that the cortex and the epinucleus is taken off. And then subsequently, the trench that I was alluding to that is made right in the center. And once I get a purchase without any rotation of the nucleus, all I do is the first chop. Again, no rotation. But on the two sides, I do two chops so that the inferior heminucleus is almost equally divided into three segments. Subsequently, I go ahead and aspirate these nucleus fragments. And once the capsular bag has been debulked by taking out heminucleus, then you can go ahead and do a hydrodissection or viscodissection. Then I rotate the nucleus and subsequently take this out in the same methodical manner. And this gives you a much more controlled removal of the nucleus. Of course, a preoperative OCT to determine whether there is an existing capsular defect or not is always helpful for you to plan the surgery. Last of my videos where you can see a Morgangian cataract like this, most often we talk about only the difficulties faced in doing a capsular rhexis in these situations. But as you can see, the capsular rhexis can be done in a methodical manner. It has been frequently discussed, and once you have aspirated much of the cortical material, which is fluid in these cases, capsular rhexis is quite easy. The challenge is this nut-shaped nucleus which is over there. It's very difficult to get a hold on this, and this is a 90-year-old patient actually. In these cases, the posterior capsule always tends to trample in. So as you could see, what I have done is an IOL scaffold. After getting the IOL into the anterior chamber, I go ahead and place the intraocular lens into the bag. Then subsequently, using gentle parameters, is not continuous phaco, I do a nucleus chopping and divide it. It's a multifocal intraocular lens that has been implanted. This is exactly a 7-minute presentation, and basically I just wanted to take you through some of the steps I observe when facing a challenging situation. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. I think that was an excellent presentation of tips and tricks on when a trench is required, and very subtle tips and tricks you gave. Again, like I said, something that you don't read in the books, you can only see on the videos. So, Dr. Tityal sir, would you like to comment? Because I know in certain situations you are, sir, also very fond of trenches and craters. Would you like to comment on this?
I think what Dr. Ramamurthy showed beautifully, demonstrating how easily you can make an effective, phacoemulsification by making a trench, and he showed all the advantage of making a trench. And I also we started with making a trench for all phacosurgery to begin with. So it may be a grade 1, grade 2, or grade 4. In fact, one of the first publication which Dr. Bajpayee published was making a crater a very, very hard cataract. So that was very useful tip to make a central debulking of the hard core of nucleus and leaving the peripheral frill of a nucleus which behaves like subsequent like a grade 3. So you have to do away with all the pieces, all the mass of a nucleus. It hardly matters you directly chop or you make a trench or crater, the amount of energy may be similar. In fact, once we make a trench or a crater in a hard cataract, we play very, very deep like deeper into the matrix of a nucleus. So you're away from the endothelium, which may not be possible in a big chunk of nucleus, which normally comes in a direct chop in a very hard cataract. So I would rather do a very nice trench, as Dr. Ramamurthy showed, and a very deep crater in a very hard cataract. And that makes the, space for your all the manipulations and saves the endothelium also. If you have to spend little more energy, it doesn't matter. You are deep into the cavity of a nucleus. That is what I think should be practiced by or younger generation. Play within the bag or below the capsular axis margin or below the iris plane. Whatever type of nucleus you have, it may be soft, it may be hard, but you have to play below the pupillary plane. Beautifully depicted.
Dr. Mahipal sir, you would want to add something?
No, I think Dr. Ramamurthy made a great presentation and the great points. So hard cataract, as has been said, it's the central core that needs to be broken, and the periphery follows what Dr. Titial just said, that then it behaves like grade 3. So that is actually the main thing, that the backbone or the spine of the hard cataract has to be broken. And once that is broken, things become easy. As long as there is interdigitating between the posterior spine of the cataract, you can end up in problems. And at times you take away the central core, but still you are left with the bottom part, which is interdigitating. And when you try to remove it, you are critically close to the capsule, and that is when you get a PCR. So I think most important is you do a trench or whatever, and then rotate it 180 degrees, deepen the trench. So it has to be in the same, the trench should not be wide. And it should be like the handpiece a little more than the phaco probe, and then you should be able to split it. That's all beautifully explained by Ram, that break the backbone or the spine of the nucleus.
Okay, I think move to the next presentation.
Yes, Dr. Ashwin. Dr. Ashwin.
Mahipal wants to speak right now, so I think we can go ahead with sir's presentation.
Thank you. Thank you very much. I'll be, is everything all right? Full screen I'm making. Is it okay?
Yeah, it's fine.
Yeah. So I'll be talking about my favorite subject, that is posterior polar cataracts. And somehow I think we have just finished a thesis also, and this has come out to be a great kind of learning that we have got as regards OCT. And I'll just be talking as to what we have found as regards doing the OCT with a high definition in the OPD also. So when you are looking at the doing a phaco or a femtolaser assisted cataract and posterior polar cataract, you are looking at pre-existing weakness of the posterior capsule, and cortical cleaving hydrodissection, if you do, and if it's forceful, can cause a hydraulic rupture of the posterior capsule. The femtolaser assisted pneumodelineation, which is very, very important. You don't really need to do any hydrodissection or hydrodelineation, because the pneumodelineation actually works pretty well. The only important thing in the pneumodelineation is that the settings have to be pretty good, so that the pneumodelineation does not go critically close to the posterior capsule, and that is very, very important. There are other things which one can do, and among them is the nuclear disassembly, the modes of nuclear disassembly that you have, and concentric rings or segments have also been described. Now, whenever you are doing a posterior polar cataract, the points that have to be met, kept in mind are that the chamber should always be closed, and as Mohan in a presentation just before he showed, viscoelastic needs to be injected before you actually withdraw the tip of the phaco, so that there isn't a decompression, because this decompression would cause an upward movement and an extension in the posterior capsular rent. Now, the anterior segment OCT can be used preoperatively. We have compared between the Pentacam, the IOL Master 700 and the AS OCT, and we have found that the AS OCT, if you are using a high definition good OCT, then under those circumstances you can pick up pre-existing capsular defects. So a good slit lamp examination and a good anterior segment OCT in the OPD are something which is very, very important. And then if you are doing a femtolaser assisted cataract, which apart from giving you an OCT, so you don't actually need to do it in the OPD, because the femtolaser will give you a good OCT picture that is there. A perfect CCC is something very important. You can have a 5 or a 5.2 millimeter, because this will give you the scaffold or the support where you can put the IOL in case of posterior capsular rent. Hydro procedures are best avoided or are very careful and can be done in situ also. Epinuclear cushion needs to be left till the very end. And this is something, this is the high definition anterior segment OCT. And what is very, very clear, what I want to show here is that this is the defect which you could have picked up in the OPD also, and which you can pick up on the catalyst system, which is there. And the offsets are customizable. And that is that you can see that this is the offset which is being raised. And this defect is being given the good solid support of an epinuclear cushion. You can see very well that this is a defect which is there. There is 100% specificity. I haven't had a false kind of a situation where it has said that there is no rent and a rent has appeared. There have been several publications, including by Dr. Titial, and has been reported by our group also that the intra-op OCT is also a great tool. But having till date, I think we'll need to publish this because the thesis has just been completed. As to the AS-OCT used preoperatively, that has not been documented as a tool that is there. Now, we have given this article as regards the use of the flax in the procedure of posterior polar cataract, and I'll just show you what I showed earlier. This is the docking that is happening. And you can see once the OCT comes into view, again, you can see a clear-cut posterior capsular defect, and you can see we are raising it so that the nuclear disassembly is here and the posterior portion is left pretty good. And this was the older times when we used to make small cubes, which is about 200 microns, but now we have gone on to 1000 micron. You can see I have a perfect capsular axis. You can see that I will not be doing any hydrodissection, hydrodelineation, and because the cataract has been softened and emulsified, most of the cataract can be removed without any rotation that is there. You just need to bend your tip and hold it at the proper point, and you can get it out because the pneumodissection makes the nucleus relatively free. Now you will see that it's only towards the end that we are taking out the epinuclear cushion, and there that's the posterior polar cataract that's shining at you. And again, as I told you, we will keep the phaco tip inside, have injected viscoelastic, and you can see that the slow removal of the cortex is happening, and just it's at the end. Again, we will put viscoelastic, and it is right at the end that you see such a huge posterior capsular rent which is there. And we go ahead and put a 3-piece lens as was shown, and we can do the optic capture of the lens. This is just to show you the slit lamp image. You can see a slit lamp image. This is a photo essay that has been published in the Indian Journal of Ophthalmology. This is the integrated OCT image. You can see a vitreous blob coming out without having a rent. And you can see that this is again the image that you could get on the anterior segment OCT. And this is where we have done the phaco, the safe nuclear emulsification, and this is the image of the OCT, which you can see this is coming out here. So the femto will give you perfect incision, architecture, etc. The capsular axis would be a make or break, because the role of a perfect axis is that if things go right, it is a blessing, and even if they don't go right, then you can use the capsular axis to put a well-centered lens and do an optic capture in these particular cases. Nuclear softening is very, very important because you don't put any pressure at any stage onto the eye. And these are the concentric nuclear softenings that have been described, which can also be done, and a pneumodissection can help you remove these. So what I will wish to say is that the epinucleus is a shield. It is precise, sharp, but smooth pneumodissection that happens. Posterior limit of the nucleotomy from 500 microns can be increased to 1000 because it's under direct visualization. You can go to 800, 900, 1000, wherever you want. And it is till the very end that you are going to have this so that no vitreous comes out, and nuclear rotation can be done without disturbing the posterior capsule. So this is the femtolaser assisted cataract surgery. I would say if you don't have that, you are going to definitely get injured. But you have femtolaser, you are having the airbags, as you can see in this, and the person will remain safe through the procedure that is there. Numbers speak volumes, and these are to show Abey's work, Titial's work, Osher's work, that the nucleus drop and the PCR that has been reported in femto has been significantly lower or absent in posterior polar cataracts as compared to phacoemulsification. So to sum up, what I wish to say is that PPC is a nightmare even for the most experienced surgeons. Though there is at times an overdiagnosis of a posterior subcapsular cataract as a PPC, but typical PPC which have the onion whorl ring and pre-existing rents have to be managed with an expertise and with you being prepared. And anterior segment OCT can be used to preoperatively determine the status of the posterior capsule, and this helps you prepare with the new techniques of femtolaser assisted cataract surgery. I think most of us have reported zero nucleus drop. Though posterior capsular rents will happen because they are pre-existing, but if you are using the femtolaser, you don't end up with a nucleus drop that is there, and you get the much needed safety cushion if you adopt femtolaser assisted cataract surgery. So I think this is one of the strongest indications where I would prefer to do, even if I have to spend from my own pocket, of femtolaser assisted cataract surgery for a posterior polar cataract. Even 3 days ago, I had a patient from Nepal who had an anterior chamber lens, was very, very unhappy in one eye because there was a huge rent, and this guy was a young guy, had a polar cataract, and it went very well when I used the femtolaser assisted cataract surgery. So this is one of my greatest indications for adapting to the femtolaser assisted cataract surgery to handle posterior polar cataract. Thank you very much for your kind attention.
Thank you so much, sir, for that excellent presentation. I think we'll take Professor Tetyal's presentation because that is also on the same subject, and then we can discuss both of them together. Sir, Dr. Tetyal, sir.
Yeah, absolutely correct. I'll let me put my slide here. Is my slides on? No, it's not there.
No, sir, we can see the whiteboard.
Tetyal sir, same problem I had. Go to the desktop and then click on that.
Yeah, it's come now.
Yes. Now it's come.
It's a Mohan Rajan syndrome coming up.
Dr. Mohan Rajan now can guide others on how to get
He's
over
become an
it.
advisor.
Thank you, DOS, and I wish good morning to people sitting in the hall A in Ashoka, especially Dr. Namrata and Dr. Subhash, other people, and people who have joined us today online for this very, very well organized, very effective international DOS meeting. I think the setting was well set by Professor Dr. Mahipal regarding posterior polar cataract, and I also believe that femtosecond laser application suits the cases like posterior polar very, very well. I'm going to describe a sign which we have described very recently, though it is was well known to most cataract surgeons, that is PPCDD, intraoperative posterior polar cortical disc defect. No financial disclosure, and as we saw in the two previous presentations, the incidence of posterior capsular dehiscence or rupture happening in any step of surgery is there in a posterior polar cataract. And I personally feel the most important step is when actually we remove the epicortical cushion. There you have a more chances of rupture happening in these cases. As described by Dr. Mahipal, you can do a very nice slit-limb assessment to look for a type of posterior polar cataract. Its size, its depth, the disc density can be measured, onion ring appearance, and most importantly, if you have nuclear sclerosis associated with posterior polar cataract, that would have more chances of a PC defect happening during the procedure. But if you have this type of picture, which already has a posterior capsular defect, so you have to assess your surgical planning according to the type of case you are dealing with. So this is the picture which can be very nicely picked up in anterior segment OCT and intraop OCT also. And the various risk signs have described very well in both with the pre-op assessment as well as intraop assessment by all of us. And we know that these publications will definitely help the people who are venturing into these type of surgeries, right from the description of a posterior polar to intraoperative benefits of these cases. This is what we published, the intraop dynamics of posterior polar cataract with IOCT during surgeries, and describe the 3 types of posterior polar cataracts, excluding the open posterior capsule in these cases. But if you do a classical phacoemulsionary surgery in these cases, you do see a central disc coming up during your surgery. That we described it as an intraoperative posterior polar cortical disc defect, or a PPCDD. And this is what we saw in cases of posterior polar in almost 67 eyes of 56 patients. It looks like a donut-shaped central defect in the posterior cortex after aspiration of nucleus, emulsification of nucleus or epinuclear aspiration, surrounded by the whitish gray rim of a variable thickness. So that is a very important associated feature of this defect. Normally, this defect would be of similar size of a disc which you see in the posterior polar in your routine examination. So that may be the feature of a classical posterior polar disc defect happening in these cases. If I just show one video of posterior polar cataract where this defect comes up, yeah. So you can see I'm doing a regular rhexis, which is normally around 4.5 to 5 millimeter central rhexis. And you can see intra OCT delineates the hydro delineation, which has been done here. This is a type 3, type 4 polar cataract. So we have done a multiple zones of delineation happening. And this has also gives a customized cushioning of a posterior polar cushion of epicortex, which is much more effective in a femtosecond application, but it can be done in the cases of the manual hydro delineation also. If you have access to IOCT, that tells you how many layers of hydro delineation have been done or how thick is the epicortex cushion. Emulsification is nicely done in such cases because you have a cushion there. Subsequently, when you remove the cushion, this is the time you start seeing the defect. You can see the yellow arrow shows the defect. So this takes away some of the heartbeats during your surgery. You feel that you have already opened the posterior capsule. But actually, this is the defect coming up in the epicortex, not into the posterior capsule. So this sign is what saves the surgeon's heartbeat at that time. You're pretty sure your capsule is intact, like in this patient. Now I'm removing the remaining cortex. Once you remove the core, you can see the capsule absolutely intact in IOCT. You can see there. Now you can implant the desired lens, which may be multifocal, toric. Any lens can be implanted safely. So if you see this sign, so that is one good way of completing your surgery without getting, fear of a posterior capsule being open. What are the incidents of posterior disc defect happening in all cases of posterior polar? Around 87% of cases, you'll see this disc defect coming up, like you see here, complete margins, or sometimes you have an incomplete margin seen in these cases, which is less. Around 7% will have incomplete because by the time you appreciate, you would have aspirated some of the cortex epicortex in these cases. And at what stage? This is after epinuclear aspiration, around 90%. After the majority of cortical aspiration, around 9%. And after the nucleus emulsification in around 2% of cases. So this also tells you the type of posterior polar cataract we are dealing with. If you have after nucleus emulsification, this is the type 3 or type 4 type of posterior polar cataract as per the anti-segment OCT or IOCT definition wise. Those cases where you don't see posterior polar cortical disc defect, around 13% of cases, normally it is either in block aspiration have to be done in these cases, like 2 out of 9 patients, or sometimes they are densely adherent to posterior capsule. You can see the wrinkling in the posterior capsule when I try to remove the posterior disc. These are the cases where capsule can open up and you have a defect coming up these patients. Basic pathophysiology of posterior polar cataract, we know some cases will have a genetic involvement of PITX gene involvement in these cases. Mutation happening in the gene, causing a variation in lens induction, especially the fiber orientation of these cases, which forms a discoid plaque in the posterior pole. And this mass, which is either will be adherent to posterior capsule, the presentation will be early like a congenital posterior polar cataract. If it's not adherent, it will be like a routine adult onset posterior polar cataract. The defect will come up when you do internal delineation, hydrodelineation, as you see here, or when you actually remove the cortex or nucleus. That time you know that how many layers of delineation done, that will give you an opening of a disc defect after the epicortical cushion removal. So this is what we see in these cases. If you have PPCD, that is a intraoperative posterior polar cortical disc defect seen, the sign is seen, there's no incidence of PCR, 0 incidence. But if you don't see this sign in a posterior polar cataract, you would have a high chance of the posterior capsule opening up during your surgery. That is around 44% of cases. So this is a safety sign in all cases. To summarize, as I said, 87% you'll see a disc defect seen in a epinucleus. Most commonly after aspiration of epicortical or epinuclear cushion. The incidence of PCR decreases to almost zero when you see this defect because your surgery is safer. But if you don't see this defect in the posterior polar cataract, that means you are dealing with a disc which is totally attached to the posterior capsule or there's no posterior capsule. So there is high chance of opening in these cases. So PPCD is a sign of intact posterior capsule for your cases. Thank you for your kind listening, and we might take some questions for a discussion.
Thank you so much, sir, for that excellent presentation. I think both the talks covered posterior polar, completed comprehensively the topic of posterior polar cataract. Any comments from Dr. Ramamurthy?
I think two of the stalwarts covered almost everything about posterior polar. Maipal so nicely talked about the importance of ASOCT, both with the femtosecond and then preoperatively examination. And this wonderful, what Dr. Tetial has documented, we've been seeing it all the time, but we never really applied our mind towards it. So this posterior polar cortical disc defect is an excellent thing that has been documented. Just a few tips. Even in case you do not have access to some of these equipments, then you can go ahead. Every case of posterior polar cataract, as was mentioned, even though the incidence from earlier reported 33% has come down to less than 2 to 4%. I think as far as the counseling of these patients and your approach to the patient is concerned, it should be, especially for the younger ophthalmologists and even the senior ophthalmologists, should be as if you are going to be having an PCR and having a 3-piece lens ready, counseling the patient that we may not be able to put a toric or multifocal intraocular lens, etc. is extremely important. Avoiding hydrodelineation, and especially once you have removed a certain amount of nucleus material, then sometimes the cortex and the rest of the nucleus are adherent because you have not done a hydrodissection. And once the bag is not filled up, you can go ahead and do a gentle viscodissection or hydrodissection so as to mobilize the rest of the lens matter. And please remember that it is, even though there is not a defect, it is still a weak posterior capsule. So we have all had videos of where the posterior capsule blowout occurring when the lens is being implanted or when the hydration of the wound is being done right in the end. So you have to treat the posterior capsule with kid gloves. Sometimes there's a small plaque over there, a small, and you tend to polish it unnecessarily. That might not really interfere with the vision. You end up with a problem. Just one thing I've started doing is that when on the ASOCT, if I find that the posterior capsule is intact, usually I used to raise my offset in the laser from 500 to 800. Nowadays, I go ahead and use 500 itself, and that has given me further control over this. Otherwise, I think learned a lot from the two presentations. As you mentioned, very complete synopsis.
Just add on to what Dr. Ramamurthy said. Sorry, just 1 minute. What in terms of a posterior polar cortical disc defect, which I was talking about, if you see this defect, then you can aspirate the peripheral cortex like a regular case. But if you don't see a disc defect, that means you have an adhesion in the center. So you have to slowly pull out the epicortex from periphery, leave it to the paracentral area from all around. Then towards the end, you remove the entire epicortex in block. So that we have been teaching earlier to our people, but this feature can segregate these two areas and you can safely complete your surgery.
But still treat the posterior capsule with respect.
Yes,
there
that's
is always a tendency for it.
Absolutely.
Can I make a comment?
Yeah, Mohan.
Yeah, I think, Maipal.
I'll just from what Dr. Ramamurthy said about the youngsters, for everybody, I think from a practice perspective, it is very difficult to get a TPA or a CGHS sanction subsequently if you are doing an anterior vitrectomy. So what Dr. Ram said, we always write plus minus anterior vitrectomy if we are suspecting that there is going to be a defect. And if you don't do a vitrectomy, you can have the patient refund the money, because subsequently, if the patient is told, nahi, mere ko vitrectomy karni padi, ye wo, to patient will not. So counseling has to be important. The 3-piece lens has to be there. And if people want a separate one, like my surgeons want a MA60 for the glued IOL. So I keep 3 lenses, the normal single piece lens, the Technis 3 and an MA60 depending upon the situation where we are. So we can implant and tell the patient beforehand that an anterior vitrectomy and additional procedure would be required. And then I give a peribulbar block if on OCT pre-operatively or intraoperatively at the flags we find that there is a higher likelihood of a pre-existing rent, then we do it under peribulbar block. So these are a couple of the other things that I'll just wish to highlight. Thank you.
Hello,
Yes.
Ityal sir.
Namrata,
According to your vast experience, what is the common rate of posterior polar cataract having posterior capsule defect on your clinical judgment? And second one, what is the clinical sign which I can see on the slit lamp only when there is a anterior segment OCT is not available and the patient doctor is placing doing the job at the periphery?
Thank you, sir. Your question, I'll answer it in 2 parts. First question was, what is the your prevalence or incidence of cases with posterior polar cataract where you have a pre-existing defect? The number of such cases are very, very less. If I see in 2 categories, if I see my older patient, those are a senile age group patient, the incidence will be maybe 1 in 2,000 as far as I'm concerned. But if I see a younger patient, that is a congenital group of cases, it will be at least 1 in 10. So there are high chances of posterior capsular defect is there in a congenital group of posterior polar cataract. So that's the difference in 2 categories. Second question was, what are the various clinical features which you can observe in your routine slit-lamp examination of posterior polar cataract, where you suspect the defect in the posterior capsule? In those cases, there are few things. One, examination-wise, if you have a disc, polar disc, which is large enough, more than 3.5 to 4 millimeter, and you have the posterior capsule cannot be delineated well with your examination or slit lamp. And if you can see that, or especially younger patient, there'll be some sort of a disturbance in an anterior vitreous phase or a hyaloid phase. People have described, especially Dr. Daljit Singh and Abhay Vasavada, showing a few whitish crystalline type of a deposition happening in the anterior vitreous phase. And that may be a suggestive of a defective posterior capsule in these cases. In a congenital cases, sometimes the entire lens thickness also gets decreased because there's a slow absorption of a cortical matter in these cases. So sometimes you have a partially absorbed other cases also coming in a congenital group of cases. But classically in a slit lamp also, you can appreciate the disc defect very easily in these cases, posterior capsular defect very easily in these cases with a proper examination. If your cataract is very dense, then sometimes doing a UVM will also give you an advantage. This will delineate the anterior vitreous phase and the posterior capsule also.
Thank you so much, sir. I think we'll move on to the next talk. The next talk is going to be by Dr. Ashwin Agarwal, the white cataract and its complexities.
Hi, everybody. I hope my screen is visible.
Yes.
So my topic today is, and first of all, thank you so much, DOS, for having me. And I think this program has been so enlightening. And, I'm learning so much from so many signs that, I'm watching Dr. Tityal and Dr. Maipal's comments on these procedures. It's really beautiful. And I think I'm going to take some of them back to my own practice. Coming to some of the features of white cataracts, which I think is important to talk about. I wanted to show this one particular surgery first before I actually showcase this is what I used to do earlier in white intumescent cataracts earlier. And I never found myself very content or happy about this. And I'm sure that a lot of us already have gone through this problem of doing the rhexis in these intumescent cataracts while having these, there's this particular sheen the cortex or the epinucleus has in these particular cases, in these intumescent cataracts. And when you're starting to do the rhexis, you'll already see a little bit of fluid come out of the main port. Once you're having that sign, and you, especially a last bit, you'll always try to finish this off in a hurry, or even if you try to do it slowly, because of the viscoelastic or anything coming out, you'll always have this rhexis run out to the periphery, and you'll actually end up, doing this procedure with a Vannas or a intracameral for scissors. And that's probably one of the situations that we always think about, especially when you're doing premium IOLs, or if you're doing a toric lens or a multifocal. Any of these, you probably will feel a little bit more query before putting that intraocular lens into this eye. And mind you, these are all fakeable cases. These are not cases that need to go into a small incision or a ECC or any of that sort. And end of the day, this rhexis does not look as pretty as a round, nice rhexis would, especially if you're going to put in a premium lens. So this scenario actually is what I want to talk about. And I think a lot of people, Mohan Rajan and all, have already spoken about this in the past. And I definitely want to give credit to everybody who's spoken about this, these cases and how to manage them in different ways. One of the procedures that I have started to do in my practice is something called as the double rhexis technique. And I'm sure that's also been spoken about, but I think it's become even more vital when you're starting to do a lot more premium IOLs, especially multifocals and EDOFs, trifocals, etc., which you really want. One of the signs that I want to talk about is this, especially as soon as you puncture that the bag, you'll have this gush of fluid come out, and that's a direct sign that tells me that I want to make a really small rhexis first. Egress some of that intralenticular fluid, maybe even massage, because you really the rubbing or the massage really helps break the vacuoles inside and actually help egress all that fluid out. And once you have egress, and you probably want to do a little bit of gushes of fluid while depressing the posterior lip of the wound, that brings out all the fluid from inside the bag. You don't want the anterior chamber to depress, you want the bag to kind of get depressed. Once it's a little less protruding, the bag, and you have a flatter bag, you actually start to do the rhexis again by using scissors and intracameral forceps, basically the rhexis forceps. And you'll see that actually you can maintain and you can monitor the size. You can ensure that you can get a really, it might take 5 minutes longer for sure, but at the end of the day, you will get a rhexis. And I'm going to forward this just in interest of time, because I want to showcase 2 more procedures. But you get a really nice round rhexis where you can place a premium IOL, or you can place a multifocal, or any of these lenses in these cases. Again, showing you the double rhexis over here. Once again, small rhexis in the beginning, and try and complete it. I know it sometimes looks really small and it can be challenging at times, but try and complete it small because it really is much more controlled. I've been able to drop my rhexis run out rate by at least 80% by just doing this one procedure. And I think we'll have a few comments after my talk by Dr. Mohan and others who have already done pancho rhexis and stuff. I'm sure that there are other techniques as well, which we can talk about after this. Some special scenarios which I wanted to talk about. This is a small, rather small eye with subluxated sort of cataract, which goes into the complexities of the white cataracts. So basically what is happening here is it's a micro, it's a 9mm cornea. And you can see here, I'm making my glue dial flaps here. Once I've made my glue dial flaps, I also have to make a SICS tunnel, because this is a hardish cataract, more so from a perspective that it's subluxated, and I do not have the time to do and there's no anterior chamber space here for me to do a scaffold of any sort. Also, I cannot see the posterior so easily and clearly. And since it being a completely subluxated case, when I'm doing my glue dial, you'll see what I try to do in these cases is, once I've placed my infusion inside, and again, I did not want to do a trocar ACM over here because there's no anterior chamber space here. Once I've created a little bit of space, I'm now opening up. I'm now making my sclerotomies. Now using the same needle, I can actually push this nucleus because it's already fully completely subluxated, I can push the nucleus into the, it's called the modified Pahl technique, popularized by David Chang. And this technique really helps bringing this nucleus into the anterior chamber space. Once that's done, I'm opening up the small incision, the SICS tunnel, and trying to bring this nucleus out, especially from a perspective that I do not want this nucleus to drop back inside the eye, which is what it was trying to do. So you really want to ensure that you bring this nucleus out. Once you bring it out, or it's just about there, start to do an anterior vitrectomy, because you don't want to be causing traction at any point. Again, I'm doing an anterior vitrectomy that automatically sends the nucleus out, because your infusion is there, and you can ensure that all the vitreous in the anterior chamber is gone. And once you have this clear space of anterior vitrectomy done on both sides, then you can start doing your glued intraocular lens procedure, which is what I'm trying to do, an anterior vitrectomy, completely thoroughly cleaning up this cortical area, this bag remnants, as well as cortex, if there are any. Plus now doing externalize my haptic, and you can see the haptic, the amount of haptic that's externalized in these smaller eyes is a lot more than you usually get in a glued intraocular lens. And that's what's really interesting in these cases. I also completed this case with a single pass 4th row to ensure that this superior optic haptic junction does not have a tilt of the intraocular lens, because the optic of this IOL can get captured into the iris, and that can cause a problem for me. Here is the end of the case, how it looks. Now basically gluing the flaps down and the conjunctiva down, and you have a pretty decent end point to this case. And this is one thing that I want to talk about. And here's the last case that I'm going to show you, is another subluxated case where you can see the fortunate point over here is that if you have a superior subluxation, it's always going to be a little bit much more easier to handle than if you have an inferior one. The inferior one does not give you the space to kind of go under the nucleus. And that's an interesting point. Again, the same steps. I'm making my flaps, making my scleral tunnel, and my infusion port is in, and making my sclerotomies. Once my sclerotomies are through, I'm using a modified Pahl technique to kind of levitate this nucleus into the anterior chamber. Once my nucleus is in, and I'm able to actually express this out with using a vectors, also closing up the wound and doing an anterior vitrectomy and a glued intraocular lens, just like I did in the previous one. In interest of time, I'm going to go ahead and not showcase the same procedure that I did before. So again, gluing the flaps down and closing up this case gives me a really great result at the end in most of these cases. And that's basically what I wanted to showcase, because I think my time is up. So thank you so much.
Thank you, Ashwin. Thank you for those array of cases. Now I'll request Dr. Sanjay Chaudhary, who's there in Hall A with us, to give his presentation. And he's going to be talking on new flaprexis technique for white turgid cataracts. So since both are white cataracts, we can take the discussion after this.
Very good talk, Ashwin.
And I couldn't resist the option of coming physically to this conference, because we have been kept away from the conference for such a long time. And it's not only an academic exchange or a feast, but it is also interacting with the people. And here I see our dedicated and committed secretary, Dr. Namrata, single-handedly sitting on the dais and managing away session after session after session. So it was a great opportunity to come up and meet her and meet up the audience.
Thank you, Sanjay.
So, great talk by Dr. Ashwin. I'm also talking on similar lines with probably 1-2 additions which we have inculcated in our practice. You can say we have devised in our practice. So we just rapidly go through the initial part of managing a white turgid cataract. So we know the problem of a white turgid cataract. So what Ashwin talked was a double rhexis technique, where you give a puncture in the center, let that milk come out a bit, make that opening as small as possible, because there is still lenticular pressure and that opening might just run out. So you have to titrate that opening, but yes, keep it as small as possible. 2 millimeters, and then you decompress the bag. Now this maneuver of hydrodissection has to be done very carefully, because the fluid is going to go behind the lens, pick up the lens up and cause a block of the anterior capsular opening. And then if you continue to hydrate, the posterior capsule may give way. So you have to keep your capsule nucleus pressed and do the hydrodissection. And once you have decompressed the bag, then the second part of the double rhexis, you extend the rhexis to the required size, which is very simple. We always felt that making a double rhexis was a problem, but if you have a sufficient thickness of this band, then it is not a problem at all. So all the more reason that your first rhexis should be small, so you can comfortably make the second rhexis to the required size. Now, but still there would be situations that a small puncture and the rhexis runs out. So that is why another technique got popular, where you enter from the mid-periphery of the lens, because the pressure in the mid-periphery is less than the pressure in the center of the bag, and then decompress the bag with a 26 gauge needle or a 30 gauge needle. Once the bag is decompressed, then you are relatively safe, and then you can start extending. But you can see when I do the extension, the rhexis is extending both above and below. Somehow I was able to manage this and bring it around. But I would have preferred if I had a better control on both the edges of the rhexis, because in some situations I have seen I was controlling one end of the rhexis and the other end of the rhexis ran out. So the concept came in that the bevel should not be up, the bevel should be down. So mid-periphery, you open this small lip here, and then after sucking a bit, you aspirate, and then this is what I call a flap rhexis. I hold the flap in the center and pull it across the center of the nucleus. Both the edges are in my control, and the moment I cross the center, then I concentrate on one edge and turn it around. So now in this technique called the flap rhexis technique, the word has been coined by me, both the edges of the flap are in my control. And then I make the usual maneuvers to decompress the bag and then enlarge the rhexis as required. So now we are routinely doing this flap rhexis in all our turgid cases, and the results are really extraordinary. One thing that has to be remembered is you can't keep decompressing the bag. You just have to do a short decompression. Here you'll see I'm trying to be overzealous and decompressing the bag. But when you decompress, that padding between the nucleus and the capsule gets lost. And the needle tip can hit the anterior capsule as it did in this case. So you see this opening here. Of course, the bag is decompressed, so managing this situation is not a problem. Again, with a double rhexis, I spread my rhexis across this tear in the anterior capsule and then turn it around. So flap rhexis is giving me a very good control on the anterior capsule in a white turgid cataract. But remember, do not be over vigorous in decompressing the bag with the needle. Thank you so much.
Thank you, Sanjay, for that very crisp and nice presentation on white cataracts. Now, open to comments. Dr. Titial, sir, would you want to say something on the white cataract? Would you, like others say for posterior polar, they won't mind, paying for it for a flax themselves. Would you do that for a white cataract as well?
Yes, definitely, Namrata. There should be no debate on that. If you have the access of femtosecond laser devices, it should be used for all cataracts. And I think importantly, there are some situations where you may force yourself onto the patient, or as Dr. Mahipal said, maybe pay from your pocket. These are the cases, intermittent white cataracts, as well as posterior polar. And the third category, which I normally do, is for a subluxural cataracts. So these three cases, scenario, I would definitely use femtosecond laser device. As far as white cataract capsulorhexis or capsulotomy is concerned, there are only two things has to be seen in those cases with your examination, which may be slit lamp, which may be anterior segment OCT, or you may have IOCT also. We have to differentiate two categories. One, where you cannot decompress the intralenticular pressure despite making the initial puncture or initial small rhexis, or those cases as soon as you make a puncture, the pressure goes down. These are only two scenarios in a wide cataracts. Accordingly, then you devise what type of technique you want to use. You want to do a double rhexis, you want to aspirate with the needle, you want to do aspiration bimanual, or do puncture rhexis, will depend on these two classical descriptions. And we all have various techniques, and technique described by Ashwin and Dr. Sanjay are useful tips. And Dr. Rajendra Prasad has described his own technique. Dr. Rohit Omprakash will describe his own technique, but these techniques are good, and people, if they can utilize these techniques for their comfort, then it is a technique which will be used for everybody. That is what I would appreciate. We should describe a technique which should be useful to other persons to improve their surgical outcomes.
Namrata, can I make a comment?
Yes, Mohan, you
I
have
think,
to make a comment because puncturexis is.
Yeah, no. Both
Yes.
posterior polar cataract and the white cataracts, 100% I will do flax. Because even if the patient cannot afford, these are the two scenarios wherein even if the patient cannot afford, I'll pay from my pocket. Tityal was mentioning, Maipal was also mentioning the same thing. So because it makes the safety problem. If we cannot do flax for mature cataracts, the other option is I do puncturexis. But if we cannot do puncturexis, the problem with Ashwin Agarwal's technique as well as the Sanjay's technique is that you are taking care only of the anterior component. Please understand, these are all type 1 cataracts. There are 3 types of mature cataracts: type 1, type 2, and type 3. Type 2 and type 3, the mature cataracts, the interlenticular pressure is not very high. The type 1 is the dangerous. Okay, there is pressure underneath the anterior capsule. The nucleus is bulky. There's a pressure in front of the posterior capsule as well, and there's a positive vitreous pressure. And that's the reason why I do a block and give a super pinky, I give preoperative mannitol, Diamox for all these patients. Please understand, if you do a 27 gauge or a 26 gauge aspiration, you are taking care of the component number 1 only. Okay, and if you do the small double rhexis, again, there's a 50% chance that it can extend to the periphery. But if you do puncturexis, the advantage of puncturexis is that because you're using a larger bore, okay, you're going straight into the nucleus, you're punching the anterior capsule, then you are also giving a phaco power, debulking the nucleus and pushing the nucleus back. Because as soon as you touch this anterior capsule, the nucleus, which is bulky, comes forward and opens up the anterior capsule. And that is why you get this Argentina flax sign, because the nucleus is bulky and there's pressure in front of the posterior capsule. So you need to aspirate both the anterior component or the pressure in the anterior component as well as the posterior component rapidly within a millisecond, and only puncturexis can do that, in my opinion, in my experience. That's what I want to give.
Thank you so much. Yes, Ramamurthy.
I think excellent presentation and comments. Just wanted to emphasize what Dr. Tityal already emphasized. Not all white cataracts are the same, and a good slit lamp examination is of paramount importance. If you find the anterior capsule bulging forward, the ACD is very shallow, that's the situation where all these things that was alluded to happens. But there are quite often cases where the anterior capsule is quite flat, and it's actually the capsulorhexis goes off quite easily, and it's a hard cataract which is underlying. I often find that the difficulty in making the rexes is inversely proportional to the difficulty with which you can take out the nucleus, because you often have a soft core nucleus which easily comes out when you have an intumescent cataract. Is the other way around. And what if, in spite of all these maneuvers that have been talked about, if the things are not going as planned? I always feel that instead of having a rexis run off in one axis, if you have a Argentinian flag sign, you are better off. Because when the tendency for the rexis to wrap around is not concentrated in one axis alone, there's less chances of it going around to the posterior capsule. Similarly, if you're having a significant difficulty making even a multiple nicks so as to do something like a what we used to do earlier, is a much better way. Can opener technique, I'm almost forgetting the name, is a better way of handling these rexes rather than having one area of weakness. And in case instead of the rexis going in a radial direction, if it starts pointing out tangentially, that's when you think that it is going to be running out into the periphery. And that's a situation where this wonderful maneuver described by Brian Little, where you place the flap along the axis in which it has come and pull it inwards as well as towards the tip of the cornea, often helps you to retract the situation. Just a few observations.
Thank you.
I will not agree with you that the Argentina flag sign on both sides will not extend. Please understand,
I'm not saying,
you have an Argentina flag sign, the inferior one, that is the one which is at 6 o'clock, 100%, if its cataract is going to be hard, okay, 100% it will extend to the posterior capsule and you will use the nucleus.
No, one, I'm not saying it will not extend anyway. I think we are running short of time.
I think we'll go on to the next talk, Ion Optics, Managing Expectations, Aberrations and Decentrations by none other than Dr. Suhas Haldipurkar. We had a wonderful surgery yesterday. Dr. Haldipurkar, please, from Lakshmi Eye Institute, Panvel, yesterday in the live surgery session. Over to you, sir.
Thank you so much, ma'am. Am I audible?
Yes.
Yeah.
Yes, sir.
Yes. Yeah. My talk is on Ion Optics. That's managing expectations, aberrations, and decentrations. See, talking about patient satisfaction, improving visual quality and managing patient expectations are two key factors in getting a satisfied patient. And more so today with the newer and newer kind of premium lenses coming in and so much hype about counseling about the fine vision. But the higher order aberrations play an important role in the retinal image quality. Talking about the sources of aberrations, corneal irregularities due to corneal scar and arcade cuts can cause image distortion, and pupil decentration, lens coloboma, IOL tilt, and IOL decentrations are other causes of image distortion. Now, this was a case, a young boy, 12, 13 years old, came with a severe trauma that caused severe, traumatic vitreosis, vitreous disturbance, quite an amount of lens subluxation, with the injury causing trauma to his macula. In the times that he came, it was treated in the best possible way. At that time, he was treated with, the Ahmed segment that I was, I think, I used Sionis ring here, and it was fixed. But in those days, we weren't aware of, the Tenno causing problem. So Tenno suture was used, and this was some 10 or 11 years back. But at the end of it, at the end of the surgery, he did have well-centered lens, but there was nothing that was done for his pupil. Subsequently, when he came and I advised him, he was not very keen on going for that. And 12 years later, like last year he came with that suture giving way, and the lens had dislocated, subluxated anteriorly. It had decentered, and I could see the broken suture. Now, this was an opportunity for me to decide whether I use the same Sionis ring or do an IOL exchange. But thinking of fixing that with a nano suture, I thought would work, and luckily for me, I could thread in the suture through that eyelet and fixed it. And at the end of that, I was also able to get his pupil to the center with a pupilloplasty, and his glare, and most importantly, the visual acuity also improved. And now he was, the vision was quite satisfactory. Sometimes it is not necessary that the trauma has to be big enough or a forceful enough to give you traumatic subluxation. Now, this man came with a history of holding his grandson, and he just hit him, the grandson, 2 years old, just hit him on his eye, and he had superotemporal trauma to his zonules, and the entire lens capsular bag, it dislocated anteriorly. With that, his vision, corrected vision, did improve to 612, but it was of a very poor quality because of severe coma and trefoil. So the only way to fix it was to see if I could fix this lens. And the first attempt, our difficulty was to create a space between the capsule and the optics, because that was the only hope for me to fix the lens. It was a single piece. The second choice for me was to fix the haptic, but I felt this would probably be a better option. And once you get a space, you can always use and inject some viscoelastic and use a technique of your choice. First, I needed this space so that I could fix the bag with the hooks, and then I created the flap. And the obvious next option was to decide which particular device I would like to use. And since my choice was the ASIA's anchor, and this is a very nice paper clip-like one. Unlike a AMOS segment, it is in one plane. So when you fix it, it stays there, and the pupil or the iris can slide over it without any obstruction. So, and the other advantage is you don't have to enlarge your main opening, because it can go through 2.45 millimeter. But it just needs to be, you need to be a little tricky, because you have to hold it with the forceps and then tuck it into the rhexis, or from both sides, with both the pillars need to be tucked in. And once it is tucked in, you can always loosen up your hooks and fix it in place. And it stays in the same plane without tilting the lens. You have a choice to either use Hoffman's pocket or a regular scleral flap. And with this, the lens is back into its position, and the visual recovery is more or less back to what it was pre-op. This was the next case, a patient who had this congenital lens coloboma that was there all the time, and gradually his vision started deteriorating to the extent that it was in one eye 660 with -20, and in the other eye it was 624 with -10. And this particular eye had, if you looked at his eye trace, it shows you a major amount of trefoil and tetrafoil, whereas his cornea was fairly clear. So this was one indication for me to go in for a surgery earlier, although the lens was clear, because he needed surgery for his visual rehab. There was nothing uneventful in the surgery, except that at the end of nucleus removal and cortical cleanup, I had to use an endocapsular ring and get the lens back, because there was no phacodonesis. So there was no need for me to use anything else to fix the back. Once the endocapsular ring was put, the thing was back in place. And surprisingly, if you looked at the pre-op and the post-op, literally all the parameters had come back to normal, including the MTF curve and the internal aberrations. So this was a very satisfactory result. And finally, in this case, this patient came with a history of a corneal tear in the childhood, and where a lot of tissue was lost. And when she came as a 23-year-old girl for visual rehab, I had a strong desire to help her improve her visual quality if possible. But I knew well that after long-standing trauma of this kind, sometimes a capsular bag loses its normal shape. It tends to become a little shorter than before in its circumference. But however, there was nothing lost in trying out. So at the end of doing the normal surgery, my main challenge was, how do I cover up for that pupillary defect, because the amount of tissue lost was huge. So conventionally, pupilloplasty was not possible in this because I couldn't really get that tissue close together. So I had to think little out of the box, and I went with the micro scissors, and at the root of the iris, I tried to make 2 nicks. That gave me some space to work and get the pupil, because my desire was to, at the end of the surgery, at least give her a small circular pupil, even if there's a small defect at the periphery, because that defect she has lived with, and that, the glare doesn't really bother her. But I want to get her visual axis to the center, hoping that it would help her improve her visual acuity. And it did improve. And I was, very happy with the result. So was the patient. So these were a few things I thought I would share with you. And that's it. So I think for want of time, I would like to cut it here. So in the conclusion, patient satisfaction can be greatly enhanced by paying attention to all the doable measures, using modern diagnostic and therapeutic measures at our disposal. And with this, I would like to thank DOS and Dr. Namrata for giving me this opportunity to be here and share my views. Thank you so much.
Thank you so much, sir. Thank you for taking us through managing expectations, decentrations, and aberrations as far as the patients are concerned. I think we'll move to the next talk, and the next talk is going to be by Dr. Kudlu. Trifocals are the way to go. We have Dr. Gaurav Luthra after this. Has he joined?
Yes, Namrata, I'm here.
Okay, okay. And Dr. Swapna Nair?
Yes, ma'am, she's also here.
Okay, okay. So
Thank you, madam. Can you see my slides?
Yeah, we can.
Yeah.
Yes.
Yeah.
Good morning, Kudlu.
Yeah, good morning, sir. Some of my slides are not moving. I'm just, you could able to see, my slides.
We can see financial disclosure.
Yeah, but it's not moving only. I don't know. So suddenly,
press the arrow on the left.
Yeah. Thank you so much, Namrata madam, for this wonderful.
Mohan Rajan is our guide now to whosoever has AV problems.
And I apologize for I could not able to participate in the live surgery because of my health issues, madam. So as we all know that a natural crystalline lens has got a good accommodation, clear vision at all distance, and in clear vision in all lighting condition with a great contrast sensitivity. These are the few options for presbyopia. You got a lens procedures, corneal procedure, and sclerosclerosis complex modification you can do. So few words about diffractive IOL, which is now most of us not been doing this. So basically it utilizes the principle of diffraction in conjunction with the interference to create more than one foci. So nowadays most of the intraocular lenses comes in the diffractive platform. What exactly the principle is? Diffraction is bending of light when it hits an obstruction, where the plane wave is transferred into the spherical wave. Spherical wave propagation from different points lead to wave interference. So constructive interference due to parallel phase relation result in a new wave. So normally what happens, the higher the grating density, stronger the angle of light. So if you have more rings are placed on the lens surface, the higher is the add power. See, you can see in this picture, shorter the width, higher the add power, wider the width, longer the add power. So if you have got a +4 add on the lens, that means it is almost around 3 plus 3.8 spectacle plane. If it is +3 means it's +2.25 on the spectacle plane. So these are the few limitations of the multifocal, because sometimes these older lens had the pupil dependency. There is an increased glare and halos. But nowadays, I think every patient need to have this intermediate vision, because of especially most of us are good drivers and computer professionals. So that's where this trifocals comes on into the play. So this is what the trifocal, normally the design, it has got a mix and match of both smaller and the bigger edges, wedges, what I have explained before. So today this is my main talk about the trifocal 839 MP. Here it has got a near addition of +3.3 for reading distance and intermediate addition of +1.6 diopters for the intermediate vision. So this lens will have a both distance, intermediate and the near vision. Because of this quality, there is a reduced potential visual disturbance and also improved night vision. So the one more, the property of this lens, light transmission rate is almost around 85.7% because of this smooth microphase optic design that results in an ideal optical image quality and reduced light scattering. So because of this one, the SMP technology, most of the patient will have a spectacle independence, light distribution you can see in the graph, equal for distance, intermediate and near. So normally you'll have a good night driving and even reading in the low vision. The one more advantage of this lens, it has got a 360-degree anti-PCO on the posterior surface of the lens that reduces the PCO formation like any other hydrophilic intraocular lens. This is the comparative study between the AT-LISA Tri-839 with the other apodized bifocal intraocular with the trifocal of some other brand. So if you can see in the pupil size of 3 mm and 4.5 mm, still how the lens behave as far as the distance vision is concerned, even in the poor lighting condition at even 3 mm pupil also, the vision always improves. When you see at the all distance, if you look at the far, intermediate and near, the lens behave really well. Now coming to the loading system, this is what I think this is one of my favorite loading system. It's called a Bluemix loading injecting system, preloaded. Once we open the cartridge, you have to pick the lens and all direction will be given by the company, how exactly plug into the slot, go into the slot, just press it, you will hear a click sound, then you just remove. I think I had implanted more than 1,000 lenses in the same Bluemix injecting platform system. I never had a single lens has been cracked or it has been torn. This is the advantage with this Bluemix injecting system. See, why I'm just telling you, most of the time we do a good surgery, something happens while injecting the lens, I think you have to cry on the table. See, this is what I'm just showing you this video. See, after the good phacoemulsification, suddenly pupil, in spite of injecting a Phenocane plus, still pupil has been constricted here. Still you could be able to see that how nicely lens is going inside the bag. This is what I just wanted to show you the advantage of these lenses. So this is about our lens of trifocal implanted in around 76 patient, 132, mean age is around 58 years and follow-up has done for 3 years. So you can see the uncorrected visual acuity to the best corrected visual acuity. What I just wanted to see that at from the pre-op, see 1 month post-op, 3 months follow-up to 3 years follow-up, the stability of the lens and the overall, how much of the spherical equivalent is remaining, which is almost next to zero. So if you see even in the logMAR scale about the intermediate vision, the patient's eye is doing really well even end of the 3 years. Even up to the near vision also, most of my patient doesn't require to wear the glass for near vision. If you see the defocus curve also not exactly sharp, you could be able to see a curved defocus curve so that the patient did not have that much night glare and halos. Of course, if you think about how much, I asked the patient questionnaires because we have been doing some small study for the eyes. See, only 20% of the patient little bit complaining of glare and only 5% of the patient really bothersome. So coming to the spectacle, 94% of the patient doesn't really require to wear the glass. Only 6% of the patient may require for a very smaller print. This is about our, once again, we implanted more than 0.75 cylindrical power. We always tell the patient to go for a toric lenses because of the quality of the vision. We have done for a big number of, these are our studies. This is about the uncorrected and the best corrected visual equivalent. But this is what the preoperative refractive astigmatism you could able to see 23% is most of the patient was around between 1 to 1.5 cylinder, one few percentage within 23%. But post-operative you could able to see only 2% had a patients with a very minimum residual astigmatism is remaining. But very important, more than 95% of the patient had a refractive astigmatism less than 0.5 diopter. In conclusion, trifocal intraocular lens implantation can perform by any cataract surgeon who is aware of the principles of the refractive surgery and handles precise IOL lens power calculation. AT laser TRI demonstrated excellent functional vision at distance, intermediate, near in all our clinical evaluation. Almost all patients enjoyed spectacle independence after AT laser TRI implantation in this clinical evaluation. Once again, I thank you, Namrata Madam, this wonderful opportunity. Thank you, Madam.
Thank you, Dr. Kudlu. Thank you so much. I think because for the want of time, I would now request Dr. Gaurav Luthra to finish his next talk in exactly 7 minutes, hydrojet polishing for PC plaques.
Less than that, Namrata. Thank you so much. So I just wanted to share, a few techniques of how I've been trying to manage these PC plaques over the years. And this is a short video where sometimes, all of us do come across these and we all have our own favorite polishers. Now, as over the years, I realized that, here you'll see that this is just an infusion, bimanual infusion. And all I'm doing is going through the main port so that the fluid flows really fast. And with that jet of fluid, you can obviously do this with a syringe and a cannula as well. But here you will get a really fast flow of fluid, especially with the Centurion systems or, high bottle heights where the pressure infusion is pressured. So, it typically you are pushing the PC away. And at the same time, you're trying to kind of use the jet of fluid to loosen out all those resistant capsules rather than go and polish them with a sandblasted cannula where you may catch the PC, especially in vitrectomized eyes where plaques are very common. The capsule is very friable and if you touch them, sometimes they'll just break. So here you can just use this technique to polish them off and comes out really well. Let's see another situation and I'll bring you to the grand finale towards the end. Now, these are high myopic eyes. Sometimes they will have these really resistant plaques which won't come off very easily. So you can go and loosen them again. Now, the newer kind of bimanuals that I've designed are also very finely sandblasted. So you will have the dual benefit of having a very, very fine sandblasting and infusion running continuously. So when the infusion is running, it sets up a very nice hydrojet. That's what I like to call it. And I've improvised this technique to polish off the anterior capsule posterior surface as well. And if there is resistant cortex stuck in the equator of the capsular bag, that gets loosened very nicely too, and then you have a very clean PC. So it takes only a few seconds and works really well. The main trick is not to go from the side port, but from the main port so that you can have better control over that. And you have a fast flowing system. And now there's another patient here. Sometimes they will not really come off with that jet, and then you can do this. I call it nibbling the PC, very gently holding onto the PC and kind of vacuuming it. And you can see here that with a very fine control of the foot pedal, you can actually go and kind of, hold it gently like between your teeth and then kind of go all along it. And that also helps in clearing of these PCs very well. And you can see here that this is getting cleaned up. So obviously this requires a lot of good control and you can go into the polishing mode. I personally don't switch to the polishing mode. I just use my usual mode and just very gentle control on the foot pedal, but you end up with a very, very clean PC like this as well. And yes, it is reproducible. I have been doing this for many years. Of course, it requires a surgeon to be very cautious and skilled at trying to do this. And at the end of the case, you will have a nice clean PC as it looks there. And I've removed 2 videos because I know we are all short of time, and I'm bringing you to the last one, which has a few learning points. And this was a black cataract planned for a toric IOL, and it was subluxated. So we had to put in capsular hooks, and it's a very hard cataract. It's a vitrectomized eye. And so these are very, very challenging because the capsule is very friable, and being subluxated, I had to put capsular hooks, and the capsule was ready to give way at the slightest touch. And very hard cataracts require a lot of patience. So at the end of the nucleus removal, as over here, we were left with a situation which was more like this: very dense PC plaques, and there's a central plaque and a lot of cortex very nicely stuck all over. And then I had to go and try to remove that. You have to be very patient because they are sometimes very adherent, as you can see, and the capsular bag is ready to give way. It'll either break or subluxate bigger. You'll end up catching the capsule trying to polish it. So here, while we are trying to do this, you can see the conventional way of trying to peel it, but it seems to be troubling me a lot. So you can see I'm catching the capsule at many points. So I decide to switch to my other technique, which I normally would choose whenever I'm in a situation like this. And I'll change hands now and go and do a jet hydro polish of the remaining. I've managed to clear off 2 clockers, but there's lots that remains. So I'm going from the main port, running the infusion, and I have this sandblasted bimanual handpiece, which again has been designed by me. And we can just go and do a hydro polishing. You can see that there is no chance of breaking the PC unless you want to really poke it, because the PC is constantly pushed away by the flow of fluid, which is really fast. So you can go polish it as much as you want, as long as you don't really want to push your cannula through it. It'll loosen up everything. It'll loosen up all the PC plaques. You can go to the equator and loosen up. Now you can see that everything is much looser, and I can now switch my hands and go and remove them effortlessly. You saw me struggling in the previous part of the surgery where I was trying to remove this. And now I'm much easier. I can just go, it becomes a breeze. Of course, that central thing will not go away because it's a plaque, and I'll show you how that can be done as well, because now I have to remove that. And these are very tightly adherent. I go in with the microrhexis forceps from the side port, and you have to find leverage somewhere and then see if you can peel them. So I'm peeling that plaque. Of course, it's always very risky because at some point, sometimes it'll just be so adherent that it'll break. So you have to be careful you don't break the PC, else you are in a bigger situation of having to make a primary posterior rhexis. So here you have to be very gentle, hold it from different areas and tug on it and see where it gives. And also the pressures have to, you neither have too much viscoelastic nor too little. Otherwise, if it's too much, then you'll push it back. So now I have to change my hand and change the axis. And now I'm going from main port because this part was not coming off from the place where I was trying to access it. You can see the PC being very, very loose and friable. And at this point, I'm kind of being very careful that I don't break the PC. And here I was able to peel it off. And once that thing peels off, then you can breathe a sigh of relief and remove the rest of the cortex with that same technique that I was showing you. In the end, this surgery looks pretty good, and this is how it looks in the end. And I think I'll stop here. I won't be showing you any more videos because I want the session to finish on time. I think the message is clear.
Thank you, Gaurav. I think those were excellent videos. And now I would request last talk, Swapna Nair, new situational challenges in flax. So thank you, Swapna, for being there, and we are looking forward to your talk.
Thank you, ma'am. I would like to thank Namrata ma'am and DOS for having me here. So I'll just start with my presentation. So I'll be talking about situational challenges that you face, especially when you do flax. I hope my screen is visible and I'm quite audible to everyone. Yeah. So now I have basically divided this into the challenges you face in flax, specifically when you do corneal incisions, capsulotomies, nucleotomies, and regarding the pupil size. So you can see here that after the capsulotomy and lensectomy, there are quite a few bubbles in the anterior chamber over there. And as the corneal incision is moving on, you can see that a small bubble over here attached to the incision keeps on expanding. So now the first point is to realize that this bubble does not lie in the anterior chamber. And we often see such bubbles through, coming out through the side ports also when incisions are done. So what happens in this case? I mean, I was unaware of the significance of that bubble at that time because I thought that like all other small bubbles, it would go off too. Once the procedure goes on, all is fine, and I keep on injecting viscoelastic because I felt that somehow it was not as stable as I would like it to be. And I was pretty unaware of the entire situation till I actually went back to the video, and so I'm able to explain what happened here. So as the lensectomy proceeds, as the phacoemulsification proceeds, it's all fine. But as the needle moves to one part to aspirate the cortex, that you'll see now, as it goes to the right to aspirate the cortex, you can see a fine line that appears along the cornea there. So that is one when I started, I got alert, and still I just continued with the surgery. And following the insertion of the lens, I could see a small arcuate mark over the cornea in the red reflex. So now what happened was that the next day, of course, the patient presented with corneal edema because around half of her Descemet's membrane was off. The bubble was actually formed between the stroma and the Descemet's, because of which it had got caught in the needle and torn off. But fortunately for me, as I waited, this behaved like a Descemetorrhexis without endothelial keratoplasty, and the patient got back 6 vision. But that gap you see where the Descemet's was torn off, it always remains different from the rest of the cornea. Now, coming to capsulorhexis, we are all aware of how a freely floating capsulorhexis is a hallmark of all types of femtosecond assisted cataract surgeries. But coming to incomplete rhexis. Now, you realize there's an incomplete rhexis when there is air bubble in the interface. Secondly, capsular movement in case of fluid cortex sometimes causes the capsule to undulate and the laser, and to go beyond the range of the laser. That's when you get an incomplete capsulorhexis along with eye movements or suction loss. Now, what you should note are the presence of laser marks on the attached capsule, because when you are completing such a capsulorhexis, besides being careful that you don't pull the capsule to the periphery, you also should be able to bring those lasered part of the capsule into the flap that you're going to remove. So that is one important aspect that I'd like to stress on for beginners. Now, coming to the hydrodissection part, what I found most important is that you'll find various kinds of bubbles trapped inside. Most of the air usually comes out as soon as a little gush of fluid or maybe just a mere movement of the hydrocannula happens. But sometimes you can have only partial air escape, and there is some air left behind that can happen once you start cleaving the lens along its planes. But sometimes whatever you do, the air remains trapped there. Movement of the lens does not bring the air out, and that is where you need to make sure that you are careful and you're not trying to damage the posterior capsule by applying too much pressure. Coming to pupil size, some people find a way around dealing with the pupil size by clearly explaining to the patient at the beginning that they'll be making only corneal incisions using the femtosecond laser and not going ahead with either the capsulotomy or the pupilotomy. So that is, the lensectomy. So that is one way. Another way is to readjust the rhexis size. I have adjusted it to around 4.3, but I don't go beyond that, because then softening of the lens with the nucleotomy becomes hard because you're working in a very limited area. Another thing to note is that sometimes when the pupil happens to constrict during the procedure, you may get a small iris hit. Now that may produce a little bit of hemorrhage, but it goes off by itself because the chamber remains pressured till you open the incisions. But sometimes the rhexis under that region of the iris may be incomplete. So you need to have extra care over there and make sure that you complete the rhexis. So be aware of that when you are dealing with a small pupil. Coming to nucleotomy, the posterior offset I have found is most important, especially lenses can vary in thickness. And depending on the posterior offset is when the depth to which the laser penetrates. So I usually keep it 500. Earlier it was 800, but now I've reduced it to 500. But sometimes it needs to be varied in a thicker lens so that you can prevent a posterior plate from forming, which prevents the lens particles from coming into the phaco tip very easily. And there's always that shelf that you need to roll off and then phaco before you can deal with the nucleus in entirety and go on to the cortex. So that was all that I wanted to stress regarding the special situations that you face when you deal with flax. Thank you very much.
Thank you very much, ma'am. Just one request, Dr. Namrata ma'am, you're requested in Hall N. वहाँ पर आपको बुलाया जा रहा है.
I will. Now, can we have the concluding remarks from our chairpersons, Dr. Tetial sir and Dr. Ramamurthy, please, and we'll close this for the next.
Yes, ma'am. Thank you.
Yeah, thank you, Namrata. It was a wonderful session. I think the presentations were of a quality which I think the audience will always look forward to, looking the list of experts who were in this particular session. And each talk was wonderfully presented, and discussion was very, very useful, not only for our audience, for us also. We have picked up so many points. And I again like to stress my sincere thanks and congratulations to DOS people, and especially seeing Sanjay sitting there on the dais with a lot of enthusiasm, and you can say the requirement of physical meeting with friends, which I think we all desire.
Sir,
Hopefully, we'll have much more.
We are
Thank
missing
you again.
you here, sir.
I was about to say that we are missing you.
We are missing you here.
Because after a long time, we are really looking forward to getting together physically, chit chat, see the fun of a conference, which all the ophthalmologists are missing now.
And Dr. Sanjay wants to congratulate you physically for becoming the chief of RP Center.
I also want to congratulate you. Sir,
Congratulations, Titiyal sir. Congratulations, Titiyal sir.
Thank you very much.
Congrats from all the entire South India for you.
Thank you so much, everyone. Thank you, Dr.
Congratulations, sir. Congratulations.
Dr. Ramamurthy is there? I think he's there.
I
Okay.
think-
Thank you. Thank you, everyone. We move to the next.
Excellent job.
Thank you so
DOS
much.
team. And
With this, we
congratulations, Titiyal
move.
sir.
Thank you.
With this, we move to our next session. For the next session, we have a chief instructor, Dr. Atul Kumar. We have a co-instructor, Dr. Harpreet Kaur Narde. We've got Dr. Mangat Dogra as well. We've also got Dr. Atul Kumar as a co-instructor. We've got Dr. Parijat Chandra, Dr. Vishali Gupta, and Dr. Rohan Chawla. Over to the chief instructor, Dr. Atul Kumar.
Thank you. And I would like to share with my speakers that unfortunately we've got the session over 15 minutes late, for which I should not be blamed, and I request your pardon for that. And also the people who are trying to watch into the retina session, I just request that future organizers should make sure that the sessions end on time and the next session starts on time. And we will ensure that though we are short by more than 15 minutes, we will finish on time.
Thank you so much, sir. Sir, would you need my assistance to help you remind just at 10 minutes?
Yes, I would need your assistance.
Sure. All right, sir. Thank you.
Just to help me keep the time.
Yes, sir. We'll do that.
This is the retina grand rounds which we tend to have, because this kind of covers a whole gamut of eye disorders which are important. And with speakers no less than Professor Mangat Dogra, Professor Vishali, and of course the RPC team, and Professor Harpreet Kaur Narde. She's a topper from MAMC, and then she topped her MD and then her SR-ship, and she's a budding and a very highly acclaimed vitreoretinal specialist and surgeon, very hardworking. So I would really like to have this team is really good, and this will give you some insight into various disorders. So before wasting any time, I just want to say one thing, that we've just launched this book before, because we're going to have Dr. Vishali speak first, because she's got to go for some friends' father's prayer meeting. So this Retina Medical and Surgical Management book is a 2022 edition. It's got a full latest innovations, the latest in retina as well as medical and surgical management, with flow charts to make it simplified for postgraduates. For ophthalmologists, they can just keep it as a desk book. It's a single volume, and unlike other books, you don't have to have multiple volumes, and there's a lot of pictorial, our own pictures, our own patients who had various diseases. So we've tried to make it as original as possible. Everything we've written is our own. And with this, Shunji Kusaka, my good friend from Japan, as there are a lot of retinal disorders in Japan, he has written the foreword and guided me also in writing the book, the first edition. So this is the second edition, which has just been launched. So with this, I'll ask Professor, there'll be a slight change. Professor Vishali has to leave. And so I will close my screen and stop sharing. And I request Professor Vishali to please share.
Thank you, sir, for the kind opportunity. And it's always a pleasure to be a part of your grand rounds, which are so well thought of, covering the entire spectrum of retinal diseases. The topic sir has given me is about macular choroiditis and how do you go about it. So macular choroiditis, as I can show you, these are the three diseases. The top one is classical MP. Middle one is serpiginous-like choroiditis, tuberculosis, and bottom line is syphilis. So when we look at it, there is sometimes a lot of confusion differentiating something non-infective like AMP from infections like serpiginous-like choroiditis or syphilis. So how do we approach the patient? The key is in the pattern recognition, and there are these 9 steps that I generally follow in my practice, and they really work. The first is to see whether it is choroiditis or retinochoroiditis. You look, is there any associate involvement of optic nerve head, retinal vessels? Are there any clinical features which fit into any known infective or non-infective entities? Look for other associated anterior segment inflammation, vitritis, scleritis, unilateral, bilateral, unifocal, multifocal, associated with systemic features or not, recurrent, what was the past episode like? And finally, if you are not going in the right direction, just look whether it is responding the way you want a particular disease to respond. This is just an example of one such patient who came to us. And when you look at this diffuse kind of retinochoroiditis, mostly involving the outer retina and maybe choroid. So when we looked at this, so like it was vitritis, immunocompetent patient, unilateral, and you look at this kind of presentation, you have quite a few differentials in mind. But what is important is most of these patients will be carrying a huge file with them, and somehow you really do not feel you have a time to look into the records. But when you look into the records, it's sometimes extremely important. This was his first presentation. So this was a very clear-cut case of toxo, because if we look at the phenotype here, it is retinitis and it's kind of headlight in fog. So there is nothing which suggests of choroiditis, but unfortunately it was diagnosed as choroiditis, treated like this, and eventually, he even had toxocyst in his vitreous because we did vitreous biopsy before we could see his original pictures. And you can see that something which had a potential for good vision, the young patient lost vision because we could not diagnose a retinitis from choroiditis or infective from non-infective. Another example of a non-infective variety is serpiginous choroiditis, and there is always an eternal debate that how do you differentiate serpiginous choroiditis, which is autoimmune, from serpiginous-like choroiditis, which may be associated with tuberculosis. Now, the classical serpiginous-like choroiditis, as you can see, begins from the optic disc. It is a single lesion with pseudopodia-like presentation, and if you look at the edges of the pseudopodia, there is disease activity. And this is how it heals with the exposure of underlying choriocapillaries and large choroidal vessels. Now, if you see a phenotype like this and the progression, this is a single plaque of the lesion. You don't see multiple lesions coming here and there. This is typically the autoimmune variety of serpiginous choroiditis. Serpiginous-like choroiditis, the name came because when the lesions heal, it resembles serpiginous-like choroiditis. But when you see the lesion presenting for the first time, it's quite different. It would have multifocality. It would have the center which is healing and the periphery which is progressing. Unilaterality, and very important, you may have some associated conditions like scleritis, which never happen, uveitis, anterior inflammation, which does not happen in classic variety of autoimmune serpiginous choroiditis. So Of course, these are the patients where we do test for TB. This patient was positive, quantiferon, Montus, and even the EBUS from hilar lymph nodes was positive for TB, and he was managed, and you can see the response to therapy. So what are the key points? Serpiginous is bilateral, TB is unilateral. Serpiginous autoimmune variety doesn't have associated inflammation in the vitreous or anterior segment, while TB would have. These lesions of serpiginous begin in the juxtapapillary area, whereas serpiginous-like begins in the posterior pole. And very key point is multifocality of serpiginous-like choroiditis. It's not only TB, we may have viral VZV, very rarely presenting like this and responding to antiviral, or syphilis, producing placoid lesion, which can be confused with serpiginous choroiditis. So always be on the lookout of these infections because they do get worse if the steroids are started empirically. So wherever we see serpiginous-like choroiditis, always investigate to rule out possible infections. Not only serpiginous-like, sometimes multifocal choroiditis could also give you surprises. So it's important always to look for infective etiologies. For example, this lady presented with features, peripapillary disc swelling, some fluid, and some spots in the periphery. And I thought we were dealing with sympathetic ophthalmia because she had trauma to the opposite eye. So we did the fluorescein, nothing very conclusive of either sympathetic ophthalmia or any other disease. So there was disc edema, there was some leakage and some spots in the periphery. Most of the investigations were negative and we thought there was probably a juxtapapillary membrane lying there. We started treating her for sympathetic ophthalmia, some initial response, and then she started progressing. So this is my last advice, that if the patient you thought was non-infective is not responding the way you think patient should respond, always take a break and re-investigate, because sure enough, you are missing some infective etiology. So this is what we repeated everything. And, we did a lot of investigations, but eventually we removed the blind eye, which showed AFB lying there. And finally, this patient responding to anti-TB drugs. So my last slide, if you see choroiditis, just look what is the type of choroiditis. Is it diffuse or multifocal? If it is diffuse, is it primarily involving retina, retinochoroiditis, or is it serpiginous choroiditis? If it is retinochoroiditis, always rule out toxo and viral. Viral tends to be more diffuse than toxo. If it is diffuse choroiditis, it can be serpiginous, which can be autoimmune or which can be infective, mostly TB, but syphilis and others can also present. I have already told you the differences between the autoimmune and infective variety of serpiginous. If it is multifocal to begin with, we have some very classical phenotypes, which I did not touch upon because they're very classic, like PIC, Mutes, AMPI. So if you look at them, you know the diagnosis, you really do not have to investigate all of them. But if the patient is not responding to whatever treatment you are giving for non-infectious etiology, it is better to investigate. But anytime you see atypical phenotype of multifocal choroiditis, it's always better to investigate. Thank you very much. And thank you once again to Professor Atul Kumar for accommodating me at the beginning of the session and giving me the opportunity to speak.
Dr. Atul? I believe we have lost connectivity, I guess. Nonetheless, thank you so much, Dr. Vishali, for finishing it in time. I did not get an opportunity to interrupt. Thank you so much, ma'am. Can I
I
have?
just wanted to ask, can I?
Yes,
interrupt?
yes, sir.
Okay, so Professor Vishali is here and she has to leave. So I'd like that the audience not to hesitate and anybody to ask questions soon after every talk, because we tend to forget the talks in the end and we take a laid back attitude by that time. So the talk is fresh in our mind, and I would like to request residents or from anywhere, any part of the country, or any ophthalmologist, if he has any queries, or any of the panelists, because Professor Vishali is an international figure in uveitis, the international terminology of uveitis has recently been, she's one of the board members, and so she holds high position, as well as the experience and knowledge which she has is unmatched. So I would ask juniors to take this advantage and brush up and improve their knowledge. If they have anything to ask, they can.
Sir, it would take some time, and as sir rightly said, ask questions. Could you just put it in the chat box and it would come popping up to us? But to save time, can I request sir to please invite our next speaker? And as the questions come up, it would be in the chat box, sir.
Yeah, but we need to, ask Professor Vishali for the answers. We don't want to interrupt the talk. The talk gets interrupted if the question answer session is not there. Because I have 1.5 hours, talks are short and we have very few speakers. I would like that the question answer is done right now, even if it's for 2 minutes or 5 minutes.
No problem.
So can I comment, sir?
Yes.
Thank you, ma'am. Thank you for a wonderful talk. And I think, ma'am, what you have stressed for the residents and other beginners in uveitis, most important that you must differentiate between a retinitis and choroiditis. And if you are not seeing that your case is responding the way you should always think of some other diagnosis and rework up the case. Ma'am, can you comment something about when do you think of masquerades?
Yeah, masquerades, I always think of one, if it is the extremes of the age, very young child, or a very old person, mostly after the age of, 70s and all. So that's the time you think of masquerade. Secondly, I think of masquerade, for example, if I have a hypopyon in the anterior chamber without fibrin, and there is not much KPs, and just those cells look bigger to me. And when I do retroillumination, the cells are not WBCs. They somehow tend to be clumping and they look bigger than the usual. And third is anything which is not fitting the bill, something which I do not understand, which seems atypical. Those are the three conditions I suspect masquerade, and I'm not including metastasis here because that has a very distinct features on its own. But whenever we suspect masquerades, then without wasting much time on investigations, I generally like to do vitreous biopsy, sometimes just as the first line of investigation, because it gives me, especially we are seeing a huge rise in the number of lymphoma patients. I don't know why, but we like to do IL-6-10 ratio, mid-88, and I do not want to expose them to steroids while waiting for biopsy. And I do not also want to withhold steroids in case it is not lymphoma. So I generally do vitrectomy or vitreous biopsy in treatment-naive patient whenever I'm suspecting lymphomas.
Thank you, ma'am. Thank you.
Thank you. We'll go on to our next speaker while the questions are being collected. And Harpreet Kaur, she was a senior resident at RP Center. Now she's joined me in my new setup, which is primarily a retina center. And Harpreet is a very well-versed. She's done her SRship and she's going to talk about the role of OCT and OCTA in this ever-changing world of retina. And with you seeing a whole lot of imaging, the first thing is in retina is to now understand the imaging. And Harpreet will tell you about OCT and OCTA, the two giants now coming in. FA, fluorescein was always there since the 60s, and ICG also came and went and again came, but it's got limited role. But OCT, OCTA improves the workflow in any
center or a hospital, and it's just that patients don't like invasive procedures now. They like more non-invasive, and they're very happy with the OCTA. Often the renal functions are impaired, diabetic, and so often I've been seeing it in the last 35 years. So they prefer a OCTA where they got a cardiac stent, they've got many anti-cardiac drugs. So we tend to hold our hand for doing any invasive procedure, lest it leads to some complication. So she's going to talk about very important OCTA in retinal disorders.
Good morning, everyone. Congratulations to. Am I audible?
Yes, ma'am. Could you start your screen sharing?
I've started it, sir. Is it not visible?
No, it's not visible to us.
I think there's some problem.
Can we request the next speaker?
Nikhil, it says Harpreet Kaur sharing computer sound. So please help her. She's not able to share the video.
Yeah, so she needs to stop the screen sharing. Let me try and do that. Dr. Harpreet, could you
Yeah.
Yeah. Start the screen sharing again, please? Again, just try once again. In the meanwhile, can I request till we iron out the issues? Dr. Atul, with your permission and your guidance, can we have the next speaker, which is you? Maybe if
Okay,
you
Harpreet, just get this in, everything's corrected, and please help her, and she can.
Yes, sir.
Do the. In the meantime, I'll just quickly finish my talk.
Yes, sir.
And
Okay, sir.
Dr. Atul, yes, we can see your screen.
so I'm going to start. Macular pathologies, the nuts, bolts, and pearls. So what are the various options we have, and what are the pearls which come out of those? Hard work brings out pearls, and that's what. So this is using the 3D screen, which I still use now. I shifted to a private center, but it's something which I'm addicted to, and so I use the Ingenuity 3D visual screen, and it's got for Polaroid glasses and passive Polaroid, and the 2 or 3 fellows which have joined have also to wear those glasses, and they also learn. And then this, I just want to tell you that the first macular pathology which I'd like to highlight is something which is very, very common in the US and in Japan and now in India, because we never had we used to do slit lamp biomicroscopy till a few years back, say about 10 years back. 10 years back, the slit lamp biomicroscopy actually does not give the contrast to pick up retinal detachments or even retinal schisis. So that was a big limitation. And then finally, when the OCT came, the time domain, the spectral domain, as they came on, the evolution, time domain was first. So now the swept source OCT, whatever said and done, now we have the TOPCon swept source OCT at my new center, and we do this very clear OCT, and there's you can see the inner retinal schisis over there, and the outer retinal schisis. And there's some cystic changes here. So this is a compound myopic retinal schisis. For most of the myopic patients, so this macular schisis is very important to see and follow up. And sometimes the macular schisis can form a hole, and when you get the hole, the retina may detach. So if the schisis is also increasing, then the vision's dropping, then also you need to do a surgery, which is center sparing. That means the center is spared, and the cortical vitreous and the hyaloid as well as the taut ILM tend to pull on the macula. So that time you do a center sparing, but when a hole develops, you've got to put the flaps on it. So this is one of those cases which came late to us, and there was a central myopic retina pathological myopia who probably in the history developed a MTM, myopic traction or myopic foveal schisis, and finally went on to hole formation and detachment. And then we did the surgery with flaps, and then patient did settle well. So this is showing center sparing. This is Shimada's work. We have to acknowledge the person who's done the work initially, and Shimada has done this work from Japan, and she advocates this is the posterior hyaloid, the thickened hyaloid, which is there often in these pathological myopathies, and you make sure that all the hyaloid layers are pulled off. Sometimes you have multiple layers. You can use a tricot to pull off the hyaloid layers, or you can use a suction of the cutter. But be very gentle that you don't get the retina in the port, and make sure that you can have a little perfluorocarbon liquid. There's no harm. It won't go subretinal. You just settle in the staphyloma. So after the hyaloid comes off, then you will start putting. And then you can inject the BBG under the PFCL, or you can do it direct injection. So see here, after the staining with the Brilliant Blue G made by Aurolab, which is very, very well, stains very well. And Aurolab is doing a great job on that. Thanks to Arvind. And so we do this peeling with the ILM forceps. And I have no proprietary interest in any of these things. And I just say that I've been using it for a long time, and I continue using it because I don't want to change my dyes and my instruments and everything. And that's because it affects the surgery, and also we've been used to certain things for many years. So I've continue using the same now in my center. And I have the facility for the Ingenuity as well as the IOCT. And so I make sure that the peeling is done, but the center is spared. And then we put in air, gas, and do interface vitrectomy just a little bit to relieve the traction in the periphery. And after that, the surgery is over. So in cases of epiretinal membrane, it's a big question mark whether to peel or not to peel. The grade 0, grade 1 may not be peeling, you may not peel, but grade 2 is when there's a lot of metamorphopsia. On the red-free photograph and or on-fast photograph, you'll see the amount of distortion here. And OCT, which actually tells you a lot of changes are apparent. The whole retina has been pulled up due to the tractional membrane, and therefore such patients are symptomatic. I always like to give them the grid, and once I give them the grid, they experience the metamorphopsia and they say that they are discomforted. So then we do surgery for them only if it's grade 2 and they are symptomatic. I hold my hand if they say they're not symptomatic. They say I can see the squares from the center white dot. Then I'd rather hold. I'd be conservative whether I'm here or anywhere else. So in the new center also, I'm very conservative when it comes to patients who are not asymptomatic, and the ERM appears that we can wait and watch, serial watch. So here this case, you can see the red, it's not so clear, but you can we have held the ERM from one side. It's better to peel the membrane in as larger sheet as possible, because the minute you start taking bits and pieces, will catch the nerve fiber layer. Once you catch the nerve fiber, there's a lot of scotomas and visual disturbance. And later on, patient comes to you from that he can't see well despite the surgery. It's because that we have kind of injured and damaged the nerve fiber layer. So try and just hold the ERM, not the retina. That I'm going to hold the retina near its edge and then peel. So that's ERM. So macular holes is another very important topic, and I'll soon finish. And it's generally said that traumatic holes close on their own, stage 1, no question. So stage 2 also, it's full thickness hole and the patient is having a positive Watt-Scallan sign, and the OCT shows again a very nice hole. So the OCT again, like OCT, OCTA, which we just here, Harpreet. And this is a case which came, I just wanted to show you this picture that she came from Calcutta and she had this hole, which is a little different. She had some turbidity in the subretinal space in the macula. So I thought probably we'd get investigated vasoproliferative tumor, VPT. So over here, so probably that was contributing to the CME and all that, led to some membrane formation and hole. So we treated this and made it absolutely dry. And then I did the surgery for her recently, and she's absolutely closed. The hole is well closed. And she's taken the train back. Of course, she's not flown, because once you have C3F8 gas inside, you would never, ever advise the patient to go by it. And so what a couple of 2 or 3 trips she's going to come by with a good Rajdhani connections. You can easily come from Cal. So this is a patient who has a myopic macular hole. I'm still going on with the macular holes. So this one video of macular hole I'm showing you that we injected the brilliant blue gel. I sometimes use perflucarbon liquid to steady the posterior pole. It's innocuous, and I use the Oro Octane again from Orolab, and thanks to the Aravind Eye Care system for having made available all these things to us. And you can see the blue stained ILM, which has now been kind of bunched, clumped over the hole. Because these myopic holes tend to open up until you don't close them well. So the IOCT guided hole closure on the Ingenuity. So the 3D surgery with the IOCT guided helps you. And then we always exchange with air and then with gas. So depending on the size of the hole and the severity of the case, we put SF6 or C3F, but I generally prefer C3F. This is the status of the hole. It was pre like that and myopic, and now it's post. So somehow C3F gives you a little extended tamponade. The last topic. So we got this cocktail of RTPA, Avastin, and air bubble into the submacular space. So generally works well, published. And so you can see on the ICG, you can see the polyps. This is submacular bleed. Usually submacular bleeds we see also today also. Yes, tomorrow I'm getting a case. So this is submacular bleed. So there's a lot of training and teaching which you can do, and you have a conference hall in our new center. And these submacular bleeds tend to have heavy blood, and there is some space over here. So in these kind of elevated submacular bleeds, no amount of Eylea and ranibizumabs or razumabs or eccentrics will work. So actually we become a little more extra, we become non-ophthalmic by talking more about these drugs, you know. We should just say that, is it going to work with anti-VEGF or will it work with a surgery? So this will work with surgery. Because the blood is extensive, it's literally covering large part of the macula and till the arcade. Second thing is the height of the hemorrhage is very high. It's very high. I'm talking about the subretinal hemorrhage, not over the sub-RPED. Sub-RP hemorrhage, we're not going to do anything. It may move a little bit, but not much. It does move a little bit, but it's a subretinal hemorrhage. So the ICG also showed us very active, huge polyps. And so we decided we have to give the RTPA here. Otherwise, it's not going to go in. It won't go in and affect the blood because it shears off the photoreceptors, cuts off the nutrition to the neurosensory retina. So it's taken as a relative emergency. That's what I feel. And this is a picture of last slide, which will finish in about a minute's time. And this will show exactly. Yeah, I'm finishing. This last video only. I didn't put in too much of theory because I'm suppose when you speak, you're actually speaking theory. So theory is like you speak orally, and whatever you present should be more pictorial and live, you know, videos and written material should be limited, because written material is something which is there in the books, there in our book also, medical and surgical. 6 of our top SRs contributed to it. Divya was my chief associate editor, and he contributed, and then Ayushi did a lot of work, and Aman did a lot of work, and Nawajish did a lot of work, and Harpreet did a lot of. So I'm very proud of my SRs, and I'd like to give them equal status for this equal position, and I hope they all do very well and train themselves very well. So this is the case. This is the case, same case. So you can sometimes get wonderful results. You could take the patient in the right. You could decide the right treatment. If you give anti-VEGF here, you're just going to fool the patient. Sham. It's like a sham treatment. You might as well give the injection, but give the patient false sense of that he's going to improve. But this kind of patients, the very large and very high bleed, I give a lot of importance to the height of the blood. And it's a high blood. Anti-VEGF may not help. It might help 5%, but finally the blood will organize. So now we can probably, these meetings are such that you can hardly ask questions. But Divya, would you like to say something? These are not question answer conferences. It's a one-way conference.
Good afternoon, sir.
Yes, good afternoon, Divya. I'd like to have your expert comments on this.
Sir, we have learned various macular surgeries from you, sir, under your guidance, and we have seen and we have
What's your
discussed.
independent opinion? What is
Sir,
your
my
independent?
opinion, sir, the kind of work which we are doing, like IOCT integrated IOCT, the IOCT guided ILM peeling, it has come a long way, sir, for the management of myopic traction maculopathy, and IOCT has got an immense role in the management of MTM. So basically, in cases of MTM, if the IOCT is there, we can always see whether there is any residual vitreous, or we can see the resolution of schisis after the peeling of ILM, and we can also we can also see if the contrast is poor, whether the flaps are there placed on the hole correctly or not. So IOCT,
Right.
integration of
Flaps are
IOCT
properly positioned over the
MTM
hole.
surgeries is very important.
We've just got Dr. Harpreet who's rejoined. Dr. Harpreet, could you just in the meanwhile try to share your screen? Yes, it is visible. Could you just go to the presentation now? On the right hand
So now
side,
we'll have
present button right next to the yellow color button, top right corner. Yes. Could you just press the present down, just down, just next to the share. Can you see the present button? Yes, you're good to go, sir. You're good to go, ma'am.
Thank you.
So we got to hear about the all important OCT and OCTA.
Dr. Harpreet, you'll have to mute yourself. You have to unmute yourself. Yes, now we can hear you. Go
Yes,
ahead.
I'm sure this book will be a great armamentarium to the field of retina. Starting with my presentation, I'll be talking about when to advise and how to interpret OCT and OCT angiography for the diagnosis and management of retinal pathologies. Swept source or optical coherence tomography is the latest milestone in retinal and choroidal imaging. OCT angiography adds on detailed information about retinal microvasculature. Swept source optical coherence tomography allows for simultaneous high-resolution imaging of the vitreous retina and the choroid, and it uses a longer wavelength and so allows for visualization of the macula, even in eyes with media haze. It allows for good imaging in undilated pupils. It allows for faster image acquisition and wider scans. OCT angiography works by detecting motion of RBCs against the static tissues, and it works on based on a decorrelation algorithm which allows for detection of movement of RBCs. Repeated B scans are taken to detect the motion of RBCs. OCT angiography scans vary from a size of 3 into 3 mm to scans as wide as 12 into 12 mm. Depending on the size of the lesion, we decide the size of the OCT scan. Coming to the clinical pictures, these are the clinical photographs of a diabetic patient with neovascularization present along the arcade, which is much better appreciated on the OCT angiography scan compared to when seen clinically. This is the other eye of the same patient with C-fan neovascularization along the superior arcade in this patient of proliferative diabetic retinopathy. This patient, who was following up with us for moderate NPDR with hard exudated macula, showed a very small lesion on OCT angiography. So OCT angiography is able to detect even very small lesions. So this lesion helped us to shift our focus from the hard exudates to the small neovascular lesion, and it showed us that there was a progression of diabetic retinopathy. This patient with superior temporal branch retinal vein occlusion showed extensive scapulary non-perfusion area, multiple collaterals, and small neovascular tissue, which indicated the need for laser. OCT angiography allows for segmentation and localization of a lesion into different layers of the retina, into superficial capillary plexus, deep capillary plexus, outer retinal layer, or the choriocapillaries. This segmentation is done automatically by using the OCT angiography software. But sometimes the automatic segmentation may not be able to pick up a lesion, and in those cases, we have to manually segment. Just like in this case, we were able to pick up a lesion on manual segmentation of OCT angiography. For neovascular AMD patients, we often can follow up the patient based on OCT and OCT angiography, which are enough to decide the course of treatment. And often FA and ICG can be avoided in such patients. This patient with submacular hemorrhage and some exudation present showed some subretinal fluid on OCT and CNV complex on OCT, showed a lacy pattern of branching vascular network on OCT angiography. This confirmed that there was disease activity present, and we went ahead and gave an anti-VEGF injection to the patient. On the angio-B scan, we can also appreciate the vascularity. The red signal indicates that the lesion was a high vascularity lesion. Also, OCT angiography can help us to differentiate between an active CNV complex from a scar tissue. This patient with neovascular AMD and a scar tissue showed no subretinal fluid on OCT and a dead tree appearance on OCT angiography. Also on the angio-B scan, there was no vascularity and no red signal appreciable, which confirmed a diagnosis of a scar tissue. However, there are few cases like this. In this case of submacular bleed in a neovascular AMD patient, there was clinically no activity. There was activity. There was submacular bleed present. On OCT, there was no subretinal fluid, just a fibrovascular PED on OCT. And on OCT angiography, there was a densely branching vascular network was noted. This branching vascular network was responsible for the bleeding in this patient. In such patients of clinically apparent scar tissue, OCTA is very useful, because if we see a densely branching vascular network on OCTA, it is better to give an anti-VEGF injection to avoid the risk of bleeding in such patients. This patient with a sharp peak PD and a double S sign and pachychoroid on OCT showed a lacy pattern of branching vascular network on OCTA, which confirmed a diagnosis of polypoidal choroidal vasculopathy. Branching vascular network is easily visible on OCT angiography because it is a high flow lesion. However, the other lesion of polypoidal choroidal vasculopathy, that is a polyp, is often not visible on OCT angiography because it is a low flow lesion. But in our practice, we have seen some cases with high flow polyps. Just like in this case, there was a polyp visible on OCT angiography, which we correlated with the ICG angiography scan. To summarize, OCT angiography is very useful in today's clinical practice. OCT angiography, being a non-invasive modality, help us to diagnose and follow up patients of retinal and choroidal vascular diseases. Thank you.
Thank you, Harpreet. That was a very nice, you really explained the OCT, the principles, the usage, and the beautiful pictures. You've shown the audience about how OCT and OCTA can be useful in present-day practice, retina work. Retina work really, you can do, the flow of the patients can improve, and patients, as I said, don't like invasive procedures. So therefore, and especially we should understand OCTA better. And nowadays we try to differentiate on a vertical line, A and B. One side would be OCTA, the other should be FA. When would we think of FA? When would we think of OCTA? Probably as a baseline. So I request my guru and my teacher, Professor Mangat Dogra, to say what does he feel about role of OCTA in diabetic retinopathy, and then he can go on to his talk. Professor Mangat Dogra was chief and head of the PGI in Chandigarh, and we did a fellowship in USA together.
Thank you, Professor Atul. I have fond memories always.
What do you feel about the role of OCTA in DR?
I think there is a lot of role these days as far as the diabetic retinopathy is concerned. We avoid in many cases doing an invasive procedure, that is doing a fundus fluorescein angiography. And we can see extensive CNP areas as well as neovascularization on the NFAS, and we can treat many of these patients. Apart from that, not only that, we also see on an NFAS image, not only that CNP areas are seen when we do OCT angiography, we see very good cystic spaces. And I think mostly, as already you said, and Harpreet nicely said, we have side by side these days, both OCT and OCTA. So we are in fact having that big advantage in managing many of our patients, but we are learning more about OCTA at this time. I think still we'll get much more idea.
Definitely.
So thank you very much for that. And with this, I'll also share my screen.
Yes,
because I'm going to talk on diabetic.
Sure.
My slides are seen.
Yes, sir, visible, sir. Nicely visible.
Okay, so I'm at the outset again thankful to Professor Atul Kumar. He has always included me being a part of whenever he did any instruction course or any courses or anything. I've been part of that. And I'm going to speak to you on diabetic macular edema, perhaps the commonest condition any of the vitreoretinal surgeon today has to face. This is the commonest disease which we all manage, and we need to learn more and more. And we also know that this is a chronic kind of a disease which require long-term strategy, and the pathogenesis of DME is also multifactorial, so it needs a multimodal approach. So we have to understand so many things. This is a complex thing. So whenever, in fact, we see for many years now, any case of a diabetic macular edema, first thing we advise are these investigations. We advise for blood glucose level, blood pressure, their total lipid profile, hemoglobin, HbA1c, 24-hour urine protein. I have seen hardly anybody get set down. They get blood urea and serum creatinine. You see, that's the biggest mistake. Serum creatinine, blood urea will derange once there's extensive damage, parenchymal damage. So try to do for the 24-hour urine protein early so that good drugs can be started and you prevent the damage. And the first time we tend to do mostly a fundus photo and a OCT. FFA, I would say you may do as a baseline, we tend to do, but at times we may not also do if everything is clear to us. And systemic therapy, once you have done everything what I said is ordered, you look for an excellent glycemic control with your internist, diabetologist, endocrinologist. Normalize their blood pressure. You need to reduce the serum lipids. That's very, very important. And treat anemia and proteinuria also. They also have a significant, so that's what I say. Since the disease is multifactorial, I'll show you here dated way back, one patient where you can see hard exudates just deposited here, so much of exudation just with a metabolic control. That means not only sugar control, also lipid lowering drugs. There's a marked resolution without any treatment here, no laser, no injection, that you will see how much remarkably it has improved in 3 months. So the DME management options are anti-VEGFs are the sheet anchor, I would say, main. We have ranibizumab, aflibercept, and bevacizumab. And also laser photocoagulation is not totally out. We do always for the non-central involving DME, as well as also add on later on to various cases where we have used anti-VEGFs. And the steroids, we have dexamethasone implant available, also triamcinolone. Fluocinolone is not available. That is Iluvien to us at present. And surgery may be required in certain cases. I'll show you a little later. So we do have these drugs. All of us are familiar with bevacizumab, ranibizumab, aflibercept, and a lot of biosimilars. So they improve the visual acuity, decrease the macular thickness, but the problem is you need repeated injections. But what is the evidence here? You see, we know, we are all familiar with this trial here. If you have good visual acuity, you can use any of these 3 main anti-VEGF agents. They do the same. That is what was shown in this DRCR net trial. But if the vision is worse than 20/50, that means 6/12, or worse, then if you can and your patient can afford, I think the choice should be aflibercept, because they do much better than others. But if the patient can't afford, then you can use any of these agents. But if you have a choice, then do that. They produce more drying, better visual acuity outcome. So as far as the summary of the protocol IA, persistence of edema is concerned, I think you must go to this paper published recently. This is in IA by Sada et al. And in this post hoc analysis of DRCR-NET protocol, what has been seen is, it is very, very interesting that 1/3 of the patients' experience of DME, all DME, persistent edema during first year after initiation of ranibizumab treatment. And this will not result in improvement in vision. So 1/3 requires something else. So that is what is the persistent or the recalcitrant edema, which is there. That is in 1/3. You must remember, very important study according to me, although it is not in a very, very classic journal in eye, but very good study. So as far as anti-VEGF in DME are concerned, early intensive treatment with anti-VEGF is the key, and we need to treat them aggressively and use Eylea or aflibercept as a choice if the vision is down below 20, that is 20/50 or less. And 1/3, must remember this, have persistent DME or are refractive to anti-VEGF, which require alternative treatment like corticosteroids. That is very, very important to be kept in mind. So real world experience, the problem is DME receive fewer injection as compared to AMD patient. I think AMD patients, they would come much more regularly. Here they have many comorbid conditions and both eyes are involved, so they miss many injections. These patients, usually if they are not treated and they come late again and they miss injection, they result in progressive visual loss. So corticosteroids, we have, I already said, we have 3 options. We don't have Iluvien, we have mainly Ozurdex and triamcinolone. It is indicated in unresponsive to anti-VEGF, chronic DME, and many of those 1/3 cases which I have. Of course, if somebody had a recent cardiovascular, either a stroke or a myocardial infarction, anything, then you would definitely need to switch to the steroids. And these steroids consider for treatment of refractive, I already talked, 3 to 6 months, usually 3 months is taken if there is a stroke or there is a myocardial infarction. I think then, and of course, in pseudophakic eyes, you can even do this as a primary therapy. You can start right with the steroids. As an adjunct during cataract surgery, I think this is very, very important. It has changed, otherwise they do very well. Of course, cataract and raised intraocular pressure can occur. And I have one of these patients here, ladies coming to me, received 9 Lucentis, so many focal grade, and also had a MI and stenting in between. And she was quite unhappy. Both eyes were so bad. And I just put her on, this is the recalcitrant DME, I put her on Ozurdex. And in fact, just with in both the eyes, initially she improved to, you can see here, 618, 612. Again, she is after 3 months, she's coming back. We use another one. And in fact, we are still using for her. And we have evidence here from the various studies from the meta-analysis, which is published here in this particular also, that Ozurdex is associated with significant mean improvement in visual acuity of 4 lines in cases of DME which are refractory to anti-VEGF. So I think we have to remember that. What about the DME surgery? This is beneficial for functional and now anatomical outcome in tractional DME, not the non-tractional DME. And the benefit of routine ILM peeling in tractional DME is still controversial. That is where the problem is. We do see sometimes excessive thinning and they lose vision. So we don't know whether we should be doing it or not. And that is still an open question. I had this lady, in fact, I could not convince earlier, 2009 to 11, many, she used to receive laser as well as anti-VEGF injection, several she received. You can see Avastin, Lucentis. And what you are seeing is that once she really worsened to 636 here, I think finally she got convinced. And we did vitreous surgery for her. That means we just removed this membrane after pars-plana vitrectomy. You can see how well she did despite so many years. She was still 6'12". And these kind of cases, they'll not be helped with just anti-VEGF steroids. They need surgical treatment, and that's what I have shown here. So with this, I'll come to almost end of my talk. I think we must remember that individual pays in India for treatment of DME or any other. So the insurance coverage and government support is limited. So the treatment will varies according to the cost involved, affordability, and diverse Indian scenario. That means you have to vary, you have to change. You may still have to do more laser. You may still have to sometimes, whoever patient, use triamcinolone 2 milligram. And so these are the issues which we should keep in mind. So we have to use standard of care, preferably with some rider, and these need to be followed despite all these problems. So often our patients are under-treated and under-monitored. This happens also in Western world in diabetics, but it is much more in our country. But we have to somehow convince them for a long-term treatment. So in conclusion, good metabolic control improves outcome. I've shown you the examples. So do that in the beginning. Don't rush for injection. Don't rush for anything. You can do that. It is not going to worsen in 1 week, 2 weeks time. Anti-VEGFs are first-line therapy in center-involved DME. Remember that. And 1/3 are non-responder or recalcitrant, which requires alternative therapy like steroid therapy. And some of them they are candidate for surgical because they are tractional DME. Steroids may reduce treatment burden. And also, I have not even touched that topic, that the steroids are mostly, if there is a patient with DME, use Ozurdex 1 week before cataract surgery. They'll do very well. Otherwise, they'll worsen and they'll be very unhappy. And vitreous surgery is, of course, required in tractional DME. I showed you the case and how well that patient responded. Thank you very much. This is a long topic. I thought whatever essential I could present here, that is what I'll restrict myself to. Thank you very much.
One short question. So what is your opinion regarding reuse of brolucizumab in recalcitrant DME?
One of the problems with us has been, I have only used in one case. It did work partially, but then this Mervin trial came and I was very scared, and it is not even approved in India for brolucizumab. Brolucizumab is only approved for AMD. So I have not used it, but I must say still many of these patients, those who are, we do have a lower threshold and go to Ozurdex, even if it is a phakic patient. So, but at this time, I am not really using too much of brolucizumab because of this reason. Because in USA, I talked to many people. At this time, the use of brolucizumab has really gone down. They're very scared, very scared. So they want the trial to come back. That is where the issue is. Yes.
Right. So thank you so much. It's an honor to have you with us.
Thank you. Thank you. Thank you, Professor Atul, for inviting.
We can now switch on to Dr. Parijat Chandra. And he said he's also talking of which you are a father. So we'd like to have your opinion on ROP. ROP and diabetic retinopathy are like Professor Dogra is the father of that. So
thank you, Professor Atul. You are always so kind. And
so
I'm so proud of Parijat also.
Yes, Parijat is doing excellent work.
Absolutely, absolutely. Be so
one
proud
thing good
of
about Parijat is he has stuck to ROP and
exactly. Yes.
Good.
Yes.
Okay, Parijat, all the best.
So good afternoon. So I'll be talking about ROP surgery, and I'm very thankful to Professor Atul Kumar for letting me and inviting come in his instruction course. And always a pleasure to speak in front of Professor Mangat Dogra, and a legend in this field. And I'm very grateful to them for giving me this opportunity. So I'll be speaking on ROP surgery. So how much ROP surgery do we get? So this was a paper which we recently published, and if you look into it, we find that around 32.7% of outbound babies referring to RP center come with stage 4 or 5 ROP. So that's a huge number which comes to us. And if you look at the inborn babies, no baby develops stage 4-5 ROP because of good NICU care. So the problem in this whole situation is we are getting a large number of the babies and we need to deal with them. The COVID pandemic has particularly led to a lot of missed and delayed screening during the lockdowns, and a lot of emergency surgeries were only being done, and stage 4 and 5 got ignored, and we are getting more and more stage 4 and 5 babies now after the lockdowns are lifting us across the country. So when should we operate for ROP? So I like to show this picture because this case came to us, and this case had stage 4A ROP developing in both the eyes. You can see that hemorrhage is also happening in one of these eyes. So this baby was planned for surgery, but unfortunately the child got sick and didn't get clearance for surgery. And when he came back to a surgery 2 weeks later, this is what he looked like. So as you can see, the picture has totally changed from what it was earlier. And what was the case of 4A has now become 4B, and the traction is increased, and there's macular drag which has happened, macular hemorrhage is happening there. So the case which was much easier to operate earlier now is much more tough to deal with. So we need to understand that if you delay surgery, the ridge is going to pick up more height, become more peripheral, more vascular, and all this is going to lead to a difficulty in instrument access and difficulty in relief of traction. Also, if the central TRD starts to develop, then the lens might get involved, the macula might get involved, and the outcomes might not be so good, because you might have to do a lensectomy and you might have to deal with macular issues as well. So how are the results of stage 4 ROP surgery? So this is a case of advanced stage 4A, as you can see, developing in this eye. So if you operate this eye, this is what it's going to look like at 4 weeks. So what I'm trying to tell you is that if you operate this case, you relieve the traction to a good extent, and if you do a good vitrectomy, all that VEGF load in the vitreous also goes away, and the ridge tends to fall back very nicely. This to show you a case of stage 4 ROP surgery. As you can see here, this is some of the steps just to show you that. So this eye is developing stage 4A. So you relieve the traction which is developing from the disc towards the TRD, and then you relieve the traction over the disc. You can see the laser marks in the periphery. And as you relieve the traction, because it's all neovascularization going into the vitreous, which is pulling all this, it tends to bleed. So you need to dithermize all that so that bleeders are not left at the end of surgery. There is a vertical traction, and there is circumferential traction, and there's central traction. So all those tractions have to be relieved. So when you see the circumferential traction is relieved, the vertical traction is relieved, and now localized PVD is being done so that the central traction is also relieved. Here's another case which has a more central kind of TRD, where it's a zone 1 TRD, which you can see here. You can see fresh laser marks have been given just prior to surgery, and here you can see the traction is being relieved, and vitrectomy is done all around. You can see the yellow glow is coming because the vitreous appears yellow right now, and now you see the yellow vitreous is removed and a pinkish glow of the retina has come in. You can see that even the macula is not vascularized in this case, and a localized PVD is being done here to relieve all the traction. This is what it looks like at the end, and this is what it looks like at 4 weeks. So you see all the traction has gone away, and the retina falls back very nicely in this case. But even the photo on the left eye is pretty advanced, and it could progress in an unpredictable manner. So it's always best to go in surgery early so that you don't have to deal with more advanced cases where the response becomes unpredictable and there's a higher risk of complications. So this case came to us, and you can see it's a heavily lasered AP ROP case, and it's got extensive traction developing in the temporal periphery, and there's also a dense membrane with the PVD which is happening at the posterior pole. So if you just want to deal with the posterior pole issues, then 27G vitrectomy works very well, and you can just do the vitrectomy and relieve the traction in the periphery, which is pulling the macula and causing a retinal fold at the central retina. So once you remove all that membranes which are there, this is what it will look like. This retina fold will relieve to some extent after the traction is relieved. 27G works very well for this. However, in the periphery, sometimes the instrument tends to bend, but it works very well for these cases. So we like to combine anti-VEGF in some of the cases. Let's see some of the case scenarios. So if you look at this case here, what you see is the child is already lasered, and he's got a progressively developing stage 4A ROP, and what you also see, he's got extensive neovascularization. So if you just do a surgery in these cases without anti-VEGF, what's going to happen is that the funnel will continue to close over. The neovascularization will take time to close just with surgery or laser alone. So in these cases, we combine injection and laser if it's not done, and this is what it looks like at the end of a few weeks. So this kind of response cannot be obtained with surgery alone, because this extensive neovascularization cannot be dealt without anti-VEGF. So if you do anti-VEGF combined with the surgery, then only this kind of response will be obtained, because it will lead to extensive and very quick regression of the neovascularization. But again, you need to keep in mind that reactivation of disease does tend to occur at 6 to 8 weeks. So this disease can also come back. So you have to keep a watchful eye for that. The next scenario is many of these cases come with bilateral stage 4 because it's a progressive and bilateral kind of disease. So earlier we used to do sequential surgery in this, and we used to operate the worse eye, and then the better eye also used to get bad. So it's better to do simultaneous surgery in these cases, and if you do simultaneous surgery, the timely outcome can be done in both the cases, and obviously the risk of GA is avoided. Only one child can get away with the ROP surgery. But you need to understand that a high safety margin needs to be maintained, because in bilateral surgery you don't want to pick up infection, something like that. So you have to treat both eyes at independent surgery, change the drape, change the infusion fluids, change the instruments, rescrub, and use 2 sets of post-operative drops. And obviously patient counseling is very important, so they understand why we are doing a bilateral surgery and what is the need and urgency to do this in a bilateral manner. There's some common complications which beginner might encounter. So this is a scenario commonly, you insert the instruments and it goes and hits the retina. So you see a break has happened there. So you just go ahead and laser the break, and don't do too much PVD there. Don't try to push pull things there, and this will stay just like it, and it's of no consequence. So especially people who operate adult retinas, when they start to go into pediatric and preterm babies, the length of the instruments is too long and they don't realize that they are going deeper. So you need to keep in mind that you don't go deeper. Iatrogenic lens touch is another problem. This can happen because again the eyes are very small, and as once you turn off the lights and you start operating inside, you forget to realize that the cannulas and all might turn inside. So the cannula often goes and might touch the lens, so a localized cataract might happen there. Unless you have a big posterior capsule tear and a significant lens hydration, you can just leave it as it is. Suprachoroidal fluid misdirection is another complication which can happen, and it can really alarm the person who is doing the surgery. So again, this happens because again there is very limited access for the instruments to go in, and the cannula can readily misdirect. So even if it happens, you shouldn't worry too much and just take the cannulas out, take the out, and just inject air inside. And there's no need to inject PFCL and do much manipulation, because it just fluid has misdirected. Let the fluid egress out naturally, and it will come out fine in the end. Postoperative bleeding is another common complication. So we need to be aware that, as I showed you in the earlier video, you need to dithermize all the bleeders. Don't wait for the bleeders to self-coagulate and in some hope that the bleeding will stop by itself. There's a higher chance post-op bleeding will happen because you're cutting a lot of new vessels and all of them might bleed. So work in low pressure situation, and don't keep the IOP too high, and dithermize the bleeders. So stage 5 ROP is another sad situation. Many of these babies come to us. I showed you a very large number of babies. So in that series which I showed you, 27% of babies coming to RP center come with stage 5 ROP. So that is a huge number that comes to us, and we do like to give a trial for surgery in these babies in the hope for some kind of navigable vision. Recently, the new stage 5 classification has come from the ICROP group, which divides stage 5 ROP into stage 5A, B and C ROP. So just to give you an update, stage 5A is when you can see the disc and the posterior polar P is open. Mostly these are open funnel cases. Stage 5B are cases where the disc you cannot see, and but the anterior chamber is normal. And the stage 5C is when you see significant anterior chamber anomalies in the form of posterior synechiae, shallow AC, coronal opacities, iridocoronal touch, things like that. So just to take that, this just basically I view it as a continuum of disease. And stage 5A, basically if you can make it better by surgery, then you go ahead and do it. Otherwise these babies are anyway seeing something, and they are phakic, the lens is clear, so you don't really want to go and fiddle with them unless you think you can make it better. Again, it depends on which stage you are dealing with. If you are dealing with a child who's 38-40 weeks, a funnel is progressively closing, that possibly you might have a better outcome. But a child who is 60 weeks and already the fibrosis has happened, you might probably leave it alone if you can't make it better. Stage 5B, obviously you can give a trial for surgery, because as a lot of retina surgeons are competent doing PVR D3, you can possibly go in and open these funnels, and the child might get something out of it. Stage 5C, if it's dealing with early cases with just few posterior synechiae are there, then it's just like 5B itself. But if you're dealing with a complex stage 5C advanced case with posterior synechiae and coronal opacities, then some people like to do two-stage surgery in this. Do the first surgery, leave the posterior synechiae, remove the lens, let the coronal opacity clear for a few weeks, and then in second stage surgery you can go in and deal with the rest of it. Just to show you how I like to do it, so this is like the hybrid vitrectomy. So these are 23G MVRs which go in, and through that 25G instruments go in so that a snug fit happens. And you can see that the lensectomy has been done, the synechiae have been relieved, and now the retroretinal membrane has been removed. So this is an open funnel configuration on ultrasound, which I'm trying to show you. So this child is left for blind, but if you go inside and try to remove, you see there's not much for dissection, and it's just fibrous tissue which is sitting in the center. And if you relieve all that, it gives a good chance to the child to see. And you see there the disc, the posterior pole is attached. All this not so healthy, but it's attached. So mostly these babies are left for blind, so it's worth going in and attempting surgery. And many of them do have open funnels, and you are able to see the disc and the posterior pole, all this detached. So this is how this child looked like. So I'm not trying to say that stage 5 has a good prognosis in any way. Stage 5 universally has a very poor prognosis, and it's always best to do timely screening and treatment to avoid stage 5. But if you give a trial for these babies for surgery, sometimes they do get navigational vision, sometimes the funnel do open very well, sometimes you can have a surprise like in this particular case. So you should go and operate and give a trial of surgery, and you might change the life of this baby as well as the family in the future. So thank you so much.
Dr. Atul? Dr. Atul, are you with us? In that case, Dr. Mangal Dogra sir, would you like to comment? I mean,
Yeah, sure.
sorry, but
I'm
over to
there,
Dr.
and
Atul.
I would like Professor Mangadogra's expert opinion after such a wonderful lecture.
Thank you very much, Parijat, as always. I think you have really emphasized the important point of doing early surgery in 4A, 4B, especially 4A. You've shown nice cases how they progress fast. And if we can do early surgery, which you elegantly demonstrated, we can give them very good outcome. And regarding stage 5, you have very sensibly put even the new classification that how we have to really select out and what we expect and where we should even watch, or where perhaps we should not even be doing. But the where we do, it is very important, even if they don't get ambulatory vision, but they do have a vision which navigate them and all that. You very nicely shown, and I really congratulate you for your excellent surgical videos, as well as the way you presented the entire ROP surgery here. Thank you very much.
Thank you.
Thank you, sir. Now we'll come to the last talk of this session, retina grand rounds, and we'll have Dr. Rohan Chawla, who will be talking to us about diabetic vitreous surgery. When and how?
Thank you, sir. And thank you very much for inviting me and giving me the opportunity to participate in this session. And sir, congratulations on the new book, new edition. It has come out so well.
You're also part of it.
Thank you very much,
You've
sir.
written chapters on it.
And sir, it's always nice to be a part of your IC, like Dr. Dogra said. And also very nice to meet Dr. Harpreet again, who, like you said, is a very wonderful senior resident.
Wonderful.
Also said Dr. Dogra, I think you have a very nice background there. So are you fond of art?
Dr. Dogra is very fond of nice things.
Thank you,
We
Professor.
were together
Rafi.
for fellowship
I think
in USA.
yeah, we know about each other.
So Professor Dogra is good in his work and also likes good things.
Thank you.
Very
Thank
nice,
you.
sir.
Thank
Thank you, sir. Okay, so I'll quickly go to the talk. So I think, so for diabetic surgery, indications, some of them Dr. Dogra mentioned, and some of them all of you might be knowing. So before surgery, we must ensure a very good systemic control. And like Dr. Dogra said, that in diabetic, systemic control goes a long way, not just to improve macular edema, as well as to reduce the progression of diabetic retinopathy. And even if you do laser prior to surgery, it makes your life easier. I generally am using preoperative anti-VEGFs 4 to 5 days prior in cases which have significant fibrovascular proliferation. And if there is an associated cataract, then that must be dealt with either before surgery or in the same sitting. Now, I've recently given a thesis in which we are giving preoperative anti-VEGF as well as at the closure, again, to try to reduce, to see whether it reduces the incidence of early rebleeds. Now, when you do this surgery, The most important thing is you have to identify the planes, and the first plane is the posterior highlight. So if there is already a posterior vitreous detachment present, surgery becomes easier. Otherwise, you have to make an opening in it, drain the bleed, subhighlight bleed, and extend the opening all around the tractional retinal detachment. So here you can see that you have created an opening which are marked with black arrows, and this opening you're going to extend all around to try to clear the vitreous. So in some cases, a gap is present between the posterior highlight and retina, and these are easier. But in some, the posterior highlight is totally plastered onto the retina. And then in these cases, we do use some bimanual maneuvers to try to create a plane. So this bimanual surgery helps. And here you see with one hand in the forceps, you are lifting the membrane gently. Do not want to lift too much to cause a break, but just enough to help you insert your scissors and cut the adhesions between the fibrovascular proliferation and retina. So these OCT studies have just recently shown that the adhesion of the vitreous in the central part is not that strong, whereas it is stronger at the edges. So in the central part, probably it is easier to navigate your instruments, and thus we have introduced this concept of radial segmentation, where you go towards the center. Because although it appears like you're going towards the fovea, but here you might get the plane, and if you just keep operating near the arcades, the plane might be difficult to find. So the other thing what you have to do is you have to identify these pegs, and these pegs you can cut with your curved scissors, and that also helps to remove the membrane. For bleeders, again, bimanual surgery helps. You can flush with one hand and use the cautery with the other hand. Sometimes small breaks can be easily assessed with intraoperative OCT. Also, you need to know when to stop. Too aggressive surgery might mean that you might create unnecessary breaks. So it is always better in advanced cases, especially one-eyed patients, to just stop when you have cleared the disc and macula and removed most of the traction at the macula. And that itself might be sufficient to give mobile vision to the patient. So coming to some surgical videos, this is the case with large subhighlight bleed. So we have to make an opening in the highlight overlying the bleed. You can use a forceps for that, or you can use active suction. So only once you have removed this highlight, like I'm peeling it with this forceps now, will you be able to remove the underlying bleed. So extend this towards the arcades and periphery, and you will find that yes, it is attached at the arcades more strongly. But in some cases, with experience, you will know that yes, now here I can take a chance and just pull it off directly with the forceps itself and might not create a break. But when you notice that there is an adhesion or a peg, then you introduce your scissors and cut it, and still keep extending the highlight forward anteriorly. And now you see it's become like a nice posterior highlight detachment, as in a case of any routine detachment. And you can remove the blood and carry on with the next part of the surgery. So this is a more complicated case where you cannot see the anatomy very well, the disc and the macula, and the entire thing is covered by this fibrous tissue. So here I'm doing bimanual surgery, and like I told you, we are finding that plane and inserting our instrument radially towards the center. So with our scissors, we are dissecting that. And once you dissect it, you'll notice that the retina underlying is absolutely something different. And the fibrous tough tissue over it was obscuring it. But once you remove it, the underlying retina may not be that bad. So the central quadrant has been cleared. And again, using scissors as well as cutter in between, we are removing, trying to remove this fibrous tissue as much as possible. Now we are going from inside out. So both approaches are possible, outside in as well as inside out. So now from inside out, we are going up to the arcade. So the main aim is to segment this tissue into multiple parts so that the area of traction at the posterior pole is relieved as much as possible. So with the scissors, you can do both blunt dissection and create a plane, as well as to cutting. So whenever you find bleeders, try to deal with them immediately. Otherwise, they will form a second membrane, and then you will have a problem dealing with the second membrane. You'll have to remove it again separately. So with the bimanual maneuver, we cauterize that bleeder. Again, using the cutter, we are trimming the membrane. And in the nasal half, with the cutter itself, I have found the plane. So no need for bimanual dissection here. And just trimming it and separating the two halves of this taut band, which is keeping the retina lifted. So the nasal part of the membranes also can be just trimmed and left. No need to be aggressive about them, as I mentioned earlier. But yes, we need to cauterize it like Dr. Parijat showed. Otherwise, we can have rebleeds. and then do an air fluid exchange. So I will skip this video for time. Now, another case, similar case, where we have a component of fibrovascular proliferation as well as some amount of bleed. So unimanually also, we can segment these membranes, separate them out. Small tufts of tissue over the disc can be left. So this case I just wanted to show because recently I've started doing this ILM peeling. Now, like Dr. Dogra said, we should also not cause much damage. So if possible, I think we should avoid to peel over the fovea, but sometimes inadvertently the tissue over the fovea also tends to come. But what I have found is that at least when you do ILM peeling near the arcades where the traction is, it relaxes the central retina. And even if you have not managed to remove the entire traction, because now the connection is gone, so the central retina settles better. But you see here, because the central retina has a tractional detachment, it has fluid under it, so how mobile it is when I'm trying to peel the ILM. But slowly and gently it is possible to peel the ILM. Now here I think I've got the tissue over the macula, but in future my aim is now to leave a little island in the center, but try to remove the rim around it so that you can remove the connections from the arcade. Now here is another video where sometimes you see the traction is going up to the periphery. So in such cases also you have to be meticulous. With the wide angle you can see it, and we can make the posterior hyaloid fall back. So you make an opening in the periphery and gently cut it, and you can see that there is again a plane there, and wherever in the periphery it is adherent, you separate it. So the posterior part of the hyaloid becomes distinctly separate from the peripheral anterior hyaloid, and then you lift off the membrane with forceps. Now sometimes you are lucky and you will get away with it. So again, then just trim it and leave it. And you see, now you can see the disc and macula, and probably would leave such a case. So some of these cases where I have left traction in the nasal or inferior halves, but since the macula and the disc was good, the patient on this left, this patient was a young patient. This patient did achieve around 6/18 vision. Patient on the right was an elderly with some amount of probably ischemia, maybe not that good vision, but the patient did achieve about 2/60, which is navigable for him. For a one-eyed patient, that is quite enough. So I would summarize to say that before taking up patients for surgery, they should be well controlled systemically. If they are having any renal problems, then probably do a dialysis a day prior to surgery. In advanced cases, definitely use anti-VEGFs. If it's a simple case of vitreous hemorrhage, then probably you can just go ahead, do the surgery, do laser, and at the closure of surgery, you could inject an anti-VEGF to take care of any associated macular edema. Identification of the planes is the most important aspect of the surgery, posterior hyaloid as well as the fibrovascular proliferation. Try to segment and delaminate them and divide it into smaller parts. Some cases you can get away by doing a en-bloc dissection where you feel that it is not very strong, the adhesion. Then in one go you can pull it off, and that makes the surgery even easier. Go slow if the proliferation is too much. Try to avoid breaks. And if you can avoid breaks, like the cases I showed you, most of them I have left just under air. If you have made a superior break, you can just leave under gas. But some cases would require silicone oil, especially if there are large breaks or you feel there is a large, thick amount of SRF and you have to make a retinotomy to drain it. But I would say definitely air or gas is better for diabetic cases. But with advancements in viewing systems and these newer machines and cutters and finer instruments, I think the results of diabetic surgery have definitely improved. Thank you. Thank you very much.
Thank you, Dr. Rohan. That's a very nice overview also on diabetic vitreous surgery. Diabetic vitreous surgery is a challenge to all retina vitreous surgeons because they offer complicated issues sometimes. When they're least expected, you will have extensive fibrovascular proliferation over the disc, and especially as Rohan mentioned, along the arcades. So yesterday I did a surgery. There's a very severe traction along the arcades, the TRD along the arcades, extending extramacular and intramacular. So the traction was so severe and long-standing that you have to cut the retina at right angles to just relax. Otherwise, the retina wouldn't settle. So I had to do two retinotomy relaxing incisions at the arcade, one at about 10 o'clock, another at 4 o'clock. So on the temporal side, away from the maculas. So sometimes the patients come very bad, and ultrasound may give you a deceptive picture, and it's on-table decision. And on table, you realize that this is what you need to do, and then you modify your surgery. So you should go with an open mind for diabetic vitreous surgery at least. Second thing I want to say is that, Rohan, what do you feel about the role of chandelier?
So I think for bimanual surgery, it is most important. It is quite helpful. And some people place it at 12 o'clock, some people place it in the infranasal quadrant, but that is, I think, up to the surgeon, and depending on the case where you don't want the shadows. And now we also have twin chandeliers. So all these systems are good and they are helping us in improving our surgical results.
So true bimanual we can do with chandelier. Sometimes we require it even for RD surgeries where you want to train, or a giant ear. So with these, I think, Professor Mangadogra, what do you think, sir? Should we conclude the session? Or any questions?
Yes, great session. Great, Rohan.
Thank you, sir.
Absolutely. Great tips.
And Rohan and
Everybody.
Parijat and
everyone.
On behalf-
Harpreet, nice meeting you and great talk. Yes.
Thank you, sir. I think this one way we all meet each other.
Yes.
Thank you.
On
Thank you.
behalf of the
Thank you,
organizers,
Professor Atul. Thank you.
I would like to thank each and everyone present over here.
Thank you very much.
The chairpersons, the moderators. Thank you so much for finishing this in time. We understand that the hall was given to you 20 minutes late, but you are giving us the hall back 10 minutes early as well. Thank you so much, and really appreciate it, sir. Thank you so much. The next.
Thank you for having been there and to help us keep our time.
Thank you so much.
Thank you so much. Thank you.
We shall try and do that in the next session as well. We've got our next session getting started. I request the chairman, Dr. Ramamurthy sir, our co-chairman, Dr. Mahibal Sachdev sir, convener, Dr. J.S. Titial sir, our co-convener, Dr. Gaurav Luthra, and our moderator, Dr. Namrata Sharma ma'am, to please unmute herself and switch on the camera. We're about to get started. To save time, can I request our first speaker, Dr. Rohit Shetty sir, to please also start his screen sharing. Over to Dr. Ramamurthy. Dr. Namrata ma'am is going to be joining in shortly. So I believe in that case, we have Dr. Gaurav and Dr. Ramamurthy as the moderators to fill in.
I can't share the screen. There is this icon missing. Have you
No, sir. We have. Could you try again? Let me. I've just updated the settings again.
Because photo, Dropbox, Microsoft SharePoint, bookmark, whiteboard is what is coming here.
So are you using a MacBook?
Yeah.
So maybe that's the reason why you've not given the permissions to Zoom to access the drive. My kind suggestion would be to try and keep the PPT open and then try and share it. That's one option.
It's open.
Rohit, have you updated your Mac recently?
This is a new one, sir. I think.
Oh, so then you have to go to the permissions and give permission for it to use Zoom.
Correct, sir.
Or Zoom to screen share. Otherwise, it won't work.
But I presented it many times. This is the first time.
Okay. Oh, then it should work. Yeah.
Can somebody help Rohit, or can we go to Dr. Praveen Krishna till Rohit sets it up?
Dr. Praveen Krishna is not seen over here as of now. Can we have Dr.
Sorry?
Sir, I requested Ramamurthy sir. Actually, got a small appointment.
So can we have Dr. Ramamurthy sir to present? Is that what you're saying, sir?
No, I think Dr. Kudlu wanted to go first. Let him go ahead and finish.
Okay. Okay.
I'll get my things ready by meanwhile with a different computer.
Sounds good.
Rohit, please. Yeah, sure. So I think the first talk, Ram, we can have of Kudlu, right?
Yes. We can see your screen, sir.
Yes.
Yeah,
Go ahead, Krishna Prasad.
Yeah, thank you so much. Today, I'll be talking about the different presbyopic classic which is available in the market and how each one has got advantages. This is my financial disclosure. I'm consultant for Carl Zeiss India. The presbyopia is a physiological progressive loss of accommodation affecting individual in their middle age, regardless of any underlying refractive error, causing difficulty in sharply focusing for near vision. So these are the different principles to correct presbyopia. Either you can do monovision in one eye and one eye for distance and other eye for near, or you can even plan for increased depth of focus, what we do it in camera inlays, or you can think about combined approaches. These are the different options. I think we have got, I think most of our senior speaker will definitely tell that now lens procedure is one of the upcurrent best options for presbyopia. There are other even procedures also we can try to do the treatment for presbyopia. This is one or two word about the camera inlays. Normally, they put it in the non-dominant eye, which increases the depth of focus. But all these inlays have got a problem. Definitely, there is a slight reduction in the distance vision in the non-dominant eye with some amount of reduced contrast sensitivity and glare. So let me come to the laser procedure, Presby LASIK. This is basically a multifocal LASIK treatment, biaspheric treatment that induces the spherical aberration for depth of field. So what they do in peripheral Presby LASIK, central zone is corrected for far vision and peripheral myopic ring created for near vision. But this is good for better reversal. So problem, these are the what we do in a central Presby LASIK. So central strip zone for near vision according to the pupil size. So this is about the Presby Max. Here, once again, it is made on the biaspheric multifocal ablation. With a monovision, the dominant eye is focused slightly more for the distance and non-dominant eye for the near. So there is one more company, I think even AMO Vizix also tried with the presbyopic laser solution. What they do here in the Vizix machine, it steepens the central zone for near vision and leaves the periphery for distance. So it is intended for hyperopic patient up to +4 diopter, probably who is at the age of presbyopia. These are the problems with Presby LASIK. Initial compromise on the distance vision up to 3 months. It takes a lot of time to adapt, and a lot of patients had a night vision problems also. Let me come to the one more equipment that becoming more and more popular about the SupraCore. What they do, it's a LASIK. Once again, it's a LASIK based procedure which is performed on the Technolas 217 examer system. So the elevation is surrounded by aspheric optimized area where the smooth transition creates the intermediate vision zone, while the distance vision is positioned in the periphery. So this is about the SupraCore. Basically, it's a varifocal principle. Even Bausch & Lomb also tried through their intracore, which is a flapless procedure with the help of Victus femtosecond laser. What we do normally steepens the cornea approximately by 1 diopter, changes the corneal biomechanics, produce the myopic shift by approximately 0.5 diopters. So both intracore is been now nobody is doing. SupraCore, most of the hyperopic patients do well, and still long-term follow-up is required, and patients tend to, I think after 3 years, there are a lot of my friends are telling that they may have to do the repeat treatment. So let me come to the one more procedure, the Presbyon. This is what I have been doing last 80 years. I think Ramurthy sir keep telling that KP will always talk about Presbyon because of my experience with this treatment is very good. But what I feel, any refractive, any presbyopic procedure, the refraction is the key. I always do a cycloplegic refraction. Being a doctor myself, I do the dominant eye testing, and also I myself perform the micromonovision testing. If you do this one well, I think who are the patient, they are not fit, that time only you can reject, then you can select them. Then after you do everything does by the CRS master, which is provided by the company. You can either perform with their older version MEL 80 or with the newer examiner system MEL 90. So why we took this treatment? Because brain tends to suppress certain blur from one eye to the other eye. This is the principles of Presbyon. Basically, it's a micromonovision with the increased depth of focus, with a neural submission and blur adaptation. What exactly we do? We make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters. And along with that, we create a controlled spherical aberration in both the cornea. Because of that, you'll have this blend zone from where the both dominant and the non-dominant eye vision meets up and binocularity retains. So as I said that 97% of the patient adapt this treatment because of the neural submission. This is the advantage with the Presbyon. Basically, it is not depending upon the pupil size. I have done up to even 5 diopters depending upon the Pachy value, even myopic up to 8 diopters depending upon the Pachy, up to astigmatism up to 3 diopters. But what I seen in all my patients had a very good intermediate vision, and more than 97% of the patient will adapt this treatment with no significant vision. So I do even do the eye trace for all these patients, make sure that patient don't have the cataract. So in my opinion, which is the best option when you compare with multifocal intraocular lens, cornea inlays, Presby LASIK, SupraCore Presbyon. As far as the distance vision, intermediate vision, near vision, night driving problem, pupil size, adaptation, and reversibility. Definitely Presbyond will have an edge over all this about treatment. Once again, I thank DOS for this wonderful opportunity. Thank you, one and all.
Excellent overview, Kodlu, as always. I mean, you presented very eloquently about multifocal intraocular lenses in an earlier session. I think with our confidence levels in multifocal intraocular lenses, our ability to biometry, etc., increasing, do you feel the time has come when, you know, maybe between 40 to 45 or 48, you go for this kind of procedure? And beyond that age, especially for the high probes, plano presbyopes, etc., if at all they're insistent about glass-free vision, going ahead and once for all handling it on the lens would be a good idea. Maybe that will be the way forward.
Only thing, sir, as you said that even Maipal sir also tell that, see, the lens option probably the best option. But one thing I want to tell you, sir, especially about the pupil size, sir. Some of the patient, even whatever the IOL master gives about the decision making about the multifocal lens or even eye trace, sometimes all these patient comes and eating our head with this glare and halo. Sometimes I am little bit taking one step behind whenever I do the eye trace. If they don't have the cataract, once again, I sometimes, even at the age of 49 or 50, I opt them for laser refractive procedures, sir.
Thank you. Any quick comment? Maipal, Tityal, anyone?
I personally feel that these options are there, and basically doing it in patients who are very in their nature of work, etc., it may not work. But I've tried it in a few patients who are generally housewives, etc., and takes a couple of weeks when suddenly the patient starts to accept this. So that is all that I wish to say. And as you have said, I am of the firm opinion that there is going to be more improvement in the lens-based procedures rather than the cornea-based procedures.
Yes, sir.
Excellent. I think now we have another stalwart, Dr. Rohit Shetty, needs no introduction, and who better than him to talk about decision-making in refractive surgery. I think he has an experience in the entire gamut of refractive surgery. Over to you.
Thank you, sir. Thank you, Namrata ma'am, and thank to DOS for this opportunity. The decision-making in refractive surgery starts with a proper evaluation from basic manifest refraction to ability to tolerate anisometry if you have any, to dry eye and multiple other things, like Dr. Kodlu said, also looking at the monovision component also. So imaging is one of the cornerstone of this procedures. We have different machines, different indices today, which helps in planning, whether to take it in or out. And I know these AI-driven or new indices really has a big role in our planning of refractive surgery. But what has also changed is use of biomechanics like Corvus and incorporating biomechanics into the topography. And this is a kind of nomogram we have been working on when you have multiple indices, both structural and biomechanical. And using this, you can actually guide through what happens, because CBI is the indices more from your biomechanics. TBI comes both from biomechanics and the topography. So you need to look at all this and decide, and both are abnormal. Phakic ICL would be a better option. And this is what we have been doing. The application starts with the diagnostics, starts with looking at LASIK. We know that the Contura is one of the new breed of customized ablation platform, even in a healthy eyes. We call topo-guided treatments. And this is something which we have published. One of the most important thing is it helps in the depth of focus and minimal change in higher order aberrations. And this is from SWIND MRS, one of the ways to move forward is customizing aberrations, what you want to treat. And I think MRS really goes really high up on that ladder, where you can actually treat what aberration you want if you don't want to treat a particular one, to save tissue and also to induce. For example, some patient you don't need to treat a depth spectral aberration to give you more depth of focus. SMILE has completely changed. I'm sure there'll be a lot of talks about it. I'm not going to go deep into this. Trans-PRK has its own advantages now, especially in today's context. Better ablation profiles really has a big role in its understanding. I use both the platform, maybe a little bit more in favor of SmartSurf from Schwinn, because they are the pioneers of PRK procedures in the world. And you can see that the abrasion profile in both of them are completely different. And you can look at customization also on this by using just a topography. We also use the wavefront wavefront guided treatment using the Pyramis. Pyramis is an abrometer using the pyramidal system, and Alcon has its own Streamlight, which looks at this, but you can't do a customized treatment on Streamlight at this point of time. And these are all the softwares, what it does, or when you're using the Schwinn platform, you can customize into wavefront optimized, ocular wavefront, and corneal wavefront. Aspheric profiling, ocular wavefront is a total abrometry guided. In the corneal wavefront treatment, you can see the difference between how an ocular wavefront, because this, when you're doing a corneal wavefront, it burns more tissue because it assumes that everything is coming from cornea. But what has really changed me is using the ocular wavefront, the total abrometry. You can see the amount of tissue saving is much, much, much higher. And when you have that, when you feel that their abrasions are very high, poor biomechanics, irregular epithelium, then we have an option of ICL at this given point of time. This is something which is becoming one of the standards, is using AI in different platforms. We're happy that this is something contribution from our end. It's used in 37 countries now, and a lot of places in Australia and other places. What happens is we have built an AI-built simulation, which tells you how and what kind of procedure would cause what kind of weakness. Now, how does this is the background of how it works. You get this report like this. We are generating the report, and it tells you if your line here, predicted post-op weakness, is more toward this side. It tells you that you are more in risk of an ectasia over time, not immediately, maybe 5 years, 10 years down the lane, or you can probably try and treating this patient on SMILE or SMILE Extra, PRK, LASIK. You can put whatever you want. And it uses a complete different principle of Newtons per meter. It's not the same as what we see in the Corvus, but the data is coming from the Corvus. And this kind of report generation probably would help us in giving us a path about what kind of refractive surgery we do. And you can probably feed in CAP or everything out there which helps to look into this. To summarize, how do we choose the algorithm? Less than 40 years, corneal aberrations are lower. Look at angle kappa, pupil size. If you're using a contact spose, yes or no. You can do the SMILE. There are a lot of other companies coming. No, and you are okay. You want to have and the cylinders are also less than 20.75. We use just a wavefront optimized or aberration free. But when you have a higher cylinders, then you can use one of the corneal wavefront guided treatments. When you have a higher aberrations, these are non-keratoconic, but I'm talking about the regular ones. And you can look at the Topo-G, that is a wavefront guided approach. You can have Contura, CW from this, and MEL 90 also has its own platform. And these are options when the patient is not suitable for it, and you can look at phakic IOLs. These are the options. And when you feel that you are not very happy doing, when it's a small power, not happy doing an ICL, you can do an option of trans PRK or any of these procedures. I thank the DOS and Namrata ma'am again for this opportunity, and open for any questions. Thank you.
Thank you, Rohit, for that excellent presentation and for the software. I'm sure it is going to be useful to all of us. And it is good to know that it is already there in 37 countries. And I'm sure others who are sitting here who are already not using it would also like to use.
Absolutely, ma'am. I'll be more than happy to share with you. One of our first users I worked with Prema Padmanabhan ma'am. And I think we both have been using this for a long time. It has its own ectasia nomogram built for geographic countries. It's not just India. Like if you have Brazil, it has its normative data for Brazil. Australia, it has its normative data. So it's a different, it's not like you don't have to worry about which population it's come from.
So I think that's the strength, because we've been, using machines and normative data from locations other than our own country or our own region, and basing our calculations on that. So I think that's a huge strength, especially for our Indian subcontinent. I'm sure others will be very keen, and thank you so much, Rohit,
thank you
for your talk. I would request a little change because Dr. T.P. Lane sir has a commitment. So we would request him to give his talk on phakic intraocular lenses.
Thank you, Namrata. Thank you very much. Thank you, Ramurthy. Thank you, everybody. Because I'm going to in BOA, so I requested Namrata. I'm going to speak on the phakic IOL, the stretching the limit. So in that, I want to cover. Okay, there is no any financial interest in this any presentation, and there is a thin line, I always say, between the wrong and right. So that we'll have to see which is the right path. And here you can see the Arjuna killing Jayadratha. There was a very thin line. Sun is there or sun is not there till we discuss. So the technology is constantly evolving, providing many, you can say, beliefs which are wrong or it may be correct. So in 50 era, implementation of IOL was considered wrong and harmful. Now we know keeping patient aphakic is not correct. Like that use of visco, there was so many controversial discussions, but now there are so many varieties of the visco we are using. The same, any ablation that time was not indicated, but now we are having so many machines which are ablating. Now safety levels of refractive surgery. See, if you consider 2000, we are considering the thickness of cornea 520, and in 2020 we have came up to 47. It means now the science is evolving, and now I will just discuss few cases with you. This is the 25 years old male. It is a software engineer by the occupation, and if you see -22 diopter with -2 cylinder and 18 diopter and 1.5 cylinder in 60 degree. Axial length is can say the 29, and this thickness of this 365. 3.8 millimeter is the thickness of the lens. And then I will go to the Pachy. You will see 515 is the Pachy. Angle is open, and the K readings can 45 and 46 and 45 and 43. Yes, but ACD is 2.66. Now, always we consider that there should be minimum 2.8, and this is 2.66. Now we should operate. We should go for ICL or we should not go. That is always a dilemma. To be or not to be is a dilemma, and in this you will see lens what is 270 micron. We operated the case, and it is doing well. There is no any intraocular pressure raise, and patient is doing well. So the borderline vault with the open angles, we can go for the IOL. The another case is 35 years old male, doctor by occupation. Now here you will see the -4 and 3.5 diopter only, and but you can say angle is open. Axial length is 24.5 millimeter. Lens thickness is 3.5, and see here, but ACD is 3.2 millimeter. So now, but the pachymetry is only 425. Everything is good, but we can't do LASIK, and as the pachymetry is less. So here you can see the corneal thickness, and then to be or not to be. As the corneal thickness is less, we should do or not. And see the lens vault is 320 micron, and here it went well, and patient is doing well. Now low myopia with thin cornea, we can go for the implantation. Now another case is 44 years old male. Now here it is -2 and -4 diopter of the cylinder, -1 and 3.5 diopter of the cylinder. You will see the angles are open. The axial length is 23.5. Lens thickness is 3.3, and you can see the K readings 52 and 47 and 50 and 46. So 9 ACD is 3.1, but here you will see the pachymetry is 435 micron. Then you will see the curvatures here, sagittal curvatures, and then the post-operatory visual acuity 6.9, 6.6, and base corrected is 6.6, excepting only 0.75 and 0.5. So stable corneal ectasia, yes, we can go for the ICL. The other case is 26-year-old male, lawyer by the occupation. And here it is -14, -30, and 1 diopter of the astigmatism. Angle is open. Axial length is 28.5. The thickness of the lens is 3.5. And here the K readings are also good. Even the ACD is 3.2, but pachymetry is less, it is 425 micron. Now in this case, there was a gonioscopy was done, dense pigmentation and the open angle was there. So here you can see the UBM, concave iris configuration was there. So IOP is 24 and 22 and normal optic disc was there. So ocular hypertension with pigment dispersion. In such situation, it is better to avoid the phakic IOL. The conclusion, phakic IOL allows the ample amount of the modification. Through work is, you can say must before, the workup is very, very important. What is always happens that we are not doing the workup and operating, but if you work up properly, then I think the phakic IOL can give the good results. Thank you very much. Thank you, Namrata. Thank you.
Thank you so much, sir. Anybody would like to give any comments or say something? Dr. Mahipal, sir?
I'd like to add something, Dr. Lane. As usual, very, very descriptive, very detailed, this thing. And I think I agree with you on all the points on phakic. The only one point I think I would add is that in case the astigmatism is higher, in my experience, I've started doing a vertical white to white also.
Yes.
Because especially if the pupil size is large, that is the time when we get stuck up. You know, if you have a pupil size 6.7, 6.8, you need to go for a larger optic size. That is the time the peripheral angles, if the vertical white to white is smaller than diameter, less than 0.2, you'll land up into tricky situations. Otherwise, I think absolutely perfect on the head, nail on the head.
Thank you. Thank you. I think what Kamal saying is very true. We should go for the vertical white to white also in some cases. Thank you. Thank you very much.
Just a couple of comments. Very good, nice presentation, elucidating a series of cases, Dr. Lane. Just a couple of points I might differ, as you mentioned a case where the AC depth was about 2.65. Of course, other factors than AC depth like the angle configuration, the lens size, etc., come in, which is not always measurable. So whenever I got into pain with phakic intraocular lens, it's when I've compromised on the AC depth. You know, in the earlier days, even if you do a PI thinking that it might help. So my suggestion generally, especially those who are just taking up phakic intraocular lenses, to stick to the decade of 2.8 millimeters or more of AC depth. The second is regarding irregular corneas like keratoconus eyes, which are stabilized because of collagen cross linkage or aging. Go ahead and use these lenses only if the patient is happy with glasses, even if it's a decentered cone, slightly decentered cone. But if the patient requires contact lenses, rigid contact lenses or a rose-tail lens for the refractive correction, these lenses are not going to work. So please be careful of that.
True. Thank you. Thank you, Ram.
I would agree with what Dr. Ramamurthy has said. The one important thing is that we are, at least I am getting, I'm getting not a great number, but we are getting cases with cataracts who are coming in, people, because I started these implants way back in 2000, about 2000 or 2001. And those were the earlier generation. And now specifically with the, though Kamal is going to make his presentation on IPCL, I have had a very bad case of bilateral cataract that has been done elsewhere. And that needs to be taken into account, that the incidence of cataract is going to be there. And one of the important things is that the viscoelastic needs to be removed, and you should not leave behind viscoelastic between the lens and the crystalline lens and the phakic lens that you have implanted. And the second thing, what Ram has said is absolutely correct. If a person is happy with a spectacle, because if the astigmatism has spilled over to the posterior surface of the cornea, under those circumstances, the implantable lens will not give you that quality of vision. And it is on those cases only they are happy with the spectacles that we need to give. But otherwise, low myopia, high myopia, with cylinder, without cylinder, these lenses are giving great results, and the person does not have to make any new investment like a LASIK machine or something like that. Some people are even using this, those who don't have a laser machine, as a treatment of choice. But I would still prefer, where laser vision correction is possible, to go in for laser vision correction and then go in for an implantable lens in case we are not having the suitable corneal parameters for laser vision correction. Thank you.
Thank you, Maipal. Only thing is that when the visco will have to remove, we are doing under the AC maintainer, and then there is no, we are not using visco only. That is better. Thank you.
But you are doing under
Such a simple procedure as a phakic IOL, why would you want an AC maintainer? You are just in and out in a minute.
No, but visco, without visco, it is better to have a AC maintainer.
Okay, so it is, yeah, it is implantation without viscoelastic. Can we move to the next talk, please?
Thank you, Namrata.
Thank you, sir. Thank you.
So let us go on to the next talk, and that is Praveen Krishna joined us?
Not yet, sir. We can't see him. Can we have Dr. Ramamurthy, sir?
Yeah, Ram, can you talk about refractive surgery in hyperopia? We all know Ram is a great cataract refractive surgeon and also a retinal surgeon, and he is the founder, promoter, chairman, director of Eye Foundation. Go ahead. And he was among the first people in the country to adapt to the LASIK technology when the 117 came in. At that time, Chiron Vision.
Thank you so much, Maipal, and thank you, Namrata, for this wonderful conference. I think we all know the prevalence of hyperopia, at least in Indian population, is just about 1/10 of what is there as far as the myopia is concerned. But still, we do come across population who require this kind of a treatment. What are the basic tenets that we want to observe? One is a good cycloplegic refraction with homotrepine, so that the entire refractive error is calculated. It's not cyclopentolate, but homotrepine that is important. Correct maximal acceptance that is possible. If there is a difference of more than 1 diopter between what the patient accepts and subjectively and what is revealed on the cycloplegic refraction, often stay away from doing a refractive correction. And it's often said when you do a correction for hyperopic error, there is significant regression. It is felt that is more often under correction when the patient has +4 diopter. And when you do a refraction and you end up correcting just 1.5 diopters, as the patient ages, maybe 1 or 1.5 diopters will become manifest. So please do remember, it's extremely important to do a good cycloplegic refraction cover as much as possible. So even if you get an initial postoperative myopia, over a period of 3 to 4 weeks, this is likely to subside as the accommodation in the patient relaxes. So it's always better to err on the side of overcorrection than undercorrection. Age of treatment is not so important because in myopia, it's an enlarging eye. In hyperopia, it's a smaller eye. The eye is not going to become any less smaller. So it's not a progressive condition. But the fact is that more often hyperopes come to us at an older age group because it's only when accommodation starts going down, the hyperopia starts bothering them. So you find that patients are coming to us more in the 30s and 40s for addressing this problem. And often there is a concomitant astigmatism which needs to be addressed. As far as most of the laser machines are concerned, there is nomograms available to correct up to about 6 diopters of hyperopia, even with 6 diopters of cylinder. But very often we look at large, thin uniplanar flaps, a large optic zone of about 6.5 millimeters, more because much of the ablation happens in the periphery. And then there's a large angle kappa that's often associated with it. And that's the reason something like a Contura, where the treatment is centered on the visual axis, is often preferred. Of course, if you're using some other platform, you might have to manually decenter your treatment so as to bring it somewhere between the visual axis and the optical axis. This is often the ablation pattern that happens, that is more of ablation in the periphery because there is a certain amount of astigmatism that is coexistent, that is more, you see a little more laser happening in the vertical direction. So why is it that we find that there is a limitation as far as a laser vision correction platform is concerned? I think it's less predictably beyond 2.5 to 3 diopters. It's because it's an indirect effect of the laser treatment that we are looking at. it's more difficult to predictably steepen cornea than to flatten the cornea by calculating the amount of tissue that needs to be taken out and removing tissue. When you're expecting the cornea to steepen by a certain amount of degree, is not just the tissue ablated, various other factors like the amount of refractive error, the corneal hysteresis, etc. also come in. So obviously there's another good platform that's available to us is phakic intraocular lenses, but please do remember the hyperopic phakic intraocular lenses are much thicker than the myopic phakic intraocular lenses, and these are biconvex lenses compared to the plano-concave lenses of myopia. So it's extremely important that you stick to at least 2.8 millimeters as an AC depth. And of late, I've started using the presbyopic phakic intraocular lenses just to show you a very short clipping. This is just the high molecular weight viscoelastic flowing in as a bolus. And this is a presbyopic phakic intraocular lenses. Whenever a patient presents to me in the 40s with a significant hyperopia with presbyopia, this is my go-to choice. And this is available in the Indian platform. And I find the results are quite predictable. As far as the PRELEX itself is concerned, because of the accurate biometry, our ability to estimate the intraocular lens power, the availability of premium intraocular lenses on whom we can trust on, amount of dysphotopsia becoming less, and excellent post-surgical visual outcomes because the laser and phaco platforms that are available to us. And there is an expectation even in the patients in the 50s and 60s who are often leading a extremely busy, active lifestyle and want independence from spectacles. So I do believe that PRELEX is something that we will go on to adding to our armamentarium as we go, as we progress in our professional lifetime. This is a typical case, a 54-year-old with a 2.25 diopters of distant correction, at power of 2.25 power, hates wearing glasses. So essentially, these are the cases. I would go ahead and do a PRELEX. As you can see, Barrett Universal 2 is my go-to formula, but I also look at the evaluation that I get with the other formula. Once they line up significantly, then I go ahead and do a bilateral implantation, usually giving about 1 week gap. And this is the ideal kind of results that we get both with the trifocal intraocular lenses and a Synergy lenses today that's available to us, where there might be a small compromise as far as the quality of vision for distance is concerned, but then the spectacle independence for all distances is often achieved quite comfortably. What happens when it's extreme hyperopia? Often said that there are Indian manufacturers who are able to give you a lens of 60 diopters, 65 diopters, but please remember these lenses are about 1.5 millimeters in thickness, and the optic zone might be just limited about 4.5 millimeters. When you have such thick lenses, then there is a significant amount of spherical aberration. And even more importantly, no formula works quite predictably in these situations. So what I do is to, this is the last of my videos, I think. So what I do is to go ahead and do a primary lens about 40 diopters, look at the residual hyperopia that's left over. In this case, what I was getting initially was a plus 6 diopter, plus 56 diopter, plus 40 diopters went in primarily, and plus 6 diopters was the residual hyperopia. So essentially, it's a plus 9 diopter Sulcoflex lens that's going in. Indian options are available today at a reasonable cost. So I believe there's 2 lenses being implanted, even these short eyes, because there's enough space available. Once you take out the natural lens, obviously this works well. So essentially, as far as options for hyperopia is concerned, laser vision correction, phakic intraocular lenses, presbyopic phakic intraocular lenses, PRELEX and piggyback lenses. Once you identify the right choice for the right patients, you often end up with good outcomes. Thank you so much for your kind attention.
Thank you so much, Dr. Ramamurthy. I think this is a topic which is covered, not covered as often as it should be. And thank you for bringing out those very important points in your presentation. Any comments from any?
I actually wanted to ask that what is the experience of cataract? Now, these are all recently coming up. We do have central flow, but there is some kind of a lens thickness increase, lens rise, all that is there. So has there been a good study of what is the incidence of cataract when you do a phakic IOL beyond the age of 40, 45?
I think years back, Zaldivar published a study where he said that, the most important reasons for cataract occurring following a phakic intraocular lens one was, of course, the AC depth, if there's a compromise in AC depth. and minus power beyond 15 diopters and age beyond 40 years. So obviously, but those were lenses, that study was conducted with the lenses which did not have a central flow. So now with all the, even the Indian and the imported lenses coming with the central hole, I think the incidence of cataract is coming down. But definitely the propensity for cataract occurring in the patients when they are older than 40 years is more than when you are doing it at a younger age. Having said that, in a highly myopic eye, I'm shifting from hyperopia, there's also a greater tendency for nuclear sclerosis to occur at a younger age. That's really not because of the phakic intraocular lens, but there's a basic propensity for the lens to opacify.
So, are there any questions before
Yeah,
we?
I just like to add something. Dr. Namrata, I'd just like to add something to what Dr. Ramamurthy said. I tend to agree with him. But each time we talk about cataracts happening with phakic lenses, we tend to, deviate from the role of this operating surgeon. A lot of times, beginner surgeons who are probably starting off, they end up, touching the lens capsule while dialing, while removing the viscoelastic, they're dipping the central part of the thinnest part, especially in a myopic lens. Also, as the lens lands in the eye. So these factors are also causing or probably giving the phakic lens a little bit higher incidence of cataract than I believe you should be expecting. So whenever we talk about cataracts with phakic IOLs, I think we as speakers should also, people who've done a lot of phakic lenses should also warn the beginner surgeons that it's not just a bad vault or a central flow or the lens itself or a lens touch syndrome, but also the carefulness of the surgeon who's operating. And he has to remember that a good cataract surgeon has to sacrifice the anterior capsule, whereas here you have to preserve the anterior capsule with all your might and all your power. So that needs to go home very loud and clear to the listeners, that the sanctity of the anterior capsule is very, very important when you're doing the phakic IOL.
I would just like to add one point here, that there was one study of more than about 10,000 eyes, wherein the number of lenticular opacities were studied, and they found out that 27%, and this study was done with the V4 model, not with the current generation model. And they found out that 27% of patients had some lenticular opacity, and which majority of that included the anterior capsular opacity, and because of the retained viscoelastic. And out of those 27%, only 2.7% of
I think we've lost connection. 2.7% had visually significant cataract, if that was the sentence to be completed.
No, I believe probably what he wants to say is maybe it was a lens-induced cataract 2.7%.
No, but the point is that I would personally be of the opinion that there is a biased underreporting of the lenticular opacities, because these studies, it may not be, it's a 5-year study that normally the company people say that in 5 years, but now we are 20 years down the line, and we are getting these opacification, and 27% is a reasonably high. I agree that these anterior subcapsular opacities, because of retained viscoelastic, if they are there, they don't tend to be progressive. But as Ram said, yes, nuclear sclerosis, which according to him may not be related to the, would be related more to the myopia. But I personally, I don't have any scientific basis to say, but I feel that this is coming a little earlier in patients with the phakic implants. But nevertheless, it's a great modality because the life of these patients gets changed, and dealing with a cataract is much, much easier than dealing with an ectatic cornea or something like that. So I think this is going to stay as a good treatment modality. The quantity of the vision also, because the magnification factor goes significantly improves, as also the quality of the vision. The patient's life changes.
So thank you. I think we'll move to the, do we have Dr. Nitin Balakrishnan, Contour LASIK? I think he's not joined.
No, ma'am, we can't see him.
Then we come to the next section of this session, and that is SMILE, and none other than Professor J.S. Tityal for simplifying SMILE.
Yeah, thank you, Namrata, and good afternoon to all of you in this afternoon session. And continuing the debate, I think both Dr. Ramamurthy and Dr. Mahipal are correct. I think age is one of the important factor for a cataract, and that holds true for a phakic IOLs also. Younger patient, we hardly see cataract, but people with the older, where we are doing a presbyopic phakic IOL, the cataract incidence is definitely higher. What about the new technique of SMILE? How it is going to be effective for most surgeons? Now I see that in recent past, last 2-3 years, the significant number of installation has been SMILE machines. Therefore, I think more people are getting into SMILE surgery per se. I personally do not have any financial disclosure to be made here. And since its approval by FDA in 2016, number of surgeries has become much more through a SMILE procedure for correction of myopia and myopic astigmatism. Very soon, we're going to have hyperopic corrections also approved in world over, mainly because it has the better ocular surface, better regeneration of nerve flexes, and maybe the biomechanical strength may be better than any other procedure where we make the flap. Surgical procedure wise, just to highlight, it's a simple procedure. Takes less time than any other procedure in a corneal refractive surgery wise. It has 3 segments. One is the docking of appropriate contact lens on a patient, then application of femtosecond laser to create the refractive lenticule under the cap. Then subsequently, the physically removing the lenticule is the another challenging part for all of us. This is one of our review article for various techniques of SMILE practice across the world, and people have different ways to remove the lenticule from the cap which you make. If you look into basic area of concern in these cases, I would say first we need to dissect the anterior plane, that is separating the cap from the anterior lenticular refractive lenticule surface, then subsequently going posteriorly to open the entire lenticule, and this can be taken away. The problem starts when we don't understand which is the anterior and which is the posterior plane, because most of the cases, the refractive lenticule would be around 50 to 100 microns. And this 50 to 100 micron, when we dissect out, is reasonably thin tissue. So any dissection has to be done in a very light manner. If you don't have a proper dissection or proper identification of this refractive lenticule, then we have all those complications or difficulties which we normally see in our cases. So that can cause retained lenticule, delayed visual recovery, cap tear, side cut tear extension, posterior stromal damage because of unidentified cleavage of lenticule, then create a epithelial defect, which may not be a significant problem, but sometimes with the retained lenticule pieces, you can create the irregular astigmatism post-op period. Just to look into a small video of mine where actually the technique is being shown here. First, we normally would do a proper applanation. Now, in the Indian scenario, we select the small size applanation cone. Make sure you have a surface, ocular surface. The inferior superior congenital sac should be absolutely dry before you apply the contact lens. Once you achieve the refractive lenticule, then is the actual challenge of dissecting. Where you can see yellow arrow is showing the lenticule S, and the blue was for a cap periphery. We removed a little bit of OBL from the incision side, subsequently open the incision, which is around 2 millimeter to 4 millimeter, depending on the experience of surgeon. You can see I have dissecting the anterior lamellar plane now, then going to posterior lamellar pocket dissection, which is normally done away from the anterior dissection in a large area. This is what a frill can be seen, which is can be described as various ways, but we call it meniscus frill or sign. So with a speculated instrument, you can dissect out the anterior lamellar dissection or anterior plane dissection that is over the lenticule, refractive lenticule. So this separates the lenticule anteriorly from the cap. Once you achieve that, then go posteriorly, then dissect out the posterior. The important thing here is your dissection should be very smooth in the optical axis if possible. Then go to periphery. Always leave the lens so that your dissection becomes smoother. You don't leave any attachment there. Make sure you remove the entire thing. Most of the time, you don't require a forceps to take out this lenticule, which comes out in a bolus also, like this you can see here. It can be taken out very effectively. Many people do watch the interface, which is, I feel, not exactly required for most cases. That would complete the surgery. So this takes very less time. We all understand there would be a learning curve like any surgery, which holds true for a smile procedure also, both for application of laser as well as for removal of lenticule. So this is the way we can have 4 or 5 difficult scenarios. As you do more and more cases, the number of complications or difficult situations decrease subsequently. And if you understand, there are various ways to understand the exact area of orientation of lenticule. As I said, first we do an anterior cleavage plane that is above the refractive lenticule. In the left-hand side, you have a right-hand surgeon. Then make a small pocket posteriorly for a posterior dissection of these things. But this area can be nudged out to create this little bit of frill of meniscus. You always have a little bit of block here. When you dissect posteriorly, you don't come through and through to other side of dissection. If you are attached to anterior only, you will come directly this side. So this is a little bit of heaviness or a dissection difficulty we see, which Dr. Mahipal has described very nicely. So this is what we see, the prominence of edge over the dissector shows that you are beneath the lenticule and your dissection will be absolutely all right. There are situations where you would have done a different manner. I'll just avoid this for a time safety, where we would have dissected correctly first. To the area, you understand that you are dissecting normally, like I'm going to anterior side dissection. Then I'll do a posterior dissection here, make a little frill. So I have understood that I've done a 2-plane dissection for this. And you do a first separation of anterior plane. It is very difficult to understand that you are not anteriorly or you are in the posterior area when you are actually dissecting this, because you'll be reaching up to the periphery of an entire cap cut, whichever plane you are dissecting with. Once I have this, I'm struggling to see the posterior plane. Actually, what has happened, if you see very carefully, I have already started with the posterior dissection here. You can see a frill here. When I started, I actually gone through posteriorly. So if I had seen this posterior frill, I've just nudged out at that time only, which you'll see now how I'll do it. We'll take a reverse side of a spatula with a sharper one and nudge out the cap, the lenticule is attached to the cap, right up to the central area. Once you do the central area, you can take a spatula above that and dissect out like a normal thing. Sometimes I do it this way also. I start with a posterior dissection first nowadays and do anterior, which may be a little faster. This is a within a week picture of under a dilatation. The bed looks quite smooth. OCT also is quite smooth in these cases. For doing a rhexis type of procedure, normally we like to have 2 areas of meniscus formation so that we can do a rhexis easily where you don't want to do dissection in your cases. The incidence of complications or difficulties are quite less with the experience. This is the algorithm for how you identify the meniscus sign and anterior posterior dissection, how you go it. The retreatment rate, which is a major concern, was there for many people, is not much now. Incidence is very less for retreatment, less than 4%. And the idea is also there to how to handle these cases, depending on cap thickness, the sports patient on. The interface is very, very important apart from the residual bed thickness. You can program various ways to tackle cases which may require a re-procedure subsequently. Most interestingly, PRK done for most cases. One thing we like to highlight here, the PRK results in a re-procedures is different than a primary procedure. So that we'll have to understand very, very clearly. So learning curve would be there. I would say lenticule dissection is a major challenge for our beginners, but as you cross onto 100 eyes, you are quite experienced. Section loss, it also happens in early phase of your learning. Subsequently, there are hardly any cases of section loss with better counseling of patient and better surgeon experience. And I would also understand people have access to various ways to learn, see videos, listen to various experienced person to decrease their apprehension and complication for future. Thank you for your kind listening. These are our books we were recently published on refractive procedures, which will be, most people will get it from our side to have a better access to these books. Thank you for giving this opportunity, Dr. Namrata and entire DOS group.
Thank you, sir, for going through that entire entire surgery of smile, right from the learning curve as to how to manage the complications. Any comments from the panelist there? Or I think we'll
I
take.
think Dr. Mahipal has the same
Yeah,
subsequent
yeah.
talk. You can have questions later.
Yes, sir. So Dr. Mahipal sir, for innovations and smile.
Yeah, thank you very much, Namrata, and always a pleasure participating in DOS, and thank you for the program, and always either I follow Dr. Titial or he follows me. So both of us go back a long time, and Titial is one of the finest surgeons I've seen in this part of the world. I'll be talking about certain things about innovations in Smile. So Dr. Titial has really taken up the first one, which is the improving the dissection techniques, which is there. And I'll be talking about dissection techniques, astigmatism, complications, circle software, and innovative use of the lenticule. So this has been described by Dr. Titial, and he has very eloquently told about meniscus sign, which I am sure is a very good sign that all of us should be looking at. There is a sign that has been described by Susan et al., and that is the white ring sign. So if you see this particular area where you are lifting, or you see this particular, what you have is that this is where you get like a white ring. So this is very clear that the plane of dissection that you are having is at the present moment, it is going below the lenticule. Now, this is a sign that has been described by Dr. Ramamurthy, group Gitansha, Shreyas, Dr. Ramamurthy, and this is what is known as a stop sign. So if you look here, that means that if you are at two planes, you can see here, this is the first plane that you are going, and you can see that this is the second plane. But if you look and coming towards the right, you see there is a stop here. That means that these are two separate planes. If you were in the same plane, you would not get this resistance. So you can see that there is a resistance on either side. And that is what is called as a stop sign, because you are at two different planes, which is there. Now you can see in this particular case, when you have, this is the side cut that is being opened. And as you go in, you can see this is the entry. And then you see the OBL getting released. So whenever you enter into the anterior plane, you get a release of the OBL. And just look here, when you look at this particular point, you can see that there wasn't a resistance. So this is going into the same plane that you are having. There is a lack of cyclotorsion. So what you have to do is you can look at the crosshair, and once you look at the crosshair at that particular time, you can see this mark here. You can try to have the lenticule aligned to these marks, so the infrared ink does not come in the way of this, and you can have, but the newer versions of all the machines, I would say, including the Visumax, are going to have the cyclotorsion compensation. So that is one important thing that is there. Now, intra-op OCT, again, Dr. Titial's group has described that post-operatively, the OCT can be obviously of great help, but intra-op OCT can obviously give rise to the identification of an edge of a lenticule, or if there is a retained lenticule. Sri Ganesh has also described. Dr. Ramamurthy, Gitansha, and Shreyas, they have described the use of triamcinolone. So you can see here that if you use triamcinolone, you can get, so you can use even hydration. Simple hydration can make it more opaque, the lenticule or the retained lenticule. You can use triamcinolone. You can also use fluorescein stain. So anything that, or you can use the slit beam or the intra-op OCT to take out any retained lenticule that is there. Again, you can see in these particular cases, if there is a retained lenticule, which you can see on the OCT, then you can have a central remaining area which is there. So this is the circle scan, which I'll show a couple of uses of the circle scan. And this is the software that we have used in this particular case for taking care of the time when we had repeated suction loss in this particular case. So you can see in this particular case, this is, so you can see there is a suction loss here. Now, what does one do? I'm trying to go in. I'm using even a particular blade, which I'm trying to use in this particular case. But then we go on to the circle scan. So this is the previous cut that you can see. Where was the previous cut? Sorry. This was the previous cut, and in the previous cut, we could see at this that with the circle scan that we have done, we are now going in and raising it. And you can see we made a flap, and then the circle scan, we can remove the lenticule in this particular case. Now in this, this is another case where you are having a problem, which is a loss of suction again and again. And there is a loss of suction again and again for making a flap. Now, in this particular case, there was a use of the circle scan when the flaps were not there. One was able to use the circle scan cases, and this is the circle scan which is being used. So just see here, 3 times suction has been lost, and you can see we are using only the side cut in the circle scan. Scan can be used only for making a side cut. So if you are stuck at one particular time, you can actually work on this particular way of raising the length or raising a flap if you are short of licenses. So this is something that we have talked about. So this is the paper that has been published, which is there. Now we have also described tailored stromal expansion with refractive lenticule for cross-linking of ultra-thin corneas, wherein we just have the lenticule we put onto the cornea. You can take any donor tissue if you want, and you can actually have the thickness and go ahead and use the lenticule to increase the thickness. So this is the cornea that is being taken off the epithelium. This is the lenticule that you can see that's been taken out. The lenticule will be put on the center of the cornea, and you will increase the thickness of the cornea, central cornea, and go ahead and do the cross-linking that you want to do. We have also used this. This is published in American Journal of Ophthalmology, and that is the use of a similar procedure of a lenticule for intacs as also with cross-linking. Philly has been described, but I think this will be a thing of the past because all machines are now coming out with a hyperopic mode. I am personally also working with one. This has been also used for keratoconus by putting in tissue, and this has been described by Shri Ganesh. And there is also the use of the lenticule that has been used for part of the lenticule as intracorneal ring segments also. So friends, what I feel is that with hyperopia coming in, with cyclotorsion compensation having been taken care of, this is the least invasive thing that is there, and all the companies are working very aggressively. The Zimmer has already released commercially the availability of an equivalent of a lenticule extraction, and other companies are soon following up. So I think this is the future. Dry eye, biomechanical stability, environmental condition, humidity, etc. not coming in the way. And as Dr. Titial said, the incidence of retreatment has gone down significantly. So this is all that I'll wish to say. And I think tomorrow we'll also be able to have SMILE on top of SMILE. So that is the other thing that has been left just now uncovered as things stand. But the retreatment rate is so low that SMILE on SMILE may or may not be a very, very great kind of a thing where the companies are working on. So thank you very much. And this is what I feel, that this is the technology of the future. And we are having more and more people go in for this technology as compared to what it was, say, 10 years ago. Thank you.
Thank you so much, sir, for going through the innovations in SMILE. And I think everything that has happened or will happen has been covered. Can we now have the comments from the panelists, please, on this? Dr. Gaurav Luthra, Dr. Ramamurthy, Dr. Rajesh Sinha.
Thanks, Dr. Namrata. I think 2 very wonderful talks, comprehensive talks from the masters of SMILE. And I think we've covered almost everything. And with the launch of the new Visumax 800 and a couple of other machines, I think there was a live surgery session yesterday where coming from the Schwinn platform, and there's also the Z8 which is coming in. So these are exciting times because all the research is actually happening on this front, lenticule extraction itself. And with the upcoming hyperopia treatments available and the short times for treatments, I think many things which were, and with cyclotorsion control coming in, lots of things which were thought to be problems with SMILE. Actually, frankly, we kind of managed very well with SMILE even so far, but things will get even better and better. So I think the techniques are evolving. Everything seems to be going for SMILE right now. And there's only one thing which yesterday I was going across a study, and I'll take the opinion of our other speakers about a comparative trial between topo-guided LASIK and SMILE, where this was published in the JCRS, I think in the last month itself, about their finding that the centration of ablation on the visual axis, they found that topo-guided ablations were way better than SMILE. So any comments on that?
As things stand today, Gaurav, because of the stringent FDA, etc., one is the optimization of the machine. Every machine needs to be optimized, and Dr. Titial, as he had pointed out, the dissection needs to be as smooth as possible. If you have a smoother dissection, there is the visual outcomes are much better on day one, etc. But the centration we cannot really do today. See, the point is that wherever you have held, it will be held at that. But even though it's an aspheric lenticule that we are taking out, and it is much more amenable to some amount of decentration, but if we get it on the center, in the machines that at least I'm looking at, there is a possibility of changing the centration even after docking. So like you have in the interlace, you can change the centration after docking. So similarly, you will have this possibility of changing the centration after docking, and I think that is going to make a difference. And obviously, if there is some amount of topography guided situation that is there, there is obviously a thought process, because there are these machines where they had topography guided, or they had abrometry guided ablations like you have in the custom view, etc. And they will try to marry both these technologies. Just now, if you look at the platforms that are available, they have not tried to marry these two technologies. So that also I think will come. And one point that I missed out saying was that irrespective of the amount of refractive error that you are taking out, the time taken for a lenticule is the same. So whether I am doing a -10 or a -1 or a -2, the time taken is going to be 22, 23, 24 seconds. And with the newer machines, they have all come down, including where I would be working, they're all below 20. They're around 14, 15, 13, 14, 15 seconds that is there. And the amount is very little for a suction loss. But this study has to be worked or looked at where we can do a centration on the SMILE platform.
I think just to answer Gaurav's question, what Mahipal has already mentioned it, but what we are looking at with SMILE is auto-centration, because the patient is looking at the visual axis. And also the fact that unlike in excimer laser, when the eye is free to move, here it's held down by the suction apparatus, so that most often we do not get a problem. But having said that, if you're dealing with corneal aberrations, you're looking at correcting aberrations, maybe a excimer laser platform as of today will have an advantage. But I believe that the SMILE machine that we are using is being from a single company, and it's essentially a first generation machine. And in the next 2 or 3 years, with Zyma, Schwend, Zeiss itself coming with a second platform, Johnson & Johnson looking at, all of these, as was mentioned, are going to be having a cyclotorsion ability, SMILE on SMILE, ability to correct even aberration guided profile as far as removing the lenticule is concerned. So these are exciting times, and the advantage of having a flapless surgery with just a 2 millimeter incision, this might be the way that the world is going to move. And whenever you have competition, you find that the things improve, and maybe the cost will also come down, which is extremely important as far as the uptake of a technology is concerned. One thing I have a reservation about is the SMILE for hyperopia. You know, they have been talking about it. It's not a recent thing. It was tried way back in 2010. And what you get is a donut-shaped lenticule. Somehow that has not clicked. It has been coming off, and it's something like the some technologies which have really not been adapted. So I'm not very sure that that's really going to fructify. And even the current models of machines that are coming in really are not emphasizing too much about hyperopia being taken up by SMILE or a similar technology. Zyma calls it clear, but basically it's just a difference in nomenclature, but the theory behind it, most of these procedures is the same.
So Ram, I have worked on animal eyes, and basically there's no problem in taking out the lenticule, and I have looked at the profile geometrically that has been shown as to what it is. So I'm pretty confident that this is going to come, because obviously when you do studies, FDA phase 1, phase 2, phase 3, you can't have all the things. You have to have tighter this thing. But at least on animal eyes, I have not found any difference in removing the lenticule for hyperopia, and the optical geometry looks pretty good. that this is how it will be taken
And
care
you know, people like Jyotbir Mehta, Walter Secundo, and all have been doing on right from 2008, 10. Of course, it is the earlier machine,
Yeah,
but
they've been
let's
working
hope
on
that it
that,
works. I mean,
let's see.
I think, okay, I think with this, Dr. Tityal sir, would you like to comment before we move to the next talk by Dr. Chitra Ramamurthy?
No, I think we can move. Most of the things have been covered. We fully understand SMILE is going to be the future corneal refractive, laser refractive procedure for most cases. With the newer advances coming up, definitely it will be the way forward.
Okay, so I would now invite Dr. Chitra Ramamurthy, Chairman, Academic and Research Committee, AIOS, and a very experienced and a skilled refractive surgeon, needs no introduction at all. Extra procedures. Where are we? I think a difficult topic to cover, Chitra.
Yeah, a very good afternoon to one and all of you, and thanks a lot, DOS and Namrata, for having me here today. So without ado, I'll go on to telling you about extra. Okay, there's a problem. Not moving. Yeah, so it is a very small additional step to the laser vision correction, but there is this controversy which has shrouded us all along, that are we doing the right thing? And in the next few minutes, it's about the literature search which has been done for doing cross-linking with laser vision correction. And truly it has unraveled very encouraging factuals, nothing very drastic, but one thing which definitely came across is all that it probably needs is refinement of protocols to keep it more stable and consistent and robust. Now, why is it we want to do an extra procedure is because when we are looking at high refractive errors, thinner corneas, thinner residual beds, and especially those borderline topographies where we are not very sure whether there is exactly some kind of ectasia which we are neglecting or ignoring, or those eyes which are more prone to rubbing or pregnancy, and of course, family history of keratoconus. These are areas where we sometimes feel we could touch, we could do a laser vision correction, but do we just stop with us is which challenges us. So then essentially a weakening procedure of the cornea is either in presence of ectasia or a regression where there is a biomechanical change. And towards this, these kind of LASIK extra, SMILE or PRK extras have come to stand its test of time. Although having been doing these procedures over the last number of years, we do know that yes, there is refractive accuracy and it is safe and efficacious, but we are still not sure because of the limitation of the biomechanical ways of measuring whether we stand right. Again, the arguments for it is yes, the incidence of iatrogenic ectasia is small, and there is some news about different enzymes contributing towards it. But then there are these higher refractive errors which we do correct, or thinner corneas, where there is a chance of regression, and those corneas which are at risk, which tells us that why not we go ahead and do these cross-linking procedures in these eyes. So then what is the concern? The concern is, yes, there is some amount of flattening of cornea, there is compactness of the lamellae, maybe there's a mild haze. So, but then could these have a refractive impact? Experience tells us that it has not been so. So have numerous studies told us. But all that we have is a quantitative impression of better biomechanics on the ora and corvis. So then there were different published studies.
I think we've lost connection from
Yes, ma'am.
Chitra, Dr. Chitra, or is it that we've lost everybody's connection? I can only see.
No, ma'am, I can hear you. I can see you very well, and I'm in Pune, so yes.
Dr. Tityal's this thing is moving. I think Dr. Ramamurthy is also frozen up. So I think they're probably at home and they've lost their internet.
Yeah, we are fine. We can see.
So
These two frames are to just become still.
can we then move on to the next talk?
Yeah, I think Rajesh.
We'll move to the next talk then, and the next talk is by
Dr. Gaurav Luthra.
Dr. Gaurav Luthra, ICL Pearls and Pitfalls, and when we have Chitra back, we will continue hers. Gaurav, are you there? Gaurav is also not.
I think, ma'am, even Dr. Gaurav is not here. We have Dr. Rajesh Sinha. Yes.
Rajesh can start. Rajesh.
Rajesh, you can start.
Yeah, I'll start.
I think Dr. Chitra has come back.
Dr. Rajesh, we can see your screen. If you could put it in the presentation mode.
Yeah, I'll do that. Okay, so many thanks to the DOS executive, especially Dr. Namrata Sharma, for having me in this session. I'll be discussing about an important issue which is still there with ICL, and that is extremes of vault, which is it's not moving. The normal vault, as we all know, and we all, most of the people have described the normal vault as 250 to 750 microns because we need to have a proper vault in order to prevent complications. Now, with this normal vault was described when we had the earlier generation lens, that was V4 lens with no aqua port. Now, with the current generation lens with the aqua port, the risk of the less nutrition to the lens or the risk of pupillary block and all these things have minimized significantly. So we may go a little low, a little up, depending upon the anterior chamber status. But in any case, less than 200 and more than 1000 is definitely not acceptable, because if you have less than 200, definitely the risk of cataract formation is there, because many times we have seen vaults of 60 or 70 wherein it's almost touching the lens, so the risk of cataract formation is there even in those lenses. The vault is too low. What happens that the contact area of the uveal tissue of the iris and the phakic implant is more, and that results in more of rubbing, and that can result in post-ICL uveitis. So that is one issue. And if the vault is too high, then the peripheral, there won't be pupillary block, but the peripheral depth will reduce. There will be risk of peripheral synechia formation, and that can result in glaucoma, even with the current generation lenses. So the issue is that we have reached so far, but we have not been able to sort out the issue of sizing. Why? The reason is this, that we basically implant the lens based on the white-to-white correlation, and the lens is implanted in the sulcus. And as we know that relative to the limbus, the sulcus is on average 0.21 millimeter more peripheral on one side, that is 0.42 millimeter longer than white-to-white measurement. But this is not absolutely fixed in each degree, in each axis. It is variable, and that is one reason why we have still not been able to find out an absolutely perfect lens. And various studies have been done. We have also done a study wherein we wanted to see what are the factors which procedure will help us to get the proper size of the lens. We did the UBM also to look for the sulcus to sulcus dimension, because the ICL or any phakic implant is implanted in the sulcus. Now, this is absolutely fine that if we get an absolutely perfect sulcus, then we will be able to know, and particularly in a particular axis, then we will know that in that axis, if we implant the lens, then this will be the vault. But what happens normally and practically, if you do UBM yourself, you will understand that the cursor has to be placed manually only. And sometimes because of the insertion of the iris, which is variable in different individuals, the visibility of the end of sulcus is sometimes, not absolutely accurate. And then when you place the cursor there at the visible end of the sulcus, then you may have some error. And that is why, even in our study, when we found out that 80% of eyes showed appropriate size with digital caliper and OpScan. But only 7% additional patients, like 87% of the patients, showed a good correlation with the UBM sulcus to sulcus dimension. And that is the reason why we felt was that the sulcus dimension measurement is perhaps has some human error in that. The second reason why the vault may be inappropriate in all these cases is that there was one study which was published. It's a big study of a large number of patients, something like 11,000 or something. And then what they found out that a large chunk of patients had one of the foot plates on the ciliary process. And on the and a few on one side it was in the sulcus, on one side it was on the ciliary process, on the some foot plate landing on the zonules. And with time it moves, with time it changes, and that is also perhaps one reason why it can result in, even if you don't document definite increase in thickness of lens, the value of the post-op vault changes with time, and that is perhaps one reason. So all these reasons are there, and if there's a very low vault, then in that case you have to explant the lens and replace it with one size bigger. If it's a high vault, if it's toric, then you may have to wait for some time, as I mentioned, because of multiple factors. And we can see after a couple of months, if it has come down to less than 1,000, then we can go ahead. But if it's still high, then we have to explant and put a lens of one size smaller. And if it's a high vault and it is spherical, then in that case, you can rotate it and make it vertical, because as opposed to the wide to wide diameter, which is more in the horizontal meridian, the sulcus dimension is more in the vertical meridian. One point I would like to emphasize here is that while you are rotating, as you can see here, in the intraoperative OCT helps you to know, it guides you that the vault is changing by rotation. And one thing that you should do is that when you are rotating the lens, the pupil should be well dilated, and you should inject viscoelastic at the edge, dispersive kind of something like methylcellulose at the edge of the ICL, so that it goes behind the lens as well and above the lens, so that while you're rotating, you're not damaging the zonules. That is very important. And once you have rotated, as you can see here, intraoperative OCT gives you the idea that the vault has reduced quite significantly. So as you can see here, the vault has reduced quite significantly. And a lot of studies have been done in order to predict the vault post-operatively. There are some studies which have used the lens thickness and the sulcus diameter in order to predict the post-operative vault. And we have also done at our center under Professor Titial, we have given a formula to predict the post-op vault. Now, this is one study which states that the intraoperative vaulting correlates well with the post-op vault. And that is useful because you get to know intraoperatively when you are rotating the lens, you get to know that if the vault is something around 500, 600 or 700, it will be something around that only, about 60 or 70 microns up or down. This is the pre and post-op picture. Now, if the vault is too low, in that case, you have to explant the lens. As you can see here, this is the lens wherein the phakic implant is almost touching the crystalline lens. See this is the crystalline lens margin, and this is the phakic implant margin. It is almost touching here. So in that case, you have to explant it and replace it with one size bigger. Once again, here also you have to take that precaution that when you are explanting, you have to inject viscoelastic at the edge so that little bit of viscoelastic goes underneath. Then you push more viscoelastic behind the phakic implant, very gently mobilize to bring one foot plate above, and then hold at one foot plate, not at the center of the foot plate. Hold at one side of the foot plate so that while you are explanting, it comes out very easily, and you can explant it through a 2.8 millimeter incision through which you can implant another lens. There are various formulas, as I was mentioning, that there are various formulae there in the literature which have predicted the post-op vault, and even in RP Center under Professor Titial, this formula has been given to predict the post-op vault. However, this may not be very useful in the sense that you need to have an inventory of lens. If the vault is too high, then of the same parameters, you require another lens to put it on the table. So values which are pre-operative, which can predict the post-op vault, may be more useful. However, even with all these prediction formulae till date, the postoperative vault is a matter of concern, and perhaps the only factor that is a matter of concern, although it has reduced to a great extent, and in very few cases we do get surprises in vault. However, we need to do I guess, a little bit more of work in this direction in order to be absolutely correct in getting an absolutely perfect post-op vault in ICL or any phakic implant. Thank you very much for your patient listening.
Thank you, Rajesh, for that excellent presentation on the ICL vault, which itself is a very difficult problem to deal when you have it too low or too high. I would now request Dr. Chitra is back. Dr. Chitra, to please continue your talk of LASIK Extra. I think ICL, IPCL questions we can take when other two talks are over.
Yeah, that was a lovely talk, Rajesh. So I'm going to continue from where I left off. I believe you all heard some of it. So essentially in LASIK Extra, you would invert the flap like a taco and then
make it slide. Make it slide.
Yeah.
Yes.
And then apply riboflavin, wash it off. But again, herein also the energy protocols in the different studies varied from 1.4 to 5.4 millijoules. In other words, there was never a consensus on the final. I don't know what is happening today. So then again about Smile Extra, as we all know, here Vibex Extra is placed in the pocket for 90 seconds and washed off, and then the laser was done. And here there were two sets of energy protocols which are used, one at 30 milliwatts and at 45 milliwatts. But the energy delivery actually varied herein again from 1.4 to 5.4 millijoules. So essentially, there has never been a standard protocols in the different studies, and each of them have had very positive results. Again, what was seen was that the ectasia rates, there was not enough long-term data available post cross-linking, post extra procedures. But what they did come to see is wherein this regression suspects were concerned, definitely there were positive results because there was a better biomechanical strength which was conveyed. But what was more obvious was there was less of hyperplasia and less of epithelial modeling, which was one encouraging sign. There were essentially 10 papers on myopia and 3 papers in hyperopia, and in all the myopia the results were very comparable. Maybe a little better uncorrected visual acuity was seen in the extra procedure eyes, and in the hyperopia it was significantly better, and actually they noticed less regression. And this was a 2-year study done by Kanellopoulos et al, and herein he has noticed that wherever the LASIK Extra was done, there was only a 0.19 diopter increase in refractive error from regression as against 0.72 where the LASIK alone was done. With the Extra, there were 4 studies. What they could convey in that was there were indices, biomechanical indices, but again on aura only, which showed that there was improved biomechanics. So then what we realized was that in the Smile Extra, the few studies which were there were some 15 eyes where the form frustrate keratoconus eyes were treated with 5.4 joules, and there was a temporary increase in haze, but they also claim that there was no loss of visual acuity and the refractive impact was not there. So, but then there is certain questions which remain. That is PRK, we need to use as accelerated mode because on a conventional mode, you might have a refractive impact. Again, with LASIK, we do know that the flap does not contribute to biomechanical strength. And what are we doing by cross-linking over the flap? With Smile, the epithelium is intact. And we do know that epithelial barrier is going to ensure there's a reduced efficacy of cross-linking. So none of the studies were head on it. And there was one case of a young hyperope which had ectasia in these studies, but overall, consistently, efficacy and safety index was better or comparable in all the studies, and the keratometric stability was uniformly good. The other interesting thing which came off from looking at these literature search was none of these eyes, there was an adjustment made for the nomograms. And MMC with PRK was used in majority of the cases, and everywhere it was suggested that we should ensure that the flap is hydrated so that there's no shrinkage. And one study also claimed that the riboflavin diffusion in the superficial stroma ensured that the flap adherence was better, and there were hardly any case of keratitis, DLK, or toxic keratopathy. But again, Why do we still think of using extra S? We need to understand that there is tissue subtraction, there are vertical cuts on the flap with LASIK, the SMILE, there is a delamination cut, there is Bowman's membrane disruption in PRK. So then when we look at all of these, it still seems to tell us that probably PRK would be a more logical argument for doing extra procedures. And as far as regression is concerned, we do know that the epithelial hyperplasia has been less in most of the studies. There is a tightening effect of the lamellae, which you all know does happen with cross-linking. So probably we still could keep our minds open for higher refractive corrections and thinner corneas. And the transepithelial approach definitely tells us that the cross-linking is questionable. So all these studies have looked at patients over the two-year period, and we do know that ectasia could develop over many years. So just the 2-year study and the supportive evidence it gives is not conclusive enough. There have been studies which have even shown gain in lines in these extra eyes, and the temporary haze which was seen settled within 2 months. So probably we could conclude saying that we do not transgress into areas of form frustrated keratoconus. We need to avoid haze and ensure that there is no visual impact. And we need to keep in mind that the energy protocols should be only half so that there is no refractive impact. Probably we need further studies and a more uniformity in protocols in all the studies to come to something conclusive. But then we need to also keep it in mind that yes, it has a role in the armamentarium of refractive surgeries. Probably we need to look at many more studies with stable protocols before we conclude that extra procedures stay in or do not stay in. Thank you.
Thank you so much, Chitra. Like I said, it is such a difficult topic and you covered it so well and so completely, like always. So anybody who would want to comment on this, because I know that Dr. Chitra and Dr. Ramamurthy would leave after this. So if there are any questions for them, otherwise we move on to the next talk. So the next talk is going to be by Dr. Gaurav Luthra. You've joined back on ICL, followed by IPCL by Dr. Kamal Kapoor.
Thank you, Dr. Namrata. And sorry, I was logged out for a moment in between. And so I'll try to, excellent talks on ICL so far, and Rajesh's talk was really nice and crisp. So, and I know that Kamal is doing excellent work with IPCLs as well. I wanted to share a few pearls, and here a situation where an ICL was being attempted, and it's important, of course, to load the ICL correctly and being able to see that the holes, the 3 holes align under the microscope. I always like to check for that, so that when you're injecting, if there is any twisted ICL, you will know in advance. And here, as we injected this ICL, we realized that if you have a moment of hesitation, or if your counter pressure from the left hand is less, you will sometimes have the cartridge tip disengaged, and then it's best to either withdraw the cartridge even at a late moment, or you can re-inject it using, reload it and then re-inject it. So it's always better to ensure that your ICL opens up the correct side up. Otherwise, you can always abort the injection even at the last moment and manage it better. Now, sometimes you will have a situation where once you've put in the foot plates, and nowadays we don't use pilocarpine much, so it's always a small chance of having a situation like what I'm going to show just now. And once I was kind of confident that my ICL had gone in nicely and I was going to get out of this. And since I do hydroimplantation nowadays, I don't have to wash the viscoelastic. So I was ready to kind of stop operating when I suddenly noticed that there was a funny peaking of the pupil over here. And at this point, you have to be very, very careful, because if you don't watch out for these situations, you will sometimes end up being having a pupil which is and haptic which is beyond the pupil edge, and it's not really visible. So you have to be really alert, and that's a very good sign as what I showed over there. And you can see for a small peaking of the pupil between the 2 foot plates. Now, this is another small video clip where ICLs typically require you to make an incision of at least 3 millimeters. It's a good idea to check for any leaky wounds. And sometimes if you have a leaky wound, which happens very rarely, but it can, and then you can just make a supraincisional tunnel, and that can help you seal the wound nicer, because you wouldn't want to suture a ICL wound to induce astigmatism. And here you can just hydrate the pocket and then do the trypan blue test, which I typically use in my pediatric cataract to ensure that there is none. And here another small video clip of ICL. As you're injecting it, sometimes it twists, as I was mentioning, and if you're not careful about that, those alignment of the 3 holes, you will have a problem, and the ICL can sometimes, with your best efforts, still have a situation where it might flip, but you have to just bring it out. Don't try to flip it inside. It's easy to just explant the ICL from a 3 millimeter incision by just holding, as Rajesh showed. Comes out very easily, and then you can re-inject, of course. And going on, sometimes you will see there's been talk by Dr. Maipal sir about some of our old patients coming back with cataract, especially those who had no central flow ICLs. So this was one such patient where the second eye had a very, very low vault. So I'm sorry, I think this one is about the low vault ICL, where an ICL exchange can be easily done. And nowadays with the central flow, it is very good. The tolerance for low vaults is very good, and you may not have to. And Rajesh has actually spoken quite well on that. But when an ICL exchange is required, I think we've already seen videos of that. So I won't waste time on this. Go on to the next one, where we are dealing with the cataract. Now, the good thing is when you have a cataract, you don't have to worry about the biometry in such eyes. And typically you'll see these cataracts only in your very old patients before central flow became available. There are rare instances recently where viscoelastic was retained, and some of my IPCL patients from the initial days, but off late with the central flow on the ICL as well, things have changed. So cataract can be very easily managed. The biometry is straightforward. ICL can be brought out, and it can be, the rexes can be done. The few things about which you have to be careful. Let me take you to this next video, which is more recent. And here we had a 35-year-old female operated by me in 2012, both eyes ICL, no central hole in these lenses, came back with a bilateral cataract after following up almost after 7-8 years. And had to be taken up for surgery. The first eye we went ahead with a standard straightforward phacoemulsification, but patient was very anxious, and we realized that the capsule had become very, very friable, and we had to be very careful about that and managing the capsule. So for the second eye, we decided to do a femto-assisted surgery. And in this, it's always a challenge because the laser does not detect the ICL as it should, because it's not programmed to do that. So you have to modify the landmarks very carefully and change the energy settings and also the offsets for the anterior capsule. And then it still becomes a very predictable surgery. And you can get good ablation with the laser. The femtosecond laser is very useful in patients like these where you are having a situation. This patient was, a little uncooperative and anxious, so we had to be. That's why we decided to use the laser, and I think it's very good. I've seen that being done by a few of the other surgeons as well. It worked very well for us, and also ensures that your access is much better and more predictable as long as your settings are correct. Now here another learning point for us, because this was almost a 10-year-old surgery, and typically ICLs come out very easily, and using the hand-on-hand technique, as we started removing the ICL from the 3 mm incision, we could remove it only partially before the ICL gave way and tore. And so I think there is some denaturing of the ICL material sometimes, and over a period of time. So if your ICL has been in the eye for a very long time, it may be better to have a slightly bigger incision. This is what we learned, because in the past, every time that we've done any ICL exchanges or removals, we've never had this problem of the ICL tearing the material or material degenerating. This was the first one, which was more than 10 years old. So here, however, later on, we were able to manage it and get a good result. And eventually the surgery, of course, is uneventful. And I think I have just one last more video to show. I was referred to this patient with an inverted ICL by from one of our colleagues who did not know what was going on. He did not have an OCT to check, and he was wondering why the ICL is behaving in the peculiar way. And this is how it looked. And patient was sent back to them for explantation. The patient came back with a big punctured hole in the anterior capsule, which had to be subsequently managed in a very, very challenging way. And this became a big challenging surgery for subsequently for us. So I think it's very important for us to be careful on table. I think intraoperative OCT has a big role there. And I think I'll stop with this, because take home message. I think phakic lenses have become so popular, and our threshold for implanting them, even with small bars in suspect corneas, has gone down. Even 2 or 3 diopter phakic lenses we are implanting now. And though complications are rare, but they are on their own set of complications. And meticulous workup and meticulous execution can help avoid most of the complications. Thank you.
Thank you so much, Gaurav, for covering it in a fast-forward mode. I think cumulatively yours and Dr. Rajesh Sinha's talk, completes the whole picture. Issues of vault, and you left those issues from your talk. So thank you so much. I think we will take Dr. Kamal Kapoor's talk. Dr. Kamal, your talk on your experience with the IPCL.
Okay, is my presentation visible?
Yes, your photograph is visible.
Okay, just let me see. Okay, yeah, I think now it should come on. Is it there?
Yes.
Okay, so I think excellent talks by my dear friend Gaurav and Dr. Rajesh. Rajesh covered excellent points on ICL vaults. I would just like to add a few little experiences I've had with the phakic lenses. In case in the initial period only, you realize that the patients come out with a very low vault or a very high vault, and you will need to order another lens. That's a little tip I have, which I've tried. In case the vault is too high and you want to wait for another lens, you need to order for that. It's a good idea to put the patient on pilocarpine. Believe me, the vault goes down by 250 to 280 on diluted pilocarpine. And if the vault is very low, put the patient on a mydriatic, cycloplegic mydriatic, and tell the patient that by the time the lens comes. So, these things will buy you time. The vault will go up by 180 to 200 on dilatation and go up to down by 250 also on constriction of pupil. So that's a little tip I have. I've tried that and works great in my situations. I have no commercial interest in any of the products I'll be talking about. So there's a large gamut of surgeries we've done. I guess we do a lot of phakic lenses. I'm a big fan of phakic lenses. I use it in most of the situations. Extreme situations, I'll be just kind of touching that. I do a lot of ICLs, but now off late, I'm just heavily into IPCLs. And of course, again, these are few points I would just barely touch because my topic is more so on my experience and some difficult situations. Power availability, of course, one of the reasons why I go in for the Indian brand is huge power variability, huge size variability, complete customization to what I want. I can get the optical sizes I want, unlike the earlier one. I was restricted with sizes. So I get a lot of bounced off cases from my other friends all across because, there are some situations, no need to rotate, a customizable lens. So these things. So I'll just come to the numbers. Size availability is 11.5 to 14. It can be actually personalized. I have also got lenses manufactured till 8.5 millimeter optic diopter, 4.5 millimeter small optic diopters. I'll be seeing some of these videos. It needs no rotation. So approximately 2,600 cases, 6 years plus follow-up, 17 cases of secondary piggyback lenses also done for pseudophakic patients, presbyopic lenses done. So this is my experience in a nutshell. I've exchanged oblique explanted explanted 6 cases. One was a post-traumatic. The patient has a subluxated lens, and then 4 other explanted for due to bad sizing, shallow vaults. Exchange was that out of 11 cases I did exchange, the patients were bad size, they were low vaults, or they were getting early cataract, very low vaults. So I had to shift it. The issues which I usually confront in my experience of practice are that in case the IPCL size is large, then I have to see that preoperatively, does my patient's pupil even dilate to the level of size I want to put in? That's a good tip. In case your pupil dilatation is 8.8, 8.5, because some pupils probably do not dilate completely, then you are stuck up, because in case you need a 13.5 millimeter lens going into an 8.5, that's going to be tricky. Another thing is, if your resting pupil size is large, again, then you need to order a larger pupil size. One small tip is I also measure the vertical white to white, which I did mention when Professor Lane was talking about that. In case my astigmatism is more than 2.5, I need a larger optic size. I measure white to white. It really helps me. Measuring the lens rise and the angle also is a very, very important part of collection. Now, some cases will be just saying, now this is a patient with minus 27 with 3 diopter cylinder, minus 29 with 2 diopter cylinder. Unfortunately, this girl had a retina detachment after 3 years of surgery, of course. So she was operated for retina with the silicone oil. She did develop a cataract in one eye where she had retina detachment surgery. So I did record this surgery as Gaurav showed one surgery. So I did the cataract surgery under the IPCL without removing the IPCL. And then after finishing surgery, I took the IPCL out. Now, this is one of my highest cases, minus 34 with minus 2. Now, some of the tricky situations could be, as I said, in case of a keratoconus, please let us not get confused with the anterior chamber depth, because sometimes in a keratoconus, which is not very, very off center, you might get a very good anterior chamber depth. Now that is a trap. Always measure the angles, always get a gonioscopy if you're going to be putting an IPCL or an ICL in a keratoconus patient. Make sure that the keratoconus is done cross-linked and it's stable, only then go ahead. In case you're planning for a toric lens, plan for a larger lens. If you would go for, let's say, a 13 millimeter for a standard spherical, go for a 13.25 in a toric lens, because that gives a far better. Now, this is one of my cases. This was fantastic 3.3 millimeter anterior chamber depth, keratoconus. And this is where I learned the lesson. I had a 0-degree angle after 4 days of surgery, and I had to explant this lens. So after that, I learned the lesson that my measurement of the angle is very important when I'm taking care of keratoconus. This is another patient where I've done an optical diameter of 8.5. I'll be skipping the video. Now, this is an interesting video, as Dr. Sinha and Dr. Gaurav also showed. Now, I use the hook method of explant. This is a bad vault. So what I do is I inject viscoelastic under the lens, slightly lifted, because I want to preserve the anterior capsule, and also want to preserve the cornea. I just get it into the anterior chamber, and I use one of the holes which is given there on the edge of the haptic to get it out. So I call it the hook technique. You will see that I hook my blunt instrument into this, and it works 100 on 100 times, and I just get out the lens. So as Dr. Rajesh said, never pull it from the center, hold one edge of the haptic and pull it out. This lens comes out of 2.8 and does the job. Now we will see some very, very tricky situations. This is a patient with corneal scar, 11 diopters of cylinder and minus 3.5 diopters. Now, either we had to go for a cornea procedure. So I thought, let me go ahead and see if I can help this person. This was a beer bottle injury. It was repaired many years ago elsewhere. This patient came to me, look at the corneal scar. So I put in a minus 11 diopter cylinder with minus 3.5 sphere. I'm going very fast because I have a lot of interesting videos to show you. This patient was 6x12 parts, very happy. And this patient was not even 6x60. Now this is another patient with central corneal scar. I'll skip the video. Minus 4 diopter sphere with minus 5 corneal scar, did a specially customized toric IPCL. Now, this is a very interesting case, which was operated by me approximately 16, 17 years ago. There's a child who came with an injury, and the cataract was done. There was a corneal scar. And now this patient reported after so many years with minus 17 diopters of sphere and minus 2 diopters of cylinder. And the whole lens is fibrosed with posterior sanique. So what are the options I have? Either I explant the whole thing with the bag, the whole lens, or I break the sanique. So I decided to break the sanique and actually evaluate what I'm going to do. So we got a customized, since I was not much bothered about the vault here because it was a pseudo-phakic eye, I cut with my micro scissors, I cut the sanique, I got the IPCL in, and this IPCL of such a high power. This is post 18-year-old surgery. This again, patient did exceptionally well with 6x9 part surgery. So without explanting the previous lens, I just did sanique, breaking the sanique, broke open the fibrosis between the posterior surface of the iris and the capsule. And I think this works great. So I'll have very, very interesting videos like these. Now, this is the same patient post-operatively. Now, this is another patient, small non-dilating pupil, fixed, complete fibrosis of IOL in the back, total posterior sanique. Now, this again, patient has got minus 13 diopters and a very thin cornea, high refractive index of high refractive error minus 13. So see, what did we do? We got a customized lens made because I was sure this pupil is not going to dilate enough for me to put in the lens. So I got a 4.5 millimeter optic IPCL manufactured for this patient. Standard phakic IOLs, as we all know, a range between 6 to 6.5. You can actually go to 8.5 millimeter. So I tried to dilate this patient. I tried to do a sphincterotomy, stretch. Nothing was working. So this was the max I could achieve. There's a complete fibrosis and adherence on the posterior surface of the iris. So I do a little bit of sphincterotomy to, probably help the patient and see what I do. This is a 4.5 millimeter optic size manufactured with minus 13 diopters. Look at the size of the IPCL.
So there we go ahead with a 4.5 and a 12 millimeter, specially customized phakic lens manufactured for this patient. The lens goes in. We just use a normal insertion procedure. The lens goes in very, very comfortably. It was a small optic with a smaller diameter because it was a smaller eye. And the lens works perfect. The patient is very, very happy. And this patient has sent me a lot of more patients because this patient was sent back from a lot of the patients. I have a decent experience of nearly 12 patients with the presbyopic phakic IOL. One of the patients is my OT technicians who I had operated 14 years ago with a simple monofocal. And I've replaced and just put a simple presbyopic IPCL, which was one of the first few lenses which was given to me. And this, one of the eye was operated in DOS live surgery many years ago. And this, my OT technician is actually able to bend the cystitome without glasses. Unlike me, I still need presbyopic glasses. He bends this needle without glasses. So that goes a long way to, say that the presbyopic phakic lens is also good. Thank you.
Thank you so much, Kamal. I think that was an array of, cases which you showed. So would Gaurav or would Rajesh want to comment on this? Your experience of IPCL, and Dr. Mahipal sir is also there, and then we will conclude the session.
I think
Of late, Rajesh first.
Yeah. So I think most of the things have been covered, and amongst the complications, what Gaurav was presenting very nicely covered almost everything in a very fast forward mode, as mentioned earlier. Very nicely covered. One thing I just wanted to add to it is that what I have noted in a couple of my own residents, that when they load the ICL, I'm talking about ICL, and they load it, they pull it with the forceps. Rather, it should be held with the forceps, and it should be pulled on the other side. That has a very controlled loading of ICL. That was one thing which I wanted to add, because there may be people who must have started ICL, and that's what I tell all my residents. That is one. Apart from that, one thing what I could figure out from Kamal's presentation was that most of your refractive surprises, you put IPCLs and not Sulcoflex or anything.
No.
So
I'd just like to add one thing, Dr. Rajesh, the way you explained beautifully about loading. One tip for at least IPCL, I feel, is it's a good idea to load the IPCL with the wings upwards. I've seen some of the beginners, they fold it with the wings downwards. So when the lens opens, it tends to touch the anterior capsule and open. So I folded with the wings upwards. So it opens, touching the iris, and then it opens. So I think that's a good tip which you brought out, and we must discuss it here.
So Rajesh, what you were saying is correct. Actually, the higher powers in a Sulcoflex are not available. So if you have, so ICL I have also used ICL when you're looking at say -16, 17, 15, because those are normal powers. The only question or the only doubt that I have about Kamal's presentation is that varying the size of the optic to 8 millimeters, 9 millimeters, 4 millimeters, whatever it is, I don't know whether any controlled studies have been done, because the vault is going to be different basis that particular.
Absolutely.
One second.
I think.
One second, Kamal. So the point is that about the smaller diameter, I didn't quite get the whole hang of it, because the size of the lens is the same. So we're making the optic zone smaller or larger doesn't matter, because the lens is whatever 11, 12 millimeters, whatever it is, because that's going into the sulcus. So whether it has a smaller, making it a smaller zone, does it really matter? And having a 7-8 millimeter, would it not increase or decrease the vault to any extent? And would like in other countries, won't similar FDA kind of an approval, etc. be done? Because the standards are pretty strict, and we are working on human eyes. And do we have any controlled study that the change in the optic? And the next thing is the power variation. Why is it that the other companies are not able to manufacture these powers? Does it not cause any physical problems in having the lenticules or the central portion with those powers regarding the thickness, etc.?
Can I come in?
Yeah, sure. That's for you.
Yeah. So I think that's a very, very good and keen observation, Dr. Mahipal. The reason why I went for a smaller optic size was even on the UBM, there was a very dense fibrosis. So I was sure that maybe if I could, have an elongated, because I had a
10.75, 11 millimeter white to white. It was a small eye. So I thought, if I'm able to break some Sanike to fit it in, but even if my optic size was bigger and the Sanike was not totally broken, in case you missed that part of the video, I needed to break a lot of Sanike. So it might have pushed my optic slightly downwards. So I went in the maximum pupil dilatation I was getting was 2 millimeter, 1.5 millimeter in this patient. So trying to put in a 6.5 or a 6 millimeter optic through 2 millimeter would have landed me in a situation where I might have got the lens in lengthwise, but the optic may be decentered. So that is why we designed a 12 millimeter lens with a 4.5 millimeter optic, hoping that slight amount of saniculosis in 2 millimeter pupil, which is totally fixed and plastic pupil, I would be able to get 3.5 millimeter optics pupil size and able to slip in a 4.5 millimeter lens, which it worked. It worked beautifully.
Kamal,
So seeing is believing.
I think that is counterintuitive, because if you are expecting decentration, you would want a larger optic rather than a smaller optic. So I don't
No, but sir, no, again, you're missing the point. You're missing the point. If there's a complete saniculitis, my Sanike will push the lens downwards.
Kamal, without breaking the synechiae, how can you push the lens in? After all, the entire plate lens has to go in and it has to settle on the sulcus. So without breaking the synechiae, how do you push in the lens? If you have been able to pull a 12 millimeter lens in
So I think you probably skipped seeing the video. I'll go back again.
I
broke
see
the Sanike. We broke the Sanike. But 360 degrees Sanike, I was not sure. So I was spending more time in the longitudinal part or the horizontal part, spend more time break the Sanike, where I could slip in the lens.
So you did selective saniculitis, and the selective saniculitis, the plate lens can go in, but the optic needs to be smaller, because
because I didn't know I might cause a lot of bleeding. If I tried to break the whole Sanike, I would have probably caused a lot of bleeding.
Okay, I would be anyway. That's besides the point.
What about the long-term outcome of these cases, Kamal?
This is Rajesh. Most
if
of
the
these
Sanike
patients,
reforms, it may have,
okay, I think most of these cases, some of the video quality would have told you are around 4-5-year-old cases. They're all on my old VHS quality, and these patients are on follow-up. Not all of them are on follow-up, but most of these patients are on follow-up and they're doing great. They're happy patients. They're sending me more patients, and I guess that says a lot for what we did. I tend to, as Gaurav said, our threshold for doing these surgeries is going down slowly. We have to be cautious. We have to be scientific. We can have our own reservations. I agree with whatever you're saying. If I was sitting on that side of the chair, I would have said the same things. But slowly I'm lowering my thresholds, and slowly, step by step, baby steps, I'm able to help patients who have been said no to by other surgeons.
Yeah, because you need to be cautious, because they don't have the approval of the government. It's a device that you are doing and playing with the optic size, etc. When a trial has been done with a fixed optic size, etc., may not be legally valid.
I agree with you there, sir. We have our own nomograms for going beyond 6.5 millimeter optic size. I have my own nomogram where I calculate the wall pre and post over time, and we've done over 100 such cases, sir. And we have a nomogram.
But the DGCI should approve it, no? That's what I'm saying.
True.
I think another thing is that some of the cases, like you showed, were repaired corneal perfs. So they would have some amount of corneal astigmatism, which may be irregular, which will not get corrected by your lens.
Absolutely.
I think that has to be factored in. The regular part would definitely be corrected by it.
So see, ma'am, either we go over with Dr. Namrata, complete corneal procedures, keratoplasties. And again, nobody can predict the astigmatism come out. So this is a stopgap. You go in between. Patients are getting 612 parts vision. They're happy with it. And even in case you need to top it up with a contact lens, if required. I've not done that till now, but the patients are happy.
Kamal, you don't top it up with a contact lens. Just go in straight with an RGP lens, and you will get 6/6 vision.
Absolutely. Yeah. True.
So you do get great 6/6 vision with RGP lenses. So you don't.
I've never needed to do these contact lenses.
Okay.
Okay, so I think we conclude this session. It was a 2-hour session with the great discussions, great videos, and excellent presentations. So thank you everyone for this, and hope to see you again on another session on another platform. So thank you everyone.
Thank you. Thank you.
Thank you.
On behalf of the organizing committee, I would like to thank everyone for finishing it on time. Thank you so much again for your support. Thank you. We shall be getting started with the next session at exactly 3 o'clock. So we'll just take a quick break and come back. we have the cataract plenary session 2, which is starting at 3. We shall be trying to get started at 2:55. Thank you so much. See you at 2:55. Hello, Dr. Himanshu. Dr. Himanshu, can you hear us? Hi, Dr. Himanshu.
Hi, Nikhil, how are you doing?
I'm good, sir. Just waiting for everybody to join in.
Correct. Let me just see if I can share my screen.
Yes, sir. The screen is visible. Even the animation and the video is visible, sir. So we shall be going live in the next 2 minutes.
Hi, Manchu.
Hi.
How are you?
Hi, Baipal. How are you, sir?
Good.
खाना खाया महिपाल कि खाना खाते नहीं आप?
खाना भी खाया, बियर भी पी.
How are you?
I am good. How are you doing?
Great, great. Rocking, Avi. How is DOS doing? Great.
DOS is great. Attendance, I think, is less, as you can see from the chairs in the hall. But anyway, I think things are coming back. अब काम वाम ठीक हो गया पूरा?
Yeah, better, definitely than what it was earlier on. The fear has gone down with people. How about fear in Delhi? I think no fear anymore now.
No, I think July, August, September have been reasonably bumper, I would say. The one trend that I have seen is that the number of femtos has increased phenomenally. I don't know whether you have seen it or not, but I was just checking out on about a dozen machines in Delhi NCR. Between 19 and 21, there is a more than 100% growth.
Wow, fantastic.
Not mine alone, but
Yeah.
So we are going live in 1 minute.
Okay, जी.
और सर आपको देख के तो मुझे आधा तो टेंशन खत्म हो गया. आप हो तो
आधा टेंशन तो खत्म हो गया, मगर कोई है नहीं तो
हाँ, मेरा वही आधी बात तो उधर थी. मैं रोक तो लूंगा लोगों को 7 मिनट में, लेकिन रोकने के बाद क्या करूंगा वो नहीं पता.
कोई है ही नहीं. I don't see anybody else. Ragini has joined. Good. Bans is not there. Ragini is there. Then Ragini has 2 talks. Great.
Madam, good afternoon. You're muted. You're muted.
Good afternoon, Maipal sir. Good afternoon, Himanshu bhai.
How are you?
I'm fine, sir. Sir, I'm combining both my talks. I'm presenting only.
Great. You read my mind. I was going to say that. Please and you are the opening batsman as things stand, because I can't.
Okay, sir. So I'll just check and see if I can share my screen.
Yes, please. Yes, please.
Please. Because I can't see her once.
Yes.
Dr. Ragini, I just have one question. So shall I just put the timer as 14 minutes in all and interrupt?
No, 7 or 8 minutes, not 14 minutes.
आपके दोनों talks है ना? तो 14.
लेकिन वो जितना time में खत्म होएगा उतना ही time, not 14 minutes. या 8-10 मिनट का talk होगा उतना ही time.
नहीं, हमारे स्पीकर कम है ना, थोड़े ज्यादा बोल देना.
अरे
सर वो वापस आ जाएंगे सर, मुझे तो वो भी डर लगता है.
चलो कोई नहीं.
मुझे ज्यादा बोलने को बोला तो फिर तकलीफ होती है.
अच्छा ठीक है.
तो मैम हम लोग 2 टाइमर लगाएं आपके लिए, 7 and then again 7, ऐसा करें?
I'll finish before that.
या तुम टाइमर लगाओ ही मत, या लगाना है तो 14 मिनट का लगा लो.
हाँ.
बस ठीक है. ओके, shall we start?
Yes, sir.
Okay, good afternoon, everyone, and welcome to this session on cataract. And I have with me the co-chairperson, Dr. Himanshu, has joined, and let us see when the others do join in. And this will be a session where we'll be taking on various things, including soft cataract, toric IOL, etc., and also femtolaser assisted technology. As also we'll be talking about the glued IOL and also a talk on spherophakia. So without much ado, I think let us go on to this, and I wish to thank the organizers of DOS, Subhash Dadia, the president, Namrata, and the executive for giving us this opportunity to do this session. And the first speaker would be none other than Dr. Ragini Parekh, who is the HOD and Professor Ophthalmology at GGMC and JJ Hospital. She's really somebody who's very nice, available, and always willing to help. And I've always seen her to be a smiling person, and really been nice and great to have known you, Ragini, and always a pleasure to listen to you. So we'll go on to Dr. Ragini. She'll be combining both her talks on the soft cataract as also, I think, on polar cataracts. Ragini.
Thank you so much, sir. Mahipal, sir, you are one of the biggest ophthalmologists in India and abroad, and compliments coming from you mean a lot to me. Himanshu Bhaiya, who's well known and has had the nerves to operate the biggest person in India today. My teacher, Padma Shri, Dr. Lahane sir, and everybody. Thank you, DOS, Namrata, Dadaya sir, Bhalla sir, for giving me this opportunity. I will be talking on tips and tricks of soft and posterior polar cataracts. So, posterior polar cataracts invite capsular rupture. There is a difficulty because there might be a frank defect or there may be an abnormal attenuation. So what are the signs of caution? There is a peripheral thin opacification and mottling all over, suggest an intact capsule. Thick opacification in the periphery of the central plaque may suggest dehiscence. Thick central plaque may suggest attenuation. What is the difficulty with a soft cataract? Because posterior polar and soft cataracts are both soft, chopping is extremely difficult because you might end up chopping the posterior capsule. The posterior capsule is weak. Patients are young. Mostly, so many patients taking steroids today, and they have high expectations. Technically, they have a longer life to lead. So patient counseling is extremely important. You have to change or adapt your operative technique because each case is customized, and especially these type of cataracts. And you need to have a posterior segment instrumentation ready and standby. And that I feel it should be there for every cataract surgeon and for every case, not only for that. Every cataract surgeon must learn automated vitrectomy and the basic steps required to tackle a complication like a PC tear. It may not be a pars plana vitrectomy. So these are tips which are very important and we need to learn these. What is the incidence of posterior capsular rupture in these cases? So these are 11% by BJO, 26% by Osher, and 36% by Vasauda sir. What is the technique which is preferred? What are the tips for the technique? That the rexes, you can make a small rexes because you need to have a capsule left over in case you want to put in a sulcus lens. Hydrodissection free phaco is extremely important because, if the capsule is attenuated or there is a small defect, a large amount of fluid or a hydrodissection, which is cleavage between the capsule and the cortex, can increase the size of the rent. So only hydrodelineation. And with hydrodelineation, it also gives you a nice buttress of the remnant of the posterior layer of the cortex, which acts as a buttress and a support to prevent the PC defect from expanding. Low vacuum, low inflow, and low aspiration also helps you with the phaco-dynamics. And also, since the cataract is not very hard, you can do with such low parameters because you will still be able to remove the cataract. Dry aspiration of cortex and epinucleus, again, because you don't want a large volume of fluid. And if there is a pre-existing defect or an attenuation, then you will not either enlarge it or cause it. So these are important points to remember. So this is a video of a soft cataract, as you can see, and these are the techniques. You can use various techniques, the flip technique, the bowl technique, the flip and chip, or the no chop aspiration technique, as we will be seeing. So this is the first case, which is called as a flip technique. As you can see, there's a perfect glow. There's a large posterior polar cataract. After a rhexis, as you can see, there is only hydrodelineation, which is in the substance as far as the dissection cannula goes. And you cannot chop. So what you do is you rotate and flip the cataract, because it's, carousel it, flip it, and you eat the cataract or aspirate the cataract as a whole, as you can see over here. So there is, it's not possible to chop. The second is the bowl technique. So again, as you can see, this is a soft cataract. See, if you try to chop, even a single pass of the probe will cause a crater effect in this cataract, as you can see. So if you try to, as you can see over, this is a crater effect. Sometimes it's not desirable. What you can do is you can rotate the cataract, make it solute, and then aspirate it. So as you can see, a saucer is formed over here. These are very dangerous, because if you do not control, so this solute and rotating it and bringing it anteriorly is more desirable, and so that you can aspirate it as a whole. Here you can see a soft chopper, a sharp chopper, but I prefer sometimes to use a dialer, because the chopper can chop through the posterior capsule. You can see the large epinucleus over here. The chip and flip technique, as you can see over here, an extremely soft cataract, hydrodelineation, or a multiplanar hydrodissection. Multiplanar are actually multi-point, small amount of fluids at different areas, so that you are not using a large volume of fluid. Rotate and bring the nucleus. I always do this in phaco 2 and not in phaco 1, where you are using a lower phaco power and a larger amount of vacuum. It's very easy. It just gets absorbed a few seconds. Only aspiration mode. The epinucleus which remains can be removed with the AC maintainer, or it can be used removed with this too. So, and this always makes me feel very, very safe, the epinucleus, because it can always be removed with the irrigation aspiration or like this in aspiration mode, but it makes me feel extremely safe. As you can see over here, you can use a needle or a Utratas forceps to do the capsulotomy. In very young patients, these tend to run away, like in pediatric cataracts, and you may not have any control of the rhexis. So it's important to do it properly. And you can do it either way, whatever makes you comfortable, whatever is best and safest for the patient in your hands is a technique which works. So as you can see over here, the capsulotomy, which is small, again a hydrodelineation, a solute of the lens. It is impossible to do stop and chop. So your hydro procedure has to be very good. The cleavage to separate the nucleus is extremely, extremely important in these cataracts. If you don't have a cleavage, you have not separated the nucleus, it is impossible to do phacoemulsification in these patients. And if you try to go into the periphery with such a soft nucleus, you are 100% likely to have a big PC tear. So that's very important. A good machine with good followability, which is holding of the nucleus. And as you can see over here, this is a single port aspiration cannula, which is named as a Lahanes cannula. I find it so comfortable and comforting that the AC is formed. The aspiration can be used for 360 degrees of cortex aspiration and PC polishing. The bag remains inflated and not collapsed. To each his own, of course. For people who are using the automated irrigation aspiration is also perfect and fine. This is a little bit of cortex which is remaining over here, as you can see. The ports can be all interchanged for a 360-degree cortical cleanup with premium IOLs with expectations of patients very high. As you can see over here, this is the PC polishing, the plaques, the little fibrils, the fibers which are left. The undersurface of the anterior capsule is polished, as you can see over here, and the IOL is put inside the bag. It is all under Ringer Lactate or BSS. I don't need to put visco again and remove it, because as Mahipal sir was just saying in another session of phakic IOLs, that you have to remove the visco completely, especially in toric IOLs, in phakic IOLs, and especially you don't want any visco for any reaction in the eye post-operatively. This is a visco-free technique of the foldable IOLs, as you can see. So this is another case that we are watching, a large pupil, which is very good for this case, a small rhexis, a posterior polar cataract, a small rhexis. It is good to do this rhexis with a dilated or a magnified image, as you can see over here, and a complete rhexis, as you can see over here. The hydro procedure, going into the substance of the nucleus till you feel a resistance, is hydrodelineation. The golden ring, no dissection, multi-planar hydro procedure, as you can see over here. To separate the nucleus from the epinucleus, to leave an epinuclear bag. I am a cheater, I send away all the hard cataracts, the black cataracts to table 1, which is Dr. Lahane's, hers, and only when he is not there, that's the only time that, I end up doing it. So as you can see over here, again, the saucer. This is something that is not very desirable. I would rather flip it or chip it, because that makes me make safer. So this saucering effect is what happens, when you try to do phaco. So I would rather have a nuclear solute and eat the nucleus as a whole. This periphery is likely to get a PC tear. So this is the more desirable thing to happen, to rotate it. Since it is free, as you can see over here, it rotates very well, and it can be aspirated as a whole, and it can be removed. So this is a much safer alternative. This is a posterior polar cataract. And now this is very important, is to gently tease this whole new epinuclear bag, gently, 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 so that the posterior pole is not, if there is something, so gently tease it, bring it towards the center, tangential, not, pulling movements, no vigorous movements, gentle cleaning up of this cortex. And this epinuclear bag, though it looks bulky, it is not the nucleus, and it can be aspirated nicely. So there is no traction on the posterior pole. Small defects, if they do not enlarge and if there is no vitreous loss, you can safely put in the IOL. But if there is a strong pull or some vigorous moves, then this can be dangerous. So as you can see, cortex removal in these patients is extremely important. You cannot say that the nucleus is out and you can relax, because this remains an important part of the procedure in these type of cataracts. Luckily, as you can see over here, there is no area where there is a posterior capsular defect. So as you can see, this is an important part of the procedure in these type of soft cataracts. Complete removal of the 360 degree removal of the cortex is possible and important. So I would say thank you to my sir and for teaching me phacoemulsification, to the stalwarts of ophthalmology, Dr. Mahipal sir, Dr. Jagatram sir, Dr. Amar, and everybody who taught me phaco. So the take-home message would be avoid hydrodissection, maintain the anterior chamber so that there is no turbulence, there is no surge, and the fluidics are maintained well, low vacuum and low flow rate than usual. So soft cataracts look very easy, but they make your life very difficult. patients come with very good vision, better vision with a than a brown cataract or a black cataract or a mature cataract. And you may be duped into trying something, and patients' expectations may be hurt. So one has to be very, very careful. Thank you so much. And thank you everybody for giving me this opportunity to present today. Thank you so much, sir.
Thank you, Ragini, for an excellent presentation. I think you have highlighted the fact that a soft cataract is as difficult as any other cataract, and at times you do tend to have problems more in a soft cataract than in other forms of cataract. Dr. Lahane sir, any comments or questions, or Himanshu?
No, nobody could make it more easier than that about posterior polar. We'll let Maipal talk about the femto part later, but right now for a common human like me, how to handle a posterior polar cataract, extremely well explained. One of the things that I do is hydro delineation. I do visco delineation rather than just hydro, even for the epinucleus and the cortex. That's all that I would add to that.
So you are not a common man. And so we know how common you are. You know, there is proof of how uncommon you are. It's out there for the world to see. And I'm not going to take names over here. So you were already doing a lot when I was a student or when I was a lecturer. So thank you. And I would like to acknowledge Sumit for putting up these videos together, because we were busy the whole weekend and he put this lovely talk together for me. Thank you so much, Sumit. Thank you, Maipal sir. Thank you, Dr. Lahane sir. Thank you so much.
Thank you.
Thank you, Himanshu Bhaiya.
Thank you. We move on to the next speaker, none other than Professor Lahane, Padma Shri Dr. Lahane, who's done exceptional work in, apart from phaco and cataract surgery, I think community services, and above all, he was in the forefront of fighting for the COVID in the state of Maharashtra. Dr. Lahane is going to talk about hard cataract as to how he approaches hard cataracts. Over to you.
Thank you, Maipal, for everything that you do for me. And here I am going to speak about the hard cataract, my approach. So it is because the Himanshu and all others, they will say that the different type of approaches are there. So this is my approach. I think what has happened. Okay. Something. Okay, no financial interest in this. The challenges, you know, there are challenges is the capsule cannot be seen, no glow for the rhexis, weak zonules you always know, more endothelial damage and difficult trenching. The rhexis you will have to stain and do the rhexis. Then the dye-assisted CCC. Now this is the dye-assisted CCC I'm showing you. Here you can see I'm making this is by the needle only. I'm doing this dye-assisted CCC here. You can see this. And always remember, it should be slightly larger as you are doing the hard cataract. If it is a small one, then you can get a problem. Now, generous use of visco is important. Then the leathery fibers to be separated and use of hyperburst mode. You can use the soft shell technique also at the end of the phacoemulsification to avoid endothelial damage. Now this is the hard cataract. I will just show you the case. Now you can see this is the rubra. So whenever you are doing the rubra, see here, the trench is very important. If you are doing the chop, I think you can do it, no problem, but see, slightly larger than the tip of the phaco. So it should be, and you, I think the dissect properly, and the dissection, whenever you are making it, see the trenching. See, I'm doing it up to the periphery because this nucleus is 7 millimeter and that is a hard one. So what I'm doing here, you can see here, the deep trenching, and you can use any mode which is possible by you. And after doing this, when I complete, see here, and then you separate it. So that is very important. See here. And whenever, again, I will show you, separate it up to the center of the nucleus. Now, these leathery fibers are very, very important to separate when you are doing such type of cataract. And if these fibers remain there only, then sometimes whenever you are doing the phaco, the tips which are very sharp tips, they may trouble you and PC may tear. So to avoid that, separate it properly. And once you separate it properly, then you rotate. See, again, now I'm rotating on the other side. And once I rotate on the other side, see here, again, and here, type of cataract. So making two parts of the nucleus, the cataract is more than half done. This machine, yes, it depends on machines also, and you can see the longitudinal and torsional both. So that will help much more. But yes, by the simple machine also you can do the such type of hard cataract. I'm showing now the direct chop. Here you can see it is not much harder cataract. Now you see, whenever I'm doing the direct chop, you will see it has gone in, and you have to catch, but the forces should be separate, should go from another side. See, one goes to right, other goes to left, and then definitely you can separate the nucleus. So the chopping, whenever you are doing chopping, in that case, if the fibers are very leathery, you will have to separate it up to the center of the nucleus. And when you separate it up to the center of the nucleus, after that only you must pick one piece, and then you can see here I'm emulsifying one piece here. And once I finish that emulsification, see here. Now this is, you can see, this is the calcified type of cataract. I have done the rhexis, and now you can see the brownish reflex. Now here, whenever we are separating it, see here. Now this is very important that whenever you separate it, the chopper and the phaco probe, they will see here, they are in the same line. They should work in harmony, and then one is going on the right and other is going on left. So two parts are separated by the two instruments. Again, you will see here, whenever I'm going in, go deep, minimum 3/4 of the nucleus, and after that, see the chopper buries inside in front of the phaco tip, and then it separates. Now, once it is separated, you can make 4 pieces, or you can make 2 pieces, and then you can emulsify these 2 pieces, and then the other half of this nucleus can be rotated 90 degrees to the tip. And once it is rotated here, again the tip goes in, and you'll have to make complete pieces. And if the complete pieces are made, then you can aspirate. Otherwise, if that is, some fibers are attached, the other tip goes down, and that can trouble you. So it means whenever you are doing such type of hard cataract, you should have a good experience, and you can also see the videos of your friends, and then you should do it. Experience definitely count. Now these are all my cases that I did. So you can see 98, and now you can see in 21, cornea is totally transparent. The stop and chop or direct chop technique, effective use of the ultrasound is important. Experience. Always remember, when you are doing such type of cases, do by the experience and choose what is effective in your hand. Thank you very much. Thank you.
Thank you very much, Dr. Lahane, for actually explaining the whole thing. I think the brilliant points that I brought out was the capsulorhexis, the use of trypan blue, and being careful about, because if you lose the rhexis right in the beginning, then there could be a problem. The other important thing that he said was, till you see the red reflex, you do a crack and then rotate 180 degrees to have the crack coming in. The important thing is the depth at which you are placing your phaco probe or the chopper, because if you are superficial, then the vector forces will work like this on the lens and it is not going to crack. If it is deep
and you're doing like this, then the vector forces will work like this, and then only they'll be able to crack. So these are use of viscoelastic balance salt solution and everything. I think those are fantastic things that he has talked. And sir, being an excellent surgeon, 2020 or 2021, the corneas are definitely coming out much clearer if you take all these. And then you have the fluidic balance that has come in with the machines that has actually improved the outcomes, because you are working more on an aspiration mode rather than on a energy mode that is there. Thank you very much. Himanshu, you have any comments or anybody?
Yeah. So good afternoon. Fantastic as always, and hard cataracts to see you handling with your eyes closed. It's at the spinal level. But friends, for the new beginners, if you see, the tip was more open. The cover was way behind. He went deep into the nucleus, and he was in no hurry to do chopping. He really did a great amount of grooving. That's very important, because the good old Britisher thing, break the back of the enemy. And the worst thing here in a hard cataract is the central core part. If you have done enough of grooving there, you are way away from the endothelium, but your chop and lateral separation, chop inside to and lateral separation becomes way easier if you have trenched well and you have enough hold on that. That's all that I wanted to lay emphasis on what sir was doing. Thanks.
Thank you. Anybody else?
Use of a sharp chopper is very important, Maipal.
Yeah.
Sharp and long chopper.
Yeah, sharp, long chopper. People have devised different depths of chopper, the lengths of chopper which go in, and then you need to be within the capsular excess margin, because if you break the center, the periphery will follow. So a lot of the beginners actually try to go to the periphery to do it, because that's immaterial. Because once you have broken the backbone, as Himanshu said, the periphery will obviously fall apart. I don't see Dr. Harbanslal and Dr. Arup. Okay. Next would be going on to the femto laser, and I think Himanshu wanted to do it first. So I'll ask Himanshu, who's a great surgeon to the top guys of Bollywood and Hollywood, I suppose, in due course of time. And he'll be talking about, but mind you, I think he's one of the great people one should know, a great friend, and really a fantastic guy who is doing great work in cataract and refractive surgery. So over to Himanshu, the hype about flax.
Very true, sir. Very true. I agree and endorse. I'm too small to endorse what Maipal sir said, but it's true. Because I live in Mumbai and I know the truth. Afternoon, Mohan Rajan sir. Afternoon, Partha sir, Samresh Bhaiya, Dr. Mathur.
Good afternoon, Ragini. I also endorse what Maipal says about Himanshu. 200%.
Thanks, Paul. Thanks, Ragini, and thanks so much, Dr. Lane and Maipal, for your kind words. Really appreciate. Genuinely, we have grown in front of Dr. Lane, Maipal, Mohan, and it's wonderful to be a part of the team for DOS right now. The good old question asked is what is this hype about flax?
So before you go to flax, sir, everybody has appreciated your Bollywood connection. So 2022, we have to have Bollywood there at AIOC.
Absolutely.
Not a hybrid Bollywood.
You saw what happened last night.
Yeah,
that drug cartel being caught on a yacht last night. You know that big news.
Sorry, Shah Rukh's son. Who's the other guy?
Yeah.
Shah Rukh's son.
Yeah.
इधर ऐसा ना सब लोग करते जो पकड़ा गया वो चोर बेचारा वैसा है.
ठीक है. Okay. Go ahead.
Can you see my presentation?
No, we can see you. We love to do that. Yeah,
So the biggest hype about femto is it worthwhile? Flax surgery, femto laser assisted cataract surgery. Of course, there are brilliant surgeons like Dr. Lane, and you have a lot of senior surgeons who are great in breaking the back of the nucleus. But there are cases where, you know, it's like playing golf. You have multiple clubs. You have to decide which one is good for you. So what are we looking at ultimately for the patient's perspective? Safety, efficacy, reliability, repeatability, accuracy, precision, and consistency in your result. You know, in one day, a Sachin Tendulkar or a Sehwag or a Virat is allowed to fail 40% of the time. But we as surgeons are not allowed to fail a single time. The pitch may vary, the weather may vary, you may have a bouncer, you may have whatever, wherever you are there, but everybody expects 100% results from you. And there's nobody to salvage you here. So this is what is expected from you consistently. So if you have, you know, a really shallow anterior chamber, you have hardly any place to work on, and you have low endothelial cell count. Here you can see a case. You see how big the cataract is. It's almost going up to the retina. And you can see the anterior chamber, which has become so shallow. There's hardly any place to go. The endothelium is not very healthy. The arcus is coming in your way. Look at your problems that are there. So these are cases where you have something where you look forward to having assistance even before you start. Now look at this case. Here, the angle is almost closed. Look at this. The angle is literally closed here. This is on OCT while doing the femtolaser surgery. And you can see that the angle is literally closed there. And there is hardly any place for you to work in the anterior chamber. And the moment you get in with your incisions, God forbid, if your side port is not good, the iris valves will start coming out. If you haven't had a long port incision, it'll do that. It'll come from the main angle also. Do what you want. Do your mannitol. But if it's a small eye, you have a 20, 21 millimeter axial length of the eyeball, you have problems and a huge cataract with a bad cornea. So these are things which are very important. You have a traumatic cataract, irregular pupil. You're not sure whether the zonules are really good for you, whether the vitreous is in front or not. But you have here a ready-made case where you can start doing cases. This is something which will help you. So places where you are in dilemma, doubt, you want consistent results because patients expect 100% results from you. So you have a rescue team, the femtolaser, which is there, which can really help you, is the way forward. What it means is the invisible and the invincible third hand. Before you get into the chamber, if you have a ready-made pre-chopped nucleus with a great rhexis, the size which you desire, what more do you want in your life? 80% of your job is done once that is there. So how about that? Here you can see you have lovely incisions. You can take care of the arcuate. Now that the premium surgery is going up everywhere, people also expect that you don't have any astigmatism left. Up to 1 diopter, 1.2 diopter, 2.5 diopters, you can always take care with the LRIs with an femtosecond. So your premium surgeries themselves, you go in for a premium lens, a multifocal, with a toric multifocal. In such cases, it will be horrendously expensive. So your corneal incisions, your places, you can plan your placing, you can do your LRIs. This is how simple it is. Once you're locked in, you have the cataract, your OCT is showing you what's happening. But I'll go to more difficult cases. Here, the laser arcuate incision, as I said, which you have. And you have a mid-dilated pupil, a floppy iris, patient on prostate medications. And you don't want to use because this is somebody who doesn't want the iris to be distorted. You have very little place to go, shallow AC, but you have a pre-chopped, you have already got a good rhexis, you have a pre-chopped nucleus. And it just walks into your probe. You don't have to worry about shaffing the iris or catching the iris. You are fairly confident that your nucleus has been split into smaller parts, and it's way easier with less femto energy. The pupil will not go down that easily for you. You can always try and get it out through a smaller incision also, a small pupil. And that's how it is helpful, because these are small areas where you have the pre-chopped nucleus, which is there. So you have various patterns which are there in lensectomy: chop plus cylinder, cylindrical pattern for the posterior polar cataract, 2 chops for whatever. Here is a case where you can see an effortless Brown. 3 operative parameters: the one-eyed patient, corneal haze, low endothelial cell count, arcus. You can see what was the endothelial cell count. Once you are done your rhexis and you look at the cataract, a brown cataract being broken into pieces, you have a lovely rhexis. By the time you get in, you have a greater advantage in life to start your case with, and you can almost be sure of trying to get you good results. And this is what happens. Your cataract is being broken so well, you have a good rhexis, and you can get on with it. Decreased endothelial cell loss because of low phacoemulsification energy, because definitely, yes, you will be going in with more aspiration. In pre-existing endothelial cell dysfunction, despite using dispersible viscoelastic, you have problems. So does the capsulotomy matter? Of course, the first most important step is a capsulotomy. Like Dr. Lane mentioned, in a mature cataract, it is very important to do a big capsulotomy, because that will be the easiest way for you to get out the cataract. You won't perforate, you'll have a lot of place. But the problem is more critical when it becomes a shallow anterior chamber, hypermetropic patient, a lot of positive vitreous pressure. So your rhexis becomes small in such a case, you are in trouble. And you can see that if the lens is not properly centered in any case, if the lens is, if you have a 0.5 millimeter behind the posterior plane, a 21 diopter lens will produce a 20 diopter of correction. And if it's 0.5 millimeter anterior, then you have a different correction altogether, which will be there. So this is very important that you look at these cases. And as you can see here, a subluxated lens, which is there. And you can see the subluxation on the right side. As you have a subluxated lens and you're not sure how good it is and whether the vitreous is in front. But the biggest thing that you can plan is your rhexis, which can help you to stabilize. Because even if you want to put in a iris retractor, or you want to put in a lens retractor to get on to emulsify the lens, you have your rhexis in place, you have the nucleus which has been pre-chopped, it can help you a great time. And that is what is the most subluxated crystalline lens. Now you have a posterior polar cataract. You can very well go ahead and do a cylindrical pattern. So as you are not supposed to be hydrodissection here, you want to do it in a way which is safer from the patient's perspective. You have multiple layers being split open, and you have a white mature cataract, low endothelial cell count again. You go ahead and shoot. You have a great, you can see here how well the rhexis has been done. Once your case starts. And that's how, once the laser, that's a good rhexis, you are going ahead with it, and your cataract has been split into pieces. Here is a case again with a traumatic case. You're not sure whether on the left anterior or the lateral side you have vitreous or not. You have the zonules floating there. Once you start your case, you have a great rhexis in place. You won your case. You can see the cataract with a lot of fluffy nucleus, calcified subcortical areas. But here you have a bad, dirty case wherein you have total arcus, hardly any place to see what's going on, a bad pupil. You can see the cataract on the right side. You can see the chamber, which is absolutely shallow, and the angle, which is a closed angle. Here, the third hand helps you tremendously to get on with it. So is it a hype or is it not? I leave it to the audience to decide what is the correct thing. So you have predictability, consistency, and wow results, which you have. So effective lens position, better control of incision architecture, and phaco energy. So my time's up. Thanks so much, Maipal and DOS, for inviting me for this talk.
Thank you. Thank you very much, Dr. Himanshu. Could you stop slide share, Himanshu?
Yeah.
Anyone has any comments? Professor Lahane, sir, are you there? No, I think he's left. Mohan, Artha?
Yeah, I think I fully endorse whatever Himanshu has said, especially in complex situations. The flax is very good. Brown cataracts, subluxated cataracts, posterior polar cataracts, white cataracts, relatively small pupils. Like I don't do it for less than 6 millimeter, but it works wonderfully well. But I would say that now the indication now, even for softer cataracts, what I call as the NHNT cataracts, neither here nor there, these patients are coming with 6.9, 6.6 vision, and you want to give the best for them. I think these are cataracts also. I would say I do flax for all these patients and encourage the patients to go in for flax, because I know the results are very predictable with this. That is the take-home message.
Yeah. So one question to Partha and Meenu and Mohan and Samresh and Himanshu. I was just talking before the session started. Have we seen post-pandemic increase in the percentage conversion to flax? At least that's the case in Delhi NCR.
I'll speak up for Calcutta.
Yeah.
So in fact, the number of flax has increased over the previous time, before the pandemic to now. We did not expect so, because everybody was in cash crunch and things like that. We did not really expect so. But what Dr. Himanshu Mehta very well said, it is no longer a hype. People want that accuracy, they want that precision, they want that safety, and people read up before they go in and make a choice for flax. So it's a very educated number of patients that we have, and patients are willing. At one point of time, so patients would not be willing to pay for their cataract surgery. But now patients are willing to pay for premium cataract surgery, the toric IOLs, the trifocals, And I think it's a good trend that has been happening. Similar has been happening even for the refractive surgery. More and more patients of ours in Eastern India used to have a very large number of microkeratome LASIKs. But now that has really changed to the femtosecond laser platform.
Yeah, Partha, Maipal, only thing that I would say is that not just the post-corona scenario, but otherwise also 5 to 6 years of homework by all of us has helped penetrate into people's mind overall. And they have realized that there is safety standard which is being there. And we will see that it's here to stay. The technology is not a redundant one. It's not just the hype, but there is lot of effective results to be given for the patient. And that's how it's here to stay. And the popularity will increase from now on. That's what.
In my opinion, Maipal, I think if you talk to the counsel the patients, tell them that this procedure is definitely safer. I tell them my hands are 100% safe, but the flax is 150% safe. So if you tell them the safety profile is much better with the flax, definitely there is a willingness to come forward despite the cost.
So at least I will just give you my this thing in Saptajang Enclave. Every femto every MICS is today been matched by one femto. So earlier I used to have a conversion of 60-70%, but today I think all the doctors put together, if we are doing one phaco or one MICS, that has been matched by an equal number. And the data from Delhi NCR shows that between July-August of 19 to July-August of 21, there has been 120% growth. So that's the kind of a growth that's happening in Delhi NCR. So I think the patients now, what you're talking about counseling, I rarely have to counsel nowadays. The patients are coming themselves and they're saying, and even if I don't say anything, they will go and get this thing. I don't know, Meenu and Samresh, you want to say something?
Yeah, Kerala second wave is still not finished, so we are still struggling.
Kerala is responsible for everything.
So the number of harder cataracts, mature cataracts, that have actually increased, and they have been all waiting, and now they have started opening. Last 2 months they started coming, and numbers are becoming more. And femto wise, I don't see any change. But as Dr. Mohanraj was telling, the counseling point for our system is also that this is the safety profile and the human error factor is brought down. So that is the one which is taking our counseling part also forward. So we don't see a drastic increase in the number in this pandemic.
I think the number of lasers may be less. So there's an inflection point that happens and word of mouth becomes very strong. So I think in Delhi, there are several units that are there and there has been a lot of activity around that. So I think it will keep on changing between cities.
Just to highlight a point that you brought about post-pandemic, I don't have a flax in Jaipur, but I've seen a significant increase in my premium IOLs. So my multifocal and toric conversions have significantly increased.
Yeah, so
basically, I feel the increase in the number of cataracts. Volume of cataracts have gone up.
Yeah, but Mohan, the
volume of cataracts.
That would what Meenu has said.
Totally. So that's why the conversion rate is also more.
Yeah,
I feel.
Yeah, Dr. Lahane, you have said anything to say or?
Yeah.
No, I think what you are saying is correct. I think I'm not having any thing to add.
Okay, so I think thank you very much, Himanshu. I think Partha has made a request and you can't refuse a request to Partha.
Mamata Banerjee will come haunting for you. Maipal, don't even try.
No, so Partha is wanting to talk before because he has some other commitment. So he'll be talking about spherophakia then and now. Yeah, Partha, all yours. We all know him as a great guy, a great surgeon, a retina surgeon converted like Mohan to an interior
Really, I think you talk. Maipal, I don't know why.
So anyway, but Chairman Scientific Committee, great guy. I think a very hardworking person. Over to you, Partha.
Sir, thank you very much. Actually, the talk that I'm going to give now is actually following Dr. Himanshu Mehta's talk very well, because here we have a situation, and spherophakia has been a situation which is a rarity in itself, but it is very, very demanding. And then when it comes to you, you have to give it the best. So as of now, what we used to do and what we do now is what we would like to compare. So this was a time which was before we had the flax. So we had to have this, the great difficulty of making a capsulotomy, puncturing this capsule itself, so very difficult, like a deflated balloon, and counter pressure to just simply take a puncture into this capsule, the anterior capsule, and then trying and fashioning out the rhexis. An edited video does not show the trials and tribulations of the surgeon or the patients that it undergoes. Taking off the soft cataract is not a problem, and we have these hooks swell in place. There are hardly any zonules, and what we need to do is to support this bag of this spherophakic bag as well as possible. And here we do support it with just about 2 of these Ahmed segments, and that's all, because as you can see that the Ahmed segments themselves are encircling nearly the whole bag. We do not need to put a CTR in such a patient, and even if a CTR has to be attempted, it has to be a very small CTR. So at the end of that stage, what we have is a spherophakic bag, the intraocular lens in the bag, well anchored. You can see a lot of fibrosis in the anterior capsule, and the patient is there. Now, we have had the benefit of having a whole group, a whole family of microspherophakic patient. Some came with glaucoma, some came without glaucoma, but all of them, all these sisters and 5 sisters had microspherophakia. So it's now that what we do is quite different. So we have the flax in place, and the flax that is in place, and you can see the spherophakic bag in this flax platform. And you can see it's nearly a circle, it's nearly a sphere, as you can see, and it has to be manually made some corrections before we do it. So here we are just making the rhexis, and the rhexis is the most troublesome part. And what we do fashion is a Hoffman's pocket before we go into the actual maneuver of the intraocular lens and the capsule. As you can see that the capsule has been punctured, and these capsules needed more energy, which I did not, and that was an error on my part. And it's very important that this postage stamp capsulotomy has to be as perfect as possible. We should have placed in more of these spots, more closer, as well as we should have given more energy so that it was a better floating rhexis. However, we do not have a run out, and at times it's a very rare situation when there can be a run out of a capsular rhexis, even with the femtosecond laser assisted capsular rhexis. So again, placing these hooks once again, why I did not place the capsular hooks and I use the iris hooks is because the capsular hooks, the largeness of the flange of the capsular hooks was not good enough, and it was actually not giving enough support. So we do the same thing, and here of course we have the Hoffman's pocket threading out the Ahmed segments, and this is much more simpler, much easier, and the Ahmed segments occupy the same way the position to support the capsular bag. What is so important is what took nearly an hour of patience, of sweat in the previous patient did take much lesser in this patient. It's much more accurate. The IOL is much better centered, and what we have today is a very well centered capsular, the capsular bag. In the mid-dilated patient, we have these patients, we have to remember that some part of the Ahmed segment can actually be at the edge of the pupil. Do not have Ahmed segments which are very small and which can actually just be within the limits of the iris margin. And but the patient doesn't complain very much, and we usually have these patients who have not been able to see very well at all to get back vision of 624, 636, which is a great boon to them. Thank you very much for your patient hearing.
Thank you very much, Partha, for excellent presentation. And I think again you have highlighted the power of femto, because these are the cases, as Mohan was saying, rather than the normal cases being there, it is the difficult cases where we are having the outcomes becoming much better with the femto laser. Mohan, would you wish to say anything? Yeah.
Beautiful presentation, Partha, because you showed the past and what is happening now today, and how flax has made a huge difference in microspherography care, especially because there is a universal zonulopathy in these patients and very difficult to do a rexis because there is no resistance from the periphery. And flax makes it so easy because you've got everything ready there. Okay, it's all ready-made. Your rexis is ready-made. Your nucleus is cut into pieces, and everything is there. Fantastic presentation. I will do this flax, not 100%, 200% in microspherography care.
Dr. Lahane, sir?
Sir, I am not having a flax, but I will now purchase it.
We'll send it to you, sir.
I will give it to you, sir. Why purchase it? Okay. So, any comments, Meenu, Samresh, or should I go on with my talk?
If you don't have flax, the other option is to do a bimanual rexis. Okay, the bimanual rexis, which has been always described by Chi Soon Fek. So, yeah, you can hold it and do the bimanual rexis, and that gives you better control.
Much better control, yeah.
Okay. Can I make my presentation?
Yes, sir.
Okay.
Shall I introduce you, Maipal?
Okay.
Maipal doesn't require any introduction, you know.
Okay, great.
He's
That's
going to be probably the next
best.
Prime Minister of India. That is what I'm expecting him to become.
No.
In a nutshell, if you want to introduce Maipal.
Okay, great. Thank you very much. I'll be talking about flax, and again, this is taking the bull by the horns. Again, I'm going to talk about complicated situations which Himanshu talked about, and then Partha talked about. Posterior polar has been talked about. I'll just say that we are using the OCT pre-operatively as also intraoperatively. And this is just to show you that you can have a great isolation of a defect even on the slit lamp where you have, and integrated OCT can give you where there is a deficiency. This is the OCT after the removal of the whole the cortex also, and you are seeing the vitreous herniating out, and this is how you are reducing the increasing the safety margin in case of a posterior polar cataract. Very briefly, I have shown this before. This is the OCT that is happening. Anterior cornea, you can see this is the defect in the posterior polar. So you are raising this. This is the most important visualization, getting a good capsular axis that has been highlighted. You have a pneumo dissection, so you don't need to actually rotate the nucleus, and it is only in the end that you get a rent which is there, and the femto gives you the cushion for safety, and you definitely come out much safer in case of a femto. And there are several authors, including Dr. Titial, ourselves, Dr. Abhay, who have reported that the incidence of nuclear drop has significantly gone down. This is to show you small pupils which were earlier considered to be a contraindication. Even now you can't, you can reduce the size of the cap, use a femto procedure after putting a ring. So you can see in this particular case, this is making an incision, and you can see a Maluvin ring that is being applied into the eye. And once you have a Maluvin ring in such hard cataracts also, you can go ahead and do this is again a subluxated cataract. You can see here, and was, as was told by Himanshu and by Partha, you get a pre-chopped nucleus, you get a good capsular axis, and you are able to do things well. This is a hypermature phacomorphic glaucoma. Intumescent, you can see that the iris is touching the back of the cornea almost. This is an LRI. And as was shown by Himanshu, you can see this is a good capsular axis that you get despite the
whole thing being intumescent. The important thing is that this is being done in a closed chamber. You need to use trypan blue if there are any adhesions, and you are able to get out a very good result in these particular cases. Rock hard black cataracts, you can see that you get a good capsulorhexis in these cases. It will be a little larger. We normally tend to make 5.2, it becomes 5.5, or you can make 5.5. You're seeing those air bubbles coming through, and you can see a black cataract which is there. There is a pre-chopping that has happened, and in harder cataracts, the amount of energy that you're using is significantly less. And because of the pre-chopping and the good capsulorhexis, as was said by earlier speakers, I think half your job is done, and you can get great outcomes with these particular cases. Post-traumatic subluxation, you can see this is a subluxation which is there. Just see on the OCT, you can see this is a falling of the iris because there is a subluxation. You can actually fix your capsulotomy. This is you have to match. We are trying to get a capsulotomy. We are doing a customized centration of the capsulotomy, and we are using a 3-port system wherein we are doing the removal of the vitreous. You can see that there's tricot. We have done the removal of the vitreous, but as was pointed out earlier, your job is half done or more than half done because you already have a good capsulorhexis. You have a pre-chopped nucleus. We are putting an endocapsular ring, and there is very limited stress on the capsular bag because it is already a pre-chopped nucleus, and you are able to get the nucleus out without disturbing anything. Bimanual irrigation aspiration that you can see, followed by removal of the cortex, and a 3-piece intraocular lens that is implanted without letting the chamber become shallow. You have to have the irrigation on before you take it out, and then this is the end of the procedure. Post-traumatic subluxation, great case. You can also do flax with the ICL implantation. Again, I will show you certain nuances of that. When you are doing this at this particular time, you can see this. I'll just pause it. Can you see this ICL? It comes out very well. This is the vault. It was a pretty good vault. So despite that, the cataract has happened. Now, what is going to be an issue? This is the optic of the ICL, and this is going to be recognized as a pupil by the machine. So this is going to be something where you have to increase the pupillary size. So you see, this is the optic which has been recognized as the pupil. You can see that the lens is fine, and you have to see that you are actually focusing on the anterior capsule and not on the lens for the capsulotomy. That is also, you have to play with those things, and you can see that you get a great capsulotomy as you are getting, and you get a nuclear separation in these particular cases. So the machine may have these issues of misreading. But once you have seen this, you can see that's the ICL in there. You have got a good capsulorhexis. You have done an LRI. And you have had a pre-chopping in a case of an ICL, which is there. Here we will just go in, lift up the ICL. You can see with a blunt spatula, you can see that capsulorhexis is already there. And we will have the ICL. You can see I bring the ICL on top of the iris and just rotate that area, go in. You can use the holes in case your ICL has these holes in the central to push it up. And once you have removed the ICL, you can have a very good phacoemulsification that you can do because it's already pre-chopped. And you can see that this is the removal of the cortex, and this is a -5 or a -4 lens, which is an odd power lens. So therefore, we are using a three-piece odd power sensor. We don't get single piece in the minus powers which are there. So this is again to show you that we can do great things with the flax which is there. So I personally feel whether it is polar cataract, white cataract, whether it is subluxated cataracts, ICL, etc. These are hard cataracts. These are cases where we definitely feel that the outcomes become much more controlled and much better when you are using the technology of femto. And as the technology of femto cataract evolves, spherophakia is something else that I saw for the first time, which Partha was showing. The only thing is that if the spherophakia, the machine will not allow you to work if the distance between the back of the cornea and the top of the lens is less than, I think, 1.4 or 1. I don't remember exactly, but there is a default setting that there has to be a minimum AC depth when the machine is going to fire, because otherwise the laser is firing too near to the endothelium and the machine does not. Sorry?
1.4.
Yeah, so that is the default that is there. So as technology of the femtocataract has evolved, it has found widespread use not only in regular cataracts but in complex cases. And I think it is the time to take a leap of faith and switch to the power of femto. There are certain governments, including the Haryana government, which have allowed the use of femto to be used. So once that happens, I think they are going to improve further. So thank you very much for your kind attention for seeing these cases of femto. Thank you.
Maipal, fantastic as always. No question about it. Maipal, one of the things that I saw with an ICL being there, if your rhexis is incomplete for whatever reason, that's where when you're removing the lens, the ICL, if your rhexis is incomplete, it can get you into a little problem. That's all.
I agree with that, but you saw that one little trick that I did was that this, in spite and despite of being sure, I always put trypan blue first. So in case your rhexis is incomplete, you need to be you can go behind and kind of do the rhexis first rather than explanting the ICL, because what you're saying is correct, that you can rip the rhexis if it is incomplete and you're trying to pull it out. So that is very important. I always put trypan blue first and see that the rhexis is complete. So it was only when I'm sure that it is complete that I will take out this thing. So focusing is very important, and I had trouble once with the Lensex when I had that, but with the Catalyst I have not had the trouble, and Gaurav also showed in one of the centers, and Ram also. The only thing is that you need to be very careful to get the overlay to come right on the top of the capsule. It should not be that, because the back of the ICL can also be misread as the top anterior capsule. So that's a problem. The pupil was misread, as you can see in this case, to the optic. So those are a couple of the things. If you are sure on that, the accuracy of the HD OCT is fantastic, and the alignment, if it is good, it can happen. But spend some time on the alignment. Your point is very valid.
No, the most important thing, I think Maipal has also mentioned that in mature cataracts and especially when we have ICL or something like that in the eye, watch for skip areas in capsular rhexis. Don't try to pull the rhexis. It's not a free-floating rhexis. Sometimes there can be a lot of additions. Skip areas will be there. So you need to put trypan blue, especially in mature cataracts, find out exactly where are the skip areas and try to do use the rhexis forceps to make a rhexis in that area. So sometimes you can have attachments. If you try to pull it out, then it will tear and go to the posterior capsule as well.
That is quite true. In one of my cases, intumescent lenses, there were two attachments, one diagonally opposite two attachments. And the moment I put sodium hyaluronate after staining, one ripped open just a little bit. So when you're putting in viscoelastic also, we need to diffusely put viscoelastic from the periphery, come to the center and slowly inject viscoelastic. Otherwise, sometimes it can just rip off from that attachment area.
So Mino, I think you are using the Lensex, right?
Yes.
Yeah, so the problem there is the time that is taken for the rhexis. In Catalyst, it is very, very fast. So what happens is that the fluid that is escaping becomes the non-cutting issue, because if you have the fluid coming out and it's taking longer, that is the area where you can get the skip areas. But if you are having fast rhexis like you have in this case, cut becomes very good. So that is
I understand. No, with the Catalyst it's much less, but even then in mature cataracts,
100%.
That will be little careful. Yes.
Trypan blue cannot be underestimated. Trypan blue has to be used because you can have skip areas, and that is the weak area where it can
go back.
Yeah. Thank you very much. I think for the discussion, we'll go on to Mohan Rajan's talk on IOL implantation. I can also
IFIS, I'm talking
Dr. Harbans Lal, good to see you, sir.
Yeah, I'm there.
Yeah.
So Mohan, you can talk about IFIS, and then Dr. Harbans, will you take both your talks together?
First I take post-RK cataract surgery. Should I take it?
No, abhi, Mohan, should you want to do, or should I tell Harbans? Mohan? Let Mohan do. He will have to.
Then I'll take it.
You go.
Okay, Harbans, he wants you to go first. Dr. Harbans Lal is the Vice President of All India Ophthalmological Society, and he's a great cataract surgeon, one of the earlier people to come into phacoemulsification. He has his own center and works at Gangaram.
And you have written an excellent book on paper emulsification way back, I think about 10 years ago. I was some competitors in this year, but it's a great book that love to read and learn from. Harvansh, all yours.
Is it visible there?
No, nothing.
Shall I try mine?
Yeah, you try yours.
Yeah. So Mohan, you're going to talk on IFIS, right?
Yeah. Same problem I'm having.
Okay, again, yeah.
No, I don't know. Only in this Zoom I'm having this problem. Get it to the desktop.
Gaurav was saying there is news. You are on Mac, right?
Yeah, Mac.
Yeah, so they say that the new Mac, you need to allow it to access Zoom. So you'll have to, that's what Gaurav was saying. Maybe you could talk to him.
But other Zooms I'm doing, no, without any problem.
That's what he
The
was.
DOS I'm having this.
So Harvansh is not able. Mohan, Meenu, Samresh. Meenu, you are muted.
Yeah, I can try. Shall I try?
Yeah, sure. Mohan, Harvansh, maybe you can take.
I'll join.
Yeah, Meenu. So,
Yeah, is it?
Dr.
I have shared now.
He's from Chaitanya Trivandrum, again, one of the very good proficient phaco surgeons. Always a pleasure listening to him. So over to you. He's going to talk about these.
Okay, hope I can, hope my screen is visible.
I will do that.
Everything is good. Yeah. You can start.
Yeah, so good afternoon, everyone. Thanks to DOS and the office bearers and Dr. Namrata Sharma and everyone for giving me this opportunity to talk on fine-tuning the glued IOL techniques. We know that in FAK with no capsule support, we do scleral fixation. And here we externalize the haptic through sclerotomies and intrasclerally tuck the haptics. I think we all know the procedure, and that's where, so I think skip the basic procedure first and then go on to refining some of these steps. Once we know the regular steps, we need to identify some small points in each step which will make outcomes better. So initially doing the flap. See, previously I used to do larger flaps. See, then the problem is that the haptic which comes out, the area, the amount of haptic you get to tuck into the scleral pocket will be less. So I now do a 2 into 2 millimeter rather than larger flaps, so that the maximum amount of haptic which is exteriorized can be tucked into the scleral pocket. And the second thing is to get best hemostasis. Cauterize it well, because of visualization and bleeding going into inside the eye and all those things can be avoided by doing a good cautery around, especially around the edges of the flap which you make. So the next point is to making the Gabor-Chariot pocket. So it doesn't mean that we should make only a 26 gauge needle opening. It need not be that the haptic needs to be tightly, snugly fit into that. So we can make a 1 millimeter blade incision also. It has to be deep enough. Otherwise, it can erode through and it can expose. The haptic can come out very easily. So it has to be at good depth from the edge of your flap, and it's good to use a new blade for each pocket, because sometimes the tip becomes blunt and then it is a struggle. You'll create different planes and you won't know where it is. And again, after creating that, it is good to mark the outer part of it with Trypan blue or the blue ink which you use to mark the cornea, so that you can identify it later correctly where to tuck the haptics. So here again, multiple planes should not be made, and the blade should not be very visible once you are trying to make this tunnels. Don't make it very superficial. The third thing is, while bringing out the haptic, see, although I have held at the tip, see the way I am turning the forceps. If the forceps is turned 90 degree or 180 degree opposite to the curvature of the sclera, then you will get a deformed haptic tip. See, the haptic has been folded upwards, the tip. So now if you try, if I can try to make it straight, but sometimes it breaks off, it doesn't come back to normal size. So while bringing out, once exteriorized, the pull should be along the curvature of the globe to avoid this kind of a deformation of the tip of the haptic. Now the tip is facing up, as you can see. The next thing is to stabilize the haptic. So for the first haptic, many times there won't be a side scope. The assistant will not be able to see the haptic properly from outside. So it is, for my hands, I always use a stopper, a silicone stopper loaded onto a 26 gauge needle, and thread the initial haptic into the needle, and then place the silicone stopper onto the haptic, so that while we are manipulating on the other haptic, this does not go down. And towards the end, we can release this so that the tucking and retucking for the centration can happen. So once the haptic is inside the needle, it can be slowly slided onto the haptic, and then we can forget about this haptic and then concentrate on the other haptic. So again, the other thing is to where we place the incision. See, these are the two flaps. But here, because of the tergium opacity and all those, I had to place the incision closer to one flap. The problem here is that when we are taking in the second, the trailing haptic, there will be a lot of distortion of the optic. So now, if you can see, it will be a struggle actually to get this one inside, and we are scared that this is going to flop, the IOL is going to flip out, all those things. So it is always better if you place 90 degrees away from the scleral pockets which we have made. And another point is, when we are trying to hold the handshake technique for the trailing one, sometimes the hold will be closer to the tip of the trailing haptic. If that is so, please do regrasp. Hold the distal part of the haptic, and give some space here. Use this forceps to hold it little back, and then expose the tip. And now you can catch back on the tip, so that you can hold exactly on the tip and bring it out. Holding exactly at the tip is very important to not to deform or to crush the haptic tip. So again, visualization in some of these cases is very, very important. When you start off with very small pupil, we hold it, and now you are under the iris. You don't know what is happening. We'll be focusing on the optic, and once the optic is fully released, we try to take out the haptic, and then we have lost. In this case, the hold is lost. So it's better if your pupil is very small, put iris retractor hooks and see what is happening while holding. Now the lens is retracted, and the haptic is brought further into the center, and the tip is held again, and it is taken out. The hold has to be firm. Don't let loose the hold on the forceps. On the edges of the haptic, trying to center it or pull or something, or if your pull is backwards, it has to be pushed in and then pushed forwards. But if you notice here, I am holding the haptic and pulling it back. So there is a backward pull. See, the tip of the haptic is broken. So most of these haptics are PMMA, and they have a tendency to snap sometimes. So pulling it diagonally backwards to try to engage it again, I have a double break. So this is the worst thing that can happen. And so don't bend it backwards. Bending it down is okay, but bending it backwards is not a great idea. And last but not the least, having fluid inside the eye. We as anterior segment surgeons don't put posterior infusion as a routine. We go with anterior ACMs. So ACM, when you put, each time you get an ACM, it will be a different size. You will have it different in your clinic. So sometimes it will be the incision should match the size of your ACM. Sometimes it will be large, sometimes it will be small. We don't know what is the size, and then it will be loose, and many times it will keep coming out of the incision, or sometimes it will be so tight that you squeeze it inside and you get a lot of folds onto the cornea. And so here we can use this trocar cannula also. So now I'm using this as an AC maintainer. So this is going through the limbus. So a 0.5 millimeter through the limbus and then turn inwards and push in your trocar cannula. This is the regular trocar cannula with the needle. This is very large actually. That is made for your VR surgeries. And once that is done, it can be just pulled out and you get a sealed wound. Here again, this is a corneal thing. Corneal also you can put, but to see the length of the needle, we have to be very, very careful because this can hit on the iris, on the cornea, on the angle, everywhere, because the needle is quite large and not made for this. The Mastel makes a small one for the anterior ACM, but that is very costly one. And here you see that I am not pushing the whole needle inside, I am partially stopping and then taking out the needle, and the cannula is further pushed out after that. So one small trick which you can do here is you take a silicone band and cut it into a small piece. So here the problem is what I was showing, till here is your cannula and the needle is so long forward. So if you can put something in between these two, you can reduce the size of the exposed needle. So that's what I was talking about, the rubber bands, the silicone bands which the retina people use, cut it into a small piece, and that is really thick. And that first goes through the needle and then you place back the cannula. And so you have only this much of the tip of the needle, tip of the trocar exposed. And also another way is to break open one of this. Take one of this and break the tip off, break the trocar off, and then use this and put it into the needle which you want to use, and then put the cannula again back. Again you get a very small part of the needle outside. So by taking care of these small few things, we can have a very smooth fluid IOL procedure done for all your cases. Thank you very much.
Thank you very much, Meenu. I think those are great tips that you have given, practical things which are there. One other thing that the iris retractors, etc., that you use the plug at the back, the holder, that can also be used for threading your haptic rather than use the buckle also, right? Do you get me?
Also be used, but those are slightly thinner, so we may have to use 1 or 2 or 3 for the.
Anyway, we use it routinely, but that was described by John Bako from Canada, Toronto. And
no, what do you mean? Sorry, sir. What you meant was the silicone which is used to hold onto the haptic, first haptic.
The plug or whatever you call it, the stopper for the iris retractor.
Yeah, same thing. I use the same thing. Yeah. I pull out that only. The same thing.
So
I pull out the Grishaber one. I am showing the same thing only for the haptic. The first haptic to be retained. That is
I thought you were making it from the buckle.
No, that is for the second. That is for the last one, for the trocar cannula.
Okay. Any comments on that, or?
Are you able to see my screen?
Yeah, we can.
So, yes.
Will I go at once?
Yeah, it's okay.
Okay.
Go ahead, M1.
Yeah, Mo.
Thank you very much, Maipal. I thought you'll say a few words about me.
Oh, I know you. I will say a lot about you. So, Mohan is the successful best entertainer for OPL. He's somebody I would say, apart from that, we always love his wit, his sense of humor. But he's again somebody who works 24 hours a day. And what I feel, Rotary work has been tremendous. Community services, iBank, etc., has been great. And obviously, he's one person who is a go-to person if you want anything done. Great surgeon, again, ambidextrous, and does great work with new technologies, ably supported by Sujata. And what I will wish to say is that Rajan Mohan is a great friend of ours. And he is now presently the TNOA president, and we have seen him bring in certain new innovation like walk the talk or something. He's doing it, and I wish that he will have a walk the talk with me one day.
Absolutely. So thank you, Maipal, for the nice words. And What is the biggest problem in phaco? The biggest problem is not hard brown cataract or posterior polar cataract, pseudo-exfoliation or subluxatory cataract. The biggest problem is the small pupil. The small pupil is a big problem. Why? Because you are not able to see well. All the complications can occur because of a small pupil. Now, alpha-1 blockers are used for the benign prostatic hypertrophy, urinary retention in women, used for kidney stone management. Tamsulosin is a common one. We call it Urimax in our the trade name. Short-term use can also lead to non-reversible iris dilatation dysfunction in many patients. So progressive intraoperative meiosis is one of the major factors. A pupil coming down on you is probably one of the dangerous things you can have in your phaco. Iris prolapse, billowing of the iris, as high as 33 to 78%. Now, what happens in tamsulosin? Tamsulosin relaxes the smooth muscle of the bladder neck, iris dilated muscle as well, renders ineffective, dilatation drops, and that's the reason. And this tamsulosin is there in the blood for almost one year, and even if you stop the tamsulosin prior to surgery, the IFIS is going to be there. The alpha causing the IFIS is terazosin, alphazosin, doxazine used for systemic hypertension, and that is why you can get in women as well. We're using this thing. This is iris prolapse, which you can see here, and very, very common, and especially when you have patients, male patients above the age of 60 or 70, almost everybody is using. Be careful in your hydrodissection. If you are very violent in your hydrodissection, aggressive hydrodissection, you can see that the eyes will start coming out like this. You can see this in the particular case, a IFIS patient, there is the IFIS, the iris is coming out through all the ports. It will make your life very, very miserable, because if you try to push the iris back, the iris will tear, the pupil will become small, and it will make your life very, very difficult. You can see here, there is a progressive intraoperative meiosis, the iris is coming out. This is what you should not do, not to come out with the irrigation on when you have an IFIS, because if you come out with the irrigation on, the iris is also starting. This is iris dance, I would say, very, very typical. That's called what is called the billowing of the iris. What are the complications of small pupil? Iris chafing, iris bleeding, iris prolapse, hydrodialysis, zonal dialysis, PCR, nucleus drop, difficulty in IOL implantation, prolonged surgical time. All the problems, you name the problems, it will be there. For example, this patient, you can see here, there is an iris trauma, iris chafing there, iris bleeding. This was long before the the IFIS was described by David Chang. PCR, you can see here, we didn't even know that it was happening in these patients. And again, PCR is very, very common. Now, I'm going to give you 7 important steps to prevent or take care of the IFIS. Preoperative protocols, past or present use of alpha blockers, stopping tamsulosin will not help. Atropine, I know Maipal is a big fan of atropine 3 days prior to surgery. Some because it doesn't work in our hands. 6 millimeter, less than 6 millimeter dilatation, it's a red alarm for you. There's going to be severe IFIS on the table. You have to be very careful. Please ask the patient, because many patients are very embarrassed to tell. They do not know. Even physicians may not know that the tamsulosin can cause this severe problem of IFIS during cataract surgery. And intraoperative protocols, intracameral adrenaline can put, or phenocaine, phenocream plus intracameral epinephrine. So many things are available now. A combination of phenylephrine, the tropicmat, and proparacaine, which is available, which is making life very, very easy. Again, preoperative atropine, intraoperative epinephrine, episugarcaine, jolt sugar, which is a combination. Number 3, intraoperative protocols, well-constructed corneal incision. I go for femto incision because in my thing, I'm able to give a true triplanar incision. If you don't have it, because the anterior incision, longer incision, low threshold to suture, calibrated side port incisions, which has been described by Rohit and Dushya Om Prakash. You can see here, this patient has a incision which is made by the femto. The advantage of the femto incision is that only thing is, if you have a dense arcus cinelis, it doesn't work. But otherwise, you can have the triplanar or as long an incision as possible, and also a triplanar incision also is very, very important for you to this thing. You can see here, this is a well-constructed corneal incision. We are doing it manually. Go up the cornea. If you make it too long, you'll find it difficult because a lot of hydration will be there. Don't make it too short. If you go and make it too short, it's going to make the IFIS a little more worse, because every time you come out of the eye, the iris is going to come out of this thing. So longer incisions, very, very important. Take time in your incisions, especially when you have a patient with a Urimax on the table. So Again, OVD, don't use HPMC. Always use something like Viscoat or Hyalon 5, soft shell technique, wherein you put Hyalon. Nowadays, it's available locally as well. Appasamy is making it, Orolaba is making it. All these are available. Again, don't do very, very aggressive hydrodissection. You can see once I get the iris there, I'm just putting Viscoat. Once I put the Viscoat, it's going back. Again, trypan blue rhexis is very, very important. Why you want to do trypan blue, even if it's an immature cataract? Because I know when the pupil is going to come down, I know exactly where my rhexis margin is. Okay, so the trypan blue will make you identify the rhexis margin, which is again very, very important. Always put a trypan blue. So even if it's again, even if this patient has got a small pupil, I'm doing an intracameral epinephrine, and again I'm putting a trypan blue as well, and making it which makes life easy for me. Again, number 6 is low fluidics. Bottle light less than 80 centimeters. If you are going to use vacuum of normally 500 millimeters, I use vacuum only 250 millimeters. Low AFR, making the entire surgery very, very on a slow motion technique. Again, gradient, pressure management, hydrodissection, don't be aggressive, low flow phaco. Switch off the irrigation while coming out of the eye. When you come out of the eye, switch off the irrigation. Again, iris retractors, iris rings, right in the beginning of the surgery. Don't do it in the middle. If you do it in the middle, you're going to find it difficult to put the iris rings. The capsular rhexis will get caught. So right in the beginning of the surgery, this patient has got a mature cataract, he's on Urimax. I know this patient, this people is going to calm down. Right at the beginning of the surgery, either you put irises or you can put a single subincisional iris retractor, or you can go ahead and put a Mulligan ring, whatever you're comfortable, or you can go ahead and put a BX ring as well. So whatever you're comfortable, do it right in the beginning of the surgery, which makes your life very, very easy. Because this pupil, which is about 5 millimeter, 6 millimeter, especially in the cataract is hard, it's going to come down on you, which is going to make your life very, very difficult. And all the complications are related to that. Again, iris, IFIS, be safe, then sorry. So that is the take-home message I want to give you all. Thank you very much, DOS, for the wonderful conference and the wonderful opportunity and the patient attention.
Yeah, thank you very much, Mohan. I think you have given wonderful tips. One of the important things is that you need to, whenever there is a patient, my OPD attendant, etc., tells that the patient is not dilating, the first thing I ask the patient in the pre-op is, are you on any tamsulosin or Urimax, etc.? So that is written right in beforehand that this patient, we are expecting the problems, and depending upon where we are, we will take care. I think Dr. Harbans, you have both your talks, right? Harbans?
Abansh, muted.
Harbans?
Yeah, can you hear me?
Yeah, you have both the talks to deliver, right?
Yeah, first time, okay, one by one. Both of them are in a separate PowerPoint presentation. So first I'll present post-RK cataract surgery.
Yeah, so basically, anyone makes any other point for the excellent presentation of Mohan Rajan? Otherwise, we can start. Dr. Harbans, yeah, you can go ahead with your presentation on post-RK cataract surgery.
Not only that, Maipal, also patients who are on antihypertensives, the alpha blockers.
Yeah.
So that also you should take into account.
Yeah.
So alpha blockers are given for BP also. So these can also cause IFIS.
So only thing is in Dr. Mohan Rajan's talk, if you need to use in between the surgery you have started and half of the you have finished half of the surgery, then at that time probably rings will be better than putting hooks over there. So now I'll be talking about post-RK cataract surgery.
Yes, sir.
So how the RK works, this is just for the beginners. We used to give the paracentral cut, which causes a steepening of the paracentral area and flattening of the central area. And this flattening continues for many, many years to come. And when we see the evaluation after this, the hyperopic shift, 6 months to 10 years, had 1 diopter of shift, and 0.21 diopter for every 2 years, it keeps on happening. And there is a diurnal fluctuation also in the morning because of these patients may have the corneal edema and there may be a myopic shift by evening. So we have got to keep in mind. So there are challenges in a pre-operative evaluation, operative, post-operative, and what are the lessons we need to learn. Preoperative, we know that the keratometry is the toughest thing to do, and then trying to find out what is the right IOL and how to counsel these patients. Keratometry, when you do this, maximum flattening is in the central, while we measure the paracentral, which is much steeper. This is where is the problem is. And at the same time, the cornea is irregular and there's a wide variation in the reading in the various places. Optical biometer may not measure sometimes the readings are so low that the optical biometers cannot take the reading. There may be ectasia with a very high keratometric values. So whenever you are calculate the biometry with the flattest reading you get on the any equipment. So we go on to the IOL calc ascrs.org and then calculate over here and then take the maximum IOL power whatever you are getting. So in an operative, of course, we need to do the hypovolemic. I will not focus on that. But in a post-operative, we need to keep in mind that the chances of transient hyperopia are because of the corneal edema. So 4 to 5 diopter of post-operative hyperopia may settle over a period of 2 months of time. So we need to see how much will be the transient hyperopia. It depends upon the type of incision, the type of surgery, number, size, location. And we need to keep on watching, and every 2 weeks you keep on seeing the reading by the keratometric value, the corneal thickness measurement and the refraction. Wait 8 to 12 weeks before you decide that this is a wrong IOL power calculation. So before you go for a IOL exchange, if you got a hyperopia, they keep on taking these readings and wait for 2 months for the finally deciding. So I'll just show you some of the cases. This was the 51-year-old male. And if you see the optical biometer reading was 37.49 average and the IOL power calculation was 13.5, while the pentagam reading was 39.5. We calculated the target refraction 0. The maximum we were getting was 13.56. And if you see over here, the optical biometer is much flatter than pentagam, which is usually other way around. So take the flattest median wherever you are getting the reading and always target -1. So if you target -1, now the maximum IOL power which is coming 15, I've implanted 15 diopters. So if you go straight away targeting 0, you may be really off the point. This is the another patient. Optical biometry, you can see is 6.25 diopter cylindrical at 172 and the IOL is 21 diopter. Pentagam is again the same, but axis is 149. So 172 and 149, what are you able to use? So there's a lot of confusion. And then if you target -1, then the maximum is coming 29, while on an optical biometer it was 21. So you need to take a 29 diopter, not 21 diopter. And what toric axis? We went, whenever this cornea is irregular, the refraction may be more crucial than the keratometric value. The patient accepted, if you see the AR and the acceptance of the patient was at 165 degree. So neither at 172 nor at 149, we placed the lens at 165, not 21 diopter and 29 diopter. Still patient was slightly hyperopic. So this is another case. So in this case, if you see that the keratometric value was 37.50 and 46.80, and the IOL power which was coming was 10.50. And when we went on to the IOL calc, the maximum power was coming 12.5, and we wanted to use the toric IOL with the -1. And once we did this surgery, the patient had 9 diopter hyperopia with +4.5, nearly 12 diopter, 11 diopter of hyperopia. While we used the -1 target and a maximum, still patient had so much of it. And the error was, if you see the biometry was a 46.80, which is not possible. The center part has to be flattened, has to be somewhere around 32, 31. So that means there was ectasia which was taken into the consideration, and patient has such a surprise. So then we removed this IOL and went on to place another IOL. And this is the another case which the IOL power was coming +2 and -6 on a various formulas. So in this case, with the experience, I learned that the patient, most of the RK patients, if you are given more than 8 incision, will need 26 to 28 diopter of lens, never less than that, because the cornea is much flatter. You are getting anything less than that, there's something wrong. There's something wrong. So until this patient is myopic and had a 4 incision, has got a -3, something of that type, if you are getting 18, 19 is fine. So then we did the lens extraction, put no IOL, and post of refraction was 13, and placed the 26 diopter of IOL. So if you would have placed +2 or -6, you can imagine how much the error would have been there. So lessons learned is that the flattest granulometric value you will have to take, whatever the equipment you are getting. You calculate an IOL calc and target -0.5 to -2 diopter, depending upon the number of incision. If the number of incision are more, you will target -2. Any keratometric value, if it is more than 40, you are actually taking paracentral area. You are not taking the central area. Any biometric value below 18, you are going to be grossly wrong. Most of these patients need IOL between power of 24 to 28 diopter, I mean, maybe more than that. So we have got to keep in mind when you are doing a post-RK cataract surgery. I can explain further if time is there, that how, whatever way you look into it, if there is a hyperopia of 3 diopter or so, the patient will have 26 to 28 diopter refractive error. So this is what I have calculated. The patient had a pre-op refraction of -3. Pre-op K was 43 and he needed 19 diopter. If now patient has a hyperopic shift of 3 diopter, so 3 plus 3 is 6, 19 plus 6 will be 25. So that way we can calculate that these post-RK patients have got to be very, very careful about the keratometric value and the eye values. Thank you very much for your attention. And if there are any comments, any questions, I'll be happy to answer.
Harbans, I think an excellent presentation. You have brought out the points. Maybe you do your second talk and then we can have the comments together.
Should I go to the next talk?
Anji,
Yes.
Anji.
Very good talk, Arpan.
I think somebody else can take because I got to.
Okay, so let us just have the, I think there is one talk from you and one talk by Samresh, right?
Yes.
So Samresh, would you want?
I am ready, sir.
Yeah. So important thing that Harbans has brought out is that IOL power calculation is always an issue, and the hyperopic shift is obviously an issue in the case of post-RK. You have to be very careful not to do harm, and basically the toric IOL has to be done very carefully. As also one is very, very important that you need a simple rule of thumb is that whatever power you are getting, you need to add something on that. That's what Harbans has highlighted, and that's what all of us do. Thank you very much, Dr. Harbans. You can we can have Samresh, and then we can have you for the last talk. Thank you. Samresh, as we all know, is an excellent young upcoming surgeon. I think he's great at making video films, has won several awards at the Ascaris, and it's always a pleasure to listen to his words of wisdom, and keep up the good work, Samresh. We are proud of you. Thanks.
Thanks a lot, sir. Thank you, DOS, for the invite, and my regards to all senior doctors in the session today. I'm going to be discussing ergonomics, which is a slight shift from the discussion topics today. And it's very important for us, to all doctors, particularly as we mature up in our practices, because we spend so much time in the operating room that we pay a lot of attention to all small details because that will make a big difference in our performance in the later half of our life. The ergonomics is the art and science of fitting your work to the person. And so it's very important, because if we don't do it now, we will land up with disorders like tendinitis, back pains, and so many other problems that some of us senior doctors are suffering because we don't pay attention to these small things in the beginning of our practice. Like in our entire scenario in the operating room, there are so many factors that contribute to how we perform a surgery and how we perform a surgery consistently time after time. If we just deconstruct the parameters, there are so many things, I'll start with one of the most important things, which I think is sometimes undervalued, is our operating microscope. Many types of operating microscopes are available. In the initial training period of our life, we land up with some basic microscopes. So this is just to highlight to you that I started my practice with a 1FR microscope in the beginning, and this is although excellent optics. But if you notice, the optics are all tilted down, so it puts a lot of strain on your neck, as is demonstrated by a tech here, as compared to a new modern microscope, which has tiltable optics and lets you keep in alignment with your neck. And these are some things that are very important because you might save a buck in the beginning by buying a cheaper microscope, but you will end up paying a price for a neck issue or maybe a back issue later. Again, people who have extended necks can also look up rather than looking straight. And as the microscope keeps on adding, and you can see very classically over here, there is a Varion system that adds up, and there was an Aura system that adds up, and there are filters that add up for a retina surgeon and a beam splitter. The size of the microscope keeps on bulking up. And so something that can be adjusted to fit your visual requirement will always be a great help. So again, not a good idea to hyperextend, but to look in the line of sight because that will make your surgical performance so much better. The other very important thing from the surgeon's perspective is the surgeon's chair. Again, I started my training with a stool and I could do fairly good surgeries, but you realize that by the end of the day, if you're doing the CAM surgery or if you have a long list, your back will start to hurt. Two things are very important when you look at the chair. One is a back support, which I think is of paramount importance, and a back support that is pushed against your back anteriorly so that it supports your spine and the lower half of your spine, compared to a stool where there's no back support. A lot of your muscles align your back, the flexors and the extensors, to keep the back in a straight position. And eventually, slowly we succumb to it and our back tends to collapse and we tend to become kyphotic in our appearances. That's because of long strain on our back. So this is a surgeon doing a superior surgery with a well-supported back. As you can see over here with the neck straight and the optics of the microscope coming to use. But here's a surgeon who's still slouching. And you notice how the neck's being hyperextended, and this is a recipe for disaster. Long-term chronic back problems are so common in ophthalmologists. Compression of interspinal spaces and long-term problems have already been published. There was a survey about 150 doctors about a decade back, and that said about 75% doctors have pain associated with surgeries. And this is a pretty significant number. I mean, the survey should be done again, and hopefully the number would have come down, but it's still a pretty significant number nonetheless. The next most important thing when you look at a surgeon's chair is the armrest. And armrest is so crucial because when you're doing these fine movements that involve your fingertips, if your elbows are floating, as you can see over here, the elbows not rested, it puts a lot of strain compared to when your elbows are completely rested. So your entire back, your trapezius, everything is completely relaxed. It's the rhomboids and the trapezius which will start to fibrose if you keep your shoulders hanging at all points in time. Also, good idea is to timely keep on exercising and timely keep on stretching your back. If you find time between the surgeries, like our senior doctor, Dr. Basavara, is just demonstrating, if you find time between surgeries, the patient is getting draped, no harm in stretching yourself to keep yourself aligned and ready for long haul. Another more important thing that has come to play now with a lot of industry paying attention to the details of machines are the phaco machines themselves. There are lots of phaco machines available in the market, and I mean, one can debate on which one will perform better than the other. All of them do well when it comes to removing a cataract, some better than the others. But I think one of the greatest advantages that we have now with microscopes and phaco machines are wireless foot switches. Wireless foot switches give you the flexibility of moving your foot switch, and these machines also have rollers, so you can move your foot switches in any direction you want, giving you a lot of space to operate upon. So you don't have to really, tighten yourself in a small zone, but you can expand your feet, you can move it in any direction, and it's very, very convenient. Safety and comfort is not only for the patient, surgeon, but also for a patient. So investing in a good patient's bed, which is tiltable, reclinable, which has an adjustable headrest and maybe a gel cushion, gives the patient a lot more comfort, and particularly for surgery that lasts longer, like a retinal surgery or a complicated cataract. If the patient is comfortable, so are you, and more so if you're doing a topical surgery. We tend to use a lot of these gel pads for gel headrests and for the patient's back, so as to give them cushioning, and also knee supports that I picked up from my LASIK OT gives a lot of comfort to the patient's lower back. But like I said, tiltable, a patient's ergonomic moving chair gives the surgeon a comfort. So notice over here for a temporal surgery, so common that our knees tend to bang against the chair. But if your patient chair is movable, you can move it up and down, and then you can have enough and more space so that you can perform your surgery. And your lower limbs don't get to bang against, and the patient doesn't get uncomfortable. A big problem for the assistants is this amazing array of wires that an ophthalmic OT has. And so often, more often than not, patients, attendants and staff tends to trip and fall or pull out the wires or cause damage to these machines. So again, investing in a very basic ceiling pendant or getting one manufactured locally, which can run your power supply, your cables, your gas. If you have a network theater, maybe a LAN networking can play a big role, and just put it down at the foot end of the patient's bed. And so all wires come directly down, and your surgical environment becomes completely, or at least more or less, wire free, thereby reducing accidents, giving better ergonomic comfort, and making your machines last longer. And last but not the least, investing in a good big TV, not only for the surgeon, because the surgeon is looking through a microscope, but more so for assistant surgeons, for the anesthetist, and for observers, because they don't have to go and look at your assistant scope. They are in tune and in sync with what you're doing and operating, and they can follow your instructions better. Again, with the advancement of technology and newer machines coming up, I don't have one, but I'm hopefully looking at machines like the Ingenuity and the Zeiss systems that give you so much more ergonomic comfort and give you so much more relaxation. I think the industry is also pushing to make your life comfortable. Unfortunately, comes at a price for now, but hopefully it will become more affordable and more accessible to all, so that we can live better, be more ergonomically comfortable, and perform much better surgeries. Thank you.
Very nice. Samresh.
Nice. Samresh, one question. Which is the chair you use?
So,
or you showed?
There is a company called Knox that has made a custom chair for us that's movable and tiltable. So both the patient's bed and the surgeon's chair are made by the same company.
No, is it
I'll message you
sure,
for the address. Indian?
It's an Indian company, sir. It's made in Gujarat, sir.
Gujarat. Very nice chair.
Yeah.
I think 3D is going to be the way forward.
Absolutely, sir.
As far as ergonomics is concerned, that's the best.
Absolutely.
I think, yes, that would be from an ergonomic standpoint, that is there. But let's see how remote robotic may be the next thing, right? We don't have to do anything. Okay, let's go on to the last talk of the session, which was to be the first one, and that is by Dr. Harbansal, and he'll be talking about toric IOLs. As we are seeing more and more patients are going in for the toric lens, and I think the doctors are also advising toric lens. And I think it is very, very appropriate that we should give the option of toric lens to the patient if the patient has toricity in his eye. So how to get it right, how to do it, if you don't get it right, how to set it right is what Dr. Harbansal is going to talk. Harbans, over to you, please.
Thank you, Maibal. So I think if we want to achieve a perfection, we need to measure the astigmatism. That is whether it's irregular or regular. Whenever the astigmatism is irregular, we have got to take the refractive astigmatism in account, as I showed in RK patients. And volume and axis, out of this axis is very crucial. There should be agreement between the various instruments for this axis. When we talk of the measurement, more than equipments, it is the pitfall is most of the time is a dry eye. We have got to take care of that whenever the readings are not correct. And when we come to the IOL selection, surgically induced astigmatism, posterior corneal astigmatism, anterior chamber depth, these are minor factors which decides, or if you have got to choose between say 1.5 and 2.25 of them, these factors come into the play. And then in the surgical pulse, how to mark them, how to implant them, and how to handle the toric IOL surprises. So normally we know that the direction is more important, and the various instruments measure at a various planes. We need to understand that. And averaging versus crowding, we need to understand. Most of the machine, when they give the average and the one reading is wrong, then everything goes wrong. So you should see all the readings of the LenSSR or IOL master instead of seeing the average reading which comes over there. So I ask them to bring the keratometric chart. And there should be agreement between the two or more machines, or two or more observers, or two or more times. So there should be some agreement before you decide. And pupil size, when you are comparing the Pentacam and IOL master, so pupil size is very, very important. And we need to understand that the Pentacam, you need to compare the anterior sagittal corneal power, not total power, but put the toric IOL according to the total power. And see at 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, there may be different reading and a different axis. So you got to see between 2 and 3 millimeter to compare with the LenSSR and IOL master. So this I already talked that the dry eye, if you find the variable powers, then most likely because of the dry eye. and treat these patients with the mild steroids and lubricants for a week or two and then take reading. It should be stable only, then you should go for toric IOL. I have explanted the toric IOL placed by me because of the wrong reading, because of the dry eye. And astigmatism, when you are taking the posterior corneal astigmatism, is very, very important. If you are putting in a toric IOL which is less than 1 diopter, and if you're putting in a toric IOL which is more than 3 diopter, and if you're putting in a toric IOL which is an oblique axis, in these cases, the posterior astigmatism becomes even more important. It is important in every case, but in these cases, it is more or less mandatory to have the posterior astigmatism calculated. So when we come to the IOL selection, so SIA, temporal incision, if it is a posterior, not so much of a concern, but if it is superior incision is of course into the concern. Posterior corneal astigmatism, we already talked. Aging, anterior chamber depth. As we know that we put on a AC IOL, it needs less power. So if there is a 3 diopter of cylindrical power in a IOL, if it is placed little anterior, it will give more power of correction onto the refraction plane. And then if it is a myopic, which will give less power. But again, these parameters are only to select. Suppose you want to select the IOL power of 2.25 and 3. The reading is in between and you want to select one of them. If it is a myopic, you will select 3. If it is a hyperopic and a shallow chamber, you will select 2.25 because you will get more effect. So these are just for fine tuning your reading, not for main selection. If it is dot on, you will go for that. So all the methods work well. I think most important is when you are marking, when I do in a sitting marking, you are marking a reference point actually, not 90 or 180 degree. After putting the mark and analyze whether it is exact 90 degree or not. I will miss that. And the sodium hyalurate or hydroimplantation should be done. Never use the methyl cellulose. Because if you use the methyl cellulose, the bag remains lubricated and the post-operative lens may displace. And then when you are withdrawing your instrument, put the air from the top to press the lens down onto the posterior capsule. And back should never be inflated. IOP should not be very high. Otherwise, the lens will rotate post-operatively. So it should be pressure from the top. If you get a toric IOL surprise, what should be the next? Whether the toric IOL surprise can be corrected by the toric IOL repositioning or not, that we need to find out. For this, forget about whatever the preoperative parameters were there. Now you see what is the total refractive error now, what is the keratometric astigmatism, and what is the correction by the IOL which can be achieved at a corneal plane. If there is a difference between them, only then your rotation will help. That means if there is a first place the IOL is wrong, by rotation you are not going to correct it. So find out whether the repositioning of the IOL is going to correct it or not. And if it cannot be corrected, then the other option, laser correction, piggyback IOL or IOL exchange. So I'll show you one of my patient. I'll now miss this this is the patient who had LensStar 1.39 diopter at 92 degree, Pentacam 1.5 at 93.1 degree, multifocal toric IOL was implanted 16 with 1.5, and the post-operatively patient had 1 diopter with 1.5 diopter of cylinder, and now LensStar reading was 1.56 at 94, and Pentacam, forget about the preoperative, was at 3 millimeter 1.6 at 95. Now see the variation. At 4 millimeter, it was 1.1 and at 1.4 degrees. So 15 degree of variation over here. So we plan to put it at a reposition at a 90 degree. So see this is the mark which I feel the 90 degrees slightly onto this side of the mark. So when you place a mark, and after 2 weeks of surgery, this lens, and you don't have to open the main incision, just open the side port incision, put on a sodium hyalurate between the bag or any viscoelastic. The bag gets separated very easily, and position the lens at the right place. And before you withdraw, inject air and press it back so that it won't re-rotate. And like in DSEG, if you can keep it pressed for some 1 or 2 minutes, it will be really very, very stable over there. And make sure that your wound is well sealed before you leave the patient. So the residual refractive error was plus 0.25 diopter spherical, which was pre-alignment also plus 1 with the minus 1.5 is the spherical equivalent of plus 0.25. So the realignment will not work if there is a mistake in the first place of selection of the toric IOL. So we need to find out whether the toric IOL, the refractive surprise or astigmatic surprise you are getting is because of the wrong alignment of the IOL, and forget about all preoperative data. Forget about all of them, because if an incision has used the astigmatism, we need to take care of that. Only focus on post of refractive error, post of platometric value, and how to realign this lens. Thank you very much for giving me the opportunity and your kind attention.
Thank you, Harbans, for the fine tips that is there. We have about 4 or 5 minutes. Mohan, Meenu, Samresh, any comments?
Yeah, in my opinion, the toric lenses, no, I keep them for about 2 hours post-operatively in my hospital. I don't discharge them, and I patch them and make them lie down flat, because please understand that 80 to 90% of the rotation occurs within the first few hours in a toric lens. So I see them on the slit lamp after 2 hours, sometimes after 1 hour, or whatever it is, and make sure that I'm on the right axis. So this is one important thing. Whenever there is a doubt, I think Harbans has also beautifully pointed, always, because if the anterior chamber is not deep, it's shallow or something like that, or it's not tight, put a suture. Don't hesitate to put a suture, because otherwise the lens will move forward, it will rotate. And high myopia, still I have not got a solution. Some people put CTR. I do not know what you guys do. But high myopia, the rotation is little more than what is normal in emmetropic eyes.
So, Mohan, just to say that there are small little things that have been done. For example, the second version of the toric lens in the technique, all that they have done is that they have frosted the haptics. So just this little change of frosting the haptics is more sticky, and the rotation stability has improved very much. The other thing is that obviously a very expensive tool, but the ORA is another thing that you can have. You can find out on the table whether there's a realignment of the place where the lens is, whether that's going to be a better result or not. But then again, you have to have the array of the lenses available, because at that particular time when it comes up and says that this is.
What echo is there?
I don't know. There's.
I think the most important point is the pressure from the top by the air. Actually, if you give a good pressure from the top by the air and do not leave the eyeball slightly soft, because if you see the eyeball is soft, the lens will not rotate onto the capsular bag, even if you want to rotate. So if you put on a pressure by the air for a minute or so in a high myopia and oblique axis, and wait it there full pressure like you do in a DSEC, then you will find that the lens gets stuck to the posterior capsule. So if you keep the fluid too much into the bag, I mean, if there is a not pressure from the top, you suppose that there is no air and you injected the fluid, now whole of the bag is distended. And what happens in myopes when you try to check the IOP, so you feel the eyeball looks soft, whatever may be the distension of the anterior chamber and the bag. So you need to see that the iris is absolutely flat and the pressure is from the top. So do not keep on putting the fluid. This causes the capsular distension. So we need to prevent the capsular distension and put the pressure from the top and wait for some time. The hydrophobic lenses really get stuck well with the posterior capsule.
Well, after the air, how do you aspirate, sir? You after 1 minute, 2 minutes, you aspirate off the air.
So I do all my hydroimplantation and inject the air. And if I feel there is a chances of rotation, then I wait for a minute or so and seal the wound, and then slightly withdraw the air and put an antibiotic at that time.
So that means
I withdraw slight air, but it's after waiting for a minute or so.
So you let the air remain.
Yeah, the air is always there in my all cases. Some amount of air is there. Because I feel the IOP fluctuation which you get, air can get compressed more easily, and even say toss type of situation, any infection, because air keeps on rotating into the anterior chamber, so it does not allow the things to get crystallized. And then immediately, sometimes the air also does not give very clear vision immediately after surgery. So if patient develops some keratitis or some other inflammation, he is not very upset when he got up from the table, was absolutely fine, and next day he has seen less. So that way I feel there's some amount of air really helps in all cases, irrespective whether it is there or not.
No, I'm not sure, Abhansh, because in high myopia, the problem is the capsular bag diameter. Okay.
I
These lenses-
agree with you.
See, what happened was last week I had a case high myopia plus 9 diopter of toric lens, and every time I used to hydrate the side port at the end of surgery, it used to rotate. Then I'll go in and do that, and every time I used to hydrate the ports, the lens was rotating. So
So that's,
probably CPR is a better option in these patients. I'm not sure.
No, bigger lenses will be better option. There is no doubt about it. But at the same time, next time after hydrating or while you are hydrating, put the good amount of air as you put on the D-stick patients. Good amount of air means angle to angle, pull air and let it be compressed for some time. Wait for 1 or 2 minutes and then withdraw the air. You will see that the lens gets stuck there. It won't move.
Sir, if I may add a point here.
Yes.
So what I tend to do in the myopes with the bimanual IA, I keep my irrigation in the anterior chamber. After I've removed the viscoelastic and dialed the lens into place, I reduce the bottle height to keep the anterior chamber formed, and then I hydrate my incisions. So once I've hydrated the side port and one main port, then if I withdraw my other side port incision, the chamber doesn't collapse. It tends to stay where it is.
Yeah, you are absolutely right that the hydration of one side port, the main incision, and then withdrawing is something that can keep the chamber inflated and you can have a good result. But in any case, I think with the imaging technology, the overlay technology that is there is we are getting very good results with the toric lens. And Aura is something that I was talking, but in the post-op period, eye trace is again an expensive tool, but the eye trace gives you that if you are taking a picture as to where the lens is supposed by see if I rotate 10 degrees clockwise, anti-clockwise, what the refractive end would be. So you can go ahead and do that. So those are a couple of the things that are there. Himanshu, any last comments? I think otherwise I think we have finished our time. Anyway, thank you everyone for joining in this session, and thank you Bhuvan, Harbans, Meenu, Samresh, and the other speakers, and it was a pleasure. And look forward to meeting sometime again.
Thanks, my boss.
Okay, thank you.
Thank you.
Bye-bye,
Bye.
everybody.
Bye.
Bye.
Thanks. Bye.
Bye, sir.
On behalf of the organizing committee, I would like to thank the moderators and the doctors for finishing it on time. Moving ahead with our next session, I request the chairperson, Dr. J.S. Chittial sir, to please switch on the camera. Hello, sir. Yes, I can see Dr. Chittial sir.
Yeah. Because I was in another session. I just
No
joined.
problem, sir.
I hope other people would also be able to join this session.
Yes,
This is
sir.
a
We
very
are waiting
interesting
for them
session
to
on,
join in. The good part is we are on time, so.
Yeah, it's session very innovative things, latest tools in our or armamentarium, mainly related to cataract surgery, devices, and all those things. And I would invite other chairpersons, Dr. S.P.S. Kerewal and Dr. Krishna Prasad, if they are there. But if they are not there, doesn't matter. They'll be joining us subsequently.
Yes.
So I think they have very nice talks, innovations, and young people are talking today. The first talk is by Saurabh Patwardhan. He's an innovator. He's young and very energetic. He's going to talk about markerless solution Callisto Eye. Saurabh, are you there?
Sir, in the list, our first speaker would be Dr. Anurag Mishra. The others are yet to join in.
Okay, then let's have him.
Dr. Anurag, can you hear us?
He can share his screen. He's going to talk
Yes.
about newer
I'm
machines.
just waiting for his confirmation because we can see him live. Yes, there he is. He's come live.
Yeah,
Yeah,
I'm
he's
so
from
sorry. I'm so sorry.
No problem, sir.
Hello, sir. Good evening.
Good evening, Anurag, and you're right on time. No problems. You can share your screen and let's listen to him. What new approaches for our newer machines you're going to tell us?
Also, Dr. Chittial, I'll just keep on chatting with you as in when the other speakers come in. We will have an update. I think the next speaker that we can have is also Dr. Saurabh. So,
Saurabh,
Bhargava was
there
with
we
us.
have Siddharth there.
Okay.
Just a moment. Yeah. Why do I get this whiteboard share?
So if you're using a MacBook, it's the default
Yes.
setting.
Redo it
Uh-huh.
again.
You'll have to switch on the presentation and then try again and share the other screen, not this. And if you've not given permissions to Zoom, it will not take in. In the meanwhile, just to save time, can I also request Dr. Siddharth Sharma sir to try his screen sharing? If it works, then we would take Dr. Siddharth Sharma going in first then.
Siddharth, are you ready with your presentation?
Sir, I think I can go ahead. Let me. I'll just share the screen and see.
Dr. Anurag, in the meanwhile, you can try and updating Zoom and giving permission to.
Your thing is there. We can.
Okay. Then should I go ahead, sir?
Yeah, please. We are very keen to listen to your hybrid tips.
So whatever we know is what you have taught us, sir. So this is hardly anything that I'll be telling you, but it's always a pleasure and good evening. Just a second, it'll just take a second.
Dr. Titial sir, just a reminder, we will have to leave this hall at 6:30 for the GBM. So we'll have to keep the time accordingly. 6 minutes is the time assigned to each speaker.
So I'm going ahead then?
Yes, sir, please do. Thank you so much.
Good evening, sir. And thank you for calling us here on such a forum where we have our teachers guiding us. Dr. Titial has always been kind enough and he has been the most gracious of teachers. Just like car manufacturers keep upgrading their safety technology to avoid accidents and to make the journey safer, similarly, the phaco machine manufacturers have been constantly upgrading the performance of the machines so that to make the surgery more predictable and safer in terms of the patient side. So the hybrid interpret tip is one such innovation which has been introduced, and the purpose is to make surgery safer in patients which are on the softer side or in hands of beginners who are converting to higher end machines. If we look at this tip, there is a polymer coating all around. I've just started on a video. So when we look at the tip, there is a polymer coating all around the tip, which makes it appear as if this tip is neither going to bury, nor trench, nor be able to chop. But contrary to its expectations, this tip is able to do all the things and much better than what we expect. And the results are quite in line with whatever we would be doing with a normal tip. So looking at the tip, it appears that this won't be able to either trench or embed. But as you see in this soft cataract, I'll be showing a few different types of cataract. So it trenches very well. You can go up to the mid periphery and even deep without having the fear of damaging the posterior capsule. So if you see, this was a soft cataract. The parameters of the trench are the same as that would be for a normal tip. And it has been able to make a good deep and wide trench. And there is no problem with the trenching and splitting and going ahead with the routine phacoemulsification. This is a fairly dense cataract. Only difference that I'm keeping is to keep the bevel of the tip slightly horizontal so that I don't need to embed deep into the meat of the cataract, but it gives you a very good hold without losing occlusion, and you are able to go about surgery just like a routine would. The basic difference between the approach to this tip and the others is that you need to tweak the parameters slightly on the higher side, as this increases the overall surgical time and effective phaco time. But if you look at the eye the very next day, there won't be any corneal edema because the surgery gets slowed down. That is why the overall phaco time is increasing. The usual parameters that are increased are by 10 to 15% in terms of the torsional phaco, and the vacuum needs to be kept 10 to 15% on the higher side so that one doesn't lose occlusion. So if you see this goes ahead, that was a grade 2-3 plus cataract, and it has been able to eat up the cataract very well. This I showed because this is a soft cataract where a routine tip will keep biting through without maintaining a hold. This is the central nucleus of the cataract being removed, whereas the perinucleus is very much there. So I'll try to flip out the cataract out of the bag, and the advantage with the tip is that you can go up to the mid periphery. You can even go close under the rhexis margin and towards the posterior side, but the tip does not engage the capsule. I'll show you certain more videos. Now, like this is one cataract where one is not getting a very good hold. But once you get a hold on the epinucleus, you are able to flip it out, holding it without eating it up. So the basic difference is that the surface area being enlarged, it gives you a large grip or a large hold to the cataract without losing the grip. So thereby, even in a softer cataract, one is able to extract the cataract with good efficiency. Safety wise, since people who are transitioning onto higher performance machines, they may be slightly worried of the higher parameters. Like we work on a soft cataract, say at around 350 of vacuum to 400 of vacuum and 40 units, 40% of torsional phaco. Whereas in a dense cataract, I use 500 to 550 of vacuum settings, and torsional power goes up to 50 to 60%. So you'll just see in the next video that this is able to catch on to the epinucleus and bring out the whole thing as a sheet. Rather than in a routine tip, it would have bitten through and eaten away the cataract. This is a direct chop. So appearance wise, this does not dig into the cataract, but even then it maintains a good hold and there is no difficulty in performing the surgery. So, if anybody wants to ask anything, you can keep asking in between, because if you look at this, the tip will make it appear as if this tip is not going to get into the nucleus and hold the nucleus. But it is able to do so with good efficiency, and even if you are working close to the posterior capsule, it is much safer as it does not catch on to the edge of the tip, does not damage the capsule. I even tried a grade 4 plus cataract recently. Although the overall phaco time was nearly 50 seconds or so, but the next day the cornea was quite clear. There was no edema as such visible. And as Dr. Titial used to say earlier, that it is basically your grip, not the eating part. You don't need to use the tip to cut.
Apologies, sir, but the time is up.
Right. So I'll just show us short, one shot that this tip is holding on to the posterior capsule without damaging the capsule. This I have taken from the internet, but this is just something which shows you that at 350 vacuum, I'm not forwarding this just in case. This is a grade 4 plus cataract, hypermature, and still one could do so. I'll just get you this last shot.
Okay, I think your net is not coming out correctly.
Somehow.
Doesn't matter. I think you have given us the message across.
Right,
sir. Some innovation on a phaco tip, like we used to have in a IR tip with a silicone sleeve. Same thing here also. It looks very impressive. Yeah.
So thank you, Siddharth, for taking us through. We would like to invite our international guest today, Dr. Ishtiaq Anwar. He's joining us from Bangladesh. He's going to talk about Artibo 800. Can you share your slides, sir? Dr. Anwar? Yeah, he's there.
Yeah, good
Yeah,
evening.
please. Yeah,
Good
yeah.
evening, Professor
Good
Kirill.
evening and most welcome to this international DOS meeting, sir.
Yeah, thank you for the kind invitation. I would like to share my screen. Sir, is it visible now?
Yeah, it's visible.
Okay. I will be talking on Artebo 800 and how it helps us in our OR. So whenever we get a microscope, the things that we look for is that first of the thing is that viewing, how good we see when we are operating. And this comprises of many of the things like the clarity, depth perception, field of view, and magnification. So in the older generation, what happened that when we increased the magnification, the field of view was decreasing, depth of perception was decreasing a little bit. And I would say that with this 800, even if we go very magnify it largely, the depth perception is there and the field of view is excellent. And beside only doing our surgery, we also like to teach so that the people that they are in the OR, the students and the fellows, they can also see whatever we were seeing. And in the long term, ergonomics also comes into play, because if we are operating stiff for a longer period of time, that hurts our back. So with the Artebo, it comes with a big screen, 55-inch monitor. And as I said, magnification is beautiful, illumination is excellent. And like we used to go hit the illumination nearly 100% for getting the good view. But now with this, usually what happens that I start with a very moderate illumination like 30-40, and if needed, then only I increase the illumination. And in the panel, there is the some information that helps us many a times, like the magnification, the rate of illumination, whether we have used any filters or not. So the big question was that learning curve. How long does it take us to learn surgeries from switching on from the conventional microscope to this? So I would say that for an experienced surgeon, it takes only 3 to 5 surgeries. And that is not anything learning. I would say that, you know, the distance where to keep the monitor, the sitting position, and little bit of change to our sitting position, because we are habituated seeing straight forward. So that we have to little bit tilt our head to the left or right, depending on the right or left eye we're operating. And I would say that after my second OR, I did a live surgery. So we got this last year on 22nd, and on 25th, we had a program where I performed a live surgery. And this is just to say that this is that easy and adaptable, so that any experienced surgeon can shift it very quickly. The best thing would be, I would say that the low light. Apart from that, it reduces toxicity. But the thing is that patient is so comfortable. And usually I start from 25% illumination now. And if needed, then only I can increase it. And the magnification, depth of perception, and resolution is excellent, which I'm going to show. Just share 2 videos. Like this is a video where there was a PCT, and I was supposed to give a toric IOL. So I converted it into a posterior capsulorhexis. And this is a toric IOL given in the back. And as this is markerless, you know, we can easily see where to put that IOL. So guide it along the axis, desired axis. In this case, it was 41 degree. And I don't use any ink or marking nowadays. So it sits beautifully. We can see that posterior capsulorhexis has been converted here from the tear, and the lens is sitting excellently. So next surgery, I would like to share that this was a subluxated traumatic lens with traumatic mydriasis. So in this surgery, I had to do 3 things. And the magnification and the field, we can see that this is a wide field, which helps for us to do this sort of surgery. So the lens was taken out through a 5.5 incision, and then vitrectomy was performed. Then a Yaman technique was used. This is a common technique nowadays. So take out the haptic and do a little bit of cautery to make it ball. And again, on the opposite side, take it out. Again, cauterize it. The reason that I am showing this surgery specifically because we have to do at 3 planes, do a vitrectomy, do a pupilloplasty, and Yamani technique. And field magnification and illumination, as you can see that here I am using around 37%. So this is a 4-throw single pass pupilloplasty, which Dr. Amar Agarwal has shown us. So past the suture, I will just fast forward it because of time. So did 3 of like this, and the pupil looks great now. This was the post-op picture of that patient. So there was an apprehension that there will be a delay, but it is so minimal that we hardly can get it, and there is no delay as such. And one of the finest thing is that we can use both ocular and 3D simultaneously. So you just switch on the, there is a knob which transfers from either 3D or ocular, or there is a system that hybrid. So both are there. So that all the staffs and the fellows are on board, they see what the surgeon is doing. This is a great teaching tool too. And our experience, I would say that we had a big expectation, and we were very satisfied. A little bit of
apologies, sir, but the time is up.
Yeah, I will just finish that. Surgeon needs to little bit of move this way or that way. So in conclusion, I would say that in a short learning curve, and we did not observe any significant lag. And but I would say that, you know, if we go wireless monitor and little bit of movement of the monitor, if it is motorized, this would help us. So I would request that, you know, everybody enjoy this thing, just sit back and enjoy the surgery. Thank you.
Thank you, Dr. Ishtiaq. Wonderfully, you know, presented the advantages of the Artipo 800. We all know the future of microsurgery is going to be heads-up devices. And I'm pretty sure there will be a lot of innovation coming up. In future, we may be operating under low light circumstances, some sort of infrared lights, where patient also doesn't have light, but you can still see in our visuals. But you highlighted all the major advantages, which is then Artipo. And for anterior segment surgeons, it's been a wonderful tool with almost zero lag. You don't realize anything, and any surgery can be done through this. You sort of very beautifully difficult scenarios. Now, I think Dr. Anurag is ready with his presentation. He's going to take us through new approaches for our modern day machines. Dr. Anurag, he's from Odisha, going to talk about the new approach. Yes, sir, please start.
Thank you so much, sir. Good evening, ladies and gentlemen. I think 6 minutes is going to be WAF duration to talk about new approach with modern machines. I've just selected my diagnostic equipments and selected out a few to talk about, and in fact, brush through whatever interesting salient points that these machines speak on or boast on. This is one thing that everybody now uses, this pretty common machine, the IOLMaster 700, used for biometry. It scans the eye in 6 different meridians and scans every meridian 128 times and then repeats it 5 times to give us 2,000 scans per second. It produces a continuous B-scan image. This is the only biometry machine perhaps in the market which can do that. It has an excellent penetration and telecentric keratometry as well. So I'm not going to talk about this much. This is what the machine gives us, a continuous B-scan, so that every point to every point in the eye can be measured. These are the 5 or 6 meridians along which the machine scans. and produces this continuous B-scan picture. And it also gives us a fixation check. You can see whether the scan has been taken from the center of the fovea or not. If there's no foveal pit that's visible, it's poor fixation and you can retake the scan. So there's some interesting clinical applications. This is one of my patients in whom I had completely missed the fovea while doing a clinical examination. The optometrist came running to me showing that there is something funny happening at the fovea. We did an OCT and found that there is an ERM and there is a traction on the macula and there's a macular edema as well. I would have burnt my fingers if it had carried on and done the cataract surgery in this particular patient. It also tells us that there is a lens tilt by looking at the axis of the lens in the B-scan picture. So these are the certain bullet points that I just wanted to highlight before going into the next machine. This is a new kid on the block, the Antirion coming from Heidelberg Engineering. It has proprietary standard step source OCT and ray tracing combined technologies, but the light that has the diameter, that has the wavelength of 1300 nanometers instead of 1050 in the 700. So it has even better penetration. Tomography and in particular the anterior segment OCT are stupendous with this machine. They give you very clear scans, enormous data points. For the keratometry, it utilizes almost 26,000 points from the central 3 millimeters of cornea. Very, very precise indeed. And it also gives you access to the Oculix ray traced IL calculation formula. This is again another, the only machine in the market which gives you access to that formula. Whether that formula is very useful to know, it is a subject of debate and we can debate about it the whole day. So the fixation check is not there. It doesn't give you a B scan, but what it does give you is an A scan divided into two different graphs so that you can know from where the machine has been, taken the scan. It gives you the SIM K, it gives you the toric calculation formula according to the predicted posterior corneal astigmatism and the calculated posterior corneal astigmatism. This is the B-scan picture. There is a posterior polar cataract, as you can see, but perhaps the posterior capsule here is intact and is continuous, so you can plan your surgery accordingly. Herein, the posterior capsule is given way, so there's a communicating time, so you can plan your surgery accordingly. You can also look at the thickness of the lens and find out the intermittence from there, and then the lens tilt, if the axis of the lens and the axis of the eye do not match. The eye trace uses a proprietary ray tracing. It has both wavefront and SIM Ks to give you higher order aberrations, angle kappa, pupillometry. The modulation transfer function curve, particularly, I always look at it when I plan an 80 IOL in one of my patients. Of course, the alignment check is there, which will give you whether the toric IOL should be rotated or not. We were having a discussion on this in just the previous discussion. Now, this is one of those, one of my patients wherein you can see that the higher order aberrations are not much in the corneal front, but they are very grossly elevated in the internal front. The tracy refraction, which calculated the refraction on the anterior lens capsule, is showing a value of -20. And you can see there is grossly elevated higher order aberrations on the lens front. So this is a telltale scenario of a tilted lens. So you should be very careful. Do not plan a toric IOL in this case. Rather, the lens should be removed and you should plan your surgery accordingly. This is the modulation transfer function curve that I was talking to you about on the corneal front. If the curve bisects the square, then you should be very careful because the contrast is already reduced. Now, this is the curve that the patient has without any glass correction on the corneal front. This is the curve the patient has with a spherical correction on the corneal front. But when you completely correct the refractive error in terms of sphere and cylinder, you can see that the curve shoots way up the modulation transfer function curve. So this is a good candidate for any advanced technology IOL to be implanted. You can go ahead and do that. The Varian is a markerless system which has a dynamic keratometry to attach to it, an excellent planning cockpit. It utilizes 3 infrared and 12 LED lights. It, of course, gives you the axis on which toric IOL has to be implanted, but otherwise also monofocal IOLs can be. There are two telltale significance of this machine. One, it gives you an excellent planning cockpit. Now, for example, this patient, the recommendation was a 24.5 T3, but this particular IOL model was not available with the distributor. It will give you the spectacle power in the post-operative period in this green band zone. Now, the incision size is 2.2. Now, I asked Varian whether I can manage with a T2 in this particular patient. Varian said, yes, you can change your plan, increase the section to 2.8 with the same site of the incision and implant a T2. you will be landing with a cylinder residual of 0.18, which is pretty much acceptable. So you can go ahead and also implant a T2, just extend the section size, and the patient will do fine. This is another patient who actually had opted for flax. We had a myopic patient. This is the last slide. The patient was left with a cylinder. We had planned with a T9, the highest cylinder available. Even then, the residual cylinder was 0.86. So we asked Varian, since the patient has opted for flax, can that be corrected with arcuate? The Varian said, yes, it can. So there was a paired arcuate that was planned. But once you plan a paired arcuate within 30 degrees of that arcuate incision, you cannot plan either a primary incision or a secondary incision because of the fear of the cornea weakening too much. So the incision site was also shifted from 20 to 70 degrees, and now the residual astigmatism has come down to 0. So this is what this machine does. So this is my standard flow of things. If I'm depending on these machines in order of preference, I depend on Antirion to give me the best keratometry, followed by Varian, followed by Almaster 700. As this whole teaching goes on, you can't depend on just one machine to give you measurements. For axiometry, it's Antirion, almost equal to Almaster 700. And for the higher order aberrations, of course, it is iTrace. Antirion gives you some of them, but not all of them. So that's just a few bullet points that I wanted to share. Thank you so much, sir, for the opportunity. I sign off here.
Thank you so much, sir. With respect to time, can I request our next speaker, Dr. Saurabh Bhargava, sir, to please start his screen sharing. We would have the question and answers at the end of this session to save time. Thank you so much, Dr. Anurag. Thank you so much.
Pleasure. Thank you.
Dr. Anurag, you logged in from 2 different. Okay, yeah, perfect. Yes, Saurabh, sir, we can see your screen. You can get started, sir.
Good evening, the esteemed panel, and thank you, DOS, for the invite. I'm here to speak upon the balanced approach with optimal energy. And here I'm going to talk about the balanced energy that is delivered by the balanced tip. And that's the way forward. It's not only a way of phacoemulsification, I believe it's a way of life also, where you must keep your energies optimized and balanced. So the evolution of balanced energy started in 2006 when the Ozil torsional handpiece came into being. It had a lower fluidic consumption and enhanced phacoemulsification. And we all noticed the improved followability and the reduced repulsion. In 2009, there was the launch of the intelligent phaco, and this intelligent phaco further enhanced our performance as compared to the routine longitudinal phaco. The intelligent phaco helps us to use bursts of longitudinal energy as and when required. That is when occlusion occurs. Moreover, it reduces the occlusions of the tip, which are a bothersome thing. In 2013, with the advent of the Centurion, the balanced energy technology combined with the Ozil intelligent phaco, and here you had the intuitive system software and the new Intrepid balance tip with infusion sleeves. Now, this balance tip is a novel design which has a double hum. The function is it maximizes your torsional tip movement at the distal end, and at the same time, it minimizes movements at the incision, thereby reducing the heat generation at the incision. Since balanced energy and the movement of the tip cannot be demonstrated by a video, a surgical video, here's a small video clip from Alcon, which shows us the performance.
The balance tip is a new design intended to maximize ultrasound delivery through the shaft of the phaco needle. This design was created to maximize cutting at the shearing plane distal end of the phaco tip and reduce movement and heat at the incision site. Use of Ozil torsional energy on a straight tip results in a balanced displacement of ultrasound energy through the shaft, but a straight tip is not effective with torsional energy since there is no bend in the distal end of the tip, therefore no cutting efficiency. Use of Ozil torsional energy on a Kelman tip benefits in cutting efficiency as a result of the bend. However, the 20 or 12 degree bend could cause an unbalanced displacement of energy through the shaft. The Intrepid balance tip diminishes the potential for heat and movement at the incision site. The balance tip is a patented technology designed through extensive research and mathematical formula.
So as we can see that 39% of energy consumption is reduced, 14% of fluid turnover is reduced, you have 9% faster aspiration rates, and you have 60% less temperature rise at the incision. Now, this not only maximizes your efficiency, it also reduces the force on the eye. There is decreased trauma and better wound architecture. And as compared to the Kelman tip, it's much more friendlier on the posterior capsule. Here in this slide, I've shown my parameters. And here I would just like to highlight the salient features that we are not using longitudinal phaco at all. So in grade 1 cataract, we are just using 30% torsional. In grade 2 and 3, we are using 60% torsional. And in grade 4 and 5, we are using 90% torsional. That too in a linear fashion. This increases cataract removal efficiency and achieves a procedural balance. Now, what are the highlights of it? Number one is your longitudinal phaco is not used. Number two, you're using low IOP settings. Most of my cases I complete in between 40 to 50 millimeters of HG, which works out to be about 60 centimeters of water height. There is decreased energy, as I just demonstrated, 30 or 60 in the routine case. The vacuum settings, we're using higher vacuum settings, maybe somewhere between 500 to 600. And the AFRs are just average. This, all in all, the net result of this is a low turbulence. And we all know that a low turbulence will give rise to clearer corneas postoperatively, less uveitis, and more happy patients and satisfied surgeons. So the clinical benefits in my experience are, I'm having a lesser CDE using just 60 to 65% of the power. The BSS use has gone down. A single bottle of BSS can last up to 5 to 6 cases. There's a faster procedure than my existing system. My chamber stability is rock solid, even when I'm using lower IOP settings. Whenever we are using challenging cases like high myopes, we can just reduce the IOP. In high hypermetropes, we can increase the intraocular pressure, and this balance tip and the Interbit system works great. Patients with weak zonules, with floppy iris, it does wonders. I think the Malugan ring use has gone down by almost 80%. And you're working on a 2.2 mm platform, able to go to vacuums as high as 500 to 600. And you're very satisfied that you've completed your surgery in 2.2 millimeters. Again, there is, to reiterate, there are minimum incidents of clogging due to the tip design. Thank you so much for your kind attention.
Thank you so much, sir. Next, can we have Dr. Lalit with us? Dr. Lalit Sonaraj.
I'll just share my screen.
Yes,
Good
sir.
evening to one and all. So I'm going to talk to you about the Luxor Rivalia and the new microscope which is introduced by Alcon. Now, this is how the microscope looks like. It is basically a microscope with a wonderful red glow, and it has an electromagnetic stand, and it also has a screen attached to it which has an inbuilt recorder. So if you have a video camera, it can be connected to it and it can do the recording for you. It comes with a HD screen also. So how does a patient's eye movement actually impact our visualization during surgery? So one is there is unstable loss of red glow. So whenever the patient moves, we always have to ask him to look at the light again and again. And this reduces the efficiency and takes more time during surgery. So definitely there is a loss of red reflex with our conventional microscopes. Second thing is we have to focus and refocus because the depth perception is altered whenever the patient moves, and this reduces the efficiency. 92% of the cataract surgeries are interrupted by focusing and refocusing during surgery. So that again delays things and can reduce the precision also. So these two things are our main issues when we come across when we use the conventional microscopes. There is loss of red reflex and we have to focus and refocus again. So what is the solution that helps you handle this kind of surgical situation? So this is when I was introduced to the Rivalia. I took a demo of this microscope for a good duration, for a month. And then I decided that this is something which I should get. I was thinking about the Ingenuity and things, but then when I saw and when I used this microscope, the amount of strain on my eye and for the amount of strain for the patient also came down drastically, and the surgical speed improved like anything. I used to usually do 4 cases in an hour, but then with this microscope, I'm able to do 5 to 6 cases sometimes in an hour. So now what happens when you use the Rivalia is it has an excellent red reflex, which is 6 times larger than the conventional microscope. So basically there is 2 types of illumination. One is the coaxial and the oblique. And the coaxial illumination is the one which is responsible for a good red glow. So instead of 1 beam of light, there are 2 beams of light which are responsible for the coaxial illumination along with 1 oblique illumination. So hence you can see that the red reflex is actually 6 times larger. And when the red reflex is larger, even when the patient moves the eye under topical, it does not disturb your view and you can still continue with the surgery. So this is a comparison between a conventional microscope from some other company with the Alcon microscope, which has the Illumni eye technology, which is responsible for this wide, large, 6 times larger red reflex. The second thing which is amazing about this microscope is there is greater depth of focus. And apart from that, there is personalized LED illumination. There are various choices of LED which you can choose from. And it is a blend of coaxial and oblique illumination, which can be adjusted individually. So if you feel like, when you're doing surgeries on the conjunctiva or something where you require more oblique illumination, you can always increase the oblique illumination. And when you're doing cataract, you can switch on to the higher version of the coaxial illumination. And it has complete surgical integration with the other Alcon products. So now there is definitely a greater depth of field, and you don't have to focus and refocus during surgery compared to the conventional microscopes. That is because of the Illumni eye technology, which has 2 coaxial lights along with 1 oblique illumination. So you have 3 choices of lights which are available. You can choose from what color you want. One is the warm white, which we are generally used to, which is you can call it the yellow light, which we are generally used to. The other one is the cool white, which is the white illumination, which was available with the Zeiss microscope and the Leica also. And then the best part is there is a mixed white. So where the coaxial illumination is yellow in color and the peripheral illumination or the oblique illumination is white in color. So you can choose from whichever light source you want. And these are LED, which have a very long life. I think it lasts for around 50,000 hours, which is, quite a lot of a long duration. Apart from that, for posterior segment surgeries, you have something called AMP, because in posterior segment surgery, we use endo illuminator. So you don't have to do anything. Whenever you actually switch on the biome, the light automatically shuts off. And, we can actually do posterior segment surgeries very, very comfortably. And the other thing is the integration of the microscope with the various machines, such as the Verion, the Ingenuity. The Ingenuity can be fixed to the microscope like this. The Constellation as well as the Centurion. So they seamlessly talk to each other, and that is the amount of technology which is available to us today. So what Rivalia reveals, what you need, reveal what you need is visualization. Manage your surgical procedures with stable and enhanced visualization while improving efficiency and control at every step of surgery. That is what the Rivalia promises us. Now, this is one of the videos which was recorded through the microscope. And whenever you have a beautiful wife, you also get you generally buy beautiful jewelry for them. So I recently got a 4K camera for my Ikegami camera for this microscope, and you can see that everything is seen in such great detail. The red glow is amazing. You can alter the illumination, as you can see here. I'm just increasing and decreasing to get the optimal result. And this is how the view through the microscope is. And I personally feel this is I was the first person to get the microscope in India. And I'm really, really happy, because this was one of the best decisions which I've ever taken in my life in the 16 years of practice, because it has reduced my surgical time and it has increased the efficiency and precision of my surgery to a great extent. Thank you. Thank you, DOS, and thank you, Alcon.
Thank you so much for finishing it before time as well. Next, can I request Dr. Sartaj Grewal sir to please start his screen sharing?
Sure. Good evening. I'd like to thank DOS for giving me this opportunity today
Today, I'll be sharing my experience and some tips and tricks on achieving zero energy lens fragmentation with the MyLoop. So we all come across scenarios like these in our clinical practice. Terrifying hard cataracts such as these can pose a challenge for even the most experienced surgeons. Hard cataracts can be a struggle right from the very initial chop to every step of nuclear disassembly, especially with a dense leathery posterior plate that refuses to come apart, posing a challenge in further division of the nucleus and in emulsifying those pieces further. With the MyLoop, we have a device and technique that makes these hard cataracts no more challenging than any other routine cataract surgery. Without using any ultrasound or laser energy, we can easily divide the nucleus into 2, 4, or even more pieces as we desire. The only prerequisite is that there should be adequate zonular support before the surgery. So the MyLoop is a nuclear fragmentation device that features a retractable, micro-thin, super-elastic, self-expanding nitinol filament that has a 300 micron diameter. Fully expanded, it has a horizontal diameter of 10.5 millimeters and an anterior-posterior height of 5.5 millimeters, which is more than enough to engulf even the largest nuclei. Once fully retracted, the loop has a diameter of 1.5 millimeters and can be easily inserted through a 2.2 millimeter incision. Now let's talk about how to use the MyLoop. This is a recently refreshed MyLoop. This has a compressible rubber sleeve at the neck of the nozzle. It is very convenient to operate with just one hand. And as can be seen here, it has a very smooth mechanism of movement. It is best to hold it like a pen and then move the slider with your index finger. The older design of the MyLoop had this black mark on the nozzle. Once inserted, the black mark had to be aligned with the incision, and it was important to maintain this position as you retracted the loop. The mark served as a convenient guide, helping you align the point from where the filament expands with the center of the nucleus. As you get more experience with the device, now I actually prefer to remove the rubber sleeve, and it doesn't even have the black mark, and I'm quite comfortable with that. The rubber sleeve can sometimes press on the wound, cause some leakage of viscoelastic. So even without the rubber sleeve, I'm more comfortable with it. With the refreshed design, now there's no black mark. Instead, you can keep the rubber sleeve flush with the wound, reducing the chances of pushing the instrument too far in, eliminating the need to repeatedly visualize and reconfirm the position of the instrument. Next, let's talk about the most important step in the MyLoop. So the instrument is to be inserted with the MyLoop oriented in the coronal plane. The edge of the capsule is gently tented up. So make sure that the MyLoop, when you're inserting it, you keep it, instead of absolutely horizontal, a little tilted with the loop down towards the nucleus. Then you slowly expand the loop. Once the loop reaches the equator of the capsule, you gently rotate your hand clockwise, orienting the loop vertically in the sagittal plane. This particular step comes with a learning curve. This video shows my very first attempt to use the MyLoop, and after inserting the instrument, expanding the loop, and trying to rotate it clockwise, I struggled with getting the loop over and around the center of the nucleus. I even tried to use the second instrument to help nudge the nucleus into the center, but with no success. After struggling for quite some time, I noticed the loop had not completely encompassed the nucleus, and rather it was pushing the nucleus away. I tried to expand the loop a little further, and immediately you can see the nucleus moving and comfortably resting in the center of the loop. Learning from my mistake, in the next case, I compensated by expanding the loop completely. And as can be seen, this allowed the loop to easily slide around the nucleus and engage it, but the overexpansion put stress on the capsule margin and stretched it to an oval shape, as can be seen here. So to get this step just right, it is important to start expanding the loop gently till you reach the equator, then gently rotate the instrument clockwise and keep tracking for any movement of the nucleus. If the nucleus begins to move, compensate for it by slowly further expanding the loop till you see the reflex of the loop posteriorly and the nucleus is stable. Next, as you expand the loop and it crosses the equator and comes posterior to the nucleus, it can be easily seen as a shiny reflex, even in dense white cataracts. It is important to keep rotating the loop till it is vertical, as this can reduce the chances of tilting the nucleus and increases the chances of giving you two equal halves after division. Using a second instrument is very helpful in these dense cataracts. It helps stabilize the nucleus as you're retracting the loop, because as the loop retracts, it tends to push the nucleus up and out of the capsular bag. In this case, we can see that being a very hard cataract, even after dividing the nucleus, there can be an isthmus of a few fibers between the two halves, especially in those dense, leathery, sticky cataracts. In such a situation, the second instrument allows you to dissect these fibers and safely remove the MyLoop through the incision. So here we're just dissecting those fibers away and allowing you to just free the MyLoop and then remove it safely. After dividing the nucleus once, the pieces can rotate freely. So when you try and further divide the nucleus into quadrants, the nucleus tends to rotate with the loop as it expands around the nucleus. It is helpful to compensate for this by under-rotating the nucleus before the second division and using the second instrument to keep the nucleus stable. In certain challenging situations, you might not be able to divide the nucleus evenly in the first go. In such situation, you can first emulsify the smaller fragment, then again use the MyLoop to further divide the larger fragment into smaller pieces, and then proceed to emulsify these pieces. The MyLoop can be easily redeployed to divide the nucleus at any stage of the surgery, even if the piece is in the anterior chamber. So in my experience, the best part about the MyLoop has been that it has made surgery in these very hard cataracts far more predictable. I myself was very hesitant the first time I used the device. I was not sure how much force would be required to retract the filament divide the nucleus. And I remember being completely surprised when it just cut through it like a warm knife through butter. There was nearly no perceivable resistance at the time of retraction. And even though it appears quite traumatic in the video, I've never experienced any compromised capsule support in any case. Even some of the case series that have been published have shown that MyLoop can easily divide the nucleus in each and every case without compromising the capsule. The major reason for this is the force is applied centripetally on the nucleus alone, not on the capsule, not on the zonules. Because unlike chopping, where the stretching centrifugal force is applied on the nucleus and transferred to the zonules also. So with hard cataracts, the most challenging part is the leathery posterior plate. And with the MyLoop, even those stubborn plates are easily and completely transected. The MyLoop is now my go-to choice for all hard cataracts, and I would strongly recommend every cataract surgeon to try it. Thank you.
Thank you so much, sir. Next, can we have Dr. SPS Garewal, sir, to please share his screen?
Hello.
Yes, sir.
Can you hear me?
Yes, sir. I can hear you.
Okay. My comments on MyLoop. It's a great invention, and it has made the work on hard cataracts really very predictable. I will not use the word easy for the beginners. It does have a learning curve. But it makes it very predictable. I used to be really worried about those hard cases coming and where you are planning to do trifocal, or one eye had a multifocal already done and the other eye now he has come with a hard cataract. So in those cases, it has really made it predictable. And even if it is a brown cataract, the next day you will see the cornea is absolutely clear. So it has made a lot of difference, and I'm sure a lot more people will be embracing the technology. Thank you.
Thank you so much, sir. If I'm not mistaken, sir, you have a talk as well, or because I'm a little confused. Okay. All right. So I believe, have we finished with all the talks? We've got Dr. Jeevan Tatyal, sir.
Yes,
Hello,
I'll
sir.
make my presentation.
Yes, sir. I was a little worried because.
No, I was into some other thing, you know.
Yeah, I was like, आप chat पे respond नहीं करे तो मैं थोड़ा सा डर गया था.
Let me just share my screen now.
Yes, sir. I believe you would be the last speaker of this session then, because I think everybody else has presented.
Done. They're all done.
Yes, sir. Thank you, sir.
Okay. Again, I'd like to welcome all the delegates today who have joined us. Thank you, all the speakers who have done wonderful job for this session and other sessions also. And as we've been talking about newer devices, newer way to handle difficult situations, and beautiful talk by Sartaj on MyLoop, wonderful videos. I'm going to talk about something, a new intraocular lens, which has been brought for us for a patient care wise, and no financial disclosure from my side. So looking into this lens, which is known as Clarion, the device in fact is Clarion Autonomy. It has to be in a two components. One is the lens as such. Second part is that the way we are going to inject this lens inside the eye in an automated way. So it is an advanced foldable single piece posterior chamber monofocal intraocular lens, which has a precise edge design, which have its own benefits. And the second is an automated injection of a lens inside the eye. That is a preloaded device. Earlier, we used to use devices which is through the AutoSir. Now this device is preloaded in your hand, And the IOL is delivered gently by the carbon dioxide gas-driven mechanism. It can go through a 2.2 millimeter very nicely. And the precise edge design, which you see here with the yellow arrows, gives you advantage of sharp posterior edge 360 degrees, which will prevent the PCO formation and effectively decrease the YAG laser requirement for these cases. And basically, if you look into other options of various designs which are available, mainly apart from PCO, we're looking for a decreasing the visual photooptic symptoms like glare in these cases or positive dysphotopsia. Other important part of this design is stable in the bag, which may range from a 9 millimeter to 11 millimeter. Still, the lens is well stable because of stable force haptics, which we have been using for these alcohol lenses for quite a long time. And these are one of the best lenses in any form for a toric and for a multifocal toric lens. This design is the best suited for us. Looking into the small video, which I'm going to show it, this is a cartridge where the lens is preloaded. Through this small opening, we are going to inject dispersive viscoelastic. Normally, I use Biscode for this purpose. The Biscode has to lubricate the entire tunnel of the cartridge here. Subsequently, with the pressure onto the knob here, with the carbon dioxide delivery system, the lens will be gently pushed towards the nozzle here. You can see how easily it goes inside, and there's a weight there. Then subsequently inject. This injection is very smooth, very regulated. You can regulate the speed also. And see, the lens is nicely folded and opens very, very slowly, effectively, without causing any significant jerk in the anterior chamber. Especially this will be important for a difficult scenario where you have a bag which is maybe loose, or cases where you have a small pupil. You can see how beautifully lens is effectively placed in the bag in this particular case here. So this is what our experience is. We had done 151 eyes of 115 patients in a multicentric 7 different sites in India. So this was an interventional prospective post-market single arm unmasked multicentric study for 12 months follow-up, and ranging from patients coming from different parts of the country will have a different ethnicity also. Routine inclusion and exclusion criteria for all cataract surgery patients, or endpoint for these patients in a primary effectiveness wise to see the best corrected visual acuity, distance visual acuity of 0.2 logMAR at 1 month. And similarly, look for a monoocular uncorrected distance visual acuity for these patients, and the difference between the predicted refraction and the manifest refraction at 1 month post-op for these cases. Other points were surgeon's preference for autonomy and assessment of surface haze, assessment of glistening, and the percentage of patients requiring YAG laser capsulotomy in a 1-year follow-up period. And we looked into PCO, posterior capsulotomy requirement, any other deficiency in the device which have been given to us. These were our demographic patterns, like a routine senile cataract age group. First eye was, we had 111 patients first eye, they all successfully implanted. Second eye, we had 40 patients and they are also successfully implanted with these lenses. Looking at to our primary outcome measure, that was 0.2 logMAR or better visual acuity at 1 month. 98% of cases in a first eye achieved that, and 94.7% achieved the second eye assess. If here we had 40 patients, out of that 38 patients achieved 0.2 or better logMAR vision, and in 98% in the first eye assess. Secondary outcome measure, if you look into our patients wise, you can see the best corrected visual acuity was 0.2 logMAR, more than 95% of cases. 2025 in more than 98% of cases. Uncorrected visual acuity, almost 79-80% had more than 0.2 logMAR, and 83% had better than 20/25 vision, which is a very nice visual acuity outcome in these patients. 100% of cases were within a ±1 diopter of correction required. So this result is very, very satisfactory for us. Looking into delivery system problems, one case had one surgeon had a difficulty injecting. Otherwise, this was very safe. As per my experience concerned, there was no difficulty in IR delivery or unfolding of this device, and didn't have any intraoperative complication. There has been few reports from other centers, like one case had a general rupture, one case a posterior capsular tear. So these can be because of multicentric study. We can have these smooth delivery system was there, and it was better than earlier devices people are using. And if you look into comfort wise, people would say they agree to this device, and they might recommend to their friends also. Surface haze, which was a major concern for our previous generation IOL from Alcon. In our series, we didn't have any patient with a surface haze. Similarly, looked into glistening part for a follow-up for 1 year. We didn't have any patient with glistening. Looking for posterior capsular opacification for 1 year. We didn't have any patient requiring YAG laser capsulotomy for 1 year. Looking into all these aspects, this lens seems to be a very good alternative for a future platform for various Alcon lenses which are going to come in future, which will not have glistening, which will not have a surface opacification, which will also decrease the requirement of posterior capsular YAG laser application. We looked into wavefront aberrations also. We looked into their point spread function, the MTF. They were as good as any monofocal lenses we have seen also. To conclude, I know that this is a new device in terms of a controlled automated injection into the eye of a preloaded lens. More than 98% cases completed the follow-up, and they had a visual acuity of 0.2 logMAR or better, which is a significant result. And no cases had a glistening surface haze for 1 year. No cases require YAG laser capsulotomy. Very good device, very good lens for future to think on. Thank you all of you for listening to this talk, and definitely like to thank people who are still attached to us.
Thank you so much, sir. Now it is the time for all to switch on the cameras and have a small discussion. We don't have any questions from the audience, but if we could have a few comments, that would be
Definitely, I
wonderful.
think we finished well in time, and I can see people are still locked into all this thing. Dr. Grewal is here. Sir, any comment from your side? You are muted, sir.
I think thank you, Dr. Chatial, for a great presentation and for a new modality for a controlled injection system. And it was really good to see your videos. I would also like to make a comment on the operating microscope by the Alcon. That was really very interesting, and the photograph that was shown were really good and high resolution. And I think the 3D imaging, the RTO and they are also really an excellent tool these days. And I think they raise the bar to a next higher level. Thank you.
I think that's a nice point, sir. And if you are a user for Alcon devices, and if you have a desire to buy an Ingenuity subsequently, I think their microscope is the best suited for that. But Ingenuity can be attached to other devices also, like it can be with Zeiss microscopes also. If you have attachment requirement for other things like overlay or a OCT, then you require a Zeiss system in that. But both of these devices has given us a new way to look into our surgical area. All microscopic surgery are going to change in future, and I'm pretty sure Indian companies are working on this. Very soon we'll have a much less costlier devices for our people to work on, because this is going to be a great tool for not for a surgeon, for other people also to see what is happening, which sometimes we never knew what surgeon was doing, and you have to just imagine what he told us. What was he doing at that particular time? So this can be seen directly with the 3D devices, Polaroid lenses. And I always had a desire if somebody can make a microscope where this light doesn't hit the patient's eye. So you can have absolutely infrared type of devices which can be safe for a patient as well as for a surgeon also in future. Any comments, Sartaj? Was any comments? You did a presentation yesterday also. It's MyLoop, and it seems that you have perfected your technique there.
Yes, sir. I think for especially like relatively beginner surgeons like me, I think MyLoop is something that brings in a great amount of predictability to surgery in these more challenging situations. Other than hard cataracts, I've also found it quite useful for cases which have slightly smaller pupils. Even patients with IFIS, just going in and quickly having 4 pieces ready to just take out, even if the pupil comes down, it makes things much easier. But also what you were saying about the microscope and the fact that once you have fundamentally changed what you're viewing, once you go away from oculars to something that's completely digital and based on cameras, then the possibilities become endless. So I would completely agree with you there, so that this is the first generation platform that I think, as you become comfortable to just sort of, operating on a screen, what will come next should be far more impressive and actually able to help us as surgeons.
I think
But
you're
yes.
right, Sartaj. I have been using this for now more than a year. Then now shifting back to Oculus have become difficult for me. I can't do surgery through that now. So I've totally avoided Oculus. In fact, now we have procured some more devices. So this will help us doing surgery, because it gives such a beautiful magnification and the field of your clarity, and things would change for everybody. Yeah. Any
And
other questions
especially-
from Saurabh, Anurag, if you have some queries?
Yes, sir. So very rightly pointed out that the new technology is going to bring up much more options for doctors, and it will be patient friendly also. What I wanted to know about is Zeiss has, basically swept the microscope market till now, and this is a newer concept. So I'm in the process of buying a new microscope. So till now I considered the price of the Lumira Eye or whatever at a higher price. But now when I came to know about this Luxor device and the Luxor Revalia, so obviously it's offering us much more features, but it comes with a price tag. So being in a private practice is a little, dicey. I mean, it's 20-30 lakhs is still a huge amount over the Lumira Eye.
Can I say something?
Sure, sir.
You see, when in private practice, when you shop, you always look at the break even of a product. That will it be able to break even? Will I be able to charge more? I fully agree on that point, and that is an important point to be seen. But as a surgeon who's going to spend most of the times operating on the operating microscope, I think a good system is very important for your health. For being able to operate for a longer time. And I can share with you that with working on the RTO 800, we have the Zeiss RTO 800, the headless microscope. It's an entirely different world, as Professor Tityal was saying. Unless you use it for some time, you do not realize what it is. And I'll suggest that instead of buying an expensive car, one should, as an ophthalmic surgeon, should invest into a good operating microscope. It's a lifetime investment.
Very well said. Very well said. And the phaco machine and the microscope are your best friends, and you spend most of the time with these when you're working.
Absolutely.
So definitely worth a point to ponder.
True. Absolutely true.
The biggest hurdle that the Revalia is going to face in the market right now is the track record that the Luxor had created when the Luxor was introduced. Nobody amongst us were happy. I mean, I performed the live surgery with Luxor, and life was hell for all the surgeons who had participated. So they have to really show the world that they have changed and they have overhauled the technology, and they've come out something which is visibly and surreptitiously better than what was there in the earlier platform. Vis-a-vis that, the Lumira platform is time-tested, and everybody has his faith entrusted on the whole platform as a whole. Feature-wise, I think from what we saw, Luxor Revalia versus Lumira 700 features are quite match-to-match, neck and neck. So the prices would also be comparable. No wonders in that. I was shown the Artevo, but I did not opt for the Artevo because it doesn't work with Varian, and I can't work without Varian. I'm not very happy with the way Callisto performs. So I was always in for Varian, and this doesn't work with Varian. It's not compatible. Sir, Tityal sir, I just wanted to comment on the Clarion, just one bullet, small snippet. This is perhaps the only IOL which gets missed by the optical diameter. When you ask the patient to sit before an optical diameter like the 700, and the pseudophakic eye comes into focus, the machine automatically enters into the pseudophakic mode. But when you ask a patient who has got a Clarion implanted in one of the eyes, you ask the machine to take the reading the machine does not recognize that there is an IOL inside. So it is so clear and so transparent that it takes it as a fakey eye. So that's something that's just very, very interesting indeed. And that, I think, I've done this with all the IOLs in the market, all the premium ones, but Clarion is the only one which consistently is able to do this, dodge the optical biometer.
Okay, Anurag, that's something I have not done it. It's an eye-opener for me. I'll check it with my biometer if that is true.
Sure, sir.
But you are right, the lens looks totally different than a previous generation lens of Alcon. In fact, I was talking to the R&D people, they would ultimately shift to this material. But whatever studies we have done, the follow-up is only for 1 year. So in fact, I have already taken a IIT, that is investigator-initiated trial, to study these lenses for another 3 years. Because I have to see the surface haze, which was a major concern for previous generation IOLs, that will come up after 1 or 2 years. Because initially don't see the haze coming up these lenses. And haze is a major concern from Alcon lenses of earlier generation. Glistening definitely is not there in this particular material. Okay, sir, I think we can conclude now, and Nikhil is waiting also, and DOS is going to have a general body meeting. So thank you all of you for joining us. Wonderful session we had, and hope that we meet in future physically, not through this, screen device.
Looking forward to it.
We certainly are, sir. Certainly, we're just months away from it.
Thank you.
Okay.
The only question that I have with Dr. Anurag is how many months?
Count your days. Before you run out of the impressions on your fingers, we'll be through. Trust me.
Thank you so
I
much.
think we're
Sir.
just waiting for October to end, because all the predictions had zeroed in on October. So once October ends and we don't see a curve steepening, we would be considering ourselves to be
Post Diwali, if everything is fine, then we are through. Then the COVID era is over. If post Diwali is fine.
It's just like an astrologer nowadays. पंडित जी बताओ मेरे हाथों में क्या लिखा हुआ है. So he says अक्टूबर तक सब ठीक हो जाएगा. अक्टूबर comes अभी तक नहीं हुआ. Okay, नवंबर तक ठीक हो जाएगा.
Sir, I think we will have to now take leave because we have to start our
Just one
GBM.
second,
Yes.
Sorry to.
You had a COVID wave coming up for last 2 times, and the wave picked up at a month of Feb, and peaked by a month of April. So that is the period we have to look into. Both the year it happened like that. Okay, Namrata, we are closing.
Thank you so much. Thank you so much. Thank you so much.
Thank you so much, everybody.
Thank you.
On behalf of the organizing committee, again, I would like to thank Dr. Tityal sir for being
Okay,
a part of
thank you,
this.
Nikhil. Thank you, Nikhil. We'll have to just.
Sure. All right, ma'am. Sorry.
6 बजे स्टार्ट करनी थी क्या?
हाँ.
मैंने सोचा 6:30 करनी है.
नहीं 6 o'clock. Yeah.
6:13 schedule में. Okay.
They preponed it. चलो कोई बात नहीं. We are listening.
No, it's at 6 o'clock. It has to be adjourned till 6:15. Then you can continue, sir, if you want.
Because our session is up to 6:30.
Yes, ma'am. 6:30. Okay.
6:30 है.
मेरे ख्याल से 6:30 है.
Ma'am, it's at 6:30, ma'am, as per the schedule.
Continue then.
That's what we were just talking because.
Okay, let's have the discussion again. Dr. Namrata, what's your opinion on Zeiss Artivo device?
Zeiss Artiview. So the only problem is once you get used to that big screen and that high magnification and such clarity, I don't know how we'll do live surgeries other than in OTs of RP Center or any other place which doesn't have.
That is true. We may have to refuse the invitation in future.
It is.
Or get a Zeiss people to put a device there, before we do a live surgery.
Thank you so much, ma'am.
Okay, thank you. We see you again in the general body meeting.
Thank you so much, sir, for finishing this session 16 minutes before time. Thank you.
To people not joining at last minute.
Sometimes it helps also, but we were confused. What if they join at the last minute? That's the reason we were trying to keep it on time. Thank you, sir. Thank you. Take care.
Bye.
Okay. Bye, sir. Bye.
So, very good evening to one and all. Very good evening to one and all. Since the quorum is not complete, the GBM is adjourned for 15 minutes and we will reconvene it after 15 minutes.
But quorum is online or just physical? Where we are? Huh? We are on 15 minutes.